Hi, hello everyone. Very good morning. Welcome to Mission FMGE July 2025. We are going to discuss forensic medicine in toxicology, the most important one-liners and the most important image-based question that can be asked in your FMG exam. Is audio video, is it clear? Can anyone reply me in the chat box? So forensic medicine is one of the interesting subject and it is one of the very scoring subject. And most of the questions are usually straightforward question, usually from the standard core concepts of forensic medicine. Yes, Parul, good morning. Good morning. Irika Vani, good morning. Good morning, all of you. Yes. So let's start. So I'm going to teach entire this forensic workbook in question and answer manner. So that is the best way. You can interact with me, you can answer with me, and I'm going to teach you some important concepts in and around the question. Okay, good morning, Sagufta Kannam. Yeah, first question. So which of the following defines offenses and punishment? So the question is, which of the following define offenses and punishment? So options are BNS, BNSS, BSA and TOTA. Can anyone answer? Can anyone answer this question? Yes, it is definitely helpful for NEET PG as well. So you can make mistakes in my class and I'm going to correct you if you are wrong. Yes, so this is the question can be asked. So this is from update. You know, there are three new codes. So BNS, that is Bharatiya Nyaya Samhita, BNSS, Bharatiya Nagarika Suraksha Samhita, BSA, Bharatiya Saksha Adhiniyama. Okay, so can anyone answer? Yes, Parul. Yes, Harsha Rawat, BNSS. No, it is not BNSS. So BNSS is basically Bharatiya Nagarika Suraksha Samhita, that is related to criminal procedure code, related to investigation. So it is not about the offenses, definition of offenses and the punishment. So the definition and punishment that is given by BNS. So the answer is BNS, that is Bharatiya Nyaya Samhita. So the correct answer is BNS. So BNSS is related to criminal procedure code investigation. BSA, BSA, this can be asked, all of you concentrate. Bharatiya Saksha Adhiniyama, that is related to evidence. So BSA, like example 26(1), that is dying declaration, that is an evidence. So the answer is BNS. Very good. Vivek Tiwari, excellent answer. Very good answer. So the answer is BNS. Can anyone answer what is TOTA? What is TOTA? THOTA. Can anyone try? What is TOTA? See, TOTA is Transplantation of Human Organs and Tissues Act. So this is asked once in the FMG exam. Organ Transplantation Act. It was passed in the year 1994. The minimum age for organ donation 18 years. So two MCQs commonly asked in NEET PG and FMG exam. Okay, so the answer is BNS. Now look at this. So this is Bharatiya Nyaya Samhita. It defines offences and the punishment. This is Bharatiya Nagarika Suraksha Samhita, that is related to criminal investigation. BSA, Bharatiya Saksha Adhiniyama, that is basically evidence. Evidence. So is it clear? Do you have any doubt in this? Any doubt? Vivek Tiwari? Yes. Now we are going to discuss important BNS. So this can be asked in upcoming exam. All of you concentrate. 63 BNS. So whenever question asked 63 BNS, this must be definition of rape. Definition of rape. So as you know, rape is a legal term. It is defined by section 63. 64, punishment for rape. Punishment for rape. The punishment can be 10 years of imprisonment into life imprisonment and along with the fine. So remember 64(2). 64(2) is custodial rape. 64(2) is custodial rape. So this can be asked in your FMGE exam. So all of you write in the chat box 64(2). 64(2) is custodial rape. So let's interact. You just interact with me. You can keep me awake. You can keep yourself awake in the forensic medicine class. 64(2), custodial rape. When rape happens within the police custody, within the custody of the advocate, within the custody of doctor, this can be known as custodial rape. So all of you write. All of you write in the chat box 64(2), custodial rape. Custodial rape can be question in FMGE. Can be. It can be. Because IPC, that is old one. Old. That is passed somewhere in 1800 years back. That's why. So the IPC has been changed to BNS. That is a new criminal code. Harsha Rawat. 66 BNS, rape and murder. Rape and murder. How to remember? 6 is there, no? 6 alphabet. Murder, 6 alphabets. So murder or causing persistent vegetative state. That is known as 66 BNS. 67 BNS. That is sexual intercourse by husband during separation. During separation. During legal separation. So 67, you can remember husband. That is 7 alphabets. Husband, 7 alphabets, no? So sexual intercourse by husband with the wife without the consent during legal separation, when there is some court dispute between husband and wife. So that is known as 67 BNS. So one more, the question can be asked, 68 BNS. 68 BNS is sexual intercourse in custody. Sexual intercourse in custody by authority. By authority. So 68, 8 is there. You can remember authority. 8, authority. 68 BNS is sexual intercourse by the boss with the employee by using his power. Okay, so that is 68 BNS, that is also punishable. 69 BNS not needed. 70 BNS. 70, remember, gang rape. So you can remember G70. 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 71, repeat offenders. Repeat offenders. 71, one who is involved in the crime repeatedly. Like example, Cyanide Mohan Kumar. Okay. 70, all these are important. Then 88 to 90. So this can be asked in upcoming exam. 88 to 90, criminal abortion. CAB, criminal abortion. And one more, 22 BNS. Very, very important. 22 BNS. 𝐒𝐿 law, that is criminal responsibility of insane person. So 22, insane person. Insane criminal responsibility, CR, criminal responsibility. So I'll repeat again. 63, definition of rape. 64, punishment for rape. 66, rape and murder. 67, sexual intercourse by husband during separation. 68, that is sexual intercourse in custody. It can be with consent. So that is can be a punishable offence. 70, gang rape. 71, repeat offender. 88, 89, 90, that is criminal abortion. And the last one, 22, 𝐒𝐿 rule. Previously we used to study 84 IPC, 𝐒𝐿 rule. That is 22 BNS, criminal responsibility of insane person. Yes. So this is about the important BNS. Now I have a question for you. Look at this question. Try to answer. Husband having intercourse with wife of age less than 18 years amounts to rape if case is filed within 1 year. What do you think? Is it true or false? Is it true or false? So husband having intercourse with the wife and the wife age is less than 18 years. If case is filed within 1 year of occurrence of the offence, is it punishable offence or not a punishable offence? Yes, Sandesh, Harsha Rawat, Vivek Tiwari can answer. Irtika Vani, Parul. Parul, can you try? Parul telling, sir, true. Prince Thakkar is telling, sir, true. Yes. So, according to Supreme Court judgment, it is a true statement. True statement. So, it is a punishable offence according to Supreme Court judgment. And here is MCQ point, FMGE, the minimum age for giving consent for sexual intercourse, that is 18 years. Having sexual intercourse with consent, without consent, of age less than 18 years, when victim age less than 18 years, is known as statutory rape. Can be asked in your FMG exam. Statutory. Can be asked. 18 years. Okay, good. Good, good. Yes, fine. Okay. So next question. So next question from the workbook, that is from mechanical asphyxia. So in mechanical asphyxia, commonly as topics are hanging, strangulation, suffocation and drowning. So 4 important topics. Yes, look at this. Following is surest sign of ante-mortem hanging. Options are dribbling of saliva, ligature mark, lay faces sympathic, head bone fracture. Hanging. See, hanging is the commonest method of suicide in India. MCQ. Okay. Commonest method. It is common in males. Parasuicide, commonest method is drug injection. Common in females. Commonest cause for suicide in India, depression. MCQ. Very commonly asked in FMG exam. Yes, what is the answer, all of you? Answer. Ligature mark. Yes, ligature mark is very important. But the question is ante-mortem hanging. That means the person was alive at the time of incident. It is not post-mortem suspension. It is ante-mortem hanging. Yes, ligature mark. Not the answer. But here is the MCQ. Oblique ligature mark is seen in hanging. Transverse ligature mark is seen in strangulation, ligature strangulation. Both are MCQ. Lay face is sympathic. It can be seen in ante-mortem hanging. One eye is open, one eye is closed. Pupil on the same side gets dilated. So that is what lay face is sympathic. That is seen in ante-mortem hanging. But not the surest sign. because it is very rare finding. Hyoid bone fracture. Hyoid bone fracture can be seen in strangulation. It can be seen in road traffic accident, and sometimes hyoid bone fracture is absent in the age group less than 40 years. So answer is dribbling of saliva. Dribbling of saliva, correct answer. Very good, very, very good. So Surya, very good. Surya, Sandesh Verma, Harsha Rawat, Parul, Amit Gowda, Ajit Ras, very good answer. Prince Thakkar is asking, sir, what is the difference between 64-2 and 68? 64-2 is custodial rape, within the custody, against the consent. And 68 BNS is sexual intercourse. It is not rape, sexual intercourse in custody by using his power, like false promise of, promotion or some, okay, some demand basically. Yes, good. Dribbling of saliva. Now look at this image. You can make out here dribbling of saliva. So this is the dribbling of saliva. So can you make out? This is dribbling of saliva. This is seen opposite to side of knot. It is because of stimulation of submandibular sublingual salivary gland, which is an ante-mortem finding. Surest sign of ante-mortem hanging. Ante-mortem hanging. You can see here this dribbling of saliva. Yes. Now look at this image. One more image, very commonly asked in FMGE exam. One eye is open. Eye on the same side, pupil dilated, protruded tongue, ligature material, closed eye. What is this known as? What is this known as, and what is the reason behind this? Like this. Like this. What is that? Can you answer? Can you try? Come on, come on. Yes, cervical bone fracture necessary in hanging or not? Okay, that's fine. That topic will come. Aziz Raz, you don't worry. So it will come in the next slide. Now, time being, what is this? This is asked in FMG exam, NEET PG exam, every exam. So what is this known as? So this is known as lay facies sympathetic. Lay facies sympathetic. Why? Compression of cervical sympathetic chain. Cervical sympathetic chain. So this can be asked in upcoming exam. And also you can see here oblique ligature mark in case of hanging, transverse ligature mark in case of strangulation. Yes, very good. Surya answered, Harsha Rawat answered, Parul answered. That's great. So, and one more question, that is cervical sympathetic chain. So remember, it is a rare finding seen in 10 to 20% of the cases, not in all the cases. Now one more very important question. So that is given in workbook. This is hyoid bone. As you know, hyoid bone has body, greater cornu, lesser cornu, greater horn and lesser horn. So it is present at C3 level. C3 level, U-shaped bone. So hyoid bone fracture in hanging, how it looks. Hyoid bone fracture in strangulation, how it looks. Like example, this is, this is known as manual strangulation. Manual strangulation. In manual strangulation, it is inward fracture. In case of hanging, it is outward fracture. Okay, we can make out here. So this is outward fracture. Outward fracture, outward compression fracture, also known as anterior posterior fracture. It is seen in hanging. It is also seen in ligature strangulation, LS, ligature strangulation. Look at this. This is inward fracture. Inward fracture. So this is seen in manual strangulation, also known as throttling. Throttling. Okay. Why? Because In case of hanging, the periosteum is damaged on inner side. Periosteum is damaged on inner side. The fracture fragments moves in the outward direction. In case of throttling, periosteum is damaged on the outer side. So the fracture fragments moves in the inward like this. So this is what you need to remember. Like this, remember, this is throttling. Throttling, this is hanging. Okay? Yes. Abduction fracture, adduction fracture, commonly asked. Is it okay? All of you understood? So there are 4 MCQs. Hyoid bone at the C3 level, U-shaped bone. There are different types of hyoid bone fracture: adduction fracture, abduction fracture, traction fracture, avulsion fracture. In hanging, it is outward compression fracture. In case of manual strangulation, it is inward compression fracture. Hyoid bone fracture seen in around 30 to 40% of the cases, or sometimes less than 40. It is seen only after the age of 40. So hyoid bone ossification that takes place at the age of 40 years. So up to the age of 40 is cartilaginous. That's why. Okay. Yes. Is it clear? Yes or no? So reply me, all of you guys. Say yes or no. Sandesh Verma. Parul. Is it clear? Yes. Okay. Chirag, good. Vivek Tiwari, fine. Chalo, next. So this is what given in your workbook. You can go through differences between ante-mortem hanging and post-mortem hanging. So ligature mark, how it looks, salivary dribbling, laugh is sympathetic, drag marks. So drag marks are present in post-mortem hanging, not in case of ante-mortem hanging. This we can go through more theoretical. So I am going to teach you some important concepts. Now next question, the favorite of examiner, autoerotic hanging. Autoerotic hanging. So manner of death in autoerotic hanging. So look at this image. This is very, very interesting image. You can see here naked, ligature mark, ligature material, soft padding, protective phenomena to cut the ligature in emergency. And also you can see some dirty material there, and he's watching that, and is also mirror is also there. Closed room. So closed room, naked, seminal stain, male, adolescent. So what would be the answer, all of you guys? Is it suicidal, homicidal, accidental, judicial? Can anyone answer? So this is known as autoerotic hanging. This is accidental. So the funda is the neck compression causes hypoxia. The hypoxia stimulates the pleasure center in the brain. So there will be more pleasure. So they'll apply a ligature while during masturbation. But sometimes what happens? There can be sudden unconsciousness. Sudden unconsciousness can lead to hanging and death. So this is known as autoerotic hanging, known as 𝐒𝐿𝐻, sexual hanging, associated with masochism, transvestism, sometimes fetichism. This is accidental. Accidental, correct answer. Okay, yes, no problem. Ajij Raj. So now the one very important question asked by Dr. Ajit Raj. Sir, what is the question asked about cervical fracture? Yes, good. See, in judicial hanging. See, in judicial hanging, the body of the accused, a body of the offender. So, you know what they will do? They will do judicial hanging at the height of say 10 to 12 meters. So, sudden drop of the person can lead to separation of brain stem from the spinal cord, and there will be cervical vertebral fracture. So, judicial hanging, there will be cervical vertebral fracture, C2 fracture. C2 is commonly involved in judicial hanging, not in suicidal hanging, not in homicidal hanging, usually in case of judicial hanging. that is known as hangman fracture. You know, atlas and axis. So atlas is C1, axis is C2. So there will be C2 fracture, bilateral laminae fracture, that is known as hangman fracture. So C2, it can be C3, it can be C4 as well. C4 fracture in case of judicial hanging. Accidental, I said, autoerotic hanging, or while in children, basically accidental hanging. Homicidal, known as lynching. Lynching. Homicidal hanging is known as lynching. Suicidal is the commonest manner of hanging. Okay, there will be dribbling of saliva, suicidal note, and other findings. Okay, yes. Then what is typical atypical hanging? Very good. So typical hanging, very commonly asked, atypical hanging and judicial hanging. What is the position of knot in these three? Very commonly asked. So typical, atypical and judicial. In typical, the knot is there. The knot is there at the nape of the neck. Nape of the neck. Right here. At the occiput. Atypical, any position other than occiput. Any position. Judicial, can anyone answer? Judicial, where is the knot in judicial? Can anyone answer? Asked in FMGE exam. In judicial hanging, where is the site of knot? Is it below the chin, right angle of mandible, left angle of mandible, occiput, or anywhere? Can anyone? Mandible. Mandible. Okay. So typically it is occiput, I said back side, that is nape of neck, you are right. My question is judicial hanging. Judicial hanging, that is in case of rape and murder. Example, Nirbhaya case. Nirbhaya case. Capital punishment. In India, judicial hanging. Hanging till death. So anyone, judicial hanging? Right angle, left angle. Right angle, left angle. So your answer is left angle of mandible. Left angle of mandible. Left angle mandible. Okay. But the most effective is chin. So the most common is left angle. The most effective below the chin. So in exam, be very careful. If question asked most effective position, below the chin. Most common in India, left angle of mandible. Typical hanging, occiput. Atypical, any position. There is one more question asked. What is undertaker fracture? Can anyone answer? Undertaker fracture. Undertaker fracture. Undertaker, you know, famous WWE celebrity. Undertaker. In our days, around 20 years back, Undertaker. What is undertaker fracture? Undertaker fracture is fracture of C7 that commonly occurs in transport of dead body. When neck is unsupported, there will be fracture of C7 that is known as undertaker fracture. Yes, all of you right. Undertaker fracture is C7. C7 fracture is known as undertaker fracture. Write this in chat box. All of you write something in chat box so that you can make me awake, you can make yourself awake, everybody awake. ठीक है? Ajiz Raj, Sandesh Verma, you can keep me awake? No. Write something in the chat box. So 1 time writing is equal to 10 time reading. C7 is equal to undertaker fracture. Right. I'm just waiting. Fine. Keep writing. Sandesh, Harsha Rawat. Yes. So next question. Look at this now. This is what the question. This is the autoerotic hanging already discussed. This question, this is C2 fracture. And look at this now, A and B. This image. So now look at this. There are two types of hanging. So here no body part touching the ground. Here some body part touching the ground, right? So what is this basically? Can anyone answer? Can anyone try this? Try. So this is known as complete hanging. Complete hanging. Complete hanging. In complete hanging, weight of the body acts as a constricting force. Weight of the body. So this is incomplete hanging. Incomplete hanging or incomplete suspension. So the body weight here, the weight of the head. Weight of the head acts as a constricting force. So weight of the head maybe 10-12 kg, that can acts as a constricting force. Okay. Oh, okay, Ajiz Raj, don't worry, we are there to help you. We are there to help you. So if any doubt, you can ask me. So I'll provide my WhatsApp number. You can just contact me. I'll help you in that. Don't worry, I am there with you. Ajiz Raj. Okay? Chalo. This is okay. Fine. Yes. Now, fine. We discussed a few things about hanging. That is okay. So after the class, is go through drowning also. So drowning, typical drowning, atypical drowning, dry drowning. So hydrocution, sea water drowning. So freshwater drowning. All this very commonly asked. Go through that. So the next topic I'm going to discuss is, yes, very good. So good question from Ajiz. So what is the cause of death in case of complete hanging? See, in complete hanging, cause of death is asphyxia and venous congestion. Venous congestion. In case of incomplete hanging, it is most probably venous congestion. Venous congestion. So what happens? At 10 to 12 kg, jugular veins, carotid arteries are occluded. That leads to venous congestion, and also it leads to cerebral anemia. So cerebral anemia, venous congestion is the cause of death in case of partial hanging. In case of complete hanging, asphyxia plus venous congestion. Okay? Yes. Sure. Now, injuries caused by blunt force except blunt force. Blunt force. Very commonly asked in FMGE exam. Blunt force. Blunt and sharp. Okay? So, blunt force injuries are abrasion, bruise, laceration. Sharp force injuries are incised wound, stab wound. Again, abrasion classified into scratch abrasion, graze abrasion, pressure abrasion, imprint abrasion. Imprint abrasion, very commonly asked in FMGE exam. Laceration. So laceration is classified into split laceration, stretch laceration, avulse laceration, and tear laceration. Tear laceration. So Important FMGE question. FMG. Okay. Now question is injuries caused by blunt force except stab wound. Okay. Stab wound is caused by sharp force. So answer is D. Very good. Many answer. Answer is D. Now can anyone answer what is the most common abrasion in road traffic accident? Road traffic accident. What is the most common abrasion? FMGE question. Let's see who is going to answer. Let's see who is going to answer. Most common abrasion in road traffic accident. Very good. Anuj Kumar Chaudhary. So Anuj Kumar is telling, sir, it is graze abrasion. Very good. Graze. Graze abrasion. In graze abrasion, you will see parallel lines like this. You will see parallel lines like this. It's the most common abrasion seen in road traffic accident. It is also known as brush burn, friction burn. Okay. Now one more question in FMG. Ligature mark. So ligature mark. Say example, this is the ligature. Can you see the ligature there here? So ligature mark like this is what type of abrasion? Can anyone answer? Can anyone answer? Let's see who is going to answer. Very good. Dr. 𝐒𝐄𝐄𝐝. Sir, 𝐒𝐒𝐄𝐝, pressure abrasion or pattern abrasion. Very good. So in case of hanging, it can be pressure abrasion or it can be pattern abrasion also. Sometime you will see pattern of the ligature. Like example, see here. So this is the plastic wire. So plastic rope. You can see here, it has a pattern. So you can see the pattern over the ligature mark. So it can be pattern as well as pressure, but most commonly pressure abrasion. So when pressure is applied over the body, perpendicular to body, for long time, there will be pressure abrasion, dry, hard parchmentization. So this is okay. Yes. Now one more question asked in your exam: where to cut in? What is the site of cutting the ligature material? So example, this is ligature material. This is a knot. This is the knot, and this is the noose. Where to cut while removal of ligature material during post-mortem examination? Can anyone answer? So this is the loop, okay? Loop is there, and knot is there. Where to cut? Cut, come on. Come on, guys. Dr. 𝐒𝐄𝐝 संदेश वर्मा. कहां पे कट करना बताओ? At the knot, side of knot, opposite to knot. Where is the site? Loop. Yes, it is opposite to knot. Answer is opposite to knot, and cut ends are tied with the some thin nylon fiber. Opposite to knot. Very good. 𝐒𝐄𝐝, opposite to knot. Good. Chalo. This is okay? Fine. Now this is what given in your workbook: blunt force, sharp force, and firearm injury. Now look at this, my favorite movie. Look at this. Movie. Have you seen this movie? Pushpa 2 movie. What are the injuries caused by this sharp weapon? Sharp weapon, guys, come on, try. Sharp weapon. Simple answer. One is stab wound, or it can be incised wound. Okay. So hesitation cuts are seen in suicidal cutthroat injuries. Defense injuries are seen in homicidal cutthroat injury. Good answer. Good. Okay. Chalo. Next. Next question. Okay. This is the question. This is how. See who is going to answer. Let's see. Now this is a case of road traffic accident. Say example, I am in the forensic medicine department. I am examining dead body here, and look at the dead body, back of the dead body. You can see the parallel lines like this. This is one type of abrasion. One more case. So what I can see here, tire mark, again road traffic accident. So what are these two types of abrasion? A and B. A and B, come on. Yes, very good. Harsha Rawat. So, can you see the parallel lines? When you see the parallel lines, it is basically graze abrasion, brush burn, friction burn, most common abrasion, done. Now, look at this tire mark. When you say tire mark, MRF, sometime you will know, you will see MRF tire mark, something like that. So, when you say tire mark, it is imprint abrasion or pattern abrasion. So, and one more concept here is, pattern abrasion can be of two types. Pattern abrasion of two types. One is imprint, the second one is pressure. Second one is pressure. So, it is pattern abrasion or imprint abrasion. So, in exam, option can be either pattern or imprint or impact abrasion. Everything that is same. Good, Debaki. Good answer. Good. So, this is about the mechanical injuries. Go through all the notes given in the workbook. Done. Done. Chalo, next question. Next question from incised wound. Incised wound. Incised wound. Margins are clean cut, everted. Yes, it is true. Caused by sharp weapon. True. Spindle shape. Spindle shape. Like this. Spindle shape. What is that? Presence of tissue bridging. So C and D. C and D now. Spindle shape, that is also true. But tissue bridging, when I talk about tissue bridging in FMGE, NEET PG, so this is basically laceration. What type of laceration? Split laceration. Split laceration. Again, FMGE questions. What are the common sites? Bony prominences. Bony prominences. Bony prominences. Example, face, face, beautiful face. Scalp, tibia, okay, medial malleolus. It can occur in bony prominences because of crushing of the skin between two hard objects like vehicle and the surface and the bone. So, that is known as laceration, split laceration. Split laceration looks like incised wound. It looks like incised wound. You will see tissue bridges. Tissue bridges. Okay, and this is the most common one. Most common one. So, the answer is D. Let's say how many of you answered correctly? Yes, many answered. Anuj Kumar, Gautam, Irtika, Harsha Rawat. Very good. Good answer. Good. Good. Chalo. Now look at this image now. Now I'm in the forensic medicine department. So there is some injuries there. So what I can see here, the margins are irregular. So margins are irregular. And I can see some blood vessels, some tissues trying to bridge between two ends, one end, two end. So bridging between the two ends, tissue bridges. So my question, what type of laceration is this? Come on, try. Very good, Harsha Rawat. Split laceration. Split laceration. The split laceration because of the crushing between the two objects. Between two hard objects. Okay. Now, this mechanical injury. Now, again, I'm in the forensic department. I'm examining dead body. On the back of the hand, I can see some injury there. Injury there. And this injury has clean cut margin. And you can see there tailing of the wound. Tailing of the wound. That means it is from left to right, like this. This is the direction. tailing is there, no tissue bridges. What is this basically? So this is incised wound. Incised wound. Incised wound. So it looks like defense wound. So probably passive defense wound. Passive defense wound. So look at this now. There are two images here. One more image based question given in workbook. So this is one image A and this is the second image B. In first image, the victim is trying to grab the weapon like this. See, there is a fighting between A and B. Say example, me victim. So this is the knife. I'll try to grab the weapon like this. There can be injuries over the palmar surface. Palmar surface. Or else sometime I'll give hand like this. Like this. So what is this known as? A and B. Both are defense injuries. One is seen over the palmar surface. One is seen over the dorsal surface. My question, identify this type of passive defense or active defense injury. Very good. Dr. 𝐒𝐄𝐃𝐄𝐝, very good. So this is active defense injury. Active defense injury. So this is passive defense injury. Passive defense injury. So again FMGE repeat. FMGE favorite, NEET PG favorite. Every exam it is a favorite question nowadays. Done. Chalo, next question. Next question from again mechanical injury. Okay, this is very, very important question, guys. FMGE repeat. You can see here FMGE repeat. All are features of suicidal cutthroat. Look at this image. Suicidal cutthroat. Suicidal cutthroat. So, presence of tentative cuts. True. Tentative cuts are also known as hesitation cuts. Only one wound is deep. That is also true. Presence of cadaveric spasm. True. Presence of defense wound. This is false. So, defense wounds are seen in homicidal cutthroat. So, the answer is D. Okay. Yes. Very good. Good. So, this is what given in your workbook. Forensic workbook, suicidal cutthroat and homicidal cutthroat. There are many differences are there. You can just go through. Go through. Okay. Yes. Come on. Chalo. Next question. Look at this now. Now you are expert now. Now you are in forensic medicine department. Dead body showing something like this. We can see here. This is something. A case of murder. 103 case. Case of murder. My question is active or passive defense wound? Active or passive? Come on, try. Gautam, Parul. 𝐒𝐄𝐝. Active. Very good. Ravi, good. Gautam, good. Next is firearm injury. Firearm injury. James Bond 007. James Bond 007. Okay. Like this. Contact shot, close shot, near shot, distant shot. So there are basically 4 types of ranges. Contact, close, near, distant. Done. There are 4 ranges. The question is, all are features of firearm entry wound. Entry wound. Except is there. Abrasion collar. Abrasion collar because of spinning movement of the bullet. True it is. True. It is seen in case of entry wound. See, when bullet enters the skin, that makes some spinning movement. That leads to abrasion collar. Okay. So example. This is the entry wound. So this is the entry wound. And this is the abrasion collar. This is abrasion collar. Sometime you will get grease collar also like this. Grease collar. grease collar. Surrounded by blackening. For example, this is blackening. This is blackening. Surrounded by small superficial wounds. It is known as tattooing. So, what are the features of entry wound? Abrasion collar, grease collar, inverted margin, small sides, and tattooing. Can anyone answer? What is the reason behind tattooing? What is the reason behind tattooing? Let's see who is going to answer. You know, you will say tattooing, no, in near entry wound, a near shot. Tattooing is because of. Tattooing because of. My question, soot particle, gunpowder, bullet, wad. Very good. So tattooing is because of the gunpowder. Gunpowder. So presence of blackening, true. Presence of tattooing, true. Everted margin is false. Inverted margin in entry wound. Everted margin, exit wound. Inverted margin in entry wound, everted margin in exit wound. Very commonly asked in the exam. Okay, chalo. Done, okay. Done, all of you guys. So this is what given in your book, workbook. You can go through. Difference between entry wound and exit wound. Simple concept, very commonly asked in the exam. Go through this workbook or else go through these notes which I will provide you after the class. Yes, come on. Next is the blast injury. Blast injury. Okay. What is that next? Blast injury. So blast can be air blast. Blast can be underwater blast. Blast can be solid blast. So again, blast injury, especially air blast injury, primary, secondary, tertiary, quaternary, quinary. Okay. So the question is secondary blast injury caused by secondary blast injury. There is a bomb blast. So because of the force, all the particles are moving. Okay. All the particles are moving. So they are known as flying projectiles, secondary projectiles. So what they can lead to? So they can lead to abrasion, contusion, laceration over the body of the victim. So what is that known as? Secondary blast injury. Secondary blast injury because of the flying missiles. Flying missiles. So blast injury, very commonly asked. It can be primary. It can be secondary, tertiary, so it can be quaternary. Some books give quinary as well. So primary because of blast wave. Blast, eardrum damage, intestinal damage, lung damage. So what are the three common organs affected? Eardrum, intestine, lung. Okay. Secondary blast injury because of flying projectiles. So in secondary blast injury, you will see Marshall triad, punctate abrasion, punctate laceration, punctate bruises. Tertiary because of victim displacement. Quaternary because of structural damage. So damage to the structure. So this is again commonly asked in the exam. Quaternary, tertiary, secondary, primary. Okay. Now look at this. So blast injury I discussed already. Now look at this image. Yeah, this image. This image. So can you try this? This image, where you can see punctate bruises, abrasion, and lacerations. So what is this known as? What is this known as? Can anyone answer? So this is basically known as Marshall triad. Marshall's triad. It is seen in case of secondary blast injury. Secondary blast injury. Asked in the exam. Marshall's triad. Good. Next is the torture method. So next important question. Commonly asked, guys. Come on, come on. All of you guys. Are you enjoying forensic class? Are you enjoying forensic class? How is the Josh in forensic class? Come on, guys. Come on. 𝐒𝐿𝐴. 𝐒𝐿𝐴. Come on. 𝐒𝐿𝐴. Yes. 𝐒𝐿𝐴. Are you enjoying forensic class? Yes or no? Reply me. Now, or it is torture. What do you think? Is it torture? No. No, I think. No, right? Okay. Fine. So, yes, fine. Good, you are enjoying, right? Enjoying. Do you want me to sing a song for you? Yes, tell me. Because now it is almost 1 hour. So if you want a song, I can sing a song for you. Though I am not a very good singer, I'll try if you want. Okay. Okay, that's fine. That's why torture, no, that's why. Ready? Okay. Kannada song, okay. So Hindi to you know, so English to you will know. Kannada is my mother tongue. So Kannada is okay. Kannada is okay, all of you? 30 seconds only. 10 seconds only. ಹಾಡೊಂದು ನಾ ಹಾಡುವೆನು ಹೃದಯ ರಾಗದಲ್ಲಿ ಕವಿತೆಯನ್ನು ಬರೆಯುವೆನು ಮನದ ಆಳದಲ್ಲಿ ಹಾಡೊಂದು ನಾ ಹಾಡುವೆನು. Done. Okay, guys. Chalo. So, next question is torture. Identify the torture method. So, beating on palm and sole. Beating on palm and sole. What is that known as? So, this is known as phalanga. Phalanga. Okay. What is parrot perch? Parrot perch. Parrot perch. So, look at this. Now, look at this image there. This is, one wood is placed over the thighs, and the officer is standing on that. It leads to severe pain over the thigh. So this is known as 𝐒𝐿𝐴. 𝐒𝐿𝐴. Asked in exam. This is dry submarine. Dry submarine. You can see here, this is dry submarine. A plastic cover around the face. It leads to suffocation and death. Dry submarine. Parrot perch. So this is parrot perch. So there are 4 images. Phalanga, 𝐒𝐿𝐴, dry submarine, and parrot perch. In parrot perch, body is in the prone position. So the suspended, both the hands and legs are suspended to the pole. So this is known as parrot perch. So all are very commonly asked in the exam. Okay, good. Yes, so look at this now image. You need to identify during postmortem examination. So both the limbs are showing bruises. Bruises, not the hypostasis, bruises. See, hypostasis seen in dependent part, not in the entire limb. But here bruise is there in the entire limb. So my question is, what type of torture used by the police officers in this method? Can anyone? Yes, this is known as bastinado. Bastinado. This is phalanga. Phalanga. Okay. So this is okay. Fine. Can anyone answer this torture method? So first one is palate perch, second one is phalanga, third one, what is this? Where body is suspended at the level of wrist like this, What is this known as? Good, Gautam, very good answer. La Bandera. Good. This is dry submarine. So this is parrot perch. This is phalanga. This is dry submarine. What about this? The victim is asked to drink or asked to inhale feces, urine, water. So this is known as wet submarine. Simple. Okay, wet submarine. All these are commonly asked. Dry, wet, and other methods are given in the notes. You can just go through that. Okay. So this is what the parrot perch. Okay, some association. Just try to memorize. Okay, try to memorize. Is it okay? Okay, all of you understood? Shall I move ahead? Are you there with me? Yes. So all the methods are given here. Phalanga, telephono, wet submarine, dry submarine, parrot perch, cattle prod, chepua, gotna, sham execution, dunking and declaration of Tokyo. Everything that is given. in the notes. कोई टेंशन लेने का कोई जरूरत नहीं है, बट आराम से आपको सुनना है, बाद में आपको पढ़ना है. बस हो गया, खत्म. ओके, यस. नेक्स्ट क्वेश्चन इज थर्मल इंजरी. So thermal injuries. True about heat stroke. Very commonly asked. Heat stroke. The stroke means what? That is basically involving the cerebral arteries, middle cerebral arteries and higher centers of the brain. So in heat stroke, hypothalamus is damaged. When hypothalamus is damaged, there is no control of body temperature. When there is no control of body temperature, there won't be any sweating. Sweating is the method of heat balance in the body. Heat homeostasis in the body. So the answer is okay. Harsha Rawat. Chalo, we'll answer later. So now come back to this question. Heat stroke, core temperature, yes, that is true. Cerebral dysfunction, true. Signs of sweating, false. Impaired consciousness, true. So the answer is B. So this is asked in FMGE exam. FMGE. In FMGE, one more question asked is difference between heat stroke and heat exhaustion. This you can go through after the class. So, and one more is, that is the rule of 9. Rule of 9 is very commonly asked. Frequently asked in FMGE. Rule of 9, Palmer rule, LB formula, thermal injury, very commonly asked. So here is the question about the rule of 9. A 30-year-old married female presented with bone injuries involving entire abdomen, both lower limbs. So entire abdomen, both lower limbs. So what is the answer? Okay. Done. Come on, try this. Maybe a case of dowry death. Okay. Dowry death is punishable under 80 BNS. Just memorize this. Previously we used to study IPC 304B IPC. So B for BV we used to teach. So B for BV 304B. Now it is 80 BNS. Can you remember 80 lakh? 80 lakh dowry. Okay, this can be asked. Now it is abdomen. So abdomen, that is 18, front and back, entire abdomen, and both the lower limb. One lower limb is 18, so it is 54. Is it 54? What do you think? I think many answered wrong. You are confusing me actually. See, front of abdomen, back of abdomen, front of chest, back of chest, no. So here entire abdomen is given, no. Front, back, 9, 9, 18. One lower limb is 9? No. One lower limb is 18. Beta, 18. See, look at this. Okay. Trunk. So this part is involved, right? Entire abdomen is involved. So front of trunk, 18. Back is 18. So that means it is 9 and 9. 9 and 9. Lower limb, 18. Genital area, 1%. Head and neck area, 9%. Arm, that is 9. So one upper limb is 9. One lower limb is 18. So what is the best answer? Best answer, guys. Best answer. Look at this. This is the rule of 9. Very commonly used. Okay, other rules are Palmer rule. Palmer rule. That is rule of 1%. One more rule used in children. That is LB formula. LB formula in children. So cause of death in burn injury, hypovolemic shock, primary shock, septicemia. So what is the best answer, all of you guys? Is it still 24? What do you think? Correct yourself. Correct yourself. Yes, it is used, commonly used. Commonly used in forensic medicine. 𝐒𝐿𝐻. Yes, definitely. 54, correct answer. Front of abdomen, back of abdomen 18. One lower limb is 18. Two lower limbs, that is 36. That is 54. 54 is the best answer. 54. Memorize. Next question. Next question is antemortem burn. Burn injury. Next question is burn injury. Very commonly asked. Specific finding in antemortem burn injury. Antemortem burn injury, heat hematoma. Heat hematoma can be postmortem also. It can be postmortem. It can be antemortem. Antemortem. It can be both. Heat fracture, same. It can be antemortem, postmortem. Pugilistic attitude. Boxing attitude, like this boxing attitude. That is also antemortem, postmortem. It has no medical legal significance. When body exposed to high degree of heat, more than 70 degrees Celsius. So all the three are basically postmortem artifacts. So line of redness. Line of redness is a sign of inflammation. So inflammation, that means it is antemortem. Antemortem. So in antemortem, we will see other features like blisters. So blisters containing protein. Blisters containing protein. Soot particles in the lung, in trachea. Carboxyhemoglobin. So all these are antemortem findings. Okay. So this can be asked in your exam. Now look at this. What is this attitude? When body exposed to high degree of heat, more than 70 degrees Celsius, burn injury. You can see there is an elbow flexion. So arm is somewhat abducted like this, like this, like this, like this. What is this actually? This is known as boxing attitude, pugilistic attitude. It has no medical legal significance, interestingly. It is because of denaturation of proteins. It can be differential diagnosis of rigor mortis. Good. Next image. Look at this image. You can see there point number 1 and point number 2. And this is the blister, line of redness, the feature of antemortem burn injury. Now you need to identify this finding over the lung during autopsy. So I am in the autopsy room now. A case of burn injury on cut section of the lung. So what I can see here, black dots everywhere. Black dots everywhere, and involving trachea, bronchioles as well. What is this known as? Yes, 𝐿𝐿𝐻. Soot particles. Soot particle present in the trachea, present in the larynx, present in the lung is a sure sign of ante-mortem burn injury. Ante-mortem burn injury, FMGE repeat. Done. Next question, very important question, guys. Colors. Colors of post-mortem staining. Frequently asked. Okay. Again, the notes is there. You can just go through that. Cause of death in below case of post-mortem staining. If you see the color there, you can see this is the contact pallor. Contact pallor. You can see the regular margin. Regular margin. And cherry red. It is cherry red basically. Cherry red. So what is the answer, guys? So whenever cherry red, carbon monoxide. So it is the answer. Cherry red. Cherry red. Hydrogen sulfide, green color. Yellow phosphorus, yellow color or brown color. Opium, black color. Nitrates. What is the color in nitrates? If you answer, I'll give you 3D chocolate. Nitrates, what is the color? Come on guys. Nitrates में कौन सा hypostasis मिलता है आपको? Can anyone answer? I'll give you chocolate if you answer. Nitrates and aniline. What is the color of postmortem staining? Come on guys. Come on guys. Nitrate blue. No. I'm giving chocolate. Giving you clue. Chocolate. Dairy milk. I'm giving you clue. Dairy milk. Chocolate. Chocolate color. Very good. Gautam, it is chocolate brown. Chocolate brown and dairy milk brown. Okay. Good. Good answer. Good. This is what given in your notes. Very interesting notes. You can just go through that. Okay. Go through that. Very interesting. Very commonly asked. Next, already we discussed. Rape is defined under section 63, 64, 80, 116. Come on. Try. Definition, right? Definition. 63. 64. Punishment. 80. Dowry death. 116. Can anyone answer 116? 116. Gor agata karna. What is that? 116. Aghat. Hurt. What is that basically? 63. 116. Come on guys. 116. I'm waiting. Gautam, very good. Gautam, excellent answer. Answer is grievous hurt. Grievous hurt. The grievous hurt is 116 BNS. I hope this question will come in upcoming exam. The same question asked in NEET PG exam, INA-CET exam recently. I hope this will come again in your FMGE exam, 116 BNS. Okay, who answered? Dr. Debake? Oh, Debake, you answered. Go, great. Good. Then 116, one more question. 106, negligence. So 106, negligence. 116, grievous hurt. 106, negligence, medical negligence. 116, grievous hurt. So only difference is 0 here, 106, 116. Okay. Then, and remember grievous hurt, previously it was 20 days, right? 20 days. Now it is 15 days. So 15 days it is. 15 days. So try to correct yourself. In IPC 320, it was 20 days of inability to do ordinary pursuit. But now NBN, it is 15 days. 15 days. Okay, voluntarily causing grievous and all, don't worry. So time being, just try to memorize this. So this is more than sufficient. Okay, this notes I'll give it to you. You can just go through that. Next comes is, okay, this is what I said. You can see here, this man, group of people. So that is grievous hurt. So grievous hurt has 8 clauses. So what are the 8 clauses in grievous hurt? Emasculation, permanent privation of sight of either eye, permanent privation of hearing of either ear, privation of any member or joint, destruction of permanent impairing the powers of any member or joint, permanent disfiguration of head or face, fracture, any hurt. That is, I said it is 15 days. 15 days. 15. So all of you try to memorize this, 15 days. So all of you write 116 is equal to 116 BNS is equal to 15 days. And update 15 days. Previously 20. All of you write this in chat box. 116 is equal to 15 days. 15 days. Okay. See, how do I remember emasculation? That is 1. It is applicable to male. Okay, male. Acha, 16 minus 1, 15. Okay. Okay. But how to remember that 16 minus 1? Acha, 16 minus 1. Okay, ulta, that is fine. Okay, that's fine. That's fine. That's great. We can get both IPC, depends on examiner. But anyway, BNS is implemented. So they can ask anything, any question from BNS. So 15, 116. So some students said, sir, 16 minus 1. So that is 15 days. So it's a good mnemonic. He said 116 is there now. 16 minus 1, 15. Good. Good it is. Who answered? The answer given by Dr. Debake. Debake. Good. Very good. Keep going. Chalo. Next. Next is basically sexual offences. One more important topic. Natural, unnatural, sexual perversion, sex-linked offences. Very commonly asked. This classification given in the notes. You can just go through that. Now question is this. Identify the sexual perversion. Look at the sexual perversion here. Identify this. So what we can see here, male, consider male and a female. Female. And this male gets sexual pleasure, sexual gratification by taking pain. By taking pain. So by getting beatings from the partner. Sexual paraphilia, abnormal. Okay. So this was one of the very famous writer who was having this. So whenever he used to get scoldings, beatings, humiliation, he used to get sexual pleasure. He used to get interest to write the book. Something very abnormal, no? What is this known as? Sadism. Sadism means giving pain. Sadist. Giving pain. Giving pain. So sadism can be lust murder. Lust murder. It can be necrophilia. Extreme cases. Necrophagia. So punishable under 301 IPC. So 301 BNS. Sadism, giving pain, sadist. Transvestism known as eonism. cross-dressing, cross-dressing, okay. Fetichism, basically inanimate objects, inanimate objects. So what is the best answer then? The best answer is masochism. Masochism is the best answer. See, bondage basically sadism and masochism. It can be alternative. So the combination known as bondage. There is something BDSM also. So this answer is basically okay. Now look at these two images and try to identify what are these two sexual perversion. See, sexual perversion means sexual paraphilia, the abnormal sexual behavior, persistent for about 6 months, and a male wearing female dress, acting like a female, known as eonism. And here a male, he frequently goes to apartments and he steals the petticoat, bra, sari, and he will collect in his wardrobe. So this type of sexual gratification, inanimate objects, by looking at inanimate objects, he gets a sexual pleasure. It can be of variety of types. This is one example. Transvestism, fetichism. Yes, very good, 𝐒𝐄𝐄𝐝, good answer. It is transvestism and fetichism. Good. So all are given in the workbook. All are repeatedly asked. Sadism, masochism, bondage, fetichism, proteirism, exhibitionism, and all. Just go through that. Okay. Now I have a question for you. This is, I think, one of the movie which I liked the movie very much. Have you seen this movie, Drishyam movie? In this movie, you know, villain actually, he captures the photos of the daughter. So because of that, the story continues. He is going to kill that villain. Then the story, you know, Drishyam and Drishyam 1 and 3 is also coming now. Okay. So what is this known as? So capturing image, capturing video of the female while using lavatory or while using while in private place basically. So maybe in metros, or maybe in toilets, maybe in malls, or maybe in public toilets. So like that, what is this known as? Okay, Malayalam. Gautam, have you seen that Malayalam movie? What is this known as? This is known as, so this question basically is same. The answer is voyeurism, voyeurism. It is 77 BNS. 77 BNS. 63 definition of rape, 64 punishment for rape, 301 necrophilia, necrophagia. Acha, 𝐒𝐄𝐝, remember 77 is Shubman Gill. I had this image of staring look and okay. Chalo, you can remember like that. I remember like this 77 times. How many times? 77 times. The voyeur is not the simple crime offender. He is a repeat offender. How many times? 77 times. 7 years of imprisonment. 7 years of jail. Go to jail for 7 years, have food and come. So that is known as voyeurism. Peeping Tom, both are same. So this question is same. The camera captured images of female while using bathroom. So that is 77 BNS. Now look at this question, very interesting question. A 29-year-old female brings her boyfriend. So girlfriend and boyfriend story, very interesting story. To a couple therapist, a psychiatrist, because she is uncomfortable. She is uncomfortable. He is comfortable, but she is uncomfortable. Why she is uncomfortable? That is the question. His behavior, she found him looking at her feet all the time. All the time. All the time while having intercourse, every time at her feet. And notice that he insists on being able to see her feet while they engage in sexual activity. What is this basically? So looking at the foot, he is getting sexual pleasure, sexual gratification. What is this basically? Come on, guys. Feet fetish. Very good. Gautam, good answer. Gautam, excellent answer. This is known as fetichism. Feet fetish. Good. So this is known as fetichism. Fetichism. Exhibitionism can be asked in your exam. Exhibitionism can be asked. Okay. Now I have a exhibitionism. Okay. Can anyone tell me what are types of exhibitionism? Can anyone tell me types of exhibitionism? So there are 4 types. 4 types. If you answer, you'll get 3D chocolate from me. 3D chocolates from me. Come on, guys. What are 4 types? Come on. Gautam, are you there, Gautam? Devake, Karthik Pradhan, Harsha Rawat. Come on, guys. I'm just waiting. Types. So the first type is mooning. Mooning. That is showing buttocks in public place. Intentionally showing buttock place. So he gets sexual pleasure. Second, streaking. Streaking. Running naked in public place. Third, flashing. Showing genitals in public place like garden, public park. And the fourth one, anarisma. Anarisma. This is, I think, not found in any of the notes, I feel. Anarisma. Anarisma means lifting the skirt in public place to get sexual pleasure. The question can be asked, what is cisvestism? That is inappropriate clothing in public place. Yes. Now I have a question for you, very serious question. So be serious, guys, now for some time. In case of rape in court of law, woman states that in her evidence, evidence can be direct evidence, indirect evidence, hearsay evidence. Before the court that she didn't consent. The court shall presume that she did not consent. So once the victim can be sex worker, if she states that the consent is not given, the court will presume that, the court will accept that the consent was not given at the time of intercourse, including sex worker, I'm telling you. What is this? True or false? True or false? What do you think, all of you? True or false? Nishant Sinha. It is true. Very good. It is true as per 120 BSc. 120 Bharatiya Saksha Adhiniyama. It is a true statement. The court will accept that. Okay. So next is very, very important question. Seminal stain. Blood stain. Guys, we are into the next important topic. Seminal stain, blood stain and all. Okay. 120 BSc. 120 BSc. Chalo. Next there are 4 tests commonly asked. Tieckmann test. So all of you concentrate. Tieckmann test. Tieckmann test, you will see brown rhombic crystals. So this is for blood stain. Blood. So how to remember? Brown man. So that is brown rhombic crystals. You will see brown rhombic crystals. Question asked. Basically hemine crystals. Then Takayama test. That is hemochromogen test. In Takayama, you will see pink feathery crystals. I remember like this. Takayama is there, no? Takayama. I remember as mama. Which mama? Pink mama. See, mama to definitely lovely, no? In everyone's life, mama is lovely. But here, don't mistake me. Pink mama, lovely mama, basically pink feathery crystals. So mama will come with the feathers. Chalo beta, le lo, pink feathers. है ना? So Takayama, pink mama. Takayama basically blood. Takama also blood. Also blood. So Tikman and Takayama both are for blood. Tikman and Takayama both are for blood. No confusion at all. So both are for hemine crystals, both are confirmatory tests. We have so many screening tests. Benzidine test, tetramethyl benzidine test, orthotolidine test. So many tests for blood stain. Confirmatory test is Takayama Tikman. Okay. BNS beta, I'll share with you. I'll share with you, don't worry. It is there with this. And I have a separate video. I'll share with you in Telegram. Tony, you are, don't worry. When me is there, you don't worry about forensic medicine. You give me anything, any question, I'll answer. I'll try to answer. I'll solve your doubt. You don't worry. Okay, chalo. Tony, be ready. Chalo, look at this now. Barberio test. See, Barberio, spermine picrate crystals. Spermine picrate crystal, yellow needle shaped crystals. It is for what? Seminal stain. Seminal stain. So spermine picrate. Spermine picrate. Spermine is present in seminal vesicle. Seminal vesicles. So we use picric acid in Barberio test. That's why spermine picrate crystals. How do I remember? I remember barber with a needle. Barber shop. Yellow, dirty fellow. Yellow needle shaped crystals. So barber, dirty fellow. Like that you can remember. So okay, barber, dirty fellow, seminal vesicles, spermine picrate. It is screening test, not confirmatory. Okay, yes. Now, dark brown rhombic crystals. Florence test. Florence test. The choline iodide test. So Florence is basically seminal stain. Now here question is how to differentiate between Florence test and Tieckmann test. Can anyone answer? How to differentiate between Florence and Tieckmann? Can anyone answer this? Can you try this? Can you try this? Come on guys, come on. Come on, try. Tony, Karthik, Gautam, Parul, Nishan. I am waiting. Can anyone answer? How to differentiate between Tieckmann and Florence? Remember, Florence, the size of the crystals is large, but in Tieckmann, size is small. That's the only difference. Okay. Okay. Now comes is the ossification center. So next heading, ossification center and size of crystal. Yeah, size of crystal, correct. Good. Next is ossification center. Very, very important topic, commonly asked. Ossification center appears at 7 months. 7 months means viability. Viability. Viability means 28 weeks. Okay. Full term. Full term means it is 37 weeks. So both are very commonly asked. So when question asked about viability, your answer must be talus. When question asked about full term, it is lower end of femur. Lower end of femur. So both are very commonly asked. So at 7 months, talus appears. At 7 months, pupillary membrane disappears. At 7 months, the fetus weight becomes 1 kg. Okay, so all these are commonly asked. Talus, correct answer. Upper end of tibia, usually 40 weeks. 40 weeks. Okay, yes. You can see here calcaneum, manubrium sternum, 5 months. Talus 7 months, lower end of femur 36, upper end of tibia 38, cuboid 10th month, just after birth. Just after birth. This is given in notes. You can just go through this. Yes. Okay. So this is okay. Now I have a question for you. That is about insanity. Insanity. Now forensic psychiatry. Few questions about forensic psychiatry. Now look at this. Look at this image. So a case of schizophrenia. You can see here the man is having hallucinations. The man who is having delusions is a disorder of thought, disorder of perception, that is hallucination. So my question is, what are the features of true insanity? What are the features of feigned insanity? So this is very important. 22 BNS, criminal responsibility of insane. Any act committed by insane person is not a punishable offense. So what are the features of true insanity except? Come on, try this. Try. Gradual onset, schizophrenia. Gradual onset, sudden onset. Gradual onset. True. Trends of delusions, hallucination. True. The most common delusion is delusion of persecution. The most common hallucination is third person hallucination, auditory hallucination, hearing sounds. Okay. Delusion is a disorder of thought. Fear of detection, false. Insight is impaired, true. The insight means awareness. Awareness about one's own illness. That is the feature of neurosis and psychosis. When insight is absent, psychosis. When insight is present, neurosis. Like example, OCD, neurosis. Why? Because insight is present. Psychosis, insight is absent. Example, schizophrenia, bipolar disease, psychotic depression. So the answer is fear. Fear is present in feigned insanity. No fear. Okay, this is the FMG workbook. All differences are given. You can just go through that. Okay. Now this is one more interesting question. All are examples for psychosis except. Psychosis means insight is absent. The awareness about one's own illness is absent. Schizophrenia, yes. Bipolar disorder, yes. Mania, yes. But obsessive compulsive disorder is neurosis. It is a neurosis. Obsessive compulsive disorder. Okay, answer is D. Parul, very good. Good. So again, the differences are given. We can just go through that. Then I have a question for you. Okay, just to make you happy. There's a forensic mystery. Yes, good. Okay, I'll just enact you and say consider me having some delusion. Okay, so delusion is a disorder of thought. Say me having some delusion. So my favorite actress since my college days is Deepika Padukone. So okay, see, I'm in some deep love with Deepika Padukone. That is normal. That is normal thought. But here I have some abnormal thought. I'm suffering from some delusional disorder. You just identify. So here what do I think actually? Sometime Deepika Padukone is in deep love with me, though I never met her. So she is in deep love. She is in lots of love with me, though I never met her. I never met her in my life. So दीपिका पडुकोणे मुझसे बहुत प्यार करती है, हालांकि उनसे कभी नहीं मिला. So what type of delusion is this? So what type of delusion is this, guys? It's common in females. Common in females, uncommon in males. So this is a delusional disorder, delusion of the thought, that is the thought disorder. Anybody? What is this known as? Very good, Harsha Rawat. 𝐑𝐄𝐝 syndrome. 𝐑𝐄𝐝 syndrome, also known as erotomania. Very good. Erotomania. Erotomania. Common in females. Common in females. Okay? Yes. Chala, good. Many answered. Vashi answered. Ashik answered. Good. All are enjoying class. All are replying in the chat box. That's really nice. Okay. Then this is okay. And I have one more Brahm, that is delusion. You need to identify now. This is a bit difficult, but you can try. Unfamiliar people are mistaken for someone you know. Unfamiliar people, that is strangers, are mistaken for someone you know. Like a beggar is mistaken for your boss. A beggar is mistaken for your boss. Funny. Look at this now. A beggar. Beggar. mistaken for my boss, Donald Trump. I think he is not beggar. I think he is Donald Trump. What is this now? So very interesting. Okay, can anyone try? Anyone try? What is this syndrome known as? Donald Trump, my boss. I think he is not him. He is actually Donald Trump. So what is your thought? What is your opinion? What type of delusion I am having? अपने अच्छा आशिक हुसैन बताओ आशिक हुसैन good this is okay, this is one. Okay, and one more I have. Someone you know is perceived as an imposter, a duplicate. Someone you know is perceived as an imposter, a duplicate. Like example, Donald Trump is my boss. I think he is stranger. Hey, yaar, I don't know. He is stranger. Like that, I am having that delusion. So again, what type of delusion is this? Both are very interesting, and both are very interesting delusions. Can you answer anyone? Ashiki Hussain, thank you. Thank you, Ashan. Thank you. First one is Prigoli, second one is Capgras. So I have two questions for you. Beggar and our Trump. Trump and stranger person. So can anyone answer this? First one and second one. So there is a 3D chocolate waiting for you. So now answer is familiar person considered stranger, that is a Capgras syndrome, that is the second one. Stranger considered as a familiar person, that is not Frigoli syndrome. So the one is Frigoli, the second one is Capgras. Good. Who answered? The answer given by I think Harsha Rawat and Gautam. Harsha Rawat and Gautam. Yes. Good. Vaibhav Verma. Very good. Vaibhav Verma also answered. Okay. So this is interesting. This we can go through in FMGE book. Good. Congratulations. Good. Hope you enjoyed it. I hope you enjoying forensic class, guys. How is the Josh in forensic class, guys? How is the Josh in forensic class? Should be very high all the time. Should be very high all the time. High. Okay. Just reply me in chat box. So meanwhile, I'll have some water. Okay. I'll have some water. Come on, guys. I'm just waiting. Harsha Rawat is telling, sir, high, very high. Chalo, next. Hi, very good. Hi. Now I have a guest now. Just say hi to him. Okay, we have a guest here. We have real guest. Okay, you are from Shumaga, Vikram Shanbag. Good. Ye dekho. I have a guest, a gentleman of 40 years, male. Just say hi to him. NBS. What is NBS? Say hi to him, all of you. Say hi. Okay. So real skull. So try to memorize this. Okay. Try to memorize. In case of male skull, forehead is steeper. Okay. Forehead is steeper. Try to memorize this. Forehead is steeper. Orbits are in males. So I am discussing only the features of male skull. So don't be confused with the features of female. Okay. So male skull always it is steeper. Female skull straight. Look at the orbit. So orbits are basically rectangular. All the bony markings are very prominent in male. In female, not prominent. Then everything, zygomatic arch, mastite process, weight, everything that is large, heavy in male. But in female, eminences, frontal eminence and parietal eminences, they are prominent. Look at this here, the frontal eminence not that prominent. So this is the one simple funda. Frontal eminence is prominent in female, Parietal eminence prominent in female, rest all are prominent in male. So this is what you should remember. Okay. Now with this, now we have a question now. Cephalic index of skull is used to estimate. So now say example, this is present in the crime scene. Example, this is present in the crime scene. You can identify the race. How you can identify the race? By looking at the cephalic index. Cephalic index is maximum breadth. The maximum breadth between the two parietal eminences or maximum breadth divided by maximum length. So that is known as cephalic index. Cephalic index, race basically. Okay. So with that you can tell whether it belongs to Indian, belongs to European, belongs to Mongolian, like that. Okay. Now say example, this is a typical Indian skull. What is the cephalic index of this? What is the cephalic index of Indian skull? Can anyone answer? Can anyone answer? Indian, China. Yes, come on guys, come on guys. I'm just waiting. Waiting. Come on, come on, come on. Okay, chalo. Answer is, so typical Indian skull comes under mesaticephalic. So okay, it comes under mesaticephalic. Some books gives it is dolichocephaly. Some books gives mesaticephaly. I'll go in favor of mesaticephaly. I remember mesati, MS Dhoni. M for MS Dhoni. So that is yes, very good. I think someone answered correctly. Yes, Ashiki Hussain answered correctly. 75 to 79. M for MS Dhoni. M for mesaticephaly, India. So more than 80 Mongolian brachycephalic, dolichocephaly, that is 70-75, Aryans and blacks. Mesaticephaly, Europeans, brachycephaly, Mongolians. This is also cephalic index. Okay. So given in the notes, you can just go through that. Now this is so already I discussed. You can try. All are features of male skull except rectangular orbits, prominent supraorbital margin, forehead is steeper, prominent parietal eminence. Try this. Try guys. Try. Good. Come on. Yes, this is the D is the answer. Yes, right. D. Now, you know, in Karnataka there was a case in a house. There were 5 skeletons were found. 5 skeletons were found in a abandoned house. So which was closed since last 4 or 5 years. They found 5 skeletons. I think 3 males and 2 females and a dog skeleton. Total 6 skeleton, animal skeleton also. So very interesting case. And in that case, duty of forensic expert is to find out whether male or female and what is the age, what is the height and all. Whether animal or human, like that. So animal, human, very easy precipitating test. So whether bone or something else by Haversian canals. So male or female, look at this now. I have 2 skulls now in the crime scene. I am in the crime scene now. So look at this now. This is 1. So we take this as a 1 and 2. We just answer. Look at this one, steeper forehead. We can see the rectangular orbits. Bony markings are prominent. U-shaped mandible. And frontal parietal eminence is not prominent. Look at this one more side. This side I have V-shaped mandible and round orbit, straight forehead, frontal parietal eminence is prominent. So now my question is 1 and 2. Can you answer this? 1 and 2. So this must be male. Okay. So look at this. Look at this. Look at this. And look at this. And look at this here. Here, straight and somewhat V shape. Less obtuse angle in male, more obtuse angle of mandible in female. So this must be a male. This must be a female. Okay, male and female. Now, can anyone tell me how to identify age of the person? Age by looking at the skull. Is there any way to identify? Yes, by looking at the sutures, skull sutures. So the best suture is sagittal suture. FMGE question. Sagittal suture. Sagittal suture. So the best suture is for age estimation is, that is sagittal suture. So this is what given in your notes. You can just go through that. Yeah. Now one more question from pelvis. All are features of female pelvis except female pelvis, male and female pelvis. Averted ischial tuberosity, that is true in female. Inlet is round. Subpubic angle is 90 to 110. Greater sciatic notch is deep and narrow. So about the female pelvis. One more question asked, frequently asked in the exam. Frequently asked in the exam, what would be the best answer? Best answer is, so it is deep and narrow. So deep and narrow in case of male pelvis. So male pelvis. Again, differences are given in your notes. You can just go through the differences between male and female. Okay. Yes. Good. Professional death sentence given by. So death sentence, professional death sentence, that is a removal of name of the doctor from the medical register, that is given by State Medical Council. State Medical Council. So professional misconduct can be 6 A's, very commonly asked. 6 A's. A for association, A for advertising, A3 for adultery, abortion, addiction, alcohol. 6 A's of professional misconduct given in the notes. You can just go through that. Okay, association, advertisement, adultery, abortion, addiction, alcohol. So the punishment can be removal of name of the doctor temporarily or permanently. That is known as professional death sentence. Okay. Now, have you seen this movie? This movie, remember Arjun Reddy movie, 6 A's. 6 A's are basically infamous conduct or dishonorable, disgraceful conduct of a doctor. The punishment can be professional death sentence given by State Medical Council, and he can approach EMRB. EMRB. Okay, EMRB. So EMRB is the body he can approach in case of professional death sentence. So, okay, this is so easy. This is given. Medical negligence is punishable under. So can all of you try this? Medical negligence is punishable under. So the answer is 106 BNS. So now let's have some discussion of inquest. Okay, inquest. Most common inquest in India. So next heading, all of you guys concentrate. Next is the inquest. So inquest means enquiry towards cause of death. It can be of two types in India: police inquest, magistrate inquest. So police inquest and magistrate inquest. Magistrate inquest. Okay. Most common is police inquest. The police inquest comes under 194 BNSS. Magistrate inquest comes under 196 BNSS. So this can be FMGE question. Try to concentrate, all of you. 194 and 196. So what are the indications of magistrate inquest? Again, commonly asked in your FMGE. In FMGE is commonly asked. So magistrate inquest done in. Can answer, all of you? Can answer? Some indications for a magistrate inquest. So one is custodial death. Custodial death. So death in police custody, death in psychiatric hospital, death in jail, death in remand home. Yes. Okay. Then custodial death. Second one, exhumation. Exhumation. Third, death in psychiatric hospital. death in psychiatric hospital. So there are basically many indication. These three are common indication. Exhumation, dowry death. Yes, one more, that is dowry death. So dowry death. So 4 common indications. So this is frequently asked. Yes. So next few questions about toxicology. Only few questions, next half an hour. So we are going to discuss some toxicology questions. True about ideal homicidal agent. Ideal homicidal agent. See, ideal homicidal can be cyanide. It can be cyanide. It can be arsenic. It can be aconite. Aconite. So these 3. Even cyanide can be ideal suicidal also. So ideal homicidal, FMG repeat. Less toxic. No, it is wrong. It should be more toxic. False. Unpleasant taste, that is false. Costly by price, false. It looks like a natural disease, that is true. That is true. Good. So the answer given by Harsha Rawat and Parul, Gautam and Nishant Sinha. Very good. The first 2 answer given by Harsha Rawat. Very good. Harsha, very good. So one who answer, I am going to write his name over the slide. So answer is true. And look at this. This is the sweet pan. With this, aconite can be mixed. So aconite can be sweet poison, sweet in taste. It is one of the ideal homicidal agent. It is a cardiac poison. It leads to cardiac arrhythmia and death. The root of aconite is most toxic. It looks like horseradish root. It's a cardiac poison. Aconite is a cardiac poison. Good. Nishant, very good. Chalo. Types of poison. Again, notes it is given. Ideal homicidal and ideal suicidal. You can just go through that. It's given already. Now, one more very important topic, guys. Yeah, it looks like a pan. Fine. Following is an example for organochlorines. So next heading, organochlorines and organophosphates, frequently asked in the exam. So malathion, HTP, DEPP, DDT. So insecticides are classified into organophosphates, and organochlorines. So frequently asked. See, organochlorines, they inhibit neurotransmission. Organophosphates, they inhibit acetylcholine esterase enzyme. Organophosphates are classified into aryl phosphate and alkyl phosphate. So very frequently asked, alkyl phosphate and aryl phosphate. So the mechanism is irreversible. So organophosphates are acting irreversibly over acetylcholine esterase enzyme. Okay. So organochlorines. So what is the best answer now? Malathion is alkyl phosphate. So these also actually OP poisons. So the answer is DDT. So good, DDT. Yes, first to answer by Harsha and by, yes, good answer. DDT, correct answer. So alkyl phosphates we can see HTP, TEPP, OMPA, malathion. Aryl phosphates, parathion, methyl parathion, diazinon. And organochlorines if you see here, DDT, endrine and others, paraquats and all. So this is one frequently asked in FMGE, you must know. So yes, this is okay. Alkyl phosphate, aryl phosphate. Yes. Then the features of OP poison. You must be knowing that the mnemonic is Sludge MTF. Sludge MTF is a mnemonic. So S for salivation, seizure, sweating, L for lacrimation, urination, diarrhea, gastric upset, emesis, MTF, meiosis, tachycardia, fasciculation. So all these are the clinical features of OP poison. Can anyone tell me what is the drug of choice in case of OP poison? Drug of choice. So the first one is airway. You just maintain airway, breathing, circulation. Then comes is the drugs. So drug of choice is atropine. 2 to 4 milligram intravenously till atropinization. Can anyone tell me what is the first sign of, what is the confirmatory sign of atropinization? What is the sign of atropinization? A therapeutic endpoint. Can anyone answer? Yes, anyone? Is it pupillary response or dryness of secretion? No, it is not mydriasis. Basically, if you ask therapeutic endpoint, it must be dryness of secretions. So dryness of secretion. So therapeutic endpoint is dryness of secretion. Earliest response is mydriasis. So this is one correction, you just do it. Then we give palm and dam. So palm means prolidoxime, dam means diacetyl monoxime. Again, one of the FMGE question asked, which can cross blood-brain barrier? FMGE question. Come on, try. I remember like this. Dam is damn good. It can cross blood-brain barrier. And this palm and dam should be given within 48 hours. And this palm and dam oximes are contraindicated in carbamate poisoning. FMG repeat, carbamate poisoning, this palm and dam contraindicated. So all these are the clinical features frequently asked. The clinical features appears within 30 minutes to 2 hours. The cause of death is respiratory paralysis. The postmortem findings are cyanosis, congestion, petechial hemorrhages. It is a common agent of suicide. It can be accidental in nature. It can be homicide as well. Homicide is very rare. So this is about the OP poison. Yes, come on. Any other doubt in this atropine? Any doubt in OP poison? You can ask me. Harsha Rawat, Parul, Nishant, any doubt in OP poison? OP poison is frequently asked. Irreversible. Remember, it is irreversible. Carbamate reversible. OP poison is classified into alkyl phosphates, aryl phosphates. Malathion is alkyl phosphate. Yes, good. Chalo. Okay, next is the snakes. Some questions about the snakes. All are features of poisonous snakes except poisonous snake. Large belly scale, triangular head, nocturnal habit, always rounded tail. So large belly scale, poisonous. So example, this is the belly. So this is the belly of the snake. So when you see like this scales, like this, so it is poisonous. When you see like this, so this is non-poisonous. Triangular head. So whenever you see triangular head like this, it must be vipers. So vipers can be Russell's viper, saw-scaled viper, pit viper, hump-nosed viper. So vipers are hemotoxic. Hemotoxic. So triangular head, no. Nocturnal habit. So most of the poisonous snakes, so they do travel in night time. They are nighttime biters. Okay. So always rounded tail, this is wrong. So most of the time it is tapered tail. Tapered. So example, this is the tail, it looks like this. So this is poisonous snake. But in common cobra it is rounded. That one exception is there. Always rounded is wrong. So answer is D. Good. So this is what given in FMGE notebook. You can just go through that. Poisonous scales, poisonous snakes, what are the features? And non-poisonous snakes, what are the features? You can just go through that. Okay. Yeah. Then there are 4 snakes here. You need to identify the 4 big 4 snakes in India. Commonly asked. Come on, try. So I'll label this as A, this as B, this as C, and this is D. So they are basically known as big 4 snakes. Big 4. Big 4. Identify this. The first A that has a hood, which has a spectacle mark. The fatal dosage is 15 milligram. The fatal period is 30 minutes to 6 hours. So what is this? And this has brown color spots over the body. Brown color spots, B. And this has white wavy line. And this has transverse white line. So all are poisonous. They are known as big 4 snakes in India. And the treatment is polyvalent anti-snake venom. Some causes neurotoxicity, some causes hemotoxicity. Vipers cause hemotoxicity, DIC and death. And this common cobra, common crate cause respiratory paralysis and death. So my question A, B, C, D, identify that. Let's see. Yes, come on. A, that is basically common cobra. Common cobra. Scientific name Naza naza. Naza naza. Fatal dosage 15 milligram. Fatal period is 6 hours. King cobra 12 milligram. In king cobra, spectacle, you know, they are absent. Hood is present, but spectacle mark is absent. And this is what the Russell's viper. Russell's viper. The scientific name is Dubai russelli. Dubai russelli. And look at this. Look at this C. So white wavy line. When you see white wavy line, bird foot mark. So this is known as saw-scaled viper. Saw-scaled viper. The fatal dosage, you can see 8 milligram. Fatal period is 1 to 2 days. Bird foot mark. And the last one is the common crate. So common crate. Saw-scaled viper known as Achis carinatum. Achis carinatum. Common crate Bungarus ceruleus. Bungarus ceruleus. This is asked in FMG exam. Bungarus ceruleus. So all these are big 4 snakes in India. And if you see the common crate, the fatal dosage of dry venom is 3 to 6 milligram. So this is asked in FMGE, NEET PG exam. The fatal dosage of common crate venom, dried venom is 3 to 6 milligram. The fatal period is 18 hours. It is one of the commonest snake in India. Steel black in color, transverse white mark. So this is all big 4 snakes. So all of you, anyone, can you answer which is the most cunning snake? Which is the most cunning snake? Can anyone answer? Most cunning, like Katappa. Have you seen Bahubali movie? Katappa, have you seen Bahubali part 1? Katappa. So my question is, which is the most cunning snake which has a tendency to bite people in their sleep? So it will be searching for the food at the night time. It will go near the human, just bite and it will go without any stimulus. So very, very cunning snake like Kattappa in Bahubali movie. Can anyone? Viper? No, not viper. And the clinical features of that snake is neurotoxic. There will be paralysis, less convulsions, death in their sleep. So night, aram se food, everything was normal. He was sleeping on the floor, and morning found dead. Okay, what is this basically? Rattlesnake? No, it's not rattlesnake. Viper? No. Come on, guys. Kattappa, I'm giving you Kattappa. Kattppa. K. Rattle? No. Come on, guys, come on. Kattappa snake. You should make me happy by answering within few seconds. Crate, very good. Harsha Rawat. Common crate, asked in FMGE exam. Common crate bite resemble like stroke. It has a tendency to bite people in their sleep. Fang marks are invisible. One of the cause for negative autopsy, obscure autopsy. Then it is crate. Okay, good. Now, there is a video for you. You need to identify what type of snake bite is this and what is the fatal dosage. Okay. Yes. What is the fatal dosage? Already given there, common cobra. So what is the fatal dosage? Look at this image and the video. The person had bitten by common cobra. He is having ptosis. He is having ptosis like this, ptosis, and having respiratory paralysis, weakness of muscles, broken neck sign and all. After giving antivenom, he looks normal. He completely recovered. So this is the snake bite. We can see the fang marks there. Fang marks there. Now looks normal. See, healthy, normal. This is the beauty of medicine. This is the beauty of doctors. Okay. So what is the answer for this question? How many milligram? Common crate. Common crate. Come on, guys. Yes, I said common crate 15 milligram. 15 milligram. Who answered 8? No, it is 15 milligram. Good. Next is the one question about the smell. Smell during postmortem finding. Smell. See, in some cases, especially in poisoning, you will get peculiar smell while opening the skull cavity. Burnt rope smell is felt in which poisoning? Burnt rope. So arsenic, garlic smell. Arsenic and phosphorus, garlic smell. Cyanide, bitter almond. Bitter almond. Hydrogen sulfide, fishy. So what is the answer then? Cannabis. Cannabis. Yes. Burnt rope is in cannabis. Okay. Good, good. So you can see here arsenic, aluminum phosphide, garlic, cannabis, burnt rope, alcohol, fruity, cyanide, bitter almond, hydrogen sulfide, rotten egg, chloral hydrate, acrid, PO, naphthalene, mothball, salicylates, menthol smell, zinc phosphide, fishy smell. All these are important FMGE questions. You must know. Okay. So the answer is A. So this is, can anyone answer? So two smells here, B and A. Rotten egg and garlic smell. Try to memorize rotten egg. I said rotten egg is hydrogen sulfide. Zinc phosphide is fishy smell. Garlic is arsenic and phosphorus. Yes. Speedball is heroin, cocaine, phencyclidine, chloral hydrate, MDMA. So MDMA is party drug. So it increases serotonin level. It increases mood. It is basically amphetamine, methylene deoxymethamphetamine, as in FMGE. Chloral hydrate dry wine. So it is mixed with the alcohol to increase the effectiveness. Phencyclidine, angel dust. Answer is heroin plus cocaine. So heroin plus cocaine, that is basically known as speedball. Speedball. You can see here, this is brown sugar, heroin. This is the white powder, that is basically cocaine. So in cocaine poison, you will see tactile hallucinations, scratch mark, FMGE question. So multiple scratch marks are seen over the dead body, suspected case of poisoning. What is the answer? Answer is cocaine poisoning. Cocaine, you will see tactile hallucination, known as formication, known as Magnan symptom. So in cocaine poison, nasal septum perforation very common, and it inhibits the reuptake of norepinephrine transporter. So it increases norepinephrine level, increases blood pressure. It can lead to stroke and death. It can lead to hyperthermia. It can lead to increased heart rate, tremors and all. Okay. So jet black tongue. Okay. Stomach perforations in okay. Harsha Rawat, you were telling. Okay, septal perforation. Correct. Okay. May I know what is the run amok substance? So Alfuza, run amok. Very good. Run amok is a good question asked by one of the student. So run amok is cannabis poison. In case of chronic cannabis poison, the person gets an impulse disorder, impulse of killing people. So killing friends, killing animals. So a kind of aggressive behavior, that is known as run amok, chronic cannabis poison. What are the preparations of cannabis? Bhang, ganja, charas, cannabis oil and cannabis cookies. So there are 5 types basically. Run amok cannabis. Good. So this is what the question asked. Date rape drugs. So basically rohypnol and ecstasy, that is MDMA. Angel dust, I said phencyclidine. Micafin, so chloral hydrate plus alcohol. A rave drug, that is MDMA and amphetamine. Magic mushroom, that is psilocybin. So all these are one-liners, somewhat memory-based question asked in the forensic medicine. So this is about the all the important questions, all the important FMG repeats and workbook related teaching. I hope I covered almost all the topics. So here, there I covered the entire topics and some points are given in the notes. That is more than sufficient. If you have any doubt, you can ask me. If you have any doubt, you can ask me. I'm there for next 10, 20, 15 minutes. I hope you enjoyed a forensic class. I hope you will get 10 to 12 questions in upcoming FMG exam. And most of the time, what I observed, most of the questions do come from the standard concepts only. Standard concepts. So any doubt? Harsha Rawat, Pankaj Singh, Nishant Sinha. Okay, John. Thank you. Thank you, John. Harsha Rawat. Yes. Yes. Any doubt? Any feedback? Anything? Okay, that's fine. That's in Telegram. You can message me at any time. And one more topic, abortion is commonly asked in exam. Remember, up to 20 weeks, 1 doctor, beyond 20 weeks, 2 doctor, beyond 24 weeks, medical board. This is frequently asked. The minimum age for giving consent for organ donation 18 year, abortion 18 year, surgery 18 year, medical examination 12 year. 12 year. So abortion, one important topic, especially MTP Act. So commonly asked. So that's it about the forensic medicine. Wish you all the very best for upcoming FMG exam, And if you have any doubt, even silly doubts, you can ask me in Telegram. We are there to help you. We as a team, PW Meded, we are committed to help you at any time. So you can message me in Telegram. Acha, blast injury underwater. Beta, underwater answer is your intestine. Okay, solid blast answer is skeletal injury. Skeletal injury. If head is over the water, then water enters into the intestine. There will be rupture of the intestine. So it is intestine basically. In solid blast, it is basically skeletal injury. If you know that, that is fine. Okay. And the last question, this question, I think this video, can anyone identify what is this snake? Just to conclude with the snake. What is this snake? Triangular head, constricted neck, broad body, pointed tail, looks like a sand. So this must be, what is this basically? Rajendra, Harsha Rawat, this is basically hemotoxic. This is viper, this is hemotoxic. So viper, okay. So the answer is hemotoxic. Good. So all important points are given in the notes. You can just go through this. Thank you. You're done now.
Hi everybody. Good afternoon. How is everybody on this lovely marathon afternoon? कैसा चल रहा है सबका? I am starting the session slight bit earlier. कोई बात नहीं, कुछ लोग थोड़ा सा बाद में आएंगे. They can catch up. But the whole idea is कि आप लोगों को 2 सेशन के बीच में थोड़ा ब्रेक भी मिल जाए. So I hope पिछला सेशन अच्छा गया. I understand it was FMGE. I'm going to wait for some of you to show up and tell me if you can hear me. Can you hear and see me okay? Please confirm. Before we go further, can you see me and hear me okay? That's very important. Can you hear me? Can you see me? If yes, brilliant. We'll start in just a minute. We have a very interesting session ahead. We are going to talk about many topics. Oh, there seems to be a tiny bit of an issue that the green background is getting mixed with my green screen. No problem. I didn't realize that. I will fix it. I will write things with my hand as we go along. Not an issue. Right. How are we on the audio and the video check, guys? How's the audio? How's the video? Somebody please confirm. Can you hear me and see me? Once you confirm audio and video, I will like to start, please. All right, the audio video is good. We are starting. We are live and we're going to talk about psychiatry in the next couple of hours. We'll cover as much as we can, as fast as we can, as extensively as we should, and we are all going to try to get complete full marks in psychiatry. Okay. All right. Thank you, Dr. Dasari. Let's get started. Okay. So, ignore the black parts. That's because वो green text के ऊपर text लिखा हुआ है, तो वो green screen के सामने black हो गया है. I'll write the topic for you. The first topic is delusions. What is a delusion? Hi, Dr. Irtika. Please keep answering in the chat. I'm with you here in the chat. I'd like to hear from you. False unshakable belief. Good job, Dr. Irtika. Can we make it a little bit more? False, firm, fixed, unshakable belief, even in the face of irrefutable or undeniable truth. Despite the evidence to the contrary, still the person holds that belief. Lovely. What is the most common delusion? What is the most common delusion that there exists? Most common delusion, please. Take a wild guess. If you don't know, no problem. What is the most common delusion? Most common delusion, guys. I will wait for some time for some of you to answer because I'm hoping with the exam being so close, you all know. Delusion of persecution. Dr. Ritika Vani has read a lot of psychiatry. Great. Delusion of persecution. All right. Delusion of persecution means the fear that somebody will harm me or kill me. Okay. What is Othello syndrome, guys? What is Othello syndrome? What kind of delusion is Othello syndrome? What kind of delusion is Othello syndrome? What happens in Othello syndrome? Who would like to try? Other than Dr. Irtika. Irtika, aapko aata hai. I'm very happy. But you can answer also. No problem. What is Othello syndrome? Othello syndrome. Okay. If nobody's answering, I'd like Dr. Irtika to please try. It's great if you know it. It's okay. Otherwise, we're learning. What is Othello syndrome? Othello comes from a Shakespearean play. Shakespeare had written a play in which there was a character named Othello, and hence the term Othello syndrome. Does anybody know what is Othello syndrome? Othello syndrome, going once, going twice. Anybody else? Well, if you don't know, then guys, even I don't know. Try at least. Galat hone do. Doesn't matter. Give it a try. Delusion that partner is cheating. Delusion of infidelity means that they are convinced that the partner is cheating on them. Just yesterday I saw a case of Othello syndrome. How do we know? Well, number one, everything that the person is presenting as the possibility of the partner cheating is not even possible, like as a normal human being, not possible. Hence, we know that those are delusions, and also the partner concurs that they're not, and other features as well. Okay. Now, there are two things called Capgras syndrome and Frigoli, and people often tend to get confused. The core of the matter in both of them is that you feel somebody is replaced by somebody. Can you tell me who is replaced by whom in only Frigoli syndrome, guys? Only Frigoli. We'll start with Frigoli. Dash is replaced by dash person. Just Frigoli. Tell me only Frigoli. Close person, Capgras. Far person replaced by... So Frigoli has got a very interesting background. Frigoli was this magician, Behrupia, who could change his disguise very, very fast. So as a result, Frigoli syndrome comes from the fact that you feel like so many people are the same person because they've quickly changed their clothes and become somebody else, right? Frigoli, the stranger is replaced by familiar. So random strangers. So I like to say far person or stranger is replaced by the same person. They're typically the same person who's somebody familiar to us, right? And in Capgras, the close person, like my parent, is replaced by stranger. Okay? एक याद रखना है, उससे दूसरा करना है, right? Stranger is replaced by known. Okay? So, far person is replaced by close person, and in Capgras, close person is replaced by stranger. All right. Next, what is delusion of love? Also called. Now, clearly, delusion of love means that you are in love with somebody who is not in love with you. You are in love with somebody who is not in love with you. You are in love. You are in love with a person that is not in love with you. What is the syndrome called? Ma'am, give example. So in Frigoli, it's basically the same person, like I told you. Behrupia. Somebody who can change clothes very fast, but is the same person. So I am your psychiatry teacher, but today all of your lectures are being held by me only by changing my disguise. So I'll change my face and my clothes very quickly and I'll appear to be somebody else. But in reality, I am Dr. Era only. That is Frigoli syndrome. समझ गए? अब इसका opposite हो गया Capgras. Capgras is कि मेरे घर में मेरे जो मम्मी पापा है ना, वो मेरे मम्मी पापा नहीं है, कोई और है. They're somebody else. Okay. Next, I want to come to delusion of love, also called, see, just like there was Othello syndrome, which was delusion of infidelity. We have a name for delusion of love also. We have a terminology of the delusion and we also have a syndrome. Who can tell me the name of delusion of love? Not personification. Try again. Eroto. Anybody wants to try? No, not Magnon. Magnon is when there are bugs under your skin. D. Clarenbaud syndrome. in which there is erotomania. Pyar hona pagal ki tarah. Eroto means love, eros means love, mania means like to be completely obsessed with that person. Typically happens with a person of higher stature. Higher stature. अपने से ऊपर, मतलब मुझे शाहरुख खान से हो जाना, ओके, और मुझे लगना कि वो भी मुझसे करता है. Delusion of parasitic infestation, meaning I feel there's bugs under my skin, is called which syndrome? Which syndrome? Yes, erotomania, right, Dr. Shom Shubhra, that right, Dr. Vani. Can you tell me what is delusion of parasitic infection called? Magnan syndrome, also Ekbom syndrome. Ekbom syndrome and Magnan syndrome both are correct. Interchangeably नहीं use कर सकते हैं, but both are correct. All right. Delusion of grandiosity or grandeur are of the following kinds. Either it could be delusion of grandiose identity or grandiose ability. Where is delusion of grandeur seen, guys? Where is delusion of grandiosity seen? Whether it is identity. I am the Prime Minister of India. My name is Dr. Era and I am the Prime Minister of India. In fact, I am the President of US. That is identity. Ability is I have so much power that if I call up the President of USA, he will take the decisions on the government policies as per my demand. I have so much influence on him. That is grandiose ability. Okay. So it is seen in bipolar disorder, particularly in mania. Good. Great, guys. Thank you. You guys are doing a great job in staying up. And next, we are going to ask you what are first rank symptoms? Very important. Seen in schizophrenia. Can somebody tell me how many? And can somebody just tell me the first rank symptoms? I've given you the cheat code on the screen. हेडलाइन टाइटल्स मैंने दिए हुए हैं. First rank symptoms of schizophrenia, please. First rank symptoms of schizophrenia. Yes, Schneider, 11. Very good. What are they? There are 11 of them. Can someone please tell me the first rank symptoms? Three, 6, 9, 10, 11. Thought echo. Okay. सारे बताओ. कोई तो पहले सारे बताओ. एक साथ सारे चाहिए मुझको. Commentary on thought. Those are voices commenting. Those are voices commenting. थोड़ा सा अलग है. आप जो बोल रहे हैं उसका मिक्स कर दिया आपने. Auditory hallucinations. Okay, those are voices. What kind of auditory hallucinations are these? What kind of auditory hallucinations are these? Okay, okay. So what kind of auditory hallucination? Auditory, primary, secondary? I don't know what you mean by that. What I am looking for. Okay, we'll wait for some more people to answer. And then I think आप दो चीज में confuse हो रहे हैं, but okay, no problem. चलिए. I'll explain each one. Okay. So, all right, let me explain, guys. Simple. Voices में 3 चीजें हैं, made acts में made में 3 चीजें हैं, thoughts में 3 चीजें हैं, somatic एक है, that is somatic passivity, and delusional perception एक है. ठीक है? तो 3 6 3 plus 3 6 plus 3 9 plus 10 1 11 11 हो गए. Got it? Now let me explain. Voices commenting मेरे बारे में बात कर रहे हैं, मेरे बारे में डिस्कस कर रहे हैं थर्ड पर्सन में. मतलब देखो वो ना अपने पेन से लिख रहा है, देखा कैसे कैसे बातें करता है. So these are auditory hallucinations. These are auditory hallucinations. So these are voices commenting, voices discussing on the patient's behavior. Okay. Next is made. Made मतलब मुझसे करवा दिया. They made me do it. Act और volition मुझसे काम करवा दिया. Impulse कुछ आया मन में और मैंने कर बैठा. And they're making me think in a certain way. Okay. Thought insertion means किसी ने मेरे माइंड में ऐसा ख्याल डाल दिया जो मेरा तो ख्याल है ही नहीं. This is not my thought. Somebody put it in my head. Thought withdrawal मेरे माइंड में कुछ आ रहा था, मैं बात करते करते एकदम भूल ही गई, वो बात मेरे दिमाग से निकल गई. Now that can happen as a slip to all of us. That is not schizophrenia symptom. In schizophrenia, you will see while talking, the patient will suddenly stop and you will ask क्या हुआ, and they will say somebody took my thought out of my head. Now third part they will say is they are broadcasting on the television. They are broadcasting on the television. Somatic passivity. Somatic means anything to do with your body. Passivity मतलब वो मुझसे कुछ भी हो रहा है. And delusional perception means assigning a delusional meaning to a normal thing. So डॉक्टर दत्ता ने ना ऐसे पेन दिखाया था, इसका मतलब वो मुझे थ्रेटन कर रही थी, पता है, मुझे समझा रही थी कि बस समझ लो तुम, मैं आ रही हूँ तुम्हारे घर पे, I'll expose you. Now that I lost your chat, guys. 1 second. That is delusional perception, assigning a delusional meaning to a normal thing. Okay? समझा सबको? Everybody thumbs up, thumbs up. I need some thumbs up. Somebody give a thumbs up, say 100%, say something that shows that you have understood the concept. Very important. All right, next we are going to talk. All right, thank you. A couple of you have said yes, samjha. Lovely, thank you guys. Next we are going to understand another very important part, which is essentially about the difference between hallucination and pseudo hallucination. Now hallucination क्या होती है? Hallucination होती है परसेप्शन में. परसेप्शन क्या होती है? हम 5 चीजों से परसीव करते हैं. Disorder of perception. How do we perceive? 5 sensory organs. So how we see, how we hear, how we eat, how we taste, how we feel, and how we see, how we hear, how we smell, how we taste, and how we feel. These are the 5 senses. Okay. Now remember, hallucinations are always in the objective space. Objective and subjective में ये फर्क होता है. Subjective होता है मेरा, subject का, और objective होता है कि आपका भी. तो I may say आवाज आ रही है कान में, because auditory hallucinations are the most common type of hallucination. Now I'll say yes, the voices were coming from outside. Where did I hear them? I heard them through my ears. No, I cannot stop them. I'm unable to control them. And yes, they are real. I'm sure somebody is talking ill about me. That is what is a hallucination, auditory kinds. Now versus pseudo hallucination. Pseudo hallucination is subjective, and I always say कि वो एकदम अंदर सुनाई दे रही होती है एक तरह से. मतलब आवाज कहाँ आ रही है? मेरे ब्रेन के अंदर आ रही है, कान के बाहर से नहीं आ रही है. Okay, and it is number 2, not perceived by a sensory modality. Another thing, when I ask people with pseudo hallucination to describe what they're experiencing, their description is not as clear and crisp and vivid as somebody with hallucinations. And if I say, can you stop it? To say, yeah, I can with some time like distract myself and completely stop it also. And they know that this is not true. They say, ऐसा मुझे लग रहा है. So they know there's a kind of, I know doctor, it sounds kind of strange, but this is happening to me. This is what they will say. Good, Dr. Ajay. Yes, that is one of the right points. Okay, this is the difference between hallucination and pseudo hallucination. Moving on, I want to know about neurotransmitters from you. We will pseudo hallucination is seen in even sleep deprived people, even very stressed people can have it, extremely anxious people can have it, sometimes after the drug use also you can have it. Pseudo hallucination is present in many situations, but they're also far more in under control like we discussed, and less distressing than hallucinations. Okay, so neurotransmitters. Now, can somebody name 4 or 5 important neurotransmitters for me before we talk about each disease and which neurotransmitter goes up or goes down in which particular condition and in situation? First, name 4 5 common, name 2 3 common neurotransmitters in the brain. 2 3 common neurotransmitters. Dopamine, great. Next. Serotonin. Anything else? Acetylcholine. Anything else? Serotonin, trypsin. Anything else? Anything else? Norepinephrine. Acetylcholine. Anything else? Has anybody heard of GABA? Has anybody heard of GABA? Gamma acetyl butyric acid. GABA. Have you heard of GABA? Glycine. Very good. Glutamate. Good. Good. Great, guys. Excellent batch, I must say. The few guys who have logged in today, smart, very smart. Very happy with the funds of knowledge. But yeah. Okay. In schizophrenia, which neurotransmitter is excessive and increased? Good, good. All the answers are correct so far. In schizophrenia, which neurotransmitter is increased? Okay. Anything that happens to serotonin in schizophrenia as per you? ये थोड़ा पीजी लेवल है. डोपामिन इंक्रीज होता है, you're absolutely right. सेरोटोनिन को क्या होता है स्किज़ोफ्रेनिया में? If you know, great. If you don't know, problem. If you know, no problem. If you don't know, no problem. सेरोटोनिन को क्या होता है? सेरोटोनिन टिपिकली बढ़ता नहीं है, डिस्टेबलाइज होता है. ओके, ऑलराइट. डिक्रीज होता है. यस, दैट्स राइट. थोड़ा डिक्रीज होता है. राइट. नो, सेरोटोनिन इज नॉट इंक्रीज्ड. ऑलराइट. Now, first generation antipsychotics work on what? On what receptor and what do they do? And second generation antipsychotics do what? What do they do and where do they work? First generation, tell me for a first generation antipsychotic. Then tell me for second generation antipsychotic. D2 receptor, fantastic. First generation antipsychotic works on D2 receptors mainly, and hence they decrease the dopamine. All right, D2 blockers, very good. What about second generation? First are D2 blockers, very good, absolutely right. It's fantastic. 4 5 6 7 जितने भी लोग लॉग्ड इन है, मजा आ रहा है, बहुत अच्छा लग रहा है. ये FMG बैच कि ये 5-7 बच्चे बहुत सॉलिड कर रहे हैं, आई मस्ट से. सो 5HT2A में क्या कर रहे हैं? पहली बात, एक बात बताओ, आप किसका आंसर दे रहे हो डॉक्टर दास? D2 एंड 5HT2, ये किसका आंसर दे रहे हो? Please write. I don't know what you're giving the answer for. What are you giving the answer for? Serotonin, second. Okay, second generation mein, you're saying that it does work on D2, it also works on D4, and it works on 5-HT2A. Very good, fantastic. तो क्या करता है? डोपामिन को कम करता है और सेरोटोनिन को बढ़ाता है, राइट? स्टेबलाइज करता है. ऑल राइट. Fantastic, guys. Fantastic. Very nice. Very nice. डिप्रेशन में कौन सा न्यूरोट्रांसमीटर कम हो जाता है? डिप्रेशन में कौन सा न्यूरोट्रांसमीटर डिक्रीज हो जाता है? Let me type. Depression, which neurotransmitter is decreased? In depression, which neurotransmitter is decreased? Hi, good afternoon for those who are coming in. Sorry, we started the session a little bit earlier. So, अभी तक हमने ज़्यादा कुछ नहीं कवर किया है guys. अभी तक हमने delusions के बारे में बात किया है. आप लोग delusion वाला पार्ट रिवाइंड करके बाद में ज़रूर देख लेना. हमने first rank symptoms के बारे में बात किया है. We discussed about differences between hallucinations and pseudo hallucinations. And अब हम neurotransmitters के बारे में बात कर रहे हैं. तो you haven't missed out too much. अभी बहुत बहुत पढ़ाई बाकी है. ओके, सो मेरा क्वेश्चन था कि कहाँ गया मेरा क्वेश्चन? डिप्रेशन, इन डिप्रेशन व्हिच न्यूरोट्रांसमीटर इज डिक्रीज्ड? somebody said serotonin, somebody said ACH decrease, somebody said dopa decrease, ACH increase, somebody said dopamine, serotonin, dopamine. Okay, let's keep it simple. Serotonin is considered to be decreased in depression. That's one of the theories, of course. So remember, serotonin is to depression. Which neurotransmitter is notorious in anxiety? Norepinephrine भी decrease होता है. You are right. Your answer is not wrong at all. Now I want to know anxiety. Anxiety में क्या चीज increase होती है? किस चीज की, किस न्यूरोट्रांसमीटर की एक्टिविटी बढ़ गई? गाबा. कहते ना एड्रेनलिन बहुत ज्यादा बढ़ गया, बहुत बढ़ गया, राइट? 5-HT is increase in anxiety. Serotonin does not increase in anxiety. On the contrary, serotonin also tends to decrease in anxiety. We are looking for the answer GABA or norepinephrine. We are looking at the answer GABA or adrenaline, which increases excessively in anxiety. That's the GABA. GABA not and adrenaline and norepinephrine will be obviously proxy, is increased excessively in anxiety. ओके, ओसीडी में कौन से न्यूरोट्रांसमीटर्स इंक्लूड होते हैं? ओसीडी, ऑब्सेसिव कंपल्सिव डिसऑर्डर. विच न्यूरोट्रांसमीटर्स इज इंक्रीज्ड, डिक्रीज्ड? See again, you know, you can have multiple answers in all of these. You can have the involvement of even acetylcholine and the other things as well. I'm just looking for the most common ones. Okay. Serotonin is decreased, right? And in some people, GABA can also be increased. Okay. Alzheimer's dementia. Which neurotransmitter is decreased in Alzheimer's dementia? Which neurotransmitter is decreased in Alzheimer's dementia? Next question is up. अल्जाइमर्स में कौन सा न्यूरोट्रांसमीटर डिक्रीज होता है? ग्रेट, एसिटाइलकोलिन. ओके, पार्किंसंस डिजीज में कौन सा न्यूरोट्रांसमीटर डिक्रीज होता है? पार्किंसंस में कौन सा न्यूरोट्रांसमीटर डिक्रीज होता है? पार्किंसंस डिजीज में कौन सा न्यूरोट्रांसमीटर डिक्रीज होता है? पार्किंसंस में कौन सा न्यूरोट्रांसमीटर डिक्रीज होता है? डोपामिन। तभी हम लीवोडोपा देते हैं ना। तो नोटिस, जब हम स्किज़ोफ्रेनिया जैसे डिजीज में जिसमें डोपामिन बहुत बढ़ जाता है एंड वी गिव देम फर्स्ट जनरेशन एंड सेकंड जनरेशन एंटीसाइकोटिक्स, समटाइम्स द पेशेंट कैन डेवलप Parkinsonian features secondary to the use of antipsychotics, because the dopamine which was very high has decreased too much, and that is why the motor issues begin. Good. Levodopa is the drug of choice. In ADHD, which neurotransmitter is dysregulated or less? ADHD. Yes. First generation antipsychotic side effect. Lovely. In ADHD, which antipsychotic is dysregulated or lesser? Which antipsychotic is lesser? ADHD. It is proposed that in ADHD, which antipsychotic is dysregulated or lesser? Main. We're talking about the main ones here, guys. अगर मैं डिटेल्स में जाऊँ पीजी लेवल तो ओसीडी में तो इतने और इन्वॉल्वमेंट है, बट आई एम टॉकिंग अबाउट द बेसिक वंस. ADHD, which neurotransmitter is dysregulated or lesser? नहीं, डोपामिन डिसरेगुलेशन होती है. अगेन द ब्रेन इज प्रोड्यूसिंग not enough dopamine, and again the dopamine is not so low as Parkinson's. Remember, this is a different kind of dysregulation. ठीक है? All right, dopamine. Let's shift. All okay till now? All okay till now? Because now we're going to shift our focus on therapies, various kind of therapy. All okay? सबको समझ रहा है? Yes, no, maybe, yes, no, maybe, yes, no, maybe, all okay? Okay, great. Now we're going to talk about some therapies. For example, I've written the first one for you. Sensate focus is a type of therapy used in Masters in Johnson sex therapy. Which SNRI is used in ADHD? Good question. Okay, sorry, let me just go back. All right, this is a PYQ, which So what is the drug of choice for ADHD? First, tell me the drug of choice. I have a drug of choice column later, but okay. What is the drug of choice for ADHD? Drug of choice for ADHD is drug of choice for ADHD first. Drug of choice for ADHD. Dr. Das, you've asked a good question. SNRI can be used in ADHD. You are right. Your answer is not wrong. Like I'm constantly saying, I'm talking about the most common one. Norepinephrine regulate karega SNRI. I completely get where you're coming from. Serotonin bhi to karega. But I was talking about the most common ones. First wala. Okay. So drug of choice is methylphenidate. Correct? Now, this is a stimulant. Then we have non-stimulant. Amphetamine, methylphenidate, these are stimulants. Then we have non-stimulants, right? And we can use SNRI also as a drug of choice, but weak in line. So, for example, SNRIs के नाम कौन बताएगा? पहले मुझे SNRI के नाम बताओ. कोई SNRI के नाम बता सकता है? Name some SNRIs. 1 second, I'll try to add one sheet, okay guys? बहुत cluttered हो रहा है. Atomoxetine. Acha. Now I asked you SNRIs के नाम. No guys, fluoxetine is not an SNRI. So the answer is correct. Duloxetine, reboxetine, atomoxetine, desvenlafaxine, and venlafaxine. Okay, fluoxetine is not. Oh, I know it sounds like the same bhai behan, but it is not. Okay, so if you are asked an SNRI used for the treatment of ADHD, if atomoxetine is there, choose that. If that is not there, choose reboxetine. So reboxetine is also a good answer. Atomoxetine is the main answer, and duloxetine can also be written if the SNRI is there, depending on what options are there. Understood? Understood, guys? Okay, great. Let's move on, right? So as I was telling you, I would like everybody to try something here. What we are going for is that I will be sharing the name of a therapy. For example, here I've shared about sensate focus. Sensate focus is a therapy used in Masters and Johnson's sex therapy, where there is a stepwise approach. So somebody who comes with sexual issues, partners are taught in sex therapy how to de-escalate. So basically start from the start. I call it start from the start, meaning they are not allowed penetrative sex. They are told to actually have the basic steps of intimacy first. Now, every time I will name a therapy, I want you all to tell me 2-3 key things about that therapy. ओके सो ऐसे करके हम हर थेरेपी के बारे में थोड़ा थोड़ा डिस्कस कर रहे हैं, की पॉइंट्स डिस्कस कर रहे हैं रिवीजन में. ऑलराइट, नेक्स्ट आई वांट टू नो व्हाट इज बायोफीडबैक थेरेपी, वेयर इज इट यूज्ड, व्हेन इज इट यूज्ड, व्हाट इज इट, what is it and where is it used? What is it and where is it used? Biofeedback. What is biofeedback? No, not PTSD is one, not a great use, but okay, can be used. What is it, first of all? In biofeedback, the feedback of the various physiological responses to real or imagined scenarios is measured. What are these? So your sweating is measured, your heart rate is, that's a heart, okay, it's a very bad heart, that's heart rate. अच्छे से बना दूंगी. BP, pupils, etc. So in this you will be essentially shown something and then your reaction to it is being measured. So its excellent use is in phobias. Because for example, if I'm afraid of flying, so they can be a complete biofeedback. So aajkal, have you seen those big VR goggles? We used to use those, like now we use those. Earlier it used to be different. So you can use those big VR goggles if somebody has height phobia to look around and then kind of overcome the height phobia. Okay. So used in various anxiety disorders, can be used in PTSD, but phobias mainly. Okay. All right. Next question. What is CBT? Full form of CBT. Where is it used and what is it? CBT. Guys, दो 3 पॉइंट्स पढ़ेंगे हर चीज के बारे में, क्योंकि MCQ बनेगा तो इधर से ही बनेगा. बहुत डेप्थ तक जाने के लिए रिवीजन के टाइम पे इसलिए जरूरी नहीं होती है, बिकॉज अब आप होपफुली 1-2 बारी पढ़ चुके हैं तो आप सरफेस स्किमिंग करते हैं, राइट. CBT एक्सपोजर नहीं गाइस, CBT. व्हाट इज CBT? आप 4th पे चले गए इर्तिका, आप ER पे चले गए, मैं CBT पूछ रही हूँ. आई एम आस्किंग व्हाट इज CBT. Cognitive behavior therapy. Where is it used? Various uses. It's used in depression, can be used in anxiety, can be used in some phobias, can be used in even substance for some people, various uses. The triad is thinking, feeling, and behavior. TFB. How we think affects our feelings, affects our behavior. Yes, it can be used in OCD. However, there are better therapies for OCD. That is why I did not write it. There are better therapies for OCD. It can be used, but better therapies are out there. What is ERP? ERP. First line is in depression and anxiety, all kinds of anxiety disorders. What is ERP? ERP. ERP. What is ERP? कोई पहले बता रहा था. Exposure. Where is it used? Used in OCD. Okay, it is used in OCD, but it has poor outcome in hoarding disorder of OCD. It has OCD subtype of hoarding disorder. होर्डिंग डिसऑर्डर, इस वाले में इसकी पुअर आउटकम होता है. ठीक है, ये याद रखना. ग्रेट गाइस, वी आर ऑन अ वेरी गुड ट्रैक सो फार. नेक्स्ट, नंबर 5. व्हाट इज सिस्टमैटिक desensitization? Systematic desensitization. What is systematic desensitization? All understood so far? All understood so far? Any questions? If I'm going too fast, slow me down, no problem. Okay, next question is, what is systematic desensitization and where is it used? Systematic exposure to fear. Yes. So least to most fearful idea or place, graded exposure plus relaxation. Where is it used? Gradual decrease in fear by exposing to it. धीरे धीरे करके बढ़ा. Phobias is the best placed. Best places in phobias. Even in anxiety, most other anxieties also helps, but phobia is the main place. ठीक है? For example, if I have, let's say, fear of flying, which after the AI incidents, a lot of people have again developed or have developed. So you will be graded, not directly flight पे चढ़ा दिया, कैसे धीरे 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 उसको इमेजिन करना है, इमेजरी करना है, फिर धीरे धीरे करके उसको एक बार एयरपोर्ट के बाहर तक जाना है, एयरप्लेन उड़ते हुए देखना है, मूवीज देख, उसके साथ की वीडियोस देख सकते हैं. दैट इज कॉल्ड systematic desensitization. बढ़िया. Milieu therapy is used in schizophrenia where therapeutic community or family is used. So milieu means like बहुत सारे लोग मिला के, that is a milieu, and they are also taught how to deal with the patient. What is the full form of JPMR? It is a auto-hypnosis form in which you slowly, stepwise, gradedly, progressively relax your muscles one by one. What is the full form? JPMR का full form? Type of psychotherapy used to structured and supportive environments. Yeah, that is milieu. Now JPMR का full form कौन बताएगा? J is Jacobson's, P is progressive, क्योंकि एक के बाद एक हो रहा है, progressive, muscular relaxation. That is JPMR. Okay. Again, it is used like you will teach one muscle, two muscle, alag muscles ka. It is used in any form of anxiety. Okay. Jacobson's progressive muscular relaxation. Yes. What is stop squeeze technique used for? What is stop squeeze technique used for? Stop and squeeze. What are you squeezing? Premature ejaculation. When there is a difficulty where the person, not erectile dysfunction guys, एक difference समझ लो, premature ejaculation और erectile dysfunction दो अलग-अलग phases of sex की problems हैं. They're disorders of different stages. Erectile dysfunction means difficulty in achieving erection. Premature ejaculation means that one can have both. I'm not dismissing that. But premature ejaculation means that the erection has been achieved, but the ejaculation or the orgasmic, it's a disorder of orgasmic phase where the ejaculation happens earlier than what is considered average. Okay. So the answer for stop squeeze technique or Siemens technique is premature ejaculation, not erectile dysfunction. Okay. All right. And what is squeeze? The coronal ridge of the penis. All right. Understood? Difference samjha? Say 100% if the difference is understood. Difference understood, guys? Exposure therapy for anxiety phobia, kind of aversion. Okay. Right. Exposure response prevention is for OCD mainly, and anxiety becomes a part of it. Yes. Okay. All right. Next, depression symptom के criteria कौन बताएगा मुझको? Duration कौन बताएगा मुझको? Criteria means symptoms. Okay. That how many do we? Criteria means that how many do we need? Tell me the symptoms of depression, please. Symptoms and duration of depression. Symptoms and duration of depression. I want to know from you all. Hopelessness, helplessness, hopelessness, worthlessness, helplessness. 6 month criteria. Hey भगवान, 6 month wait करूंगी तब तो patient मेरा बेचारा बहुत ही डिस्ट्रेस में आ जाएगा guys. 2 weeks. 6 months is for anxiety disorders. Okay. 2 साल नहीं गाइस, मेरा पेशेंट तो 6 मंथ नहीं सह पाएगा तो 2 साल कैसे सहेगा? 2 साल मत वेट कराओ मेरे पेशेंट को. 2 महीने भी वेट मत कराओ मेरे पेशेंट को. 2 हफ्ते वेट कराओ. ठीक है. क्राइटेरिया तो बताओ. ये होपलेस, वर्थलेस, हेल्पलेस एरन बेक बोला होगा, बट व्हाट आई एम लुकिंग फॉर इज द एक्चुअल आईसीडी क्राइटेरिया. ICD DSM criteria, please. Schizo? What schizo? No. Guys, tell me this thing. Low mood or sad mood, right? for most of the time, if not all the time. Loss of interest and pleasure in previously pleasurable activity. Fatigue or tiredness despite adequate rest. Sadness, okay, decrease sleep either too much or too little. Appetite either too much or too little. Anhedonia means lack of pleasure. Anhedonia. Psychomotor changes. The psychomotor changes could be retardation or agitation. Psychomotor means, psycho means दिमाग कैसे चल रहा है, motor means मैं बाहर से कैसे दिख रही हूँ. Concentration issues, unnecessary guilt, unnecessary excessive guilt, and suicidal ideation. कुछ रह गया? कुछ रह गया? Feeling of hopelessness, worthlessness are there, of course, that's true. We usually combine it with the guilt part only. Okay? 2 weeks, guys. 2 weeks. All right? Okay. Now we are coming to the drugs. Drugs of choice. Drug of choice. Now we are coming to the psychopharmacology. Very important. Psychopharmacology is very important. Let's talk about the various drugs of choice. I've written concentration, Dr. Trawat. Thank you for reminding me. Let's talk about the drug of choice. The drug of choice. What is the drug of choice in depression or major? I like to call it major depressive disorder and not just depression. What is the drug of choice in major depressive disorder? Perfect, Dr. Rawat. SSRIs. Okay, what is another group of drugs that we can use in depression? Can you tell me a second line drug for SSRI? Everybody correct. SSRIs, SSRI. Who will name some SSRIs? Name some SSRIs. Name some SSRIs. Please name some SSRIs. Name some SSRIs. Name some SSRIs and tell me the second line drugs for group drug choice for depression or major depressive disorder. Second line drug. ADHD ka already done. Okay, we are now naming some antidepressants, SSRIs. Fluoxetine, sertraline, escitalopram, sertraline, paroxetine. Very nice. And the second line drugs people have said are SNRIs, MAO inhibitors, TCAs. Correct? There's also NDRIs, and there's also nowadays newer drugs. Spari. There are many other drugs, but I want SNRI as one of the main answers. So good answer, guys. Good answer. Good. Okay, now SSRIs are, let me write in a different pen. Okay, all right. Great job, guys. ADHD हमने already कर दिया, तो मैंने आप लोगों के लिए भर दिया. Nocturnal enuresis. What is the drug of choice for nocturnal enuresis? Very good batch, I must say. I've had a few batches and I feel y'all are like smashing it out the park, guys. बहुत मजा आ रहा है. आप लोग बहुत solid कर रहे हैं. Please tell me, what do you think is the drug of choice for nocturnal enuresis? Drug of choice for nocturnal enuresis. First line and second line. चलो कोई भी एक भी बता दो. That's good enough. No. Guys, I'm just gonna close my curtains and put on one light. So answer both for me. Till then, answer OCD. OCD drugs also. Just switching on my lights. I'm going to switch on my lights. Okay, guys? Don't worry, I'm reading your answer. थोड़ा अंधेरा होगा उसके बाद फिर एकदम से ठीक हो जाएगा. Guys, I'm right here. Keep answering. One second, guys. Just want to. Okay, I hope I'm visible now. Yes, it's much better. All right, so where are we? All right, desmopressin is correct. Imipramine is second line. OCD, fluoxetine, correct. And any other drug in OCD? Okay, can you name one TCA which is used in the treatment of OCD as a second line drug? A TCA which is used in OCD as a second line drug. TCA which is used in OCD as a second line drug. If you know, great. If you don't, no problem. Second line drug. Behavioral therapy is the treatment of choice. That's right. Amitriptyline, no guys. Clomipramine is a drug used. So SSRI is the main group. In that, fluoxetine is also one of the main ones. Next is fluvoxamine. And if you have to go towards TCAs, then it's clomipramine. Okay. And we can also add on something called, again, not important. I think I'll confuse you all. Let me not add on. Okay. All right, guys. Clomipramine. Good. Next, drug of choice. What would you prefer to give? 4, 5. What would you prefer to give in the case of panic attacks? What would you like to give in the case of panic attacks? Treatment क्या देना चाहेंगे? What would you like to give if the patient is having panic attacks? Benzodiazepine. Okay. And actually, you would like to give them some reassurance. Okay. And this is immediate relief. And for longer treatment, you will give. Absolutely right. This is a fantastic batch, I must say. क्या बात है. बहुत अच्छा batch है. बहुत सही आंसर दे रहे हैं. So benzodiazepine is given as an immediate treatment relief in the case of panic attacks. But for longer period, we give SSRIs. Also, reassurance is given then and there that the patient is fine, they're not having a heart attack. But CBT is encouraged as a treatment of choice for long term. Badhiya. Alcohol withdrawal. I do have a separate section for this. Okay, so let's not talk about this. आगे बढ़ लेंगे, ठीक है? Alcohol को मत करो आंसर. ये भी I have a separate section. ठीक है? चलो ये बता दो. Why don't you tell me what are the drugs used for reducing craving of alcohol? Start with this. What drugs are used for reducing alcohol craving? Drug of choice नहीं है इसमें. No drug of choice, but what are the various groups of what are the various molecules that are given for reducing alcohol craving after stopping alcohol? Acamprosate, not bupropion. इथाइल अल्कोहल पिला दोगे तुम मेरे पेशेंट को? अरे उसकी अल्कोहल क्रेविंग कम करनी है. So acamprosate, naltrexone. Anything else? No, no bupropion, no bupropion, no bupropion. Anything else? One more, one more, one more. Baclofen. Thiapride. No. Acamprosate, naltrexone, topiramate, baclofen, pregabalin. These are the ones used for reducing alcohol craving. What is used in opioid overdose? What is used in opioid overdose? Opioid overdose. OD. OD. Opioid OD. What is used in opioid overdose? Nal what? Shortcut answer Dr. Singh. Nal क्या होता है? Nal what? मैंने भी nal लिखा है आपके कहने पे. What is nal? Naltrexone. No, 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 no. Nal का दूसरा भाई. Naloxone. Naloxone is the shorter acting immediate one. Naltrexone is long acting. Naltrexone is not used in OD. Opioid abstinence maintenance. You can use naltrexone, buprenorphine, okay. Oh, sorry guys, one sec. Yeah. So remember, when the patient is coming with overdose, you give them naloxone for immediate and it is shorter acting. But naltrexone is longer acting. Let me move out of your way to show you the answer here. In opioid abstinence, you will give them naltrexone, buprenorphine or methadone. Okay? Remember this difference. थोड़ा speed पकड़ेंगे guys, वरना तो खत्म ही नहीं कर पाएंगे. Okay, we've already done the names. We've already done. Can you tell me the indications for SSRI? And can you tell me the common side effects for SSRI? Indications for SSRI. We are now on to SSRI. Guys, मैंने ये जानबूझ के ऐसे बनाया है कि बहुत सारे टॉपिक रिवाइज हो जाएंगे, पता है, क्योंकि हमको इतनी बुक चाटने की आदत हो जाती है ना, वो बुक भी खाने को पड़ती है. Oh my God, I've read this like 1,000 times. Correct? Yes or no? Yes or no? I agree, right? Same thing, same तरीके से पढ़ने से ना मुझे लगता है कि मेमोरी भी नहीं जॉग होती है. सेम चीज अलग अलग तरीके से पढ़ने से मेमोरी बहुत बेटर जॉग होती है. Do you agree with that point? That's why I'm doing this separately, right? So it is used in major depressive disorder. Okay, what else? Correct. What else? Active recall. Yes. Drowsiness. अरे साइड इफेक्ट पे पहुंच गए तुम सीधा. Anxiety disorders. We already discussed. जैसे कि पैनिक में भी इस्तेमाल होता है, OCD में भी इस्तेमाल होता है, फोबियाज में भी इस्तेमाल होता है, PTSD में भी इस्तेमाल होता है. Correct. Many indications of premature ejaculation में भी इस्तेमाल होता है, ED में नहीं. Side effects are number 1, yes, drowsiness. Number 2, Delayed ejaculation, yes. Hyponatremia, correct. Sedation, drowsiness, weight gain, nausea, vomiting, diarrhea, har jagah na? But that's true because excessive serotonin causes the diarrhea. Can cause insomnia in some people, correct. So see, it can cause both sedation and insomnia. And sexual side effects. These are the most common one. All right. Can be also used in eating disorder. All right. Next is NDRI. What is an NDRI? Which drug is NDRI? Full form of NDRI first. Full form of NDRI. What drug is NDRI? And tell me a few indications for NDRI and side effects of NDRI. Guys, I'm very proud of this entire cohort of 13-15 people who are participating. बहुत अच्छा आंसर दे रहे हो. I'm very impressed, I must say. I don't compliment unnecessarily. I compliment, but ये cohort बहुत सही है. Bupropion is an NDRI. बहुत मजा आ रहा है. Like, you all have really put in the effort. I'm very proud of each one of you. Norepinephrine, dopamine, uptake inhibitor, right? So it is used in, number one, wherever there is sexual side effect due to SSRI, you can use it. Also, it helps in increasing libido. Smoking, cessation. Did you know it is also a weak line drug for ADHD? Very weak line. Okay. Side effects. It can cause insomnia. It can decrease seizure threshold. क्या बात है, किसी ने ये भी लिखा है. ये मेरा favorite question है पूछना. It can increase seizure threshold. It can cause a fair bit of anxiety in the beginning for people. Very nice. Nice, Dr. Sharma. Absolutely right. Can be used in ADHD as a weak line drug, as a low on the card, but can be used. SNRI, नाम हमने काफी सारे कर लिए हैं. I think मैं लिख दूंगी. Why don't you tell me indications and side effect? Weight loss, if you want to write. Yeah, it doesn't. One more good is weight neutral. So we call it weight neutral. Okay. Acha. Now I want SNRI indication and side effect. बिकॉज नाम आप लोगों ने ऑलरेडी कर दिए थे, तो मैं आपको नाम मैं लिख दूंगी, आप लोग मुझे SNRI के साइड इफेक्ट, इंडिकेशन एंड साइड इफेक्ट बता दीजिए. Anxiety disorder. Panic disorder. What else? Somatic aches and pains. Okay, side effects are discontinuation syndrome is very common. One more side effect is hypertension can happen from venlafaxine. Drowsiness or sleep is very common side effect. Good, guys. Good. Insomnia से ज़्यादा इसमें sedation होता है, guys. I'll just move out of your way for you to see the pointers. Okay. Don't worry, notes तो आपको मिलने ही वाला, right? Hypertension होता है venlafaxine से commonly. Okay. All right. Next is number 1, 2, 3, 4, 5, 6. Who will tell me what is vanicline? Used for smoking cessation. And can you tell me which receptors does it act on? Which receptors does vanicline act on? Some smoking cessation, yes, but which receptor? Alpha 4, beta 2 partial agonist. Very nice, Dr. Das. Next is ketamine. Which drug is this used for? Other than psychiatry, where is it used? Indicated in psychiatry for good alpha 4 beta 2. ये फॉन्ट कैसे मिला तुमको अल्फा 4 बीटा 2 का डॉक्टर सिंह? मुझे कभी नहीं मिलता है. हाथ से लिख के तो कर सकते हैं. I never knew that you could actually write alpha 4 beta 2 with that actual Latin font. I always learn something in each of my class, I must say. All right, so ketamine is an anesthetic agent. So it is an NMDA receptor antagonist. It is mainly used for inducing anesthesia. Where is it used in psychiatry, guys? Where is it used in psychiatry? It's trick, ma'am. Oh, thank you. सिखाइएगा ये trick. It is used for major depressive disorder, especially very acutely suicidal patients. Very acutely suicidal patients. Also, there is something called Spravato, which is brand name, but the composition is S-ketamine, which is the intranasal very quick response ketamine. Spravato, S-ketamine. Okay. Next is my favorite, clozapine. Clozapine. बाइपोलर क्यों? बाइपोलर में तो नहीं इस्तेमाल होता है. Wow, I'm getting such cute emojis to comment here, guys. Wait, मैं एक comment करती हूँ. क्या? Clozapine में क्यों? बाइपोलर क्यों बोला? अच्छा. Cute emojis are here. Okay, I want clozapine. What is it? Where does it act? This section will keep for side effect, life-threatening, and other side effect. And we'll talk about indication. Okay, let's go. All right, it is a second generation antipsychotic. Absolutely correct. Where does it act? Dopa, D1, D4. Okay. Plus also on serotonin receptors, right? D2 and 5-HT2. Very good. It is a novel antipsychotic. Very less to no extrapyramidal reaction. Very less to no extrapyramidal reaction. So where is it indicated? In where is it indicated? Treatment resistant schizophrenia. Who will tell me what is treatment resistant schizophrenia? What is treatment resistant schizophrenia? What is TRS? What is treatment resistant schizophrenia? Come on. What is treatment resistant schizophrenia? What is treatment resistant? 2 antipsychotic failed, but one has to be. One has to be typical and one has to be atypical, right? So second generation and first generation दोनों में से एक first generation जरूर try किया हुआ होना चाहिए. Now you can also use clozapine when there is extrapyramidal reaction due to some other antipsychotics. The side effects, life-threatening one are agranulocytosis, myocarditis, and has somebody written the third one? What is the third life? Yeah, haloperidol की वजह से हो सकता है. Correct. Haloperidol is the most commonly tried one, but you can try something else also. Can you tell me what is the third life-threatening side effect? Agranulocytosis, myocarditis, and yes, halo is first generation. Correct. So the side effects like sedation, dyslipidemia, weight gain, diabetes mellitus, and wet pillow syndrome or siloria. Everybody is mentioned. What is the third? Janleva, guys. Siloria is not janleva. Not gonna die because of your pillow being wet. Agranulocytosis, myocarditis, and let me see if somebody's written up. Seizures. Great. Dr. Kushagra Singh. No, Harsh Rawat. Seizures. Correct. Okay. Oh, ये तो हमने कर लिया है. First generation and second generation antipsychotics हमने पढ़ लिए हैं. Already done. Can you name some mood stabilizers? Name some uses. Good. Metabolic dysfunction वगैरह मैंने लिखा है guys. वो ना मेरे पीछे लिखा हुआ है. मैं हट के दिखाती हूँ आपको एक बारी. I've written everything for you. दिख रहा है सबको? Are we on the same page so far? Are we on the same page? All okay? All okay so far? Give me a thumbs up if all okay. Give me a emoji. Give me a heads up. Tell me आता है सबको अभी तक सब कुछ समझ. Class till when? विदुषी जी. अभी तो हमारी नैया आधी पार हुई है. आधा और पार करेंगे. If you are okay with it. Would you like to? Are you comfortable? जल्दी बढ़ाना मैं जल्दी बढ़ा सकती हूँ, बट अच्छे से बढ़ाना मेरे को ज़्यादा अच्छा लगता है. ठीक है? All right. We are right now on the mood stabilizers. मैं ना साथ साथ notes सेव करती रहती हूँ. What does happen is that sometimes my notes get lost. Mood stabilizer, name some. Lithium, okay. Any other? Sodium valproate, okay. Any other? Class अच्छे से पढ़ाओ. अच्छे से पढ़ाऊंगी. आप ही पूछ रहे हो, जल्दी आपको है, मुझको नहीं. मैंने पढ़ाने के लिए यहाँ पे बैठी हूँ. What other are mood stabilizers, guys? Other mood stabilizers, name some, name some, name some. Other mood stabilizers, please. Name some more mood stabilizers. Name some mood stabilizers. इसके बाद तो अल्कोहल रिलेटेड पढ़ने वाले हैं. वो तो सबसे इम्पोर्टेंट और सबसे फेवरेट है मेरा. We still have to study alcohol. We still have to study postpartum, personality, some IBQs for y'all. बस अच्छा इंटरेस्टिंग रखेंगे. ठीक है? कार्बामेज़ेपिन, गुड. उसका भाई या उसकी बहन ऑक्स कार्बामेज़ेपिन. एक और लैमोट्रिजिन. बहुत बढ़िया. क्या सॉलिड क्राउड है. लैमोट्रिजिन. Olanzapine, QTPin can be used. Yes, I was hoping some second generation antipsychotics like olanzapine, QTPin can be used as mood stabilizers as well. Fantastic. Where do we use mood stabilizers? Name some places where we use mood stabilizers. Bipolar, mania, hypomania और कुछ? मूड स्विंग्स नहीं यार, मूड स्विंग्स के लिए मत दे देना. Bipolar affective disorder, schizoaffective disorder. We can also use in certain impulse control disorders. Suicidality, bipolar depression. Okay. All right. Very quickly doing a little bit of lithium. वो जगह को मैं यूज करना चाहती हूँ. लिथियम ब्लड टेस्ट कब किया जाता है, उसका क्या नॉर्मल रेंज रहता है ब्लड में जब हम कहते हैं दैट द पर्सन इज ऑन गुड थेरेप्यूटिक डोज. Why is it contraindicated in pregnancy and it is excreted renally? Something I'm telling you. So lithium blood therapeutic levels, please. Who will tell me the therapeutic level of lithium in our blood, please? Okay, abstain. But can you tell me the blood therapeutic level, please? 0.8 to 1. डॉक्टर चंदानी थोड़ा और सोचिए. डॉक्टर रावत फिर से सोचिए. मैं मेंटेनेंस डोज की बात कर रही हूँ. मेंटेनेंस. लेस देन 1.2. दैट्स वेरी वेग. दैट मीन्स अगर 0.1 रहेगा तो थेरेप्यूटिक रेंज में. 0.8 to 1.2. Right? More than 1.5 is toxicity. Toxicity if it is more than 1.5. Okay. And the blood test is done 12 hours after last dosage. Okay. 0.8 to 1.2. 0.8 to 1.2. 0.6 to 1.2 in some labs, especially in the acute phase. Maintenance phase में 0.8 to 1.2. Okay. All right, guys. Fantastic. Let's talk about alcohol. What is Mellanby effect? What is reverse tolerance? What is pathological intoxication? At what range of lithium do we need to do hemodialysis? More than 1.5, the patient will be in renal failure. Different alcohol level during consuming and after. थोड़ा सा और 2%. नहीं 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 डॉक्टर दास थोड़ा सा और बेटर डिफाइन करिए. ओके, अपवर्ड एंड डाउनवर्ड ग्राफ। ठीक है, बड़ा वेग आंसर दिया है आपने। So when the alcohol level is same, even though the level is same here and here, the person has more intoxication symptoms while the levels are going up than when going down, even though the blood alcohol level are the same. Okay, intoxicated and are more likely to overestimate their ability to drive. That's a good example. Okay, reverse tolerance क्या होता है? Reverse tolerance. अरे अच्छा example था, क्यों delete कर दिया? Reverse tolerance क्या होता है? It means sensitization. थोड़ी सी पी है बट बहुत चढ़ गई है because the liver enzymes are bad and the person may be having liver dysfunction, and that's why he gets drunk on sensitive to smaller doses, right? Tolerance means I need more and more and more and more. Reverse tolerance means even on lesser I can have the same effect or worse. Okay, next, pathological intoxication or pathological drunkenness. What is pathological intoxication or pathological drunkenness? Pathological intoxication or pathological drunkenness? Pathological intoxication, pathological drunkenness. Come on, guys. People who get drunk even on small amounts. A sudden onset of aggression, impulsive, violent behavior after ingesting small amount of alcohol because they do not lack they lack the enzyme to break it down. So they get very, 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 very high on a small dose. Okay. All right. This is my gift to you. A way to revise all the withdrawal features. All the withdrawal features. Very important. Very, very important. Alcohol is a very important topic. Yes, disproportionate reaction. Great. So far, are we together on the same page? After the alcohol topic, I would like to take a tiny little quick washroom break and come back. So let's finish the alcohol related all the questions and then we'll move on to the next. Are we together on the same page so far? Everybody सब समझ आ रहा है? कुछ भी चीज जो नहीं समझ आ रहा है प्लीज पूछो. नहीं समझ आ रहा है तो पूछ लो. Okay, great. Now remember that it is important to know the time frame. Why is it important to know the time frame? Because the questions, if they are clinical, will be formed based on the time frame. So if somebody's had their last drink at 12 p.m. today and they come to you around 6 to 7 p.m. today evening, they may, and they are a chronic alcohol user, meaning they've been drinking for many years and they suddenly stopped today at 12, meaning by night 7 8 p.m. their hands may start shaking, they may start sweating, they may start having tummy issues. This is called mild withdrawal. Withdrawal means when you suddenly stop or reduce the consumption of a substance that the body is dependent upon. Now let's say they come in the middle of the night or they come tomorrow afternoon. कल 12 बजे आपकी ओपीडी में आते हैं, 12 कल का नून आते हैं, tomorrow, one day. Now they may present with alcoholic hallucinosis, which means they're conscious, they're alert, but they may be having some hallucinations in clear consciousness, meaning they are not disoriented. They can still tell you how they got there, but they're saying अजीब अजीब सी feelings हो रही हैं, अजीब अजीब ऐसे लग रहा है, बॉडी में कुछ चल रहा है, ऐसा लग रहा है कान में कुछ आवाज आ रही है, right? So next is severe. Severe is after 1 to 2 days. 1 to 2 days. Thank you, Dr. Kushagra. Full power, ma'am. Yes. 1 to 2 days. Sorry, मैंने days 1 to 2 days. 1 to 2 days. एक दो दिन के बाद अगर वो पेशेंट आया, बोला डॉक्टर, उसके रिलेटिव कहते हैं पता है कितनी अच्छी बात है, इसने दारू पीना बंद कर दी, पर देखो इसको तो मिर्गी का दौरा लगने लगा. दिस पेशेंट started having generalized tonic-clonic seizures. That's because he is in severe withdrawal and these seizures come in clusters. One happens, after sometimes the patient gets better, again another comes, again another comes, which are called Rumfitz cluster seizures. Rumfitz because typically these patients may be drinking rum, maybe rum users. And finally is most severe, that is called DT, which is called delirium tremens. Tres means 3 in many language, teen, tres, treh. So again in many language we say tree, like that. And this happens about 3 days later after stopping alcohol, after a chronic user has stopped it suddenly, leading to delirium tremens. Delirium means disorientation to time, place and person, and tremens means having a lot of autonomic symptoms plus hallucinations, delusions to support the hallucinations. Okay, bugs crawling can be there, auditory hallucinations, visceral hallucinations, a lot of kind of hallucinations can be there. Who will tell me what is Wernicke's and what is Korsakoff? कौन मुझको difference बताएगा? Wernicke's, मैं ये इसलिए कमेंट में लिख रही हूँ हर चीज, इट्स इजियर टू देन ट्रैक कि हम क्या चीज के बारे में बात कर रहे हैं. वर्निकेज एंड गोवा तो चलेगा, सब बता दो गोवा में क्या होता है. गोवा में क्या होता है ये तो बताओ. ये हाथ धोने वाला इमोजी हो गया. B1 होता है गोवा में. What happens? Oh, your center is in Goa. Go Goa. But पहले बताओ गोवा का सिम्टम क्या होता है. गोवा का सिम्टम भी तो बता दो. लोड हो रहे हैं सबके आंसर. हाँ, ग्लोबल कंफ्यूजन. ओके, मैं देखना चाहती हूँ आप लोगों को आता है क्या. अगर आता है तो मैं मेहनत ही नहीं करने वाली. मेरे को लगता है आप सबको आता है. बॉस टेल मी, आता है क्या. थायमीन, ऑफ्थैल्मोप्लीजिया, कोर्साकॉफ इज क्रॉनिक, गुड. अटैक्सिया, ग्लोबल कंफ्यूजन. ओके, और कोर्साकॉफ में क्या होता है. गोवा तो हो गया, अब कोर्साकॉफ. प्लीज टेल मी कोर्साकॉफ इज वेल, इक्वली इम्पोर्टेंट. A question can be formed in either forms. Just because more frequent questions have been on Wernicke's, don't be fooled. It can be on Korsakoff. I think everybody knows. I'm very, very proud of this crowd. I told you all, and this is great. Now, what happens after the chronic use of alcohol? Suddenly, when the patient stops and is low on thiamine, there could be acute presentation in the form of Wernicke's, which is reversible, but if not treated properly, will progress to Korsakoff psychosis. Symptoms are confusion, global confusion, ophthalmoplegia, where sixth nerve, cranial nerve is involved, and ataxia. This is treated by giving thiamine immediately. Thiamine is given essentially IM. Okay, and the part of the brain on the MRI, when you do the MRI brain, which it shows that is affected, is the mammillary body. However, in Korsakoff, there is retrograde amnesia, anterograde amnesia, confabulation. Confabulation means making up stories about how did you come here. Oh, you know, I was in the market and then from the market somebody picked me up and they brought me here. That's not true, because I can't remember where I was before this. I have made up this story. This happens in chronic alcohol users, right? So that is going to be in Korsakoff. Here, both mammillary body and other parts of the brain are also affected, and you have to give oral thiamine up to long, like 1 year. Always give thiamine before giving glucose. Always give thiamine before glucose. Thiamine before glucose. Thiamine before glucose. Thiamine before glucose. Even if the patient's blood sugar level is super low. Okay, even if the patient's blood sugar level is super low, always give thiamine before glucose. Okay, all right. Everybody knows this. All right. Okay. What is antabuse? Antabuse and अच्छा दिख ही नहीं रहा आपको antabuse क्या है? Yes, we will still have to, even if patient comes with hypoglycemia, give thiamine first. Yes, yes, yes. That's exactly my point. If you don't give thiamine first, the patient will have more damage because what happens? Demyelination may happen. That is why you do have to give thiamine first, even if the BSL is low. Okay. Thiamine दो और तुरंत start कर दो ना. चिंता की बात नहीं है. Please tell me what is antabuse. Antabuse and antabuse. Yeah. What is antabuse? Yes, it's disulfiram. Lovely, guys. मैंने PG level पूछा तुम लोगों से. So, tell me. What is disulfiram? What does it do? How does it work? Yes, you are right, Dr. Rawat. Budding psychiatrist, I think. So, it is aversion therapy. Absolute. Oh, I'm so sorry. It is aversion therapy. Absolutely right. What does it do? It makes the person want to throw up, feel like they are having a heart attack, autonomous hyperarousal, right? Flushing, nausea. If they take alcohol on it, what should we avoid on it? Obviously, alcohol. What else? Other than alcohol, what should we avoid on it? I've clarified my question. Which enzyme is responsible? Aldehyde dehydrogenase inhibitor. What should we ask the patient to avoid? What food items should we ask the patient to avoid? What other items should we ask the patient to avoid? So we should ask the patient to avoid anything which has alcohol in it. Now, while obviously alcohol per se, we should ask them to avoid aftershave lotion should be avoided. Okay. Other than that, what should be avoided? Certain kind of cheese should be avoided. Yeah, those should also be avoided. All right. When will we use chloropropexazole? Are you sure you're writing the right thing? Do you mean chlordiazepoxide? Are you saying नहीं, टायरामिन रिच फूड होता है माओ इनहिबिटर्स के लिए. बट कुछ चीज जो होती है ना वो फर्मेंट होकर उसमें अल्कोहल बनता है, तो उसके अंदर हम डायसल्फाम में इस्तेमाल करते हैं. वो टायरामिन रिएक्शन होते हैं, वो टायरामिन रिच होते हैं. आफ्टर शेव लोशन में देयर इज अल्कोहल इन इट. उसमें कोई टायरामिन नहीं होता. आफ्टर शेव लोशन कोलोन जो जेंट लगाते हैं शेविंग के बाद, दैट आल्सो हैज अल्कोहल इन इट. Rice vinegar also has alcohol in it. So those are the also ones we avoid. Cough syrups, yes, good answer, good answer. So some cough syrups have alcohol bases in it. We should avoid. Certain ointments have alcohol base in it. We should avoid. Alcohol base. Good point. Okay. I think you mean chlordiazepoxide. Chlordiazepoxide is a benzodiazepine that is used in alcohol withdrawal. Okay. नो प्रॉब्लम, वी आर ऑल लर्निंग. मैं भी सीखती हूँ, आप भी सीखते हैं, हम सब साथ साथ सीख रहे हैं. ठीक है. सो जिसको नहीं याद था, दिस इज द फिगर, दिस इज द डायग्राम. लेट मी जस्ट हेल्प यू रिवाइज. एंटोब्यूस, it blocks an enzyme which is involved in processing alcohol. What is that enzyme? So basically aldehyde dehydrogenase which breaks down into acetate. जब नहीं होता है ब्रेक डाउन तो बहुत ज़्यादा बन जाता है बॉडी के अंदर एसिटाल्डिहाइड. जब एसिटाल्डिहाइड बहुत ज़्यादा बन जाता है तो बहुत ज़्यादा वॉमिटिंग, नॉजिया, अनईजीनेस, जो सिम्टम्स हमने डिस्कस किए वो हो जाते हैं. ओके, ऑलराइट, आर वी ऑल ऑन द सेम पेज सो फार? I'm going to take that tiny break that I requested earlier. I'm going to stop streaming for like about 3 minutes, 5 minutes max. 3 से ज़्यादा नहीं लगने चाहिए. Can we all boot in 3 minutes? Yeah. So just 2 to 3 minutes, guys. I'll be right back after a quick break. All right. और जो भी डाउट्स है प्लीज. हैंगओवर होता है बॉस, हैंगओवर का डेफिनेशन अलग होता है. तो हैंगओवर नहीं होता है, बहुत अनईजीनेस होता है. हैंगओवर के फीचर्स को एम्पलीफाई कर दो, लाइक दैट. ठीक है. ओके, आई एम स्टॉपिंग स्ट्रीमिंग फॉर अ बिट. आई विल बी बैक AS. Hi guys, I'm back. That was fast, wasn't it? So shall we continue? I'm back. आप लोग भी back हैं? Is everybody here? Everybody here? मैं 3 मिनट से पहले आ गई वापस, है ना? गड़बड़ कर दी मैंने. 2 लोग ही रह गए, सब भाग गए. Waiting for you all to come back, guys. No problem, I can wait. You all waited for me. Thank you. We are going to talk about eating disorders. We are going to talk about a couple of other important topics. Wait for some of you to come back. Okay, yes, more people are showing up. Lovely, guys. Okay, yes, we're going to talk about bulimia, anorexia nervosa, and binge eating disorder. Okay, let's let me ask you some questions. Test your knowledge. Active recall karte hain. And then I'll show you a cheat sheet. Which is the most common? Which is the most common out of these three? Which is the most common out of these three? Which is the most common? Which is the most common out of these three? Most common out of these three. Binge eating disorder. Correct. Most common. Absolutely. Now, which is more predominant in females out of these three? More common in females out of these three. More common in females out of these three. Anorexia nervosa. Females with professions like ballet dancers, who are, into acting, modeling. Okay. In which of these is there not any body image dissatisfaction? किस में body image dissatisfaction नहीं है कि हम जैसे दिखते हैं हमें तो वैसा दिखना ही नहीं है बिल्कुल भी. In which there is not body image dissatisfaction. डिससेटिस्फैक्शन कह रही हूँ, डिसमॉर्फिया नहीं कह रही, डिससेटिस्फैक्शन. In which one there is not severe body image dissatisfaction? No, binge eating. Okay. Okay. In which one binge eating में ना इंसान बहुत ज़्यादा खा लेता है, रिग्रेट करता है, बट अगेन उसको ये नहीं है कि यार मैं बहुत ही स्किनी होना चाहिए या आई शुड लुक अ सर्टेन वे. Anorexia and bulimia patients tend to see themselves much more different than what they really are. They have huge body image dissatisfaction. Okay. Okay. One more question. In which there is no binging. In which there is no purging. Purging means or using laxatives to take food out. Binge drink में, अरे बॉस वो अलग binge है, ये binge eating है. In which there is no purging. No purging. Yes, no purging. In which the periods can be affected. In which one can the periods? No purging is there in binge eating disorder. Binge eating में लोग बहुत ज़्यादा खाते हैं but they don't purge. Bulimia they purge. Anorexia bulimic type they purge. They can purge. There is restrictive type and there is purging type. Bulimic type. Okay. In which one? What was the question that I just asked? In which one can the periods be affected? Menstrual cycle be affected? Yes, menstrual cycle can be affected. Good. आता है तुम लोगों को काफी आता है. Not an issue. So let's just show you the way to remember. Okay. In anorexia nervosa, which is more common in females, there is an emphasis on caloric restriction. I don't want to eat. Why? By reducing the food intake and taking only foods which are voluminous. बहुत ज़्यादा पानी पी लेना, बहुत ज़्यादा सोडा पी लेना. Okay. There is a constant concern about nutrition facts, constantly label reading, right? And there's a fear of gaining weight. Oh, what if I gained weight? And you can go long periods of time without eating as well. Okay. Now, the BMI may be badly affected, less than 17.5 in severe cases. The menstrual cycle may be badly affected in some cases. Okay. And they may need to be admitted because they may go into, again, what kind of problems can happen from purging? What kind of problems can happen if you keep purging? Now, binge eating disorder is when there is episodes of बहुत ज़्यादा खाना. Sorry, let's move to bulimia. I want to talk about bulimia first. Okay. Yeah, metabolic alkalosis. Yes. This was a question recently. Right? BMI less than 18.5 and less than 17.5. Guys, purana and naya level alag hai. If you can also confirm and check which one is purana, which is naya, it'll be great. I do agree 18.5 is right, but I think I also read the newer books are 17.5. Can you please confirm and then let me know in the NEET PG in the FMG Telegram channel. Okay, it'll be helpful for me as well. Thank you. Okay, bulimia पढ़ते हैं अगला. अब bulimia में क्या होता है? Binge eating होती है, बहुत ज़्यादा खाते हैं, and then there is compulsive purging, right? USMLE में अभी 18.5 है. Okay, I'll also double check and get back to you guys. Okay, so bulimia में there is purging after binge eating, and purging behaviors could be vomiting, using of laxatives or diuretics, or excessive exercising and fasting. And I will show you some pictures, but you all already know that what is it called when the person puts the fingers and what happens to their knuckles? What are the calloused hand called and what are the dental changes called? Anybody who can tell me what are the calloused hand? हाथ उंगली डालने की वजह से बार बार यहाँ पे दांत लगने से उसको क्या बोलते हैं? And enamel के changes को क्या बोलते हैं? Okay, hands is called Russell sign. And what is this thing? Good. Very good. And what can happen to the teeth? The enamel can get eroded. All right. And they can be drinking excess amount of water, carbonated beverages, using a lot because वॉमिटिंग की वजह से बहुत एक ब्रेथ से स्मेल आती है, so they can have a lot of mint and chewing gum. Binge eating, on the contrary, is the most common, and what people do is eat large volumes, but they do not go throw up, and then they feel shame, disgust. They eat way past fullness. They eat secretly, but they're not afraid of gaining weight like anything else. Dental caries, yes. All right. Last 30 or so minutes, guys. Less than 30 minutes, I promise. जो पूछ रहे थे, last 15-20 minutes. Okay, guys? All right. Let's move on. Postpartum depression and postpartum blues. I will ask a characteristic and you will give me the answer. मैं characteristic लिखती हूँ, आप उसका आंसर लिखना. Okay. Well, answers have started coming in already. Postpartum blues, depression, and postpartum psychosis. Okay. All right. So postpartum blues happens typically 3 to 5 days. It is mild to moderate in severity. About how much percentage of population has it? And if not treated, it can self-resolve in many cases or go on to postpartum depression. Patient treatment needs support from family, and CBT is the treatment of choice. Okay. And symptoms are tearfulness, crying, sleep issues, but reactive to baby. They could be irritability, no suicidal ideation. Okay. So reassurance and CBT is needed. कितने लोगों में होती है guys? Percentage नहीं बताया आप लोगों ने. Postpartum depression happens around 2 weeks. It is moderate to severe in intensity. It does not always self-resolve, and the patient may need SSRIs. And there are, now this is the trick question, newer drugs that we can give, and obviously need support, and more intense plus debilitating plus unable to bond with child plus suicidal. All right. Okay. Percentage कोई नहीं बता रहा मुझे. In what percentage do we find postpartum? In what percentage do we find postpartum blues? In what percentage do we find postpartum depression? Percentage का मुझे किसी ने नहीं बताया तो मैंने नहीं लिखा. Okay. That's correct. Everybody's answers are absolutely right. The newer drugs used for postpartum depression are 20%. नहीं, about we also do a 70-30 sometimes ratio, but exact specifics are not there. Okay. So about 70 to 85% people can have postpartum blues, but about 10 to 15 people, about 30 to 50, 15, sorry, 30 हुआ ना? 70-30. 30 to 15% people will have this thing. Could be 80% for PPB. Yeah, 70 to 85 ballpark. Okay. All right. Good job, guys. Do we need something extra apart from this class? Dr. Vani, are you FMG or NEET PG? The only big difference in NEET PG and this I do is sometimes in NEET PG I go a little further down, but I am finding this entire batch to be very good. So I am teaching almost NEET PG level. तो आप नीट पीजी हैं डॉक्टर वानी, डॉक्टर अर्तिका वानी, कि आप FMG हैं? Okay, next we are going to talk about personality clusters. Who will be able to tell me what is cluster A, B, and C and features? A, B, C. All right, Dr. Vani, good luck. I'm happy. This is quite enough in my humble opinion. I may have just taken it one notch more, maybe when the NEET PG marathon is there. आप एक बारी बस पैसिवली सुन लेना अगर चाहिए तो, तब तक साइकियाट्री बंद करके एक बारी कुछ समय सुन लेना if you want. Okay. All right. So, personality. Who will tell me cluster A, B, and C? Cluster A, B, and C. Cluster A, B, and C. Mental health conditions that are grouped together due to sharing overlapping symptoms. Tell me the symptoms. Odd and eccentric, dramatic, anxious and avoidant, or perfectionistic. Dramatic and कोई questions है इसमें? Excessive sensitive, self-imposed, solitary. Correct. कोई questions है personality में? I feel this cohort is doing so well. I don't want to get into a topic unless there is a specific question. कोई question है क्या? Odd or eccentric in GTs. What about it? Please mention the question. I'll be happy to guide you particularly. Because again, एक एक के बारे में सब ग्रुप पढ़ना इतना जरूरी नहीं है. एक ब्रॉड पिक्चर अगर सबसे ज्यादा इंपॉर्टेंट है मेरे हिसाब से तो बॉर्डरलाइन पढ़ लो, ASPD पढ़ लो. I'll ask you one question about ASPD. Okay. Which childhood diagnosis is needed for ASPD or antisocial personality disorder diagnosis? Do we need to know defense mechanism related to these? I don't know, the PYTs that I have seen, not typically. You can read them as an add-on. Yes, you should know the splitting in borderline. You should know the undoing in OCD and OCPDs. You should know the displacement in paranoid, projection in paranoid. Should know the broad ones. Okay. Yes, conduct disorder is a prerequisite as a diagnosis in childhood for antisocial personality disorder, not ADHD. ADHD, if untreated, can sometimes lead to conduct disorder or oppositional defiant disorder. Okay. But good answer, guys. Good. ODD, nay, conduct disorder is mandatory diagnosis for an antisocial personality diagnosis, disorder diagnosis. हम जरूर childhood history बड़े अच्छे से लेते हैं. All right, moving on to my top favorite quick pictures. What is picture A? What is picture B? What is picture C? Shoot, shoot, shoot. A is ASPD, means antisocial personality disorder. Trichobezoar, seen in trichotillomania, which means pulling hair, and it is an OCD spectrum disorder. Okay. ODD then conduct then antisocial according to the age. नहीं, डॉक्टर सिंह ये ना समझाने के लिए बोला जाता है. ODD जो है ऑपोजिशनल डिफाइंड डिसऑर्डर होता है. ऐसा नहीं कि वो बच्चे में और फिर मिडिल एज में कंडक्ट और बड़े में ASPD है. ODD is less intense and less problematic than conduct disorder, which it means yes, sometimes ODD can progress to conduct disorder, but most of the time an ODD child is different than a conduct disorder child. An ODD child will be just defying authority figures, meaning they will not talk to them properly, they will answer back, they will be difficult, they will always be opposing. Conduct disorder children are threatening other children, are bullying other children, are harassing other children, are taking their lunch money, are threatening them sometimes with a knife, are stealing from their mothers. Conduct disorder children diagnosis is needed for the ASPD diagnosis. ODD converts to ऐसे नहीं होता है, ठीक है? All right. So, yes, this is a naloxone. This is a naloxone nasal spray used for opioid overdosage. Okay. All right. नहीं, मिडाजोलाम नहीं है. I think दिख नहीं रहा है, guys. Here you go. वो ग्रीन में लिखा है. naloxone लिखा है. naloxone है. Okay. A is what? A is trichobezoar. All right. B is okay. Great, great. Everybody's answered correctly. Fantastic. What is D? What is E? D is EOG. I want to know what is it showing. Yes, it is showing non-REM sleep cycle stage 2, K complex and sleep spindles are very pathognomic. Can somebody tell me that REM sleep cycle में क्या characteristic मिलता है? क्या characteristic मिलता है? क्या कैरेक्टरिस्टिक मिलता है रेम स्लीप साइकिल में? अगर ये रेम स्लीप साइकिल का होता इमेज तो क्या डिफरेंट दिखता? अगर ये रेम होता तो क्या मिलता है इंस्टेड? Seesaw, saw tooth appearance. Sawtooth appearance. Yes, sawtooth appearance. Absolutely right. Sawtooth appearance. Okay. ये मैंने बनाया है. ये मेरे beautiful sawtooth हैं. ठीक है? मैं ऐसे बनाती हूँ. All right. Sawtooth appearance. Correct. All right. What is image number F? What is this procedure? F is the same. What is this procedure's name? Okay, this is electroconvulsive therapy. Which anesthetic agent is used? Methotrexate. Which muscular relaxant is used? Succinylcholine. What are the indications? Depression, mania, suicidal ideations, schizophrenia. What else? What else? Schizoaffective disorder, neuroleptic malignant syndrome, extrapyramidal reactions. We can give in these situations also. Okay, what are the side effects of ECT? What damage can it do? What is the problem if we give ECT? Seizure to process hai boss. What can the seizures cause? It can cause fracture, headache, transient, memory issues. Okay? Yes. No, not hypokalemia. It can cause fracture, especially if the patient is held too tight or if the muscle relaxant doesn't kick in. It can cause transient memory loss. It can cause headache after it, which resolves immediately in some time. Okay. What are the absolute contraindication for ECT and what are the relative contraindication for ECT? What are the absolute contraindication for ECT and what are the relative contraindication for ECT? Absolute मतलब बिल्कुल ही नहीं ले सकते आप. So there is no absolute contraindication. All are relative. Raise ICT, okay. Recent MI. Raised intraocular pressure. Seizure disorder में दे सकते हो, not a problem. So recent MI, raised IOP, intraocular pressure, raised intracranial tension, intracranial pressure. You will not give immediately SOL, but these are relative contraindications. Can you give ECT in pregnancy? Yes or no? 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 Can you give SOL is correct. I've written SOL. मेरे पीछे छुपा हुआ है. Can you give ECT in pregnancy? Yes or no? Yes or no? Yes or no? क्या बोलती है जनता? Yes or no? Yes, we can. In fact, in pregnant mothers who are actively suicidal, ECT is indicated. Okay. All right. We are inching in towards the last couple of things. Very important. Let's quickly revise. What are the stages as per Freud, the gentleman named Freud? When we are born, from the birth to 1 year, we have this need to actively suck because we drink milk and rely on nutrition mainly from there. Now, somebody is stuck in that state, what will happen? They will have oral fixation. तो जो लोग मुंह में हमेशा पेंसिल डाल के रखते हो, आपको शायद oral fixation हो सकती है. All right, that is oral fixation. छी, मेरा पेन गंदा हो गया, just to show you all. Now, this could happen in substance dependence. It could happen in dependency on a person. It could be when the person's ego issues are there or aggression issues are there. These are the usual outcomes of oral fixation. Next is the stage of anal stage. When does it happen? When the child turns 1 to 3 years. In this, the potty training is initiated by the parents. They make sure that the child doesn't poop in the pants and is taught to do potty on the pot. But as a result, a lot of children want to not give up that control. They want to poop in their pants. They want to poop wherever they want. So they become anal retentive. They actually become constipated. They get impaction of feces. They need sometimes, enema, digital evacuation, because they want to hold on. This is a power struggle. And as adults, you can see when we say the term, why are you so anal? Which means that why are you so obsessively clean, obsessively punctual, obsessively particular? OCPD, that is obsessive compulsive personality disorder, also has these traits. And also when parents are very strict and harsh, we say that why are you so controlling? Why is there so much need for control? Next is phallic. Phallic means to do with the sexual organs, penis particularly. This happens in the 3 to 6 years of range, where the sexual organs के बारे में awareness होने लगती है. बच्चे को पता चलने लगता है, am I a boy? Am I a girl? There's some sense of semblance of identification. Who will tell me what is Oedipus and what is Electra complex? What is Oedipus and Electra complex? Who will tell me what is Oedipus and what is Electra complex? What is Oedipus and what is Electra complex? Son to mother what? No incest. No. No, incest means, again, incest is not the right word to use here. I understand in your way you are trying to say that having sex with a relative or like a loved one of the same family lineage, but no, incest nahi mante hain isko, because again, these are impulses that people have but don't necessarily always act on. So in Oedipus, there will be castration anxiety, and penis envy. So the term daddy's girl and mama's boy may emerge from it, not used obviously, but just to explain to you all, I'm telling you, the son becomes very possessive and close to mother and fights with father. And here the daughter may become very possessive and close to father. Okay. All right. Next is latent. यहाँ कुछ नहीं होता. 6 years to puberty में कुछ नहीं होता है. Pure sex friendships बनती हैं और passive सी stage है. And final is genitalia stage, puberty to adulthood, where love interests develop and romantic partners come into place. Okay. Are we all on the same page? I have one more slide to go, or 2 more. So any questions so far? Anything? Okay. Now, next, impulse related disorder. Impulse क्या होती है? इच्छा होती है. Right? It means इच्छा. मेरा कुछ करने का मन कर रहा है. That is impulse. What is kleptomania? What is trichotillomania? Pyromania and compulsive shopping. Tell me A, B, C, D. Trichotillomania we already discussed is the impulse to pull hair, unable to stop. Kleptomania means urge to steal things that are not, if this is important, of value to the person, or they can even afford it. For example, you must have heard of celebrities stealing things from shops. Celebrities stealing things from shop. Now you're like, अरे but ये तो इतना बड़ा celebrity है, ये तो कुछ भी खरीद सकता है, खरीद सकती है, right? So they are stealing. Why do they need to steal? They don't, but they get a kick out of it. So that urge impulse gives them a kick. All right, not sexual, just mental kick. That is kleptomania. Pyromania is setting fire. Again, this may start as a symptom of, can be a part of symptom of conduct disorder also. These children keep setting fire to things. They may hurt animals as well. I was going to ask the question, Dr. Rawat, आपने तो आंसर दे दिया. Oniomania is also compulsive shopping. Oniomania is compulsive shopping. So मेरे को जरूरत नहीं है इन कपड़ों की, but I'm still buying compulsively. How many of you have oniomania, self-diagnosed? That is compulsive shopping. All right. A patient with history of chronic alcohol use was admitted and operated for acute appendicitis. After the surgery, 2 to 3 days later, the patient appeared confused and reported seeing snakes in the wardroom. What is likely the likely diagnosis? Is it delirium tremens, Wernicke's encephalopathy, Korsakoff syndrome, or delusion? Read the question again. Delirium tremens, क्योंकि जब अगर पेशेंट क्रॉनिक अल्कोहलिक एडमिट हुआ होगा, ये मुझे क्लैरिफाई इसलिए करना पड़ा क्योंकि मुझे पता था ट्रिकी है अगर मैं नहीं लिखती. तो जब उसके अपेंडिक्स की सर्जरी हुई है, मान लो अगर उसके आज एडमिट हुआ है तो उसकी सर्जरी हुई है कल सुबह, तो उसके बाद उसको रिकवरी में रखा है, उसके बाद हुआ है, तो 2-3 दिन अपने आप पकड़ के चलो ना. कभी टाइमलाइन ना लिखा हो तो प्लीज ट्राई टू यूज लॉजिक इन दैट क्वेश्चन. ओके, the answer is not delusion. No, the answer is delirium tremens. Also, this is not even delusion. He said that he's seeing snakes in the wardroom. अगर आप लोग hallucination भी बोलते तो चलता, but it is not that. No, आंसर काफी इजी है because वर्निकेस और कॉर्सकॉफ्स तो नहीं है. delusion तो होएगा ही नहीं क्योंकि delusions is thought. This person is seeing snakes, so they are having perceptual issues. Okay. And with that, guys, thank you so much. आज मेरी सारी slides green है तो इसलिए green black बन गया है. Any questions? Please share. I had a fun time teaching you all because इतना fantastic crowd था. मुझे मजा आया पढ़ाने में. आप लोगों को कैसा लगा? How did you all like the talk today? How did you all like the quick active recall of the FMG topics, which I thought were the most relevant and important ones? Do you have any questions? Thank you, Dr. Vani. Thank you, Dr. Nazar. Thank you, Dr. Nick, Dr. Rawat, Dr. Singh, another Dr. Singh, Dr. Das, and Dr. Rijik, Dr. Nephrotoxic, Dr. All of you all have been fantastic. I don't know if I've missed some names out, but ye log ka, Dr. Sharma, Dr. another Singh, बहुत लोगों का अच्छा एक्टिव पार्टिसिपेशन था आज, मजा आया. arigato gozaimasu. Thank you very much. Thank you as well. Bye bye.
Hello, everyone. Very good evening to all of you. Good to see you all. And I hope you guys are all charged up. I hope you guys are on the sprint regarding the foreign medical graduate entrance exam. तो हम लोग कर क्या रहे हैं in PW Merit? We have been carrying out a sprint of the last time that you need to read. सारी चीजें in the form of a workbook. We have created a workbook for every subject and we are running through every topic of each and everything what you require in your FMGE preparation. Now, I am Dr. Sanchit Bajpai. I am your PW Merit faculty of ENT. And in this particular segment, I'll make sure that by the time you end up today, you know everything about what comes in ENT segment of FMG. If you do this workbook, I can assure you that there is no question outside what is there in ENT except for what we'll do today. So, हम लोग क्या करेंगे? We are going to take up all the topics one by one. I'm going to finish ear, then we're going to go to nose, फिर करेंगे हम लोग oral cavity and pharynx, and then finally going to the larynx. Right? So, सारे questions schematically we are going to cover, and I'm going to show you the diagrams wherever necessary, and we are going to go one step at a time. Whichever question is required, you can just put it on over on your chat, and we'll straight away answer that question. Okay? So, welcome you all. Stay hydrated. This is going to be a little long lecture, but at the same time, everything will get finished if you stick with me till the end of it. Okay, fine. So let's begin about what exactly you need to know in our mission FMGE for otorhinolaryngology or ENT surgery. Okay, so beginning, what I'm going to do, we have got this FMGE workbook. I hope you guys have downloaded it. It's available, right? And this covers almost 80 pages of ENT. All those 80 pages are high yield questions, and all of them are required for your ENT preparation. Okay. So we're going to start off with the first segment of ENT, और वो क्या है? That is our ear. Okay. Now ear कहाँ से start होता है? The first and foremost thing where the questions come are from right away from embryology of ear. कि development of ear कहाँ से शुरू होता है? Right. So हम लोग सबसे पहले देख लेते हैं the first part of our ear, that is our external ear. External ear में क्या parts होते हैं? The external ear consists of pinna as well as external auditory canal. Right. अब pinna क्या चीज है? How is the pinna getting formed? Is my voice audible to all of you? Is it coming fine? Can you just confirm me about the voice that is coming? Any one of you, can you just confirm me about the voice? Is it coming fine and is the video fine? What you can see over here? Okay, fine. Okay. Okay, we'll continue. So the first and foremost question is, what is the development of pinna? Now, if you are asked any question about the development of pinna, you need to know the rule of 6. Rule of 6 का मतलब, pinna develops from 6 tubercles or 6 hillocks. These are called as 6 tubercles of his. 6 tubercles of his. And these 6 tubercles develop at 6 weeks. So pinna develops with 6 tubercles at 6 weeks. अब ये 6 tubercles कहाँ से बनते हैं? These 6 tubercles are formed from the first and the second pharyngeal arch condensation. We know that there is an embryo, right? The first and the second pharyngeal arch condense to form these kind of 6 swellings, and these 6 swellings are called as 6 hillocks, or we call it as tubercles of his. Question number 1. Second, which week does it form? It forms at 6 weeks. Till when does it develop? It finishes development by 20th week of gestation. 20 हफ्ते तक पूरा पिन्ना बन जाता है. One more important question that comes from here. What is the first tubercle going to form? The first tubercle is going to form the tragus of the pinna. Tragus मतलब this elongated projection जो बाहर निकला हुआ है. This triangular projection is tragus that is formed from the first hillock. बाकी सारे जितने hillock हैं, second to sixth, they are going to form the rest of the pinna. So the first is forming the tragus. Now one important question is, if there is a malfusion, या अगर हमारे ये fusion नहीं होता of these tubercles together, what is the congenital anomaly that you will see? The congenital anomaly that you see because of malfusion of tubercles is called as preauricular sinus. Preauricular sinus. Preauricular sinus क्या होता है? You can see here there would be a hole just in front of your external ear. Just in front of your external ear छोटा सा hole होगा. That is called as a sinus. Preauricular क्यों? क्योंकि ये auricle के सामने है. Auricle is the pinna. That hole is formed because the first and the second arch could not fuse. ये जो tubercles हैं, they cannot fuse properly और छोटा सा hole बन जाता है. That is called as preauricular sinus. बस. This is about what you require in embryology of pinna. चलो. Now let's move on to the next embryology question that is asked. That is from the external auditory canal and eustachian tube. ये कहाँ से बनते हैं? Right? Now we know every embryo has got 6 pharyngeal arches. Right? Pharyngeal arch क्या होती है? Pharyngeal arch is a condensation of mesoderm. Right? So we have got 6 pharyngeal arches and all our ear gets developed from the first and second pharyngeal arch. The whole of our ear gets developed from first and second pharyngeal arch. सारा का सारा ear first 2 arch से ही बनता है. This is our first arch, this is our second arch. अब arch के अंदर क्या होता है? There is mesoderm. There is mesoderm that is present inside the arch. Right? आर्च का आउटर सेगमेंट, एवरी pharyngeal arch का आउटर सेगमेंट कंटेन्स एन एक्टोडर्म एंड एवरी आर्च का इनर सेगमेंट कंटेन्स एंडोडर्म. So there is ectoderm on the outside of each arch and there is endoderm on the inside of each arch. And this is the first pharyngeal arch, this is your second pharyngeal arch. Between the first and the second pharyngeal arch on the ectodermal side, there will be an invagination. एक groove की तरह अंदर जाएगा. There will be an invagination between the first and the second pharyngeal arch. This first and second pharyngeal arch groove जो बीच में बनता है, this is called as the first pharyngeal cleft. This is called as first pharyngeal cleft. Right? And between the endoderm of the first and second arch, there forms something called as first pharyngeal pouch. तो फर्स्ट pharyngeal pouch होता है endodermal side पे, first pharyngeal cleft होता है ectodermal side पे. This is what we have understood. Now one important question in your FMGE exams that will be what? External auditory canal किससे बनती है? External auditory canal will be formed from the first pharyngeal cleft. ये जो ectodermal side पे invagination है, this will form the first pharyngeal cleft will form the external auditory canal. So answer is first pharyngeal cleft will form what? It will form future external auditory canal. What will form from the first pharyngeal pouch? This first pharyngeal pouch will go and expand inside. You can see this. This pouch will go and expand inside. It will go and expand like this. What is this projection called as? This projection of the first pharyngeal pouch is given a very important name जो बहुत बार पूछा गया है. That is called as tubotympanic recess. This is called as tubotympanic recess. What is the derivative of tubotympanic recess? Tubotympanic recess से क्या बनता है? Tubotympanic recess के distal segment से there will be formation of tympanic cavity. And tubotympanic segment के proximal part से will be the formation of eustachian tube. So I am telling you two questions here. Tubotympanic recess forms what? Tubotympanic recess will form the future eustachian tube and the future tympanic cavity. If I talk about the proximal segment of the tubotympanic recess, it will form the eustachian tube. If I talk about the distal segment, answer will be tympanic cavity. इसमें हमें ध्यान देना है कि वो proximal पूछ रहे हैं कि distal पूछ रहे हैं. But this first pharyngeal pouch gives derivatives to both tympanic cavity as well as the eustachian tube. Okay, fine. तो first pharyngeal cleft हो गया, first pharyngeal pouch हो गया. This is what I have written. That first pharyngeal cleft से निकलता है your external auditory canal. Tubotympanic recess is going to be the one which will form the tympanic cavity as well as the eustachian tube. Right? Now, tympanic membrane कहाँ से बनेगा? This is also a question to you. Tympanic membrane कहाँ से आता है? So I told you the ectodermal side बाहर की है, endodermal side अंदर की है, बीच की mesoderm है. Right? Tympanic membrane has got 3 layers. उसमें ectoderm भी है, mesoderm भी है, endoderm भी है. So the ectodermal side of the tympanic membrane or the outer layer of the tympanic membrane will be formed from this ectodermal side. Middle layer will be because of the mesoderm and the endoderm will be formed by this tubotympanic recess. ये तीनों मिलके बनाते हैं all the 3 layers of the tympanic membrane. That's what written over here, that all the 3 layers of the tympanic membrane, the outer epithelial, middle fibrous and inner mucosal layer are derivatives of epithelial, mesodermal as well as endodermal layer. This finishes about what you require in your embryology of ear, जो बहुत बार पूछे जाने वाला question है, and they will ask you about what is the eustachian tube formed from, what is the pharyngeal cleft formed from, what is this pinna formed from. Okay, fine, चलो. अब इसी के basis पे, let's come to a very high yield question. How many ossicles are there in the ear? There are 3 ossicles. Malleus, incus, stapes. ये हो गई malleus, then there is incus, then there is stapes. Right? मैलियस इंकस स्टेपीज किसके डेरिवेटिव हैं? वेरी इंपॉर्टेंट क्वेश्चन. इफ आई आस्क यू मैलियस एंड इंकस आर डेरिवेटिव्स ऑफ विच फेरेंजियल आर्च, छोड़ के हमें यह बताना है दैट मैलियस एंड इंकस आर डेरिवेटिव्स ऑफ फर्स्ट फेरेंजियल आर्च. ये दोनों फर्स्ट फेरेंजियल आर्च से निकलते हैं. बट द ट्रिक क्वेश्चन दैट विल कम टू यू विल बी स्टेपीज. स्टेपीज में दो पार्ट पूछे जाते हैं. स्टेपीज का एक पोर्शन होता है ऊपर का विच इज कॉल्ड एज सुप्रास्ट्रक्चर ऑफ स्टेपीज, और एक पोर्शन होता है नीचे का विच इज कॉल्ड एज फुट प्लेट ऑफ स्टेपीज. If I ask you what is the suprastructure of stapes developed from, suprastructure of stapes will get developed from second pharyngeal arch. तो ऐसे याद रखो, S for stapes, S for second pharyngeal arch. Malleus incus first, stapes suprastructure second. But when I talk about foot plate of stapes, ये foot plate is derivative of otic capsule. ये इंपॉर्टेंट क्वेश्चन है कि फुट प्लेट अगर पूछा गया है तो वो ओटिक कैप्सूल से आएगा. रेस्ट यू कैन जस्ट रिमेंबर एज कि दैट विल बी डिराइव फ्रॉम द सेकंड फेरेंजियल आर्च रिगार्डिंग द सुप्रास्ट्रक्चर ऑफ स्टेपीज. राइट? ओके, चलो. नाउ लेट्स कम टू द नेक्स्ट इंपॉर्टेंट क्वेश्चन ऑफ व्हाट कम्स इज द नर्व सप्लाई ऑफ पिन्ना. अब नर्व सप्लाई ऑफ पिन्ना में क्या इंपॉर्टेंट है? बहुत सारी नर्व सप्लाई करती हैं पिन्ना को. देयर आर मेनी नर्व्स, राइट? बट देयर आर सर्टेन इंपॉर्टेंट क्वेश्चंस रिलेटेड टू योर नर्व सप्लाई ऑफ पिन्ना, राइट? अब देखो, ये पर्पल कलर, द ग्रेट पार्ट ऑफ योर पिन्ना, सारा ग्रेटर पार्ट, बचा कुचा सारा ग्रेट पार्ट, ऑब्वियसली ग्रेटर है तो ग्रेटर. सो ग्रेट पार्ट ऑफ द पिन्ना और द ऑरिकल विल बी सप्लाइड बाय अ नर्व दैट इज कॉल्ड एज ग्रेटर ऑरिकुलर नर्व. ग्रेटर ऑरिकुलर नर्व इज कमिंग फ्रॉम C2 to C3 cervical plexus. ये ग्रेट पार्ट ऑफ आवर ईयर है, राइट? नाउ आई वांट यू ऑल टू पुट वन फिंगर इन फ्रंट अबव योर ट्रेगस. बिल्कुल ट्रेगस के ऊपर यहां पे उंगली रख दो. This part, just above the tragus, इस part को is supplied by auriculotemporal nerve. What is the auriculotemporal nerve? Auriculotemporal nerve is a branch of V3 division of trigeminal nerve. There's trigeminal nerve, उसके V3 division से निकलती है auriculotemporal nerve. Okay? Now I want you all to put one finger over in your concha. ये जो hole है, ये there's a concha, right? The bowl-like projection. इस bowl के अंदर अपना एक हाथ रख दो. This particular area is supplied by two nerves, that is 7 and 10, facial and vagus. Facial and vagus will supply this area around the concha, which is 7 and 10. This is also a very important question. अब एक important question आता है, what is the auricular branch of the vagus nerve called as? Vagus nerve की कौन सी branch अंदर जाती है ear के? So the auricular branch of the vagus nerve is given the name as Arnold's nerve. It's called as Arnold's nerve. That's called as auricular branch of vagus nerve. What is the auricular branch of glossopharyngeal nerve called as? The auricular branch of glossopharyngeal nerve is given the name as Jacobson's nerve. ये दोनों important FMGE questions हैं. What is Arnold? What is Jacobson's? Okay? चलो. So we have understood about the lateral surface कि यहाँ पे 7 and 10, greater part, greater auricular nerve, right? And the rest in front is by the auriculotemporal nerve. ये हमने पढ़ लिया, right? This we have understood. Okay. अब पीछे क्या है? If we turn the pinna like this, the same area corresponding to the concha पीछे, इसके just पीछे, this area will also be supplied by 7 and 10 together. तो 7 and 10 हमेशा साथ चलते हैं पिन्ना में, right? And of course, the rest of the greater part will be supplied by greater auricular nerve. And the top portion of the back part of pinna, ये top portion of back part of pinna will be supplied by lesser occipital nerve, which is a branch of C2 division of the cervical plexus. C2, C3 greater auricular, C2 cervical plexus. Okay, fine. So this is something that you need to understand about what you require as far as nerve supply of the pinna is concerned. ठीक है, चलो. Now let's move on to the next one. अब क्या important part है what you need to understand as far as anatomy of external auditory canal is concerned. External auditory canal कभी सीधी नहीं होती. It is twisted. And our external auditory canal is in the form of an S shape. S की तरह होती है external auditory canal. And this is our tympanic membrane. It's like an S. Right? So what is the direction of orientation of external auditory canal? This is your question. Our external auditory canal is directed forward, downward and medially. Simple. So our external auditory canal is directed forward, downward and medially. Forward, downward and medially. That is what creates an S shape or S shape configuration to the external auditory canal. अब एक इंपॉर्टेंट क्वेश्चन आया है कि व्हाट आर द पार्ट्स ऑफ एक्सटर्नल ऑडिटरी कैनाल. ऑब्वियसली देयर आर टू पार्ट्स, आउटर कार्टिलेजिनस, इनर बोनी पार्ट, राइट? सो व्हाट इज द आउटर पार्ट? द आउटर पार्ट इज कॉल्ड एज द कार्टिलेजिनस पार्ट, इनर पार्ट इज कॉल्ड एज द बोनी पार्ट. The total length of the external auditory canal is around 24 millimeters. This is an important question. Okay. Now, how long is your cartilaginous part? The cartilaginous part is around about 8 millimeters. The bony part is around about 16 millimeters. Okay. This is about what you need to require as far as dimensions are concerned. एक important question जो आता है, which area is the narrowest area in the external auditory canal? The junction between the bone and the cartilage. This area is going to be the narrowest area of the external auditory canal, and this area is given the name as isthmus. The narrowest area of the external auditory canal is given the name as isthmus. This is a very important question. अब isthmus में वो क्या पूछेंगे? Isthmus में ये पूछेंगे that what is the importance of isthmus? The most common area for foreign body lodgement is also the isthmus. So सबसे ज़्यादा foreign body, let's say बच्चे ने कोई मटर का दाना रख लिया, or let's say some kind of a toy, a small toy has gone inside, or a pearl has gone inside. Where will it get stuck? That foreign body will get stuck at this area, which is called as the isthmus, also called as the narrowest area of the external auditory canal, which occurs between the bony and the cartilaginous junction. Okay? Now, two important questions. So after the isthmus, we come to two important questions. What is fissure of Santorini? What is foramen of 𝐒𝐻𝐃? If I tell you there are certain important deficiencies which are present in the cartilaginous canal के inferior part पे, there are certain important deficiencies. These deficiencies which are present in the cartilaginous canal are called as fissures of Santorini. ये important question है. And what is foramen of 𝐻𝐃? If I have any deficiency in the bone in the bony canal, that is called as foramen of 𝐻𝐃. Yani foramen of 𝐻𝐃 is a space, or it is a deficiency in the bony canal. Fissures of Santorini are deficiencies which are present over in the cartilaginous canal. This is something which we need to very, very well understand. And that is the most important question what they have asked. That fissures of Santorini occur in the cartilaginous canal. Foramen of 𝐻𝐃 कहाँ पे होता है? It is present in the bony canal. Now usually ये foramen of 𝐻𝐃 जो होता है, this usually gets covered by 4 years of age. ये पूरी तरीके से heal हो जाता है by 4 years of age. But if it remains patent, then there could be cross infections from the external auditory canal to the parotid gland and mastoid. बार बार infection इसके थ्रू ट्रैवल करते रहेंगे between the parotid as well as between the mastoid as well as temporomandibular joint. This is the significance of foramen of 𝐻𝐃. Okay, fine. So this finishes about the important questions that are related to the external auditory canal. चलो, अब एक इंपॉर्टेंट क्वेश्चन आता है कि हाउ टू आइडेंटिफाई कि टिम्पैनिक मेम्ब्रेन कौन से साइड की है. दिस इज अ वेरी इंपॉर्टेंट पार्ट. सबसे जरूरी पार्ट ये होती है कि हमें ये डिसाइड करना होता है कि टिम्पैनिक मेम्ब्रेन का ओरिएंटेशन क्या है. क्या ये राइट की पूछ रहे हैं, क्या ये लेफ्ट की पूछ रहे हैं. आई टेल यू अ वेरी सिंपल वे टू आइडेंटिफाई द साइड ऑफ टिम्पैनिक मेम्ब्रेन. टेक योर हैंड, tilt it towards the right. If it is tilted towards the right, it is right side. Take your hand, tilt it towards the left. अगर left की side tilted है, that means left. मतलब अगर in case I have drawn a tilt towards the right, तो obviously this is a right-sided tympanic membrane. That is the first clue कि कौन से side है, right? अब एक और important point. जिस तरफ tympanic membrane tilted है, वो side will become anterior and पीछे का side will become posterior. That means if this is the right tympanic membrane tilted towards the right side, this side will be anterior and the opposite side will be posterior. Tilted side is always anterior side. Remember that. Okay? Now we know that the tympanic membrane has got two parts. नीचे के part को we call it pars tensa. ऊपर के part को we call it pars flaccida. Pars tensa is grey and glistening. Pars flaccida is obviously pinkish in color. Now we divide the whole tympanic membrane into 4 quadrants. कैसे divide करते हैं? One line along the handle of malleus. One line passing perpendicular to it at the umbo. इस point को हम कहते हैं umbo, which is the point of attachment of the malleus on the pars tensa. That is called as umbo. So in this way, we can divide the whole of your tympanic membrane into 4 quadrants. That is, ये anterior है, so this will become anterosuperior, anteroinferior, posterior-inferior, and posterior-superior. Now, important questions that will be asked to you as one-liners. In which part of or in which quadrant of the tympanic membrane will you see cone of light? And I think already Irtika has answered it. So the cone of light will be always seen in which quadrant? It will always be seen in the antero-inferior quadrant. That is the first question that they will ask you. Cone of light किस quadrant में दिखती है? That is antero-inferior. Second important question that they will ask you, इस पूरे पार्स टेंसा में सबसे अनसेफ क्वाड्रेंट कौन सा है? विच इज द मोस्ट अनसेफ क्वाड्रेंट ऑफ दिस पार्स टेंसा? द मोस्ट अनसेफ क्वाड्रेंट ऑफ पार्स टेंसा इज द पोस्टेरो सुपीरियर क्वाड्रेंट. Why? Because in the posterior superior quadrant there is 𝐒𝐄𝐝 joint. So 𝐒𝐄𝐝 joint की वजह से this is the most unsafe quadrant of the pars tensa. That is also an important question. Okay, fine. चलो, अब ये हमने समझ लिया. We can also now. Can you tell me which side is this? Is it the right side or is it the left side? What I've drawn over here, is it the right or the left? We have got this as the handle of malleus. ये हमें दिख रहा है. This is the handle of malleus. This is your cone of light, right? And these are the four quadrants of the tympanic membrane. You can also see a shadow of the 𝐒𝐄𝐝 joint. So which side does it become? Is it the right side or is it the left side? This is something. Great. So I think 𝐒𝐿𝐻𝑖𝑘𝐻 has already answered. This is the right side. Right, correct. So this is the right side. This is how we see, right? This is how we get to know which side is there. अब एक important question है, what is the nerve supply of the tympanic membrane? अब इसका सिंपल तरीका ये है, टिम्पैनिक मेम्ब्रेन को दो पार्ट में डिवाइड कर दो. आई टोल्ड यू द साइड टुवर्ड्स विच इट इज टिल्टेड इज एंटीरियर, पीछे वाला इज पोस्टीरियर. A for anterior, A for auriculotemporal. मतलब anterior side of the tympanic membrane is supplied by auriculotemporal nerve. पीछे का side, the posterior side, is the one which is supplied by vagus nerve. Which is supplied by vagus nerve. This is on the lateral aspect of the tympanic membrane. But when I ask you medial side of the tympanic membrane is supplied by, can you answer that? The medial surface of the tympanic membrane is supplied by what? ये तो lateral हो गया. A for anterior, A for auriculotemporal, पीछे वाला is vagus. But what is about the medial side of the tympanic membrane? Which nerve supplies that? There is a very important nerve which is present inside in the middle ear, which is supplying the medial aspect of tympanic membrane, and that is Jacobson's nerve. And we have already discussed Jacobson's nerve is a branch of, it is a branch of glossopharyngeal nerve. So the medial part of the tympanic membrane is supplied by glossopharyngeal nerve. That is by Jacobson's nerve. Okay, fine. Laterally हमने देख लिया, anterior A for auriculotemporal and posterior is vagus. Okay, चलो. If we see the supply of your external auditory canal मतलब canal के अंदर की क्या supply है? This has got very important questions to it. ये हमारी external auditory canal है through which we are seeing the tympanic membrane, and obviously this is tilted towards the right, so ये right side की है, right? So ये क्या हो गया? What is this? This is the anterior half of external auditory canal. So A for anterior, A for auriculotemporal is supplying the anterior part of external auditory canal, and the posterior part of the external auditory canal superiorly is supplied by facial nerve, and inferiorly it is supplied by auricular branch of vagus nerve, which is called as Arnold's nerve. अब दो important question I will ask you here. If suppose in one disease, there is a disease in which if the facial nerve gets compressed, there will be loss of sensation in the posterior-superior part, or there is hypoesthesia of the posterior-superior part of the external auditory canal. Can you tell me that disease? Which disease has got hypoesthesia of the posterior canal wall? And what is that sign called as? Very, very important sign, very important disease. उसमें posterior-superior part में sensation चली जाती है. What is that disease? What is that sign? That has to be a very, very important question, very high yield question. I'm going to come into that, but we are discussing about it, so we'll discuss it quickly over here. What is that called as? This is called as Hitzlsperger sign. बहुत commonly asked question. What is Hitzlsperger sign? Hitzlsperger sign is hypoesthesia of the posterior canal wall. Hypoesthesia means इस area में अगर हम छुएंगे posterior canal, we will never be able to feel it. Right? So I think already Som Subra has answered. Great. Hitzlsperger sign is a characteristic when there is vestibular schwannoma, या उसे हम acoustic neuroma भी कहते हैं. Whenever it actually compresses over the facial nerve fibers. Okay, that's a very, very important sign that you guys should know. Okay, fine. चलो. Now we move on to another important question कि क्या होती है Prusac space, right? This is something which has been recently added in your papers as far as FMGE is concerned. अब हम लोग क्या देख रहे हैं? This is again the lateral view. हम लोग सीधे laterally अंदर आ रहे हैं. We are seeing that this is your malleus, which is getting attached to the pars tensa. You can see that this is your pars tensa, and the upper portion here a little bit. This is your pars flaccida. Let me make it in green color. ये आपका ऊपर का portion is pars flaccida, right? Now, one more important thing you are seeing, there is a ligament which is going from the malleus to the outer attic wall. ये हमारा attic की wall है. This is the attic, the upper portion of the middle ear. ये इसकी बाहर की wall है. That's why we call it outer attic wall, right? Can we see this kind of a space over here? What is this space? This space is called as Prusac space. अब ये Prusac space की boundaries क्या है? This we should understand. Prusac space is lined by anteriorly. What do you have? You have got the pars flaccida. right? Anteriorly, you have got the pars flaccida. Posteriorly, you have got what? You have got the neck of malleus, correct? Superiorly, you have this ligament. And what is this ligament present superiorly? This is called as lateral malleal ligament. This little ligament over here, this is lateral malleal ligament. And inferiorly, you have got the lateral process of malleus. So this little space over here, this is the space which is called as Prusac space, which is bounded by the lateral malleal ligament superiorly, lateral process of the malleus inferiorly, in front the pars flaccida, and behind the neck of the malleus. This is the most important site where primary acquired cholesteatoma arises. This is a very, very important question. Primary acquired cholesteatoma arises from which of the following spaces? Most important space is Prusac space. जहां से सबसे ज़्यादा ज़रूरी ये चीज़ निकलेगी. Right? This is what finishes what the Prusac space is. One line question. Primary acquired cholesteatoma arises from where? It arises from the Prusac space. Simple. Done. Okay? चलो. Now let's move on to the next question. अब आते हैं ट्यूनिंग फोक टेस्ट पे. ट्यूनिंग फोक टेस्ट के रिगार्डिंग बहुत सारे कंफ्यूजन होते हैं. And this is something that you should remember about what is asked in tuning folk test. Okay. Now, let me just make it very clear to you. दो चीजें आएंगी आपके सामने. You will get Rinne's test, Weber's test. That will be the most common questions to you. अब एक चीज सबसे पहले देखना, what are they telling in Rinne's test? Normal people में Rinne's test में air conduction is more than bone conduction. मतलब अगर हम normal लोगों को देखें, always the Rinne's test is positive. That means air conduction, bone conduction से ज़्यादा होता है. This is what Rinne's positive means. Okay? But Rinne's positive, or it is also seen in one more condition, जहाँ bone conduction poor हो जाता है. And that is sensory neural hearing loss. So in two conditions, you will see Rinne's test positive. मतलब आपको दिया जाएगा that the air conduction is more than bone conduction. So obviously two things should come inside you. One is कि या तो ये आदमी normal है. Second, the patient may be about sensory neural hearing loss. ठीक है? That is the first thing that should come in your mind. अब आपको second clue देंगे Weber's test में. Weber's test में what will they tell you? That Weber's will get lateralized to which side? Weber's always lateralizes to the worst ear in conductive hearing loss. Weber's always lateralizes to the worst ear in conductive hearing loss and to the better ear in sensory neural hearing loss. So in all probable cases, you will get this question कि आपको दिया जाएगा कि Weber's is lateralized to this side, and you will always say that Rinne's is positive or negative. These are the two things that you will tell in your Weber's test or your Rinne's test. They will be given to you as hints कि कहाँ जा रहा है. Because normally हमारा Weber's test equal होता है on both the sides. Right? That's what I have written here, that Rinne's positive air conduction is more than bone conduction. Right? And also it is positive in cases of sensory neural hearing loss. Now, one important question that FMGE loves to ask is, what do you understand by false negative Rinne? False negative Rinne is seen in which condition? ये सबसे important question आता है. False negative Rinne is a classical feature of severe unilateral sensory neural hearing loss. This has to be one of the favorite questions, और ये आप नहीं भूल सकते. There is something called as severe sensory neural hearing loss. तो अगर एक साइड का सिवियर लॉस है on the sensory neural segment, the patient will have false interpretation of Rinne's test. That is called as false negative Rinne. That happens because of transcranial vibrations coming from the opposite cochlea which stimulate this side. The transcranial transmission happens through the skull bones. That is the reason why you get false negative Rinne. And that is the reason why you get it in severe unilateral sensory neural hearing loss. Okay, fine. So these are the two things that you should understand. These are the two important questions that you should remember. Now, one thing that has been asked somewhat 4 or 5 years back was that conductive hearing loss में what will be the interpretation of Shawback test? तो होता क्या है? Shawback test and absolute bone conduction test are two tuning fork tests which have got only bone conduction as the criteria. We test for bone conduction by these two important tests, what is called as absolute bone conduction test and Shawback test. अब absolute bone conduction test में हम क्या करते हैं? We close the tragus, we take a tuning fork, we place it over the mastoid of the patient. When he stops hearing, then the examiner will place it over him. If the examiner is still hearing, that means patient की bone conduction examiner से poor है. And that means the patient has sensory neural hearing loss. If we keep the tragus open, और हमने same चीज करी, that is called as Shawback test. If we keep the tragus closed, उसे हम लोग कहते हैं Absolute bone conduction test. Absolute matlab tragus closed. Absolute. Shawback mein tragus opened. Right? And we measure how much is the bone conduction of the patient with respect to the examiner. Right? अब एक इंपॉर्टेंट चीज है, वी ऑब्वियसली नो कि अगर बोन कंडक्शन ऑफ एग्जामिनर पेशेंट से ज्यादा है, that means the patient has got sensorineural hearing loss. And that is what I have written here, that in sensorineural hearing loss, the absolute bone conduction test of the patient will be shortened. वो कम हो जाएगा for obvious reasons. Right? But one important thing is, Shawback test में क्या होगा? Shawback test में you will get a shortened bone conduction, but at the same time, because the tragus is open now, you will get a lengthened bone conduction in cases of conductive hearing loss. This is something you need to remember. That agar conductive hearing loss में there is lengthened Shawbacks, they are asking about some pathology of the external or middle ear. That is the only thing which is a clue in Shawback's test, जहाँ पे conductive hearing loss पता चलता है. Other than that, you can easily get to know that the bone conduction of the patient will be shorter than that of the examiner. In simple words. Okay, fine. So remember two questions over here. One is about false negative Rini. One is about Weber's test कि वो किस तरफ lateralize करता है in conductive hearing loss and in cases of sensorineural hearing loss. चलो. Next. Now I'll come to important audiogram images about बहुत सारे audiograms that are asked to you in your exams, right? And what are the important takes और क्या इनकी diagnosis है? Now, what is this called as? Can anyone tell me what is this dip called as? So, if you see an air conduction plus a bone conduction dip at 4000 hertz, ये देखो ये 4000 hertz है, this 4000 frequency, यहाँ पे there is a conduction of air conduction and bone conduction, both have gone down. This is a characteristic notch and this is called as boiler maker notch. Boiler maker notch को हम लोग acoustic dip भी कहते हैं. It is seen at 4000 hertz. So your answers obviously become noise-induced hearing loss. This is a classical feature of noise-induced hearing loss. 4K पे noise-induced hearing loss, right? अब ये देखो, if there is a bone conduction dip at 2000 hertz, यानी सिर्फ bone conduction में dip है and it is at 2000 hertz, your answer will become what? Your answer will become otosclerosis. So otosclerosis में there is going to be a bone conduction dip which is going to be at 2000 hertz. Right? And this is a characteristic which is called as a Carhart's notch. Very good. You guys are already answering. That's called as Carhart's notch. Okay, this is called as Carhart's notch. Carhart's notch क्यों दिखती है at only 2000 hertz? Because the ossicular resonance of the stapes footplate is at 2000 hertz. सबसे ज़्यादा stapes vibrate 2000 hertz पे करती है. और अगर stapes fix हो गई because of otosclerosis, obviously the notch that will be seen will be only in bone conduction, and that is called as Carhart's notch. Okay, fine. This is the second most important type of clue that they will give you as far as otosclerosis is concerned. Third important curve. अगर आपको किसी भी audiogram में चढ़ती हुई curve मिली, if you see a laddergram audiogram where the things are rising, this is called as a rising curve. हमेशा audiograms में falling curve दिखती है, but ये एक unique audiogram है जिसमें rising दिख रही है, right? So this is called as a rising curve on pure tone audiogram. And what is seen in cases of rising curve? जब भी rising हो, your answers should become Meniere's disease. So Meniere's disease में there is a rising curve on pure tone audiogram, and that is usually seen in cases of higher frequencies. And there will be a lower frequency sensorineural hearing loss. You see that the lower frequencies it is dipping, and at the higher frequencies it is rising. This is because of the phenomena of recruitment. This is because of phenomena of recruitment. अब क्यों ये राइज करती है, दैट इज एन इंपॉर्टेंट पार्ट. और रिक्रूटमेंट क्या होता है, दिस इज ऑल्सो एन इंपॉर्टेंट क्वेश्चन. रिक्रूटमेंट का मतलब क्या होता है कि आई हैव गॉट हेयर सेल्स इनसाइड माय कॉक्लिया. मेरे कॉक्लिया के अंदर हेयर सेल्स हैं, बहुत सारे हेयर सेल्स हैं मेरे कॉक्लिया में, राइट? एंड व्हाट हैपेंस इन मीनियर्स डिजीज इज कि कोई भी कॉक्लियर पैथोलॉजी में हेयर सेल्स स्टार्ट टू डाई, हेयर सेल्स मरने लगते हैं. In any particular disease, hair cells start to die in the cochlea. So if it is a cochlear disease like Meniere's, hair cells will start vanishing. अब हेयर सेल्स अगर जाएंगे, so what happens is there is a phenomenon of recruitment which is seen in cochlear disorders. उसका क्या मतलब होता है? इसका मतलब ये होता है, let's say I have got 10 friends, right? और उनमें से 5 लोग मार खा के जा चुके हैं. Okay, I sent them to fight, but now they are no more. They have gone. अब बचे 5 लोग. तो now 5 of us who are remaining, in order to compensate the function of the lost 5, we will work double. तो पहले 10 हेयर सेल थे, अब उनमें से 5 बचे हैं, तो अब उनको कॉम्पनसेट करने के लिए ये 5 हेयर सेल डबल काम करेंगे. और अगर ये डबल काम करेंगे, so obviously they will become very sensitive. So now when they become very sensitive, suddenly the patient of Meniere's disease will start to hear a little louder. And if the patient hears a little louder on pure tone audiometry, you will see that there is a rising curve. That is why recruitment में rising curve मिलती है, because you will say that it is a hearing disorder. Sensory neural hearing loss होना चाहिए. फिर rising curve क्यों मिल रही है? That is an important point, right? Now, if the patient continues to have Meniere's disease for some amount of time, this particular curve will become flat. क्योंकि अब हमारे बचे कुचे hair cells भी काम करना बंद कर चुके हैं. And if all the hair cells are gone inside the cochlea, then you will get a sloping curve. That means in the late stages of Meniere's disease, I'll show you, you will get a sloping audiogram. नीचे गिर गया. Why? Because now no more hair cells are left. In the mid stages, you will get plateau curve. It will be straight. In the earlier stages, because of recruitment, क्योंकि double काम कर रहे हैं hair cells, you will get a rising curve on a pure tone audiogram. This is an important feature. What do you see in cases of Meniere's disease? Okay, fine. अब इसी से related देखो, what is this? You can say that this is the opposite of what I showed you in Meniere's disease. यहाँ पे the audiogram is not falling. यहाँ पे गिर रहा है, right? And when the audiogram is falling, तो आप ये देख रहे हो कि इसमें air conduction भी गिर रहा है, इसमें bone conduction भी गिर रहा है, and दोनों साथ साथ गिर रहे हैं. अगर दो लाइनों के बीच में कोई गैप नहीं मिलता, remember this, if you don't remember bone conduction, if you don't remember air conduction, if they have given you an audiogram और आपको लग रहा है कि bone conduction, air conduction साथ साथ गिर रहा है, साथ साथ मतलब sensory neural, S for साथ साथ, S for sensory neural. तो ये कौन सा टाइप का hearing loss हुआ? This is sensory neural. You don't have anything as a gap between them. If there is a gap or an airborne gap, that will be conductive hearing loss. That's an important part between the two. So now this has got no airborne gap between it. So this is sensory neural hearing loss. Sloping type of audiogram is seen in which type of disease? अगर sloping मिलता है, what we should consider? Sloping audiograms are a characteristic of presbyacusis. Presbyacusis का मतलब that it is age-related hearing loss, right? Ototoxicity. अभी हम आएंगे ototoxicity पे. That is something which is related to certain drugs which produce hearing loss. Vestibular schwannoma, which is a nerve tumor, the eighth cranial nerve tumor, that produces sloping curve. Late Meniere's disease, which I already told you just now, will also be producing this particular type of scenario. तो जब भी sloping audiogram है, कुछ important differential diagnosis को लेके चलना है, and this is what you should know about. Okay, fine, चलो. Now let's move on to another important thing. This is something which is very important. This is asked, and this is your impedance audiometry. Impedance audiometry में we test for two things. One is called as compliance. One is called as pressure. Compliance का मतलब कितना tympanic membrane move करती है. Pressure मतलब middle ear में क्या pressure है in order to match that compliance, right? Now let's say this is the centermost point of the pressure curve. ये बिल्कुल center में. If a patient has got normal mobility of tympanic membrane at normal pressure, we call this curve on impedance audiometry as A curve. A curve का मतलब normal pressure, normal compliance. ये normal होता है, right? But the most famous question of your FMGE is, what is AS curve seen in? AS curve क्या होती है? AS मतलब same pressure, normal, but compliance has reduced. मतलब compliance मतलब now the tympanic membrane has become stiff. उतनी नहीं चल रही. If the tympanic membrane has become stiff and it is not moving, मतलब उसमें कुछ ना कुछ sclerosis हुई है, because it is not moving. So S for sclerosis, you can remember AS. S for sclerosis. Sclerosis कौन सी होती है? Either it could be otosclerosis or it could be tympanosclerosis. That means if you see any particular option जिसमें दिया हुआ है otosclerosis, tympanosclerosis, what type of curve you will see on impedance audiometry? You will see AS type of curve. आँख बंद करके. Okay? अब देखो दूसरा क्वेश्चन. दूसरा क्वेश्चन है, if you see at the same pressure, if you see a curve which is like this and not closing, बंदी नहीं हो रही, that means the compliance of the tympanic membrane बहुत ज्यादा हो गई है, बहुत ज्यादा tympanic membrane move कर रही है. That means what? This is called as AD curve. D का मतलब discontinuity, mnemonic. Discontinuity मतलब ossicles are discontinued. Malleus incus stapes एक दूसरे के साथ नहीं है. Now if the malleus incus stapes एक दूसरे के साथ नहीं है, so obviously your tympanic membrane will become hypermobile. So that is called as ossicular discontinuity. What will you see? You will get AD curve. S curve sclerosis, D curve discontinuity. ये कभी बंद नहीं होती. Now let's say you get a patient जिसका प्रेशर नेगेटिव हो गया है बट कंप्लायंस नॉर्मल है जितनी पहले थी, बट प्रेशर टुवर्ड्स नेगेटिव साइड आ गया. ये नॉर्मल है, तो ऑब्वियसली दिस इज लेट्स से -200. ये नॉर्मल, ये नेगेटिव की तरफ आ गया. Which condition produces negative pressure inside the middle ear? Obviously एक ही condition है जिसमें negative pressure होगा जब eustachian tube block हो जाएगा. So that means if the eustachian tube gets blocked, there will be negative pressure, and that will produce which curve? You will get a C curve. अब C को remember कर लो E की तरह. Eustachian tube में मिलेगी C curve. C curve will be seen in eustachian tube blockage. Okay. Now let's come to the last curve. What you will see. Last curve is that let's say your tympanogram is showing something like a flat line. बिल्कुल flat है. अब F मतलब flat. Flat curve को हम लोग कहते हैं B curve. Now how I remember it, flat मतलब बिल्कुल flat या तो fluid की वजह से होगा या फिर there will be some kind of a फटा हुआ eardrum. फटा हुआ eardrum का मतलब perforation. So flat matlab F is seen in fluid, that is otitis media with effusion, or it will be seen in फटा हुआ eardrum, that is perforation. तभी हम लोग की compliance नहीं नापी जा सकती. It will not be able to get the compliance. That is why we say that we get B curve or a flat curve in these two conditions. Bas, that's it. That's what you need to know as far as these audiograms are concerned. Chalo. Now I move on to more important questions. अब आते हैं next question, that is BERA. Right? What is the mnemonic for auditory pathway? Auditory pathway का mnemonic है 𝐒𝐂𝐿𝐼. यानी whatever our sound is traveling, it is traveling from the 8th cranial nerve to the cochlear nucleus, then goes to olivary complex, then it goes to lateral lemniscus, then it goes to inferior colliculus, then it goes to medial geniculate body, and finally it goes to the auditory cortex. 𝐒𝐂𝐿𝐼, ये हमें सब पता है, right? This is our auditory pathway. What is BERA? Brainstem evoked response audiometry. मतलब जब भी कोई बच्चा आता है हमारे पास, when they are a newborn बच्चा, we need to test them for their hearing. हम उनको क्या करते हैं? We put certain electrodes over their vertex, right? उनको एक sound देते हैं. That sound goes through the whole auditory pathway and it is caught by these electrodes, और हम इस auditory pathway की electrical activity को एक graph बनाते हैं. Whatever the sound is traveling, whatever electrical activity is happening at these areas, it will form a graph. And the BERA will have 7 waves. You can see these are the 7 waves which are produced by BERA. Right? अब important question क्या आता है कि BERA की waves की interpretation क्या होती है? What corresponds to what segment of BERA? तो BERA के लिए how we need to remember, अब ये आपकी books में गलत दिया हुआ है. This is something which is wrong in many of your textbooks. How you should remember what wave of BERA is corresponding to which site? You should remember 𝐒𝐂𝐿𝐼. 𝐒𝐂𝐿𝐼. Right? So that means this is first wave, second wave, third wave, fourth wave, fifth wave, and sixth and seventh wave. These are the corresponding elements कि कहाँ से ये waves बनती हैं. Now what is E? E means 8th nerve. So 8th nerve का distal part, the distal part of 8th nerve will form the first wave. The distal part of the first nerve will form the wave 1. That is an important part. Now comes the second important one, ये भी E है. So this is also the 8th nerve, but this is the proximal portion of the 8th nerve when it is entering inside into the brainstem. तो जब वो cochlea को छोड़ती है, the 8th nerve, that is the distal segment, that will form wave 1. The proximal segment of the 8th nerve will form the second wave, EE. Right? Now comes CO. C is forming third wave. C का मतलब हुआ cochlear nucleus, wave 3. Right? फिर आ गए हम लोग O. O is olivary complex, which is forming wave 4. Then comes L, lateral lemniscus, is the one which is forming wave 5. And 6 and 7 is contributed by the inferior colliculus. The auditory cortex and the medial geniculate body usually do not contribute in BERA wave formation. This is an important point, जो बहुत सारी books में गलत लिखा रहता है. Okay? Now, one important segment that you need to understand, इनमें से कौन सी wave सबसे important है हमारे लिए BERA में, जो देखनी बहुत जरूरी है. The most important wave that will be seen in BERA, in this case, will be the 5th wave. 5th wave is the most consistent wave on BERA. ये जो wave है, you can see it is the tallest. This is the most consistent wave on BERA जो हमें हमेशा देखनी चाहिए. This is an important part, and these are the subsites of BERA और कौन सी waves होती हैं. Right? Now I'll come to important MCQs related to BERA, and these are all as it is what they have asked. Neonatal hearing loss में सबसे important parameter for audiogram कौन सा है? Audiometry में सबसे अच्छा neonatal hearing screening में कौन सा parameter है? We take BERA as the best audiometric test for neonatal hearing screening. That is the first important MCQ. Second important MCQ. What is the most important hearing test to rule out malingering? Malingering मतलब झूठ बोलना. We also call malingering as non-organic hearing loss. That means कोई problem नहीं है, patient is telling a lie that I cannot hear. What is the best test to rule that out? It is always BERA, best audiometric test, right? Which is the best audiometric test to rule out any vestibular schwannoma, yani retrocochlear pathology, or any pathology that is occurring in the 8th nerve. That also answer is BERA, right? What is the best important audiometric analysis which gives us the difference between whether it is cochlear or retrocochlear pathology? That also is BERA. ये सारे important tests are for BERA. ये सारे important questions are from BERA. And बस इसमें सबसे important चीज है that this is the most important neonatal hearing loss की screening के लिए test. That is the most important question. Okay? Now, one more important question is otoacoustic emission. We have read about otoacoustic emission, right? Otoacoustic emission क्या होता है? Now we have got hair cells which are present inside the cochlea. Hair cells are creating certain emissions. वो अपने वो हिलते रहते हैं. Hair cells inside the cochlea are dancing. They are always in motion. Now these hair cells, when they are in motion, they create some kind of a potential. ये हमेशा potential निकलता रहता है from these hair cells, from the cochlea, from the inside. And this potential which is getting created from the inside by these hair cells, when we catch them outside by a probe, we call them as otoacoustic emissions. So अगर सोते हुए बच्चे में we put some machine so that these hair cell motions can be caught and the potentials can be caught and we can interpret them, that is called as otoacoustic emission. Important question क्या आता है? That otoacoustic emission is what created from? Is it created from the inner hair cells or is it created from the outer hair cells? The outer hair cells are the ones which create the otoacoustic emissions. Okay, right. Now, Nazar is asking that you have read somewhere that neonatal screening के लिए OAE use करते हैं. Yes, of course, neonatal screening के लिए OAE use करते हैं. But which is a better test between OAE and BERA? Obviously, it is BERA. Right? So, neonatal hearing screening के लिए we use both the tests. But ultimately, BERA becomes a better choice of diagnostics above OAE. That is something we should know about. Okay, fine. Chalo. Now, let's come to certain important diseases or उनके नाम. Right? This is something that you should remember about. There are certain diseases which you should remember as they are asked. First important disease is boxer's ear. किसको कहते हैं? So you must have heard कि कोई boxing कर रहा है, they get boxed over the ear, right? Hematoma of the pinna is called as boxer's ear. इसे हम लोग wrestler's ear भी कहते हैं, right? What is exactly this hematoma oris? This is something which happens because of the blood collection between the pinna cartilage and the perichondrium. Okay, so let me just give it to you over an insight that what is the cartilage of the pinna made up of? What is this made up of? What is this cartilage made up of? That is an important part. This is an elastic cartilage, what your pinna has, right? So elastic cartilage is there in the pinna, correct? So you have got an elastic cartilage that is present over on the pinna. And elastic cartilage के ऊपर एक covering होती है. We call the cartilage covering as the perichondrium, right? We call it as perichondrium. Now remember one thing, that this perichondrium is the one which is containing all the blood vessels, which is containing all the important blood vessels, right? Okay. Now, one important question that comes is, agar suppose किसी को चोट लग गई, somebody has boxed the ear, what will happen? These particular vessels will get injured, right? And what will happen? Blood will start collecting in this area. Blood will start collecting in this area between the cartilage and the perichondrium. There will be a lot of blood that will collect between the cartilage and the perichondrium. And what will happen? Ultimately, this perichondrium will get lifted up. ये ऊपर चली जाएगी. This perichondrium will get lifted up. And blood will accumulate between this. So what is hematoma oris? Hematoma oris is basically a collection of blood beneath the perichondrium and the cartilage. That's what is hematoma oris, right? Now, how do we treat this? Obviously, we need to drain it out. So we do incision and drainage. Jitni jaldi ho sake, we need to do incision and drainage. If we don't do it, then this particular area will get consolidated and it will get fibrosed. अगर हमने blood नहीं निकाला, all this area will become fibrosed. यहाँ पे बहुत सारे fibers बन जाएंगे and it will form a sequelae which is called as cauliflower ear. That is called as cauliflower ear. So untreated hematoma oris will form what? It will form something called as cauliflower ear. ये ऊबड़ खाबड़ type का बन जाएगा. The pinna will become a very curl type of a pinna. It will become distorted. What is that called as? That's called as a cauliflower ear, which is a sequelae of untreated hematoma oris. Okay. Now, as it is, what they have asked is that what is perichondritis? Perichondritis means that if this perichondrium of the pinna gets inflamed, if this gets inflamed, it's called as perichondritis, right? Okay. Now, perichondritis may, what is the most common cause of perichondritis? You must have seen a very common practice nowadays कि लोग यहाँ पे piercing करा लेते हैं, right? So, piercing or trauma is one thing which is the most common cause of perichondritis. ये as it is question आया है. What is the most common cause? So, it has to be trauma. Trauma कौन सा? Piercing trauma. Now, obviously, the only place that is why you pierce is the lobule, क्योंकि lobule पे कोई cartilage नहीं होती. That is only fat. Right? Okay. Now, what exactly is the commonest organism that will be causing perichondritis? This is also very important. So, cause is again trauma. Organism is Pseudomonas. Pseudomonas loves our ear. That is why cartilage की invasion भी Pseudomonas सबसे ज़्यादा करता है. तो perichondritis सबसे ज़्यादा कौन cause करता है? Pseudomonas cause करता है. What is the drug of choice for Pseudomonas? एक चीज जो हर जगह कॉमन है, you must have seen Pseudomonas के साथ एक ड्रग हमेशा आता है. Wherever you read ENT, Pseudomonas के साथ ये ड्रग लगा होगा. You always remember ciprofloxacin. Ciprofloxacin is the drug of choice for Pseudomonas. Ciprofloxacin loves Pseudomonas. Okay, so wherever you read Ciplox, you have to have Pseudomonas with that. Okay. Now somebody asked me about antibiotics. We have to give hematoma में antibiotics because of the fact that there can be secondary infection in that. But the primary treatment is not antibiotics. The primary treatment is incision and drainage. We can add antibiotics. But primary treatment of perichondritis is antibiotics alone. Okay, fine. Chalo. Now we come to furuncle. Furuncle क्या होता है? That is a boil. A boil that happens over in the cartilaginous part of the external auditory canal. That is called as a furuncle. Right? It is also called as localized otitis externa. यहाँ पे एक boil निकल आया. That is called as furuncle. Most important cause of furuncle, it has to be Staphylococcus aureus. That's it. यही question पूछा गया. That's it. They have not asked anything. Right? Thank you, Kushag. Thank you. Okay. Now we come to next question. Diffuse otitis externa. Diffuse otitis externa का मतलब क्या हुआ? पूरी external auditory canal पूरी तरीके से inflame हो गई. अब ये पूरी external auditory canal inflame हो चुकी है. Right? Now, whenever the whole of your external auditory canal gets inflamed, उसको हम लोग क्या कहते हैं? वो कहते हैं हम लोग telephonist ear. We call it as telephonist ear. जो लोग बहुत ज़्यादा टेलीफोन पे बात करते हैं, right? बहुत hot हो जाता है, humid हो जाता है this area. So, if there is diffuse inflammation of the external auditory canal, we call that as telephonist ear. Right? We also call this as tropical ear क्योंकि hot और humid climate में होता है, tropical climates में होता है. We also call it as swimmer's ear because swimming में भी there's a lot of humidity that is there in the external auditory canal. पूरी external auditory canal becomes inflamed together. These are the three names what you see in diffuse otitis externa. अगर आपसे पूछा जाए what is the most common organism for diffuse otitis externa, it has to be Pseudomonas. Right? Nazar is saying that obviously if I'm talking to my girlfriend, then obviously you will get diffuse otitis externa. It's quite prominent. बहुत सारे लोग आते हैं इसको लेके. Okay? But especially in the hot and humid climates. चलो. Now you come to another important question. एक और important question और इसका major external auditory canal के question यहीं से आते हैं. Otomycosis. Right? Otomycosis क्या है? Otomycosis means fungus inside the external auditory canal. Right? If there is fungus inside the external auditory canal, what is the most common fungus? सबसे common fungus is Aspergillus niger. Aspergillus niger. This is our most common fungus, right? दूसरा important fungus, Candida albicans. अब Aspergillus is obviously black in color, क्योंकि Niger है, Niger means black. Candida is curdy white. तो अगर कुछ भी curdy white दिखेगा external auditory canal में, it is called as Candida. अगर कुछ भी black filamentous colonies दिखेंगी, that will be Aspergillus niger. These are the most common causes for otomycosis. Right? Now, अगर कोई भी चीज white है और black है, तो वो दोनों मिलके क्या बताएंगे? They will form an appearance which is called as wet newspaper appearance. एक सीधा साधा question. What they have asked is, where do you see wet newspaper appearance? Black and white. So obviously you see it in otomycosis. But this is all that you need to remember as far as this particular external auditory canal conditions are concerned. But अभी थोड़ी और है, थोड़ी सी और है. One important question is about a syndrome. This is called as Ramsay-Hunt syndrome. ये भी बड़ी important question आता है. What is Ramsay-Hunt syndrome? Ramsay-Hunt syndrome has got a very important infection which occurs because of herpes zoster virus. It is called herpes zoster virus. इसीलिए इसका नाम होता है herpes zoster oticus. We also call that. Right? So herpes zoster virus में होता क्या है? You see three things over. Okay? और यही एक चीज हुई थी जस्टिन बीबर के. If you understand, Justin Bieber is a very famous singer and he came over online और उसके हुआ क्या था? He had got ipsilateral facial palsy. He had got blisters over the whole external ear, right? And he had severe ear pain. तो otalgia या severe ear pain together with blisters together with unilateral lower motor neuron facial palsy, ये तीन मिला के बनाते हैं एक syndrome that is called as Ramsay-Hunt syndrome. ये triad है Ramsay-Hunt syndrome का. Okay, हाँ वही baby वाला Justin Bieber. Okay, that he's the one. Correct. Now we come to the next one, right? Now we come to what is malignant otitis externa. अब इसमें हर चीज question है. This is one of the most common topics that are hit in today's papers. Please have some kind of patience in reading this. ठीक है? Malignant otitis externa का पहला important question. पहला question है, what is the most common cause for malignant otitis externa? सबसे important cause of malignant otitis externa is Pseudomonas. Again Pseudomonas. Most common cause of malignant otitis externa is also Pseudomonas. Second important question. जब भी आपको malignant otitis externa की history देंगे, they will always tell you an old man who's in 50s or 60s who has diabetes. This is a condition which usually hits diabetes, or you can say immunocompromised host. If the immunity of the host is compromised, then you can call this particular condition to be more, right? और कौन सा organism hit करता है? It is Pseudomonas. Okay. Now, very important is this is also called as necrotizing otitis externa or necrotizing osteomyelitis, or we can also say it as skull base osteomyelitis. ये सारे इसके नाम हैं. Skull base osteomyelitis, necrotizing otitis externa, necrotizing osteomyelitis. These are all synonyms for malignant otitis externa. Don't get confused. Okay, fine. Now, इसमें आपके पास कैसे patient आएगा? The patient of malignant otitis externa जो आएगा, they will be diabetics. They will have severe ear pain and they will have purulent foul smelling ear discharge. तो अगर आपने ये देखा कि डायबिटीज के बारे में बात कर रहे हैं, फाउल स्मेलिंग डिस्चार्ज है एंड द पेशेंट इज हैविंग सीवियर ईयर पेन, थिंक अबाउट इन द लाइंस ऑफ मैलिग्नेंट ओटाइटिस एक्सटर्ना, राइट? ओके. नाउ वन थिंग दे हैव आस्क्ड इज कि अगर आप इसमें ओटोस्कोपी करेंगे, इफ यू गो एंड सी इनसाइड, आपको क्या दिखेगा? तो अगर आप इनके अंदर इफ यू डू एन ओटोस्कोपी, व्हाट इज द हॉलमार्क साइन? So if this is your external auditory canal and this is your tympanic membrane, this is the outside pinna, what you will see is that at the bony cartilaginous junction, you will see granulation tissue. There will be granulation tissue at the bony cartilaginous junction. As it is, याद कर लो. This is something which is very, very important and this is a hallmark feature. अब इसमें याद रखना, they will tell you TM is normal. So don't think about middle ear diseases. They will tell you कि ये discharge external ear से आ रहा है. This is not something. अगर TM normal है, think about कि external ear के बारे में बात कर रहे हैं. Right? So there will be granulations at the bony cartilaginous junction, which will be a hallmark sign for this particular disease. Okay? Now we come to the next one. What is the investigation of choice? अब एक problem होती है that this particular disease is bone erosive. ये bone को erode करती है. ये bone को खाती रहती है. This erodes the bone. And when it erodes the bone, obviously there is a very, very important nerve which is running next to it. कौन सी nerve run करती है? Close to our external auditory canal, close to our middle ear. What is that important nerve? That important nerve is our facial nerve. That is why you can also find facial paralysis in these cases. Patient may also come with facial palsy because it is a very, very important nerve which is running next to our external auditory canal and our middle ear. Right? Okay. So you will have granulation tissues over in the bony cartilaginous junction, right? And it is a bone erosive process. ये bone को erode करती है. It can even cause cranial nerve paralysis. Okay. What is the investigation of choice? अगर हमें bone erosion देखना है, तो obviously हमें क्या देखना पड़ेगा? We need a bone scan. And what is the name of that bone scan? The bone scan name is Technetium 99 bone scan. This is the investigation of choice to see for malignant otitis externa. क्योंकि हमें bone erosion देखना है. Simple, right? अब एक important question जो आता है कि once we start the treatment, what will we do for follow-up? Follow-up में कौन से important parameters या follow-up में कौन से important scans important है, ये पता करने के लिए whether the patient is becoming fine with our treatment or not. Right? So for follow-up of patients, we do gallium citrate scans as well as ESR and CRP level. मतलब gallium citrate scan is used on follow-up. फॉलोअप पे अगर हम गैलियम स्कैन करेंगे एंड इफ वी सी की बोन इरोजन नहीं दिख रहा है, इन्फ्लेमेशन कम हो गया, दैट मींस पेशेंट इज इंप्रूविंग इन ट्रीटमेंट. ईएसआर एंड सीआरपी आर ऑब्वियसली acute phase reactants. They will come down the moment the disease has come down. Right? So that is the reason अगर आपसे पूछा जाए what among the following will you choose for follow-up? Answer is gallium citrate scan or ESR and CRP levels. What is the following you will choose as the investigation of choice to see bone erosion? Answer is Technetium 99 bone scan. What is the organism? Pseudomonas. What is the most common person who will get it? Diabetes mellitus. These are the important questions that are related to malignant otitis externa. Right? अब इसमें मुझे खुद सोच के बताओ that if Pseudomonas is the most common cause which is causing malignant otitis externa, what has to be the drug of choice? Think and tell me. I'll just wait for your answers. Okay. Now let me come to bullous meningitis. एक और important cause, एक और important external auditory canal condition. Bullous meningitis मतलब suppose you have got a tympanic membrane. This is your tympanic membrane. इसके ऊपर बुल्ला टाइप के लीजन बन गए. There are बुल्ला का मतलब they are like blisters. Right? So blisters will form over the tympanic membrane. उसे हम कहते हैं bullous meningitis. Meringa मतलब eardrum, itis मतलब inflammation. So if there's inflammation of the tympanic membrane with formation of vesicles, we call it bullous meningitis. Bullous meningitis का सबसे common organism is a question that has been asked once. It is Streptococcus pneumoniae. ये important question है. Right? Correct. So already you guys have answered. It is ciprofloxacin. So malignant otitis externa में drug of choice ciprofloxacin. जहाँ मिले Pseudomonas, ciprofloxacin. That is what the answer should be. ठीक है? चलो. Now we move on to something more important. अब आते हैं favorite question of middle year. ASOM. Acute suppurative otitis media. When we say acute suppurative otitis media, इसमें सारे questions हैं whatever I have marked in black. Right? What is the most common infection of the middle ear? सबसे common infection कौन सा है middle ear में? It has to be ASOM. How does it happen? It happens through the eustachian tube. So acute suppurative otitis media will get spread through what? The organisms will get inside the middle ear through the eustachian tube. That is the first important MCQ. Second important MCQ is what is the most common organism which causes ASOM? Answer is Streptococcus pneumoniae, which is the most common organism which causes ASOM. These are as it is questions. We don't need to discuss much about them. Yeah, as it is, हमें याद रखने हैं. Okay. What are the stages of ASOM? Right? So stages of ASOM are, the first stage of ASOM is stage of tubal occlusion. सबसे पहले our eustachian tube gets blocked because of organisms, right? That is called as stage of tubal occlusion. During the stage of tubal occlusion, obviously जब tube block हो गया, there will be negative pressure inside the middle ear. Because there will be negative pressure inside the middle ear, the tympanic membrane will get sucked in or it will get retracted. So what will you see in stage of tubal occlusion? You will see tympanic membrane retraction. That is an important clue. ठीक? Now let's come to the second point. Second stage of ASOM is stage of congestion. Congestion का मतलब, now there is infection inside the ear, there will be pre-suppuration. Pre-suppuration का मतलब, now all the vessels present inside the middle ear will become dilated. Sari vessels will become inflamed and dilated. And what is that called as? If all the vessels of the tympanic membrane become dilated, they form something like a cartwheel, and this is called as cartwheel appearance. Cartwheel appearance is seen in what stage of ASOM? It is seen in stage of pre-suppuration or in stage of congestion. This is a very, very, very important point. Okay, fine. चलो, अब आते हैं दूसरी चीज पे. What is the next stage? Next stage is stage of suppuration. Suppuration का मतलब अब बहुत सारा अंदर, there is a lot of pus that is formed in the middle ear, and what will happen? The tympanic membrane will bulge out. And this is the point where the patient will have highest grade of fever, patient will have severe ear pain, patient will have complications, patient will have, if there's a child, they can also have seizures or convulsions. Patient will have vomiting. This is the stage where the child is most toxic. सबसे ज़्यादा symptom इसी stage पे दिखते हैं, because of middle ear पस से भरा हुआ है. Right? Now what will happen if this middle ear keeps on developing pus inside? ये pus भरता चला गया. Now at one particular point of time, the tympanic membrane will break away. मतलब tympanic membrane में अब there will be a perforation that will get formed if we don't treat it on time. And if there is a perforation which will form in the tympanic membrane in the stage after suppuration, that will most commonly happen in the anteroinferior quadrant. Anteroinferior quadrant में सबसे common perforations होते हैं ASOM के. ये चीज याद रखना. Why will it happen in the anteroinferior quadrant? क्योंकि ये सबसे important gravity dependent area है. देखो सबसे ज़्यादा gravity इसी तरफ है. That is why सबसे ज़्यादा pressure इसी area में लग रहा है. And that is why the area which will get maximum perforations is the anteroinferior quadrant. So all the pus now will start coming out in the form of pulsations. एकदम ऐसे throw करेगा. It will come out pulsations के form में. मतलब आएगा जाएगा. So when you shine your light over on this, आपकी लाइट भी ऐसे ही शाइन करेगी, आएगी then go, आएगी फिर then it will go. What is this called as? This is called as pulsatile otorrhea, and this sign of pulsatile otorrhea is given the name as lighthouse sign. So lighthouse sign is a sign which is seen when there is a perforation which forms in the most usually in the anteroinferior quadrant of the tympanic membrane, and it throws out all the middle ear pus out, and this is called as stage of resolution. जब resolution हो गया है, जब सारे symptoms अब subside हो गए क्योंकि सारा पस बाहर आ गया. Now 90% cases में ये अपने आप perforation heal कर जाता है. But if this does not heal, then this ASOM will get converted into CSOM. It will become permanent and it will get converted into chronic otitis media. That is what we read as permanent perforation. Right? Okay. So these are the important 4 stages of ASOM. अब इसके साथ एक और stage होती है which is called as stage of complications. If in case this particular ASOM does not get treated, it can end up into a stage of complications. Most common complication of ASOM is mastoiditis. This is also an important question. So most common cause of mastoiditis or most common complication occurring because of ASOM, untreated ASOM, is again mastoiditis. Right? Okay? Chalo. Now we move on to the next one. Now, there is another important question that has once come कि acute necrotizing otitis media क्या होता है? ये बहुत ही unfortunate circumstance होती है. Acute necrotizing otitis media मतलब there is acute infection of the middle ear, but ये necrose कर गया है. It will necrose all the tympanic membrane. It will necrose the middle ear structures. मतलब सारी tympanic membrane, middle ear सब destroy हो जाएगा. This is a very grave condition. ये बहुत ही dangerous condition है. And this happens because of beta hemolytic streptococci. It leads to complete total perforation of the TM. Total perforation का मतलब tympanic membrane पूरी तरीके से destroy हो जाएगी. No pars tensa, no pars flaccida, no annulus. All the ossicles will get destroyed. And where does it happen? It occurs because of beta hemolytic streptococci, which is the most common cause of scarlet fever. तो ये क्वेश्चन आया है, स्कारलेट फीवर में कौन सी among the following कौन सी चीज दिखती है? This is a difficult question that was asked, and that is acute necrotizing otitis media, which is occurring post scarlet fever. Okay, fine. Now it causes a total perforation of the tympanic membrane, right? Now this is the reason why acute necrotizing otitis media also forms one of the primary reason for secondary acquired cholesteatoma. Secondary acquired cholesteatoma का क्या मतलब है? Skin in the wrong place. मतलब अब tympanic membrane चली गई, सारा का सारे स्ट्रक्चर चले गए. So now what will happen? All the skin of the external auditory canal will start migrating inside into the middle ear. And what is that called as? That is called as secondary acquired cholesteatoma. So 2 important questions. किसमें दिखता है acute necrotizing otitis media? It is seen in cases of beta hemolytic streptococci infection, seen in scarlet fever, and what will it lead to? It will lead to secondary acquired cholesteatoma. Okay, fine. Chalo. Now you have got one diagram over here. This is something which is very important, which was asked recently in INI-CT exams also, that what are the incisions called as, right? So these are the incisions for a very important procedure called as myringotomy. Myringotomy का मतलब, otomy मतलब opening, myringa मतलब eardrum, right? So this we usually do in cases of untreated OME or otitis media with effusion या ASOM. जब बहुत सारा अंदर fluid भर जाता है, we need to take that out. So we need to do this myringotomy procedure, right? Now, most commonly, myringotomy में we put an incision in the anteroinferior quadrant. I already told you anteroinferior कैसे ढूंढना है. I told you ये right side की tympanic membrane है. Why? Because it is tilted towards the right. If it is tilted towards the right, so obviously this side is anterior, this side is posterior. Itna I understood, right? This side is the anteroinferior side. And in the anteroinferior side, if I put an incision, which is a straight incision, between the umbo is the attachment of the malleus to the pars tensa, and the annulus, which is the outer rim of pars tensa, iske beech mein if I put an incision, this incision is called as radial incision. So identify the incision. This is radial incision of myringotomy. जो most common incision होता है that we give in cases of otitis media with effusion. अगर in case they give you an incision like this, like a circumference, that is mostly in the posterior-inferior quadrant, क्योंकि ये anteroinferior है, तो obviously this is posterior-inferior. So if you see a circumferential incision in the posterior-inferior quadrant, this circumferential incision is usually given in cases of ASOM. And why do we need to give a bigger incision in ASOM? क्योंकि ASOM का जो पस होता है, that is a little thicker when we need to suction it out, right? This is a little less thicker, तो इसीलिए एक incision बहुत होता है. These are the 2 incisions, circumferential incision versus radial incision. Okay, fine. Chalo. Now we come to what I told you a little before about what is serous otitis media or otitis media with effusion, right? If there is fluid buildup, sterile fluid buildup inside the middle ear compartment, then we call them as non-suppurative otitis media, or we also call that as otitis media with effusion. ये sterile fluid है. It does not contain any organisms. That is why we call that as non-suppurative otitis media. आपको क्वेश्चन क्या आएगा? आपको क्वेश्चन ये आएगा कि देयर इज अ चाइल्ड हु स्कूल गोइंग एंड दैट चाइल्ड हैज गॉट एडिनॉइड हाइपरट्रॉफी, मतलब वो माउथ ब्रीदर है, एंड दैट चाइल्ड हैज सडनली स्टॉप्ड हियरिंग और द टीचर इज कंप्लेनिंग दैट द चाइल्ड इज नॉट हियरिंग प्रॉपर्ली. सीट चेंज करने के बाद भी द चाइल्ड इज नॉट हियरिंग प्रॉपर्ली. आपका आंसर क्या होगा? द मोस्ट कॉमन कॉज ऑफ एडिनॉइड हाइपरट्रॉफी इज यूस्टेशियन ट्यूब ऑब्स्ट्रक्शन, एंड यूस्टेशियन ट्यूब ऑब्स्ट्रक्शन will lead to serous otitis media. So for obvious reasons, this child has non-suppurative otitis media. If we don't treat non-suppurative otitis media, it will become acute suppurative otitis media. In simple words, क्योंकि अब fluid भरा हुआ है, it can get infected, it will form into ASOM. That is why it is the most common cause of reduced hearing in children, and mostly in the school-going children. That is the most important clue here, right? अब मैंने आपको एक और चीज बोली थी कि बच्चों में सबसे कॉमन चीज क्या होती है? बच्चों में सबसे कॉमन चीज होती है adenoid, right? So if we see the nasopharynx में we have got eustachian tube openings. Nasopharynx में दोनों साइड पे there are eustachian tube openings, right? And on one side the eustachian tube is opening inside into our middle ear, right? कौन सी wall of middle ear में eustachian tube opens? Eustachian tube opens in the anterior wall of the middle ear. Anterior wall of middle ear में कौन सी openings होती हैं? ET और TT. Eustachian tube, tensor tympani. ET, TT. दो openings are there in anterior wall of middle ear. So if this adenoid tissue is going to block the eustachian tube opening, तो होगा क्या? If this eustachian tube gets blocked, then there will be fluid buildup inside the middle ear compartment. And if there is fluid buildup inside the middle ear compartment, so you will see these kind of bubble appearance inside behind the normal pars tensa. This is otitis media with effusion. Now, two questions over here. What is the most common cause for otitis media with effusion in children? So obviously it becomes adenoid hypertrophy. What is the most common cause of unilateral otitis media with effusion in adults? It becomes nasopharyngeal carcinoma. Always remember, adenoids are not in adults. Adenoid 12 या 13 साल के बाद atrophy कर जाते हैं. So that is why if you see an adult with unilateral otitis media with effusion, your answer has to be nasopharyngeal carcinoma. But if they are talking about a child, you have to answer about adenoid hypertrophy. Right? This is about the difference between the two and the two case scenarios. Chalo. Now we come to a little more important topic, that is atticoantral disease, right? That is a very important topic, that is cholesteatoma, right? We know that inside the middle ear, if we get skin matlab keratinizing stratified squamous epithelium, we will call that as a cholesteatoma. Skin in the wrong place, right? So if we get keratinizing type of stratified squamous epithelium inside the middle ear compartment, we will call that particular pathology as an unsafe ear, or we will call that as a cholesteatoma. Okay, fine. Now, why is cholesteatoma dangerous? Cholesteatoma is a bone erosive property. Bone erosion matlab ye धीरे धीरे करके bone erode करेगा. That is why it is a very, very important thing that we need to treat surgically on time, right? There are important things why the bone erosion happens in cholesteatoma. Bone erosion in cholesteatoma happens because it releases enzymes like acid phosphatase, collagenase, which have got bone eroding properties. ये cholesteatoma ये enzymes release करता है. That is the reason why it is a very, very dangerous condition, right? Okay. Now, very, very important slide is this, right? And this covers very important questions that come in your FMGE papers. That which theory corresponds to what, right? अब इसमें वो क्या देते हैं कि उसमें they will give you options of 4 theories. और 4 theories में एक theory will not be a theory of cholesteatoma, right? So they will ask you इनमें से कौन सी theory नहीं है cholesteatoma की. Now, primarily, we divide cholesteatoma into 3 types. One is called as congenital cholesteatoma and one is called as acquired cholesteatoma. Acquired का मतलब हम acquire करते हैं after birth. Acquired cholesteatoma is again divided into primary acquired cholesteatoma and secondary acquired cholesteatoma. This is what it is divided into, जो acquired cholesteatoma है, right? Congenital cholesteatoma का मतलब क्या है? Congenital मतलब बच्चा पैदा हुआ है with cholesteatoma, right? So what theory is given for congenital cholesteatoma? The only theory that defines congenital cholesteatoma is called as Levenson's criteria या फिर Levenson's theory, right? And it states that if there is a pearly white mass behind a normal tympanic membrane, अब ये देखो ये normal tympanic membrane है, you can't see anything, but you can see there is some kind of a pearly white mass behind the normal pars tensa. So if they tell you that the child is born with a pearly white mass behind a normal pars tensa and there is no history of ear discharge, otorrhea, there is no history of any otologic procedure, मतलब कोई operation हुआ नहीं है, there is normal pars tensa and pars flaccida, and even if the child had got history of episodes of OME, that does not form the ground of exclusion. That does not form grounds of exclusion. We call that as Levenson's criteria. So if there is a pearly white mass behind a normal tympanic membrane, if the child has got no otologic procedures, if the child has got no history of otorrhea, आपने बस देखा कि इसकी ये white mass है, the answer would be that they are asking about congenital cholesteatoma. Okay, that is the only thing that will come into play. Right? Now, what exactly will become acquired cholesteatoma? Acquired मतलब हम acquire कर रहे हैं after birth. Right? Now, there are two types. One is called as primary acquired. One is called as secondary acquired. अब एक चीज इसमें याद रखनी है. Primary acquired cholesteatoma वो cholesteatoma होता है that basically does not have perforation, does not have discharge. So there is no history of discharge, no history of perforation. So if they give you any clue about कि इसके कोई discharge नहीं था, कोई perforation नहीं था, फिर भी you can see a cholesteatoma, the answer is primary acquired cholesteatoma. If they tell you कि discharge की history थी, perforation भी है, अब cholesteatoma दिख रहा है, then they will be talking about secondary acquired cholesteatoma. So discharge and perforation both are seen in cases of secondary acquired, not seen in cases of primary acquired. Primary acquired cholesteatoma के तीन important theories हैं, Whitmack, Sades and Ruordes. अब इसको याद कैसे करना है? Whitmack theory is retraction pocket theory. It's a theory of retraction pocket, right? मतलब suppose हमारी tympanic membrane ये है, this is our external auditory canal, this is our middle ear compartment, and this is our pars flaccida, this is our pars tensa, and उसके पीछे these are the ossicles. These are the ossicles which are attached. Malleus, incus, stapes. I told you सबसे common area for this particular retraction pocket to form is in the Prusac space. Right? That's what I told you some time back कि Prusac space की boundaries क्या होती हैं. Right? तो अब होता क्या है? What is Whitmack's theory? Whitmack's theory ये कहती है कि अगर suppose eustachian tube की opening block हो गई, तो pars flaccida will form a kind of a retraction inside, which is called as a retraction pocket, and inside this retraction pocket there will be accumulation of certain debris. इसके अंदर keratin debris accumulate करेंगी. This is called as the theory of invagination of pars flaccida. Invagination मतलब देखो pars flaccida अंदर चली गई. This is called as Whitmack's theory, which classifies primary acquired cholesteatoma. क्योंकि देखो इसमें perforation नहीं हुआ है, right? इसमें बस एक retraction बना है. Second theory है Sades metaplasia theory. Sades metaplasia theory क्या कहती है कि अगर constantly infection middle ear में जाते रहे through the eustachian tube, so this whole epithelium that is present over in this area will become metaplastic. Metaplastic मतलब ये अपने epithelium से it will change into squamous. And squamous obviously does not occur inside the middle ear, so that's why that metaplasia has happened, and that is the reason cholesteatoma will form because of constant infections in the middle ear. Right? जैसे ASOM बार बार हो रहा है. So now the middle ear inflammation happened again and again, and that changed one type of epithelium normal into abnormal. That is what is Sades metaplasia theory. And the third theory is called as Ruordes hyperplasia theory. Ruordes basal cell hyperplasia theory ये कहता है कि suppose if this is my tympanic membrane, right? This is the inner part of my tympanic membrane. इसके जो cells है, they will start becoming more and more and more and more. They will start growing inwards. They start growing inwards. The cells will keep growing inwards, and these cells are hyperplastic. Hyperplasia का मतलब number of cells will increase, and that is what is called as Ruordes theory. Right? So basal cell hyperplasia is Ruordes, Sades is metaplasia, Whitmack's is invagination theory. ये primary acquired cholesteatoma की theories होती हैं. When we talk about secondary acquired cholesteatoma, मतलब कि there is a perforation जो बन चुका है. I told you, pre-existing perforation है. तो अगर इसमें perforation बन गया tympanic membrane में, let's say यहाँ पे perforation हो गया, so क्या होगा? Now all the epithelium of the external auditory canal will start migrating inside the middle ear compartment, and they will form a cholesteatoma. So if there is a perforation and now the epithelium is getting migrated inside into the middle ear, we call it secondary acquired. Otherwise, we call it primary acquired. This is what differentiates among all the theories of cholesteatoma. Okay, fine. चलो अब आते हैं एक और इंपॉर्टेंट पॉइंट पे. ट्यूबरक्यूलस ओटाइटिस मीडिया क्या होती है? टीबी हो गई किसी को कान में, राइट? नाउ दिस इज समथिंग व्हिच इज वेरी इंपॉर्टेंट फॉर यू एज फार एज योर एमसीक्यूज आर कंसर्न्ड. इसका निमोनिक है 6P. 6P का मतलब इफ यू गेट एनी पर्टिकुलर क्वेश्चन जिसमें दे टेल यू दैट देयर इज पेनलेस ओटोरिया, पेनलेस, कोई पेन नहीं है ओटोरिया के टाइम पे, There is perforations which are multiple. मतलब tympanic membrane में there will be multiple perforations. Perforations हैं. Second P. Third P, there will be pale granulation tissue. It is a granulomatous disorder. तो इसके अंदर there will be formation of some pale granulation tissues. बहुत सारे छोटे छोटे granulation tissues बनेंगे. They will be pale in color. Okay. Next, persistent discharge even after antibiotics. मतलब कि antibiotic दे रहे हैं फिर भी discharge बंद नहीं हो रहा. Why? Because TB है. TB में सिर्फ ATT काम करेगी. Right? That is why there is persistent discharge. There is palsy of the face. मतलब facial paralysis हो गई. Why? Because it is a bone eroding process. And finally, it has got progressive mixed hearing loss. मतलब conductive hearing loss के साथ साथ there is sensorineural hearing loss. If all these or any of these fit in, we will call that patient to have tubercular otitis media, जिसमें 6P दिखते हैं. Right? So these are the things that you should remember. ये 6P कहाँ दिखेंगे? TB otitis media में क्या होगा? आपको question आएगा कि एक आदमी के you're giving multiple drug treatments but उसका discharge कम नहीं हो रहा है. You see the tympanic membrane, you see pale granulations and multiple perforations. What is the diagnosis? Diagnosis is TB. Simple. Okay? Fine? चलो. अब आगे बढ़ते हैं. Now what is this? Now we come to complications of CSOM, right? What is the most common complication of CSOM? सबसे important, most common complication of CSOM has to be mastoiditis. एक ही complication है जो सबसे common होती है, that is inflammation of the mastoid or mastoiditis. What is the most common cause of mastoiditis? Most common cause of mastoiditis is Streptococcus pneumoniae. That also we know. ठीक है, चलो. अब ये सारे important signs हैं mastoiditis के, सारे questions हैं. ठीक है, whenever the mastoid gets inflamed, तो ये red hot हो जाएगा, red color का हो जाएगा, बड़ा हो जाएगा. It will become red hot. What is called that? If a mastoid becomes red hot, erythematous, we call that as ironed out appearance. Iron की तरह लाल हो जाएगा. Right? What is the second thing? They will have pulsatile otorrhea, which we already spoke. कि जब pulsatile otorrhea होता है, we call that as lighthouse sign. That I've already spoken about. What is reservoir sign? Reservoir sign means now the mastoid is full with pus. When you suction out the discharge will come back again. आपने फिर suction करेंगे, फिर discharge वापस आ जाएगा. This is called as reservoir. Why? Because the mastoid is acting as a reservoir of pus. This is called as reservoir sign. Fourth sign. If the mastoid will become too large, so obviously my pinna will start becoming forward. There will be displacement of the pinna forward. And what is this groove behind your pinna? This is called as retroauricular groove या postauricular sulcus. Now this retroauricular groove will get obliterated क्योंकि अब obviously pinna बाहर आ गया. Pinna will become forward displacement. So obviously now the retroauricular groove will become obliterated. ये बिल्कुल छुप जाएगा. The whole obliteration of the groove will happen. That is the next point which will signify mastoiditis. And it will push my external auditory canal posterior wall. So if there is pressure over the posterior canal wall, let's say this is my external auditory canal, this is the mastoid. So now the mastoid will keep pushing the posterior canal wall anteriorly, and this is called as sagging of posterior canal wall. ये मेरी posterior canal wall आगे की तरफ bend हो जाएगी. That is called as sagging. Why? Because of periosteitis. ये धक्का मार रहे हैं पीछे से. There's a lot of pus behind. It's pressurizing it. That is why there will be sagging of the posterior canal wall. These are the features of mastoiditis. खत्म. Right? Okay? Thank you हर्षित. Thank you. Okay. चलो. अब आते हैं next important पे. Next important thing is Gradinego syndrome. ये favorite है. This is favorite for your FMGE questions. Right? Gradinego syndrome में हमें याद रखना है. What is Gradinego syndrome? It is seen in petrositis. Petrositis मतलब petrous part of temporal bone का inflammation. That is called as petrositis. Right? अब इसमें हमें क्या याद रखना है? We have to understand 3 Ds are there. Gradinego syndrome में 3D दिखते हैं. 3D का मतलब discharge, diplopia, deep-seated retroorbital pain. तो discharge मतलब discharge होता रहेगा, right? Diplopia because of lateral rectus paralysis. ये lateral rectus which is supplied by abducent nerve, it will get paralyzed. So obviously there will be lateral rectus palsy and there will be diplopia, मतलब double vision. And there will be deep-seated retroorbital pain. मतलब आँख के पीछे there will be severe pain that happens because of the irritation of trigeminal nerve. These are the 3Ds. अगर 3D दिखे, we call that as Gradinego syndrome or we also call it as petrositis. ठीक. Next question. What is the most common intracranial complication of CSOM? Most common intracranial complication of CSOM has to be meningitis. Okay? Next question. In what particular situation will you see hectic picket fence fever? Hectic picket fence fever. अब ये याद रखना. Hectic picket fence fever का क्या मतलब है? अब क्या होता है? Let's say this is your sigmoid sinus. This is your sigmoid sinus. Right? Now your mastoid has got a lot of pus, right? Your mastoid has got a lot of pus, और ये pus जाते जाते it erodes the wall of the sigmoid sinus, and when it erodes the wall of the sigmoid sinus, then it will form a kind of a thrombus. It will form a thrombus. Sigmoid sinus के अंदर thrombus बन जाएगा. There will be a thrombus formation inside the sigmoid sinus, right? अगर ये thrombus बन गया, right? What will happen? This is an infective thrombus. इसके अंदर बहुत सारे organisms हैं. So what will happen? In some point of time, ये organisms निकलते जाएंगे. They will keep releasing and they will keep coming into the blood. जब ये blood में organisms आएंगे, suddenly हमारा fever बढ़ेगा, और फिर जब ये our immunity will fight back, fever कम हो जाएगा. फिर again they will be released. These septic emboli will be released. Again the fever will spike up. Again फिर हम ठीक हो जाएंगे. Then again the thrombus will break down. It will again release emboli. Again वो चढ़ेगा. So our fever will be like a picket fence. And this hectic picket fence fever is a classical representation of lateral sinus thrombophlebitis या फिर lateral sinus thrombosis. When I say lateral sinus, I'm talking about the sigmoid sinus, which is also a very common feature in cases of CSOM complications. अब ये thrombus अगर propagate किया, if it keeps becoming bigger and bigger and bigger and bigger, there is a tributary of this sigmoid sinus, and this tributary is called as emissary vein. It's called as emissary vein. This particular thrombus can go and block this emissary vein, and emissary vein drains all this area behind the scalp. So what will happen if there is blockage in this emissary vein? There will be edema that will form over the postauricular area, and we call that sign as Grisenger's sign. Very important question. What do you understand by Grisenger's sign? Grisenger's sign is basically edema over the mastoid area. Why? Because over the obliteration or the thrombosis of the emissary vein, because it is draining this area of the scalp. Right? So Grisenger's sign is a classical feature of what? Grisenger's sign is a classical feature of lateral sinus thrombosis or lateral sinus thrombophlebitis. Okay? So let me just show you if I have that picture. No, I don't have that picture. Okay. So basically this particular area will be inflamed. That is the whole point. This area will become edematous. Grisenger's sign is classically seen in what? It is seen in cases of lateral sinus thrombosis. Chalo. Ab kya hua? Now this mastoid is filled with pus. इसमें बहुत सारा pus है. What attaches to the mastoid? There is a muscle which attaches. This is called as sternocleidomastoid. You can see here, from the mastoid comes down your sternocleidomastoid. ये sternocleidomastoid है, right? Mastoid में एक और चीज जुड़ती है, which is your digastric muscle, which is coming down like this, right? Your posterior belly of digastric and your sternocleidomastoid both are attaching to the mastoid tip, right? So you have got sternocleidomastoid and you also have got the posterior belly of digastric, which is attaching to the mastoid tip. Okay? अब in case अगर ये mastoid tip टूट गई, if it breaks, why? Because there is so much of pressure because of the pus. Now this pus comes out, and now this pus comes into forming an abscess over the sheath of sternocleidomastoid. What is it called as? If there is an abscess over the sheath of sternocleidomastoid, we call that abscess as Bezold abscess. Very important question. तो अगर यहाँ पे आ गई abscess because of CSOM, we will call it as Bezold abscess. अगर ये abscess चली गई towards the posterior belly of digastric, we will call this as Cityle's abscess. We will call this as Cityle's abscess. It has gone to the posterior belly of the digastric. Correct? Okay. Now we come to another important abscess, that let's say now this mastoid abscess, you have got the external auditory canal over here. This is your external auditory canal, right? अगर ये abscess टूट के, it has come into inside the external auditory canal, we will call this as Lux abscess. Lux abscess means intrameatal abscess, मतलब external auditory canal के अंदर पस बन गया. That's called as Lux abscess. Correct? Now, finally, if this goes beyond into the zygomatic process, we will call that as zygomatic abscess. But the most important question that they will ask you is Bezold abscess and Cityle's abscess. Bezold, sternocleidomastoid, Cityle's posterior belly of digastric. Bas, done. This finishes about what are the important complications of CSOM. अब यहाँ पे I have made a huge chart about बहुत important चीजें. This is the whole chart which will finish facial nerve and revision of facial nerve. Right? So how many divisions are there in facial nerve? Facial nerve के important divisions क्या होते हैं? So there is an intracranial part, there is an intratemporal part, and there is an extracranial part. Right? Intracranial part जो कौन से निकलता है? Up till the temporal bone. There is an intratemporal part inside the temporal bone, and when it comes out of the temporal bone, it is called as extracranial part. What they are asking as questions in your facial nerve is intratemporal part के कितने parts होते हैं? The intratemporal part of facial nerve has got meatal segment, that means which is present inside the internal acoustic meatus, labyrinthine segment, horizontal or tympanic segment, and vertical segment. Okay, fine. So you have got internal acoustic canal, right? You have got the middle ear. You have got the middle ear, right? This is your middle ear. So now if the facial nerve is coming inside into the internal acoustic canal, we call this as meatal segment. From when it comes out of the meatus and it goes up till the roof of the middle ear. This is the roof of middle ear. Here it will form an important ganglion called as 𝐒𝐄𝐝 ganglion. So from the meatus till the 𝐒𝐄𝐝 ganglion, this is called as labyrinthine segment. Now this will take a turn and it will come down till an important structure over here in the posterior wall of middle ear, and this structure is called as pyramid. Posterior wall of middle ear में एक structure होता है called as pyramid. So from the 𝐒𝐄𝐝 ganglion till the pyramid, the third segment inside the temporal bone is called as horizontal segment या tympanic segment. And finally behind the pyramid it will descend down as the final portion, और इसे हम कहते हैं vertical segment. These are the four important segments of the facial nerve inside the temporal bone. Meatal, labyrinthine, horizontal and vertical. ठीक है, right? अब important चीज है क्या है कि कितने लंबे ये segments हैं, that is also important. So importantly, inside the meatus it is around 8 millimeters. इसको divide कर दो by half. This labyrinthine will become 4 millimeters, right? This horizontal or tympanic segment is roughly around 11 millimeters and the vertical segment is roughly around 13 millimeters. Okay, fine. अब इनसे question क्या है? The straight away question that they will ask you is, among them which is the narrowest segment of the facial nerve? इनमें से सबसे narrowest और shortest segment कौन सा है? तो shortest तो obviously ये समझ में आ रहा है labyrinthine है. This is also the narrowest segment. Why? Because this segment is only 0.64 to 0.68 millimeters in diameter. That is why likely the first segment to get compressed in any disease. Ramsay-Hunt syndrome, Bell's palsy, सब में, which is the commonest segment to get compressed? It is the labyrinthine segment. Why? Because it is the narrowest and the shortest segment of the facial nerve. Simple, right? So labyrinthine segment, okay, that we have understood. Now this is the narrowest segment and it commonly gets involved in Bell's palsy. This I have already told you. Now comes the next important question that they will ask you in this case. Which among the following is the most common segment to undergo congenital dehiscence? मतलब बचपन से किसके सबसे ज्यादा dehiscence which segment has? The most common segment which has congenital dehiscence is the tympanic segment. This particular segment has got maximum congenital dehiscence. Right? Okay. Now comes the next question. Among them, which of the following is the most common area to get iatrogenic injury? मतलब सबसे common injury किस area में दिखेगी? So the most common segment to get injured during surgery when we do mastoidectomy is actually the vertical segment. The vertical segment. So this is iatrogenic injury. It's actually the second most common area. The first most common area is this bend. When the facial nerve horizontal is bending to form the vertical, this is called as second genu. So second genu is the first most common area to get injured when we do mastoidectomy. Second most common area to get injured during mastoidectomy is the vertical segment of facial nerve. Most common congenital dehiscence is seen in horizontal segment of facial nerve. Most narrowest as well as most shortest area of the facial nerve is the labyrinthine segment, which usually gets compressed during any kind of disease. बस these are the important questions जो आपसे पूछे जाते हैं as far as facial nerve is concerned. और ये सारे question important है, whatever I've told you. Okay? चलो, let's move on. अब importantly एक चीज जो आपसे सीधी सीधी पूछी जाती है, these are the questions which are related to syndromes of facial nerve. सबसे common facial paralysis का cause क्या है? It is Bell's palsy, that we already know, right? If they give you that there is a patient who has got a brainstem lesion with ipsilateral facial palsy, with ipsilateral lateral rectus palsy and contralateral hemiplegia. उल्टी side hemiplegia है, ipsilateral facial palsy hai, and ipsilaterally there is lateral rectus palsy, and they tell you about there is a brainstem lesion. We will call that syndrome as Millard-Gubler syndrome. Okay, these are some things which you need to remember. There are certain syndromes of facial nerve. So this is called as Millard-Gubler syndrome. There is another important syndrome which is called as Melkerson-Rosenthal syndrome. Melkerson-Rosenthal syndrome में तीन चीजें दिखती हैं. That is what? If there is facial palsy, if there is edema of the lips, and if there is fissuring of tongue. Tongue के ऊपर बहुत सारे fissures दिखेंगे, lips will become double in size, and there will be facial paralysis. If they have 3 triad, then obviously it is Mel-Kerson-Rosenthal syndrome. Okay? Now, if this patient has got bilateral parotid swelling, uveitis and facial palsy, then that particular thing is Hereford syndrome, which is classically seen in cases of sarcoidosis. So Hereford syndrome में क्या बताया मैंने? There is bilateral parotid enlargement. There is facial paralysis. Together with that, there is uveitis. We call that as Hereford syndrome. And finally, there is something called as Fraze syndrome. Fraze syndrome means gustatory sweating. Gustatory sweating मतलब जैसे ही चबाएगा खाना, they will start sweating over from the parotid area. That is called as gustatory sweating, which is given the name as Fraze syndrome. Again, these are some things as syndromes that you need to remember, but don't worry about much, because these are the rare questions that are asked. Okay. Chalo. Now we come to another important point, that is otosclerosis. Right? What is otosclerosis? Obviously, an abnormal foci of bone that forms over the stapes foot plate is given the name as otosclerosis. Right? Okay. Now, what is the most common site of otosclerosis? The most common site of otosclerosis is given the name as fistula antifenestrum. The other name is also called as anterior focus. It's also called as anterior focus, or we also call it as fistula antifenestrum. If we divide otosclerotic foci into various types, we can divide otosclerosis into cochlear otosclerosis and stapedial otosclerosis. So on the basis of site, otosclerosis is divided into stapedial otosclerosis and cochlear otosclerosis. Okay. Now what are the types of stapedial otosclerosis? ये सारे important types दे रखे हैं, right? If it is towards the anterior crura, we call it anterior crus. If it is towards the posterior crura, we call it posterior crus. If it is involving the circumference of the stapes foot plate and the annular ligament, we call that as circumferential type. That is the third type. If it is involving the foot plate of the stapes but sparing the annular ligament matlab the area which is surrounding the stapes foot plate, that is called as an annular ligament. If it is not involving the annular ligament, we will call that as biscuit type. And if it involves the whole of the stapes foot plate, it is called as obliterative type. These are the important types of stapedial otosclerosis. इनमें से सबसे common कौन सा है? It is anterior focus. The other name is fistula antifenestrum. Okay, fine. चलो. Now, there is a very important thing that otosclerosis में question क्या आएगा? Whenever you get a reproductive age group female, reproductive age group, always remember 30 to 35 year old की female की history होगी, they will give you bilateral progressive conductive hearing loss. The answer has to be otosclerosis. और इसमें हमेशा कहेंगे the tympanic membrane is normal. तो tympanic membrane normal है, progressive bilateral conductive hearing loss है, and they will ask you about a history of a female in the reproductive age group. ये सारे clues will take you towards one diagnosis. The answer is otosclerosis. Right? Now, there is one important syndrome which is associated with otosclerosis, जिसे हम कहते हैं Van der Hoef syndrome. Van der Hoef syndrome मतलब there is otosclerosis, osteogenesis imperfecta, and the sclera are blue in color. If you get 3 of them, then it becomes Van der Hoef syndrome. Okay, fine. Chalo. Now let's come to what do you see over here. So in otosclerosis, very common question, आपको कौन सा sign दिखता है? In otosclerosis, you see something called as short sign. Short sign का दूसरा नाम is also called as flamingo pink sign. Right? So flamingo pink sign or short sign, what is that? It is presence of otosclerotic pinkish hue. So आपको pink color का area दिखेगा in the posterior-superior quadrant of the pars tensa. If you see a pinkish appearance in the posterior-superior quadrant of the pars tensa, we will call that as short sign, also called as flamingo pink sign. Right? Okay. Now, what is the surgery that is shown over here? This is an important question. Right? So usually, Morpheus is asking, usually they will tell you bilateral, because most commonly otosclerosis is a bilateral disease. It is rarely unilateral. So most commonly it is bilateral because it occurs in both the ears. Okay? Now, they will ask you, what is this procedure? This is a procedure where they are showing that there is a piston. There is a piston which they are putting over the stapes foot plate. This was a recent question in INI-CET also. और जब जैसे ही ये piston लगाता हुआ देखेंगे, the answer is stapedotomy. This is stapedotomy. Okay, stapedotomy is the surgery of choice for otosclerosis. ठीक है? चलो. Now let's come to the next one. Meniere's disease में क्या associated importance है, or what are the things that are asked in Meniere's disease? Let's see that. The other name for Meniere's disease we know is also called as endolymphatic hydrops. Endolymph बहुत सारा भरने लगता है inside into the middle ear, inside the inner ear compartment. That is why it is called as endolymphatic hydrops. Right? Now, largely Meniere's disease का कोई cause नहीं होता. It is an idiopathic disease, right? But whenever there is a secondary cause to Meniere's disease, we call that as Meniere's syndrome. जब भी Meniere's disease is associated with something, we call it as Meniere's syndrome. Okay? So, largely it is idiopathic. Now, important questions in Meniere's disease are what? I told you that these are what is called as endolymphatic hydrops. Right? Endolymphatic hydrops का क्या मतलब है? That your whole of cochlea inside the cochlear duct has got three important compartments: scala vestibuli, scala tympani, and scala media. Scala media is filled with endolymph. Scala vestibuli and scala tympani are filled with perilymph. अगर हमारे endolymphatic production बढ़ गया, अगर ये endolymph starts to increase, ये बहुत सारा बढ़ने लगा, बढ़ने लगा, बढ़ने लगा, बढ़ने लगा. So you can see here the endolymph is keeping on going on, going on, going on, going on. And what will happen? It will bulge out the Reisner's membrane. You can see here, this is your basilar membrane. This is your Reisner's membrane and it will bulge it out. This is called as endolymphatic hydrops. अब एक टाइम के बाद क्या होगा? This Reisner's membrane will actually break. ये एक टाइम के बाद break कर जाएगी. It will break away. And what will happen? This scala vestibuli contains perilymph, which is rich in sodium, and scala media contains endolymph, which is rich in potassium. Right? So now what will happen when the Reisner's membrane will break, ये टूट जाएगी, all the sodium will start getting mixed with potassium, and this toxic fluid is going to start producing death of these hair cells. ये hair cells मरने लगेंगे because they don't want this toxic fluid to come जो जिसमें sodium rich है. That is why the hair cells will lose, and that will lead to sensorineural hearing loss. Okay? Fine. Now, whenever you have got any question regarding Meniere's disease, आपको हमेशा क्या बताया जाएगा? You will get a patient who will be having this kind of a symptom, VDTA. The patient will have vertigo, the patient will have deafness, the patient will have tinnitus, and the patient will have oral fullness. So vertigo क्यों? क्योंकि suddenly when this Reisner's membrane will break away, there will be a release of pressure that will produce vertigo. वर्टिगो होने के बाद डेफनेस आएगी, दैट विल बी सेंसोरी न्यूरल टाइप. देयर विल बी एसोसिएटेड टिनिटस, अजीब सी आवाज आएगी. व्हाई? बिकॉज दीज हेयर सेल्स आर क्राइंग बिकॉज द टॉक्सिक फ्लूइड इज कमिंग एंड बेथिंग देम. एंड दे विल बी एसोसिएटेड ऑरल फुलनेस बिकॉज ऑफ एंडोलिम्फेटिक हाइड्रॉप्स. ये चार सिम्टम हमेशा होंगे. राइट? इन केस अगर आपको ये बोला कि द डेफनेस हैज कम बिफोर वर्टिगो, उल्टा मतलब पहले वर्टिगो फिर डेफनेस नॉर्मल, बट अगर उल्टा डेफनेस पहले आई है देन वर्टिगो, then that answer becomes Lermois syndrome. That answer becomes Lermois syndrome. What is Lermois syndrome? Lermois syndrome का मतलब reverse Meniere's. मतलब now the vertigo से पहले deafness आ रही है. Right? That is something which is very, very important to understand. If they tell you that there is vertigo to a Meniere's disease patient on introduction of loud sounds, that means now there is vertigo to loud sounds. The answer will become Tullio phenomena. Then it is called as Tullio's phenomena, which is also a very important variant of Meniere's disease. If they tell you that in a Meniere's disease patient, suddenly the patient was walking and he fell down suddenly, that means the patient dropped. That is called as Tummarkin's crisis. Tummarkin's crisis is also called as drop attack. Drop attack. Drop attack means suddenly the patient will drop because of the gravitational pull. And this will happen because of the disruption of otolithic membrane जो यूट्रिकल एंड सैक्यूल में होती है. that becomes disrupted, और उसके टूटने की वजह से suddenly you get a pull down, you get a gravitational pull down, that's called as a drop attack. So Lermois syndrome, Tummarkin's crisis, Tullio's phenomena, all are important questions related to Meniere's disease. Okay, fine. चलो, अब इसी के साथ I have got one important, very important MCQ for you. What is the mnemonic for treatment of Meniere's disease? So in simple words, you have got this 10D mnemonic of Meniere's disease. कि कैसे इसको ठीक करते हैं. सबसे पहले we discuss and reassure the patient क्योंकि anxiety बहुत ज़्यादा होती है. So we discuss and reassure. Second is diet restriction, low salt, low water. That is called as diet. Third is you give depressants. That means to depress the vestibular function ताकि चक्कर कम हो. That is basically depressants. Vestibular depressants. कौन से vestibular depressants? We give them cinnarizine, we give them dimenhydrinate, prochlorperazine, promethazine. All of these are vestibular depressants. Okay, they will depress the vestibular function, vertigo ठीक होगा. Next D is dilator. You know that the endolymph is not flowing off. Why? Because the endolymphatic sac has become ischemic. If the endolymphatic sac has become ischemic, you will give certain vasodilators to reverse ischemia. Most commonly used is beta histine. Okay. Next D is do not smoke, because smoke and alcohol creates more vasoconstriction. So you will tell the patient not to smoke, not to take any alcohol. Next is dexamethasone. Dexamethasone is going to be causing decrease in the edema, decrease in the or improving the hair cell function, or decrease in the ischemia of the sac, and that is why we give intratympanic injections of dexamethasone. Next D is diuretics, not commonly used nowadays because of electrolyte imbalance, but diuretics में कौन से आते हैं? Furosemide, right? Bumetanide, furosemide, very commonly used. Next is a device. डिवाइस में आती है समथिंग कॉल्ड एज मिनिएट डिवाइस. मिनिएट डिवाइस क्या होती है? इट इज अ पल्स्ड प्रेशर थेरेपी. हम एक डिवाइस लगाते हैं, वो धीरे धीरे धक्का देती है, सो दैट द एंडोलिम्फ दैट हैज कलेक्टेड इन द स्केलर मीडिया गेट्स अब्सॉर्ब्ड इनटू द सबएरेक्नोइड स्पेस, धक्का मार मार के. दैट इज कॉल्ड एज मिनिएट डिवाइस. ओके, डी से डिवाइस. देन इफ इट डजंट वर्क, देन वी डू सर्टेन सर्जरीज. सर्जरीज में आती है decompression. Decompression of what? Endolymphatic sac. We cut and open the endolymphatic sac. That's called as endolymphatic sac decompression. Finally, you are having destructive procedures, right? Destructive procedures का मतलब we destroy the labyrinth. हम labyrinth ही खत्म कर देते हैं. That's called as total labyrinthectomy. Or either we inject something with like a chemical or a drug which is called as chemical labyrinthectomy. कौन सा drug use करते हैं for doing labyrinthectomy? It is gentamicin. Gentamicin is a drug of choice for doing chemical labyrinthectomy. Okay, thank you Harshit, thank you for all these motivation things that you're writing. Thank you so much. Okay, just stick to whatever I'm telling. I know it's a huge lecture, but it wraps up whole your ENT. Okay, ये आज का यही motive है. Okay, right? Okay, now PTA I have already discussed in the previous segment. You can recap. PTA में सारे discuss कर चुका हूँ. सारे PTAs whatever I have told, Menias का भी we have discussed. चलो, Now we come to ototoxicity. अब देखो ototoxicity से related symptoms. क्या drugs होते हैं? Mnemonic ACD. ठीक है, सबसे इंपॉर्टेंट ड्रग जो आएगा अमीनोग्लाइकोसाइड्स, राइट? सो अमीनोग्लाइकोसाइड्स में दो टाइप के ड्रग होते हैं. वन इज कॉक्लियोटॉक्सिक, वन इज वेस्टिब्यूलोटॉक्सिक. अब कॉक्लियोटॉक्सिक में निमोनिक है कान में कान ही होगा, राइट? सो KAN आर कॉक्लियोटॉक्सिक, सिर्फ कॉक्लिया को डैमेज करेंगे. वेस्टिब्यूलोटॉक्सिक मतलब सेमीसर्कुलर कैनाल वेस्टिब्यूल को डैमेज करेंगे. सो कान से कान, सो कॉक्लियोटॉक्सिक. दिस इज कानामाइसिन, एमिक एसिड एंड नियोमाइसिन. ये हो गए कॉक्लियोटॉक्सिक ड्रग्स. अब आते हैं वेस्टिब्यूलोटॉक्सिक, मतलब वेस्टिब्यूल को डैमेज करने वाले. उनके कौन से ड्रग होंगे? दे विल बी निमोनिक, नो GST. ठीक, नो GST में आ गया नेटलमाइसिन, you have got gentamicin, you have got streptomycin and tobramycin. No GST. उसमें आया कान. So cochleotoxic versus vestibulotoxic drugs are the ones which are very common to ask in your FMG. वो कहेंगे which of the following is not a drug which causes vestibulotoxicity. So they will give you these options. ठीक है? Now other than that, ACD में others are analgesics. Analgesics में आ जाएगा aspirin. Antimalarial उसमें आ जाएगा quinine, right? And in C, you have got cytotoxic drugs, या chemotherapy drugs होते हैं, that is cisplatin. Okay. Then you have got, one second. Then you have got chelating drugs such as desferrioxamine. And finally D for diuretics, जिसमें सबसे common होता है furosemide. ये सारे के सारे drugs करते हैं ototoxicity और damage to our inner ear compartment. बस सबसे important हमें ये दो याद रखने. ठीक है? Thank you हेमंत. Thank you. चलो. So ये हमने पता कर लिया. Now we have understood a lot of chapters about ear. अभी हम ear में ही हैं. So we are finishing about most of the things. अब ये क्वेश्चन आपके नीट PG में भी अभी आया था and it was also in the INI CET. उन्होंने आपसे ये पूछा था that there was a patient, अब ये ध्यान से सुनना, there was a patient who got sudden vertigo on changing position or on suddenly getting up from the bed. अगर कोई भी डिजीज में आपको ये बोला जाए that a patient is getting up from the bed and suddenly उसके कुछ चक्कर आ रहा है, that episode is lasting for almost 10 to 15 seconds and then it goes away on its own. Answer is benign paroxysmal positional vertigo. They will tell you position change. They will tell you this vertigo only lasts for 10 to 15 seconds. उससे ज़्यादा नहीं. Because it is the most common cause for vertigo. So they will only have a history of a few seconds. और वो हमेशा history positional होगी. तो जब भी ये होगी, your answer should become What is there? The answer is BPPV. What is the most common canal that gets involved in BPPV? The most common canal that gets involved in BPPV is posterior semicircular canal. सबसे common BPPV इसी canal का होता है. Okay, fine. Now, there are two ways to it, right? Now, what is the diagnostic way in which we confirm BPPV, right? Diagnostic way is Dix-Hallpike maneuver. Dix-Hallpike maneuver एक maneuver होता है जिसे हम positional maneuver कहते हैं. अलग अलग ways में हम head को turn करते हैं. We find out whether there is any vertigo or nystagmus. That is Dix-Hallpike maneuver. ठीक कैसे करते हैं? We do something called as canal repositioning maneuver. हम reposition करते हैं patient को ताकि उसके सारे जितने otoconial debris हैं which are rotating around in these canals, they come back to the vestibule, and that is called as Epley's maneuver. तो Epley's maneuver ठीक करने के लिए, Dix-Hallpike maneuver diagnose करने के लिए. This is what is all about BPPV. ठीक है, चलो और आगे बढ़ते हैं. अब आता है एक क्वेश्चन. आपके पास एक पेशेंट आया. दैट पेशेंट हैज गॉट सडन लॉस ऑफ हियरिंग विद इन 3 days. आपने हमेशा उसका whenever you saw you did your pure tone audiometry, आपने pure tone audiometry में देखा that there is a hearing loss of more than 30 decibel. Now you have got 3 important things. 3 important things is rule of 3. अगर आपके पास पेशेंट आता है that has got sudden loss of hearing within 3 days या 72 hours with more than 30 decibel loss at 3 continuous frequencies. Continuous मतलब 500, 1000, 2000, 1000, 2000, 4000. तो 3 consecutive frequencies में आपने देखा hearing loss है more than 30 decibel का and within 3 days, we will call that as sudden sensory neural hearing loss. And this is a sensory neural type of hearing loss, right? अब most of the common causes of sudden sensory neural hearing loss is idiopathic. Most of the times हमें नहीं पता होता. That is why proposed theory ये है कि most commonly idiopathic causes are because of a viral infection. So they will always come post viral infection. कहेंगे upper respiratory tract infection था, अब सुनाई नहीं दे रहा. So this is what is the catch point. Most of them are coming after an upper respiratory tract infection. That is why influenza, CMV or HSV virus are most common to cause the idiopathic zone of SNHL. Or sudden sensory neural hearing loss. Now, other mnemonic is 𝐼𝐷3, right, or 𝐼𝐷3. The other ways of calling sudden sensory neural hearing loss, it can happen post-trauma to the temporal bone. It can happen post-tumor, such as vestibular schwannoma, or it can also happen because of toxins like ototoxic drugs, right? But again, most common cause is still unknown. हमें नहीं पता. That is why it is idiopathic. Proposed viral infections. ठीक है? What is the management? Very important question. What is the drug of choice? Drug of choice for any nerve-related injury is steroid. Remember that. So, इसके case में भी steroids is the first and foremost choice. Right? Now, there is another important thing that we do in this case. Not only we give oral steroids, but we also inject steroids into the middle ear. That is called as intratympanic steroid injections. So, हम दोनों steroids देते हैं. We give oral, IV, and we also give them intratympanic steroid injections. Okay. Now nowadays we have also got something called as hyperbaric oxygen therapy, जिसमें हम high dose oxygen देते हैं under pressure. We give 2.4 atmospheric pressure, 100% oxygen to the patient. A patient is lying in a chamber and we push oxygen into the body. Why? Because to reverse the ischemia present over the vestibulocochlear nerve, and the patient starts to hear again. That is called as hyperbaric oxygen therapy. ये भी इसमें करते हैं. Okay, so this is something that is related to what is sudden sensory neural hearing loss. Now, Morpheus is asking, I got confused between BPPV and superior semicircular canal dehiscence. एक चीज याद रखना. Superior semicircular canal dehiscence will show third window phenomena. There will always be 3 features in superior semicircular canal dehiscence. One is obviously the patient will have vertigo. Second, the patient will have hearing loss. Third, the patient will have autophony. Autophony मतलब अपनी आवाज खुद सुनाई देगी. So if you see vertigo, autophony, that is happening because of a third window phenomena, and there is a considerable amount of hearing loss too. Okay, it's my light amount of. BPPV में और कुछ नहीं दिखता है सिवाय vertigo के. Right? Even there is tinnitus that will come out in cases of superior semicircular canal dehiscence, but BPPV में there will be just plain vertigo. That will last only for a few seconds. Okay, fine. So this will cover up your question. चलो, अब आते हैं important vestibular schwannoma पे. ठीक है, अब vestibular schwannoma क्या है? Vestibular schwannoma is the most common tumor of the 8th cranial nerve. We already know that. So it is the most common benign tumor of the 8th cranial nerve. We already know that, right? Okay. Now, what is the most common site of it? The most common site of this tumor is the Schwann cells of the inferior vestibular nerve. Okay. So what exactly do we consider over here? let's see, this is an important diagram of the internal acoustic meatus, जो आपको पता होना चाहिए, right? You've got your internal acoustic meatus, right? You've got your internal acoustic meatus. The internal acoustic meatus is further divided into 4 quadrants. It is divided into 4 quadrants, right? Now, it is divided into 4 quadrants by one bar or one important vertical bone, which is called as Bill's bar, and one important horizontal bone, which is called as falciform crest. So there is something called as falciform crest, which is horizontal, one vertical, which is called as Bill's bar. This divides the whole important internal acoustic meatus into 4 quadrants. 2 on the anterior side, 2 on the posterior side, right? अब anterior side में और posterior side में क्या निकलता है internal acoustic canal से is a very important question. So in the anterosuperior part of the internal acoustic canal, we will have 7-up. 7-up एक आती है ना, एक cold drink आती है 7-up. So 7-up मतलब 7th cranial nerve or facial nerve is in the anterosuperior quadrant. एक cold drink आती है Coca-Cola. So Coke down. So Coke मतलब cochlear division of the vestibulocochlear nerve. Vestibulocochlear nerve के 2 division है, vestibular division, cochlear division. Cochlear division of the vestibulocochlear nerve will go into the antero-inferior segment. Then comes posterior-superior and posterior-inferior part. This is for the superior and inferior vestibular nerve. These are the important things which pass through the internal acoustic meatus. Now, the Schwann cells of the inferior vestibular nerve is the one which is going to get the maximum chances of becoming a tumor. Right? ये सबसे important site होती है of becoming a tumor. Okay? And that is where most commonly vestibular schwannoma arises from. Okay? Fine? So now, very important, it is arising from what? It is arising most commonly from the Schwann cells of the inferior vestibular nerve. Okay? अब इसमें देखते हैं important क्या है. Now, अगर हम याद रखें what we did on our on PTA, right? I told you that on pure tone audiometry, vestibular schwannoma produces high frequency sloping type of sensory neural hearing loss. That is why I have read that sloping type of sensory neural hearing loss is seen in cases of vestibular schwannoma. Now I taught you one more thing, Bera. Bera में मैंने बोला था that most important is the 5th wave, and 5th wave is produced by lateral lemniscus, right? So if there is a wave 5 increased latency, ये ऐसे ही याद रखो, increased latency का मतलब wave 5 is coming late. अब late क्यों आएगी? Because 8th nerve पे tumor है. तो first wave, second wave ये सब late बन रही है. तो wave 5 will also become late because lateral lemniscus से बन रही है. That will become late because now the tumor is obstructing the auditory pathway. So if the wave 5 latency is late on Bera, classically it is a clinical significance that the patient has a retrocochlear disease or vestibular schwannoma is there. Okay, that is also very important, right? Now let's come to the third important investigation of choice. Investigation of choice for vestibular schwannoma is MRI with gadolinium contrast. What do you see in an MRI with gadolinium contrast on vestibular schwannoma? You will see that this patient has got, see, this is a stalk of the schwannoma which is coming from the internal acoustic meatus and it is going towards the cerebellum. It is growing towards the cerebellum. This looks like an ice cream and this is called as ice cream cone appearance. So ice cream cone appearance is seen in cases of vestibular schwannoma. Very, very important point. Okay, fine. What is the treatment? Treatment generally हमारी surgery होती है. So either we drill the mastoid and do the surgery if it is a small schwannoma. उसे हम कहते हैं translabyrinthine approach. मतलब we go through the mastoid, right? If it is a big schwannoma, then usually we do a craniotomy and we do a middle cranial fossa approach. So we do a middle cranial fossa approach from the top, or we do a translabyrinthine approach through the mastoid. That is a surgical approach that we usually utilize in cases of vestibular schwannoma. Okay, fine. चलो आगे बढ़ते हैं. Now we come to the next point. The next point is cochlear implant. बड़ा important question. Cochlear implant किसने standardize किया? The answer is William House, who was the father of neurotology, where neurology and otology start working together. Okay, that was the father of neurotology, which was William House, right? So what exactly is this device? This device is placed in the cochlea when the cochlea is not functional. तभी इसका नाम ही cochlear implant होता है. So Morpheus is asking, is it benign? Yes, vestibular schwannoma is completely a benign neoplasm. Okay? So cochlear implant is something which is placed inside into the cochlea when the cochlea is not functional. When do we do a cochlear implant is a very important indication of cochlear implant. ये बड़ी important question है. ये आई भी थी. So always remember, the only thing that you need in a cochlear implant is a functioning nerve and a functioning auditory pathway. Cochlea नहीं चल रहा है, but vestibulocochlear nerve is functional, auditory pathway is functional, brain is fine. All these things should be the prerequisites. अगर आपको दिखा कि vestibulocochlear nerve is injured, it is not functioning, you can't do a cochlear implant in that case, right? So it could be done in cases where the patient has got bilateral severe profound hearing loss. In those cases, sensory neural type. Either it could be before the patient has developed language, which is called as prelingual, or after the patient has developed language, which is called as postlingual. It could happen because of temporal bone fractures, जिसमें there is damage to the cochlea. It could happen because of when you have tried the hearing aid and there is no benefit to the patient from the hearing aid. You could have a patient of ototoxicity, जिसके toxicity हो गई है because of the drugs. Cochlea has gotten damaged. Now you want to do something. And finally, you have got something where the otosclerosis has gone and advanced to the cochlea, which is called as cochlear otosclerosis. या far advanced otosclerosis, right? Or if the patient has got auditory neuropathy, जिसमें hair cells of the cochlea do not function well. In all of these indications, ये सारी की सारी indications आपको याद रखनी है. This is something which is going to come as a question कि किसमें कौन सा candidate में it is most commonly done. These are the indications for cochlear implant. Right? I told you किसमें नहीं कर सकते. किसमें नहीं कर सकते? If we have got an absent cochlea, for obvious reasons, हम कहाँ पे electrode लगाएंगे? We don't have any place. If we have got a cochlear nerve aplasia, if the nerve is absent, obviously we can't do a cochlear implant. If there is a transected nerve, that means eighth cranial nerve is injured. किसके थ्रू जाएगा impulse? We can't do a cochlear implant. And in cases of there is any central nervous system disorder. So our auditory pathway is not intact. We can't do a cochlear implant in that. Okay? Fine? चलो अब नेक्स्ट आते हैं. अब ये देखो, दिस इज व्हाट द कॉक्लियर इंप्लांट लुक्स लाइक, राइट? इसका एक एक्सटर्नल पार्ट होता है, इसका एक इंटरनल पार्ट होता है. इंटरनल पार्ट हम अंदर लगाते हैं, एक्सटर्नल पार्ट इज द वन विच द पेशेंट विल हैंग ओवर ऑन द ईयर, राइट? सो यू कैन सी दिस इज द एक्सटर्नल कंपोनेंट ऑफ दिस कॉक्लियर इंप्लांट, राइट? Now this is the internal component जिसमें सारी की सारी internally you can see that the electrode is going internal and it is placed into the cochlea. Okay. Now what will be the two important questions in cochlear implant? Straight away I'll tell you as it is. What will be the site through which you will place the electrode, and the electrode is placed inside what? So remember these two questions. The approach through which you will place the electrode is basically called as facial recess approach. Facial recess approach को हम लोग दूसरा नाम देते हैं posterior tympanotomy. This is the operation that we do in order to keep the electrode of cochlear implant. Okay? Now, inside the cochlea, if we want to go into the cochlea, we need to approach the cochlea through the round window. That means the round window here, this is our round window. Round window goes and gets continuous with the scala tympani. So now see two options what they will give you. What will be the area through which the electrode is placed, and what will be the area where the electrode is placed? So the electrode in cochlear implant is placed through the round window into the scala tympani. ये important question है. What I've written over here. Electrode is put through the round window into the scala tympani. तो अगर आपसे पूछे कहाँ पे रखा है electrode, you will say scala tympani. अगर आपसे पूछा किसके through आपने electrode push किया है, that is the round window. What is the procedure that you have done? It is posterior tympanotomy or facial recess approach. These are the important questions. What will come to you as it is in your FMGE papers. बस और cochlear implant में और कुछ नहीं पूछने, यही पूछने हैं important. Right? Okay? चलो. Now let us go further. अब आते हैं एक इंपॉर्टेंट पार्ट पे जिसका नाम है ग्लोमस ट्यूमर. बहुत सारे साइंस हैं, बहुत इंपॉर्टेंट पार्ट है और बहुत ही इंपॉर्टेंट इसमें क्वेश्चंस निकलते हैं, राइट? What is the most common benign tumor of the middle ear? It has to be glomus tumor. What is a glomus tumor? Glomus tumor arises from certain paraganglionic cells which are called as glomus bodies. These are called as glomus bodies and these are nothing but these are paraganglionic cells, right? Now, very important, it is seen in what? You will always get a middle-aged female usually giving this history. Okay. Now, there are two types of glomus. One which involves the middle ear, one which involves the jugular foramen area. Jugular foramen मतलब जहाँ से internal jugular vein निकलती है. That is the area, right? These are the areas which have got these paraganglionic cells. Now, if this is arising from the middle ear, we call it as glomus tympanicum. If it is arising in the jugular foramen area, it is given the name as glomus jugulare. अब एक बार ये क्वेश्चन वन ऑफ माय प्रीवियस स्टूडेंट्स आस्क्ड मी कि हम लोग क्वेश्चन के बेस पे कैसे डिफर करेंगे कि ये डिम्पैनिकम पूछ रहे हैं कि जुगुलर पूछ रहे हैं. वेरी इंपॉर्टेंट क्वेश्चन. अगर दे गिव यू अ हिस्ट्री ऑफ अ पेशेंट हु हैज गॉट पल्सेटाइल टिनिटस synchronous with the heartbeat and hearing loss. मतलब hearing loss है, there is a pulsatile tinnitus, thak 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 आवाज आ रही है, synchronous with the heartbeat. Only this is a symptom. Answer is glomus tympanicum. If they give you pulsatile tinnitus, mass in the middle ear together with certain cranial nerve palsies, answer is glomus jugulaire. मतलब कि that has increased and gone into the jugular foramen area also, which contains your 9th, 10th and 11th cranial nerve. So that is the reason glomus jugulaire will always have cranial nerve involvement. Glomus tympanicum will not have cranial nerve involvement primarily. They will only have got hearing loss as well as pulsatile tinnitus features. Okay, fine. Now, on this basis, you have got these important signs which are seen in glomus tumor. Okay? If they tell you that you see a red mass present behind the normal pars tensa, this looks like a rising sun. So what is it called as? This is called as rising sun sign. Reddish mass present behind the normal pars tensa. It's called as a rising sun sign. Right? Okay. Second आ गया. Now we take a Seagull speculum, और Seagull speculum से हम इस मास पे pressure लगाते हैं. We put pressure inside the external auditory canal. So this mass will get pushed. If this mass will get pushed, this mass will blanch. जैसे हम push करते हैं अपने हाथ को तो it will blanch, right? तो वैसे ही इस mass को अगर हम push करेंगे, it will blanch. So B for brown, B for blanching. If the mass is blanching on giving pressure, it is called as brown sign. Brown, B for brown, B for blanching. Now comes the third sign. If we press the carotid artery and the tumor is blanching, that is called as Aquino's sign. Carotid artery is giving direct supply to the glomus tumor. So if there is any blanching of the tumor on pressure over the carotid, we call that as Aquino's sign. Then comes important Phelps sign. बहुत important question. Phelps sign is a feature of glomus jugulaire. Right? Now what do you see over here? You can see over here that this is your glomus tumor. This is your glomus tumor, right? There is a spine or there is a bone present between your jugular as well as carotid canal. Between the jugular foramen and the carotid canal, there is a bone. जिसे हम कहते हैं carotico-jugular spine. Carotico-jugular spine. दोनों के बीच में एक spine होती है, एक bone होती है. अब glomus jugulaire के cases में वो erode हो जाती है. And when it gets eroded, that is a classical feature which is called as Phelps sign. Right? So Phelps sign is seen in glomus jugulaire. What does it mean? It means there is an erosion of the carotico-jugular spine. Okay. Now, what will you see on an MRI of glomus tumor? MRI of glomus tumor gives a salt and pepper appearance. Right? So if you see over here as an MRI, so what you will see, agar koi glomus tumor here, so you will see areas which are white. Now white I'm drawing with yellow. Just remember these are the white ones. And in between the white you will see something black. So this black and white actually gives a salt pepper like appearance, where the white is the area of hemorrhage and black is the area of flow void. मतलब वहाँ पे खून नहीं जा रहा. So the areas which lack the blood supply, they are the flow voids. They are black in color. And the areas which are under hemorrhage, these are white in color. And this is called as a black salt and pepper appearance. Okay. How will we manage it? We usually do a surgical excision. That's all. So ये सारे important signs है. These are the important things what you need to remember as far as glomus tumors are concerned. ठीक है, चलो अब आते हैं नेक्स्ट पे. चलो, so now this finishes about a lot of things from ear. इसमें इसके बाहर ear से related बहुत कम चीज. There's nothing more important. If you just revise this particular segment from the ear, it is more than enough. We've gone almost every disease into the ear and we have finished everything right from embryology till all the disease managements. ठीक है, अब आते हैं into nose. Nose we'll finish off quickly. And what are the important things that you need to require in nose? Right? Now from nose, the first I'm going to talk about is certain important congenital anomalies. ठीक है? एक newborn है. Now I want you all to participate. एक newborn है. Suddenly वो newborn पैदा हुआ. And now there is a classical symptom of the child. बच्चा रोता है और फिर बच्चा सोता है. मतलब whenever the child is quiet, the child gets cynosed. And now the child starts to cry and the cyanosis gets reversed. So that means बच्चा रो रहा है और बच्चा ठीक हो रहा है और फिर सो जाता है और फिर उसके बाद फिर साइनोस हो जाता है और फिर से रोने लगता है. This is kind of a something called as cyclical cyanosis. What is happening to the child? Right? This is what is happening to the child. Cyclical cyanosis. Can you tell me what is this particular diagnosis? Which is having cyclical cyanosis? Right? And this is the most common congenital anomaly in cases of neonates. This is also one of the most common congenital anomalies. Right? So this is called as choanal atresia. This is called as choanal atresia. Choanal atresia, which is one of the most common cause of congenital anomalies related to the nose. Right? Now, what is choanal atresia? Guanal atresia is basically means closure of the posterior guana. ये हमारे anterior guana है, जो हमारे पीछे के guana है, that is the posterior guana which is opening into the nasopharynx, they get blocked or they get closed. ठीक है, अब वो close कैसे होंगे? They can close either unilateral or bilateral, दोनों तरफ भी हो सकते हैं, एक तरफ भी हो सकते हैं, or they can have they could be made of a bone which is closing it, or they could be membranous, or they could be both bone and membranous. You can see here, this is your posterior guana. This is the image that they will give you. And you can see here, this is closed on one side and you can see the other side is open. If the guana is closed from behind, we will call that as guanal atresia. It could be bony, it could be membranous, it could be both. Okay, fine. What is the clinical feature? Now, usually if there is unilateral guanal atresia, एक ही side पे अगर बंद है, then usually the child does not have much of features. But अगर दोनों साइड से ख्वाना पीछे के क्लोज्ड हैं, then मैंने आपको जो बताया that they will have cyclical cyanosis. Right? They will have cyclical cyanosis if they are bilateral, if they have bilateral guanal atresia. Now remember one important point. बच्चे जो होते हैं, they are obligate nasal breathers. Obligate nasal breather का क्या मतलब है? In children, the larynx is very high placed. बहुत ऊपर होता है. So they cannot open their mouths to breathe. आपने कभी भी देखोगे neonate will never open the mouth to breathe. They will always breathe from the nose. तो अगर nose उनकी बंद हो गई, so obviously they will have cyanosis. So that is the reason this is a condition. If bilateral atresia occurs, it can even lead to stridor or upper respiratory obstruction. Okay? Now, if you are a doctor and if you are next to a guanal atresia child and you need to confirm the diagnosis, आप क्या करेंगे? What will you do? You will do something called as a cold spatula test. आप एक ठंडा tongue depressor लेंगे. You will keep it just underneath the child's nose. And you will see that there is absence of fogging over on the tongue depressor. That is the first important thing. There will be absence of fogging in the cold spatula test. Second thing that you can do is that you can take an infant feeding tube और आप उसके नाक में डालिए. If you feel that the infant feeding tube has some resistance, वो नहीं जा रही, obviously it can confirm that the child has guanal atresia. Okay. Now I told you that children are obligate nasal breathers. वो मुंह से सांस नहीं ले सकते, तो आपको उनको मुंह खोल के सांस दिलवानी है. What will you do? In order to make them breathe from the mouth, what will you do? Let's say this is a nipple. This is the bottle nipple of the child. You will cut the bottle nipple of the child from one end and you will tie this around the head of the patient. So see here, you have put that inside and you have tied it around the occiput. इसे हम लोग कहते हैं McGovern's nipple. Call it as McGovern's nipple. ताकि बच्चे का मुंह खुला रहे and the child at least breathe something from the mouth. Okay? Other than that, obviously we do something called as endoscopic laser excision, right? And endoscopic laser excision के साथ, so that it does not refibrose, we add a solution of mitomycin C. Now, mitomycin C is a very important drug which we utilize in order to prevent restenosis. जब भी हम कुछ exercise करते हैं fibrous tissue, we do not want the fibrous tissue to grow back. So we put a drug called as mitomycin C. Mitomycin C is an antifibroblastic drug. It is an antifibroblastic drug, right? And it prevents, it decreases DNA replication. If there is no DNA replication, that will happen. So the fibroblast also will not be formed. And that is the reason why the refibrosis will not happen. Okay. One important question from this is, what is one syndrome which is associated closely with guanal atresia? Most common syndrome associated closely with guanal atresia is given the name as charge syndrome. Charge syndrome में सबसे ज़्यादा guanal atresia दिखता है. Right? What is Charge syndrome? Charge syndrome means coloboma of the iris. Coloboma of the iris. H is for heart defect. A is for atresia. R is for retarded growth. G is for genitourinary abnormalities. And E is ear anomalies. This is a syndrome which is closely related to guanal atresia. That is Charge syndrome. Very good. Okay, so I have already gotten the answers. Chalo. Now let me come to the next one. What is this? If they show you this kind of a picture or if they show you this kind of a picture, obviously they are talking about DNS or a deviated nasal septum. अब important question जो DNS या deviated nasal septum से आते हैं, straightforward question है, right? DNS is the most common deformity of the nasal septum. That is straightforward. Okay. Most common cause for DNS is what? It is birth trauma. That is also straightforward, right? And that usually occurs during obstructive labor and forceps delivery. And forceps delivery. These are the two things why it actually happens. Okay. Third important thing is that there is something called as birth molding theory. Birth molding theory क्या होती है? That there is counter pressures from the uterus and the birth canal. So if there's too much of pressure from the uterus and the birth canal, it causes a septum to deviate. That is called as birth molding theory. Okay? Now, how many types of DNS are there? There are 5 types of DNS. First type is called as anterior dislocation. You can see here, that means as soon as you put the nose up, the septum will come khatak se is side. If you see somebody lifting the nose and the septum is shown, answer is anterior dislocation. You can see anteriorly the septum is dislocated out. This is also called as caudal dislocation. इसे हम लोग caudal dislocation भी बोलते हैं. Okay. Now the second is, if you see any septum which is bent in the form of a C, then it is called as C-shaped DNS. If it is bent in the form of an S, we call it as S-shaped DNS, right? This is a very common picture that is given in your exams, that there is a septal deviation which looks like a shelf-like projection. You can see shelf की तरह निकला हुआ है. This is sharp, shelf-like. The answer is septal spur. Spur generally impinge करता है. That is septal spur. Up 2 important questions related to septal spur. Septal spur is the most common cause for epistaxis in DNS. तो DNS में epistaxis, क्योंकि ये sharp है, सबसे commonly किस में दिखेगी? It will be associated with spur. Second important question related to spur is, if this spur impinges over the turbinate, you can see it is going and hitting over the turbinate. Turbinates are supplied by a nerve which is called as anterior ethmoidal nerve. The anterior ethmoidal nerve is actually supplying the middle turbinate. If this spur is going to impinge the middle turbinate, the patient will get anterior ethmoidal nerve neuralgia or irritation of the anterior ethmoidal nerve, and this syndrome is called as Sludder's neuralgia. This is called as Sludder's neuralgia. What is Sludder's neuralgia? The patient will develop hemifacial pain and headache. जिस तरफ spur है, the patient will say बहुत दर्द हो रहा है. So if the spur is actually impinging over the middle turbinate, it will cause anterior ethmoidal nerve irritation. That will lead to a hemifacial pain and headache. That is called as Sludder's neuralgia. 2 questions, epistaxis and Sludder's neuralgia, both associated with septal spur. Then comes the final one, that is septal thickening. अगर septum center से thicken हो गया, that is called as septal thickening. ठीक है, चलो. अब आते हैं next पे. Now what is this? This is a very important test that we do in order to find out whether the patient will benefit from septoplasty and SMR or not. And what is this? This is called as Cottle's test. Photo याद रखनी है. Cottle's test में क्या करते हैं? We take 2 fingers lateral to the nasolabial fold and pull our cheek out. If the patient develops better breathing, that means that our surgery will benefit the patient. If he does not develop better breathing, that means our surgery will not benefit the patient. This is called as Cottle's test or Cottle's maneuver. Okay? What are these incisions? So for correcting septum, we do a surgery called as septoplasty or SMR. SMR is submucous resection. Septoplasty is more conservative. Now these are the 2 incisions which are very important for you to understand. If we give an incision just at the mucocutaneous junction, just at where the septum is starting, that incision is called as Freer's incision, also called as hemitransfixation incision. दोनों में से एक नाम, hemitransfixation or Freer's incision. If we give an incision 5 millimeters posterior over the septum, then we call this incision as Killian's incision. Killian incision is given in SMR, Freer's incision is given in septoplasty. बस यही question आया, this is what you need to understand. That is what you need to understand. ठीक है? Fine? चलो. Now we move on to the next. Now let's suppose you did a septoplasty. आपने SMR या septoplasty करी. And now you get a call from the ward that now there are bilateral swellings over the septum and the patient is having severe pain in the nose. They will show you that these are 2 globular swellings which have formed over the anterior end of the septum which you had operated. What is this? This answer is septal hematoma. So what you did, once you raised the flap and you took out the extra cartilage, and when you approximated back the flaps, what happened was now blood got collected between the flaps again. And when blood got collected between the flaps again it produces a bilateral swelling over on both sides of the septum. And this is called as a septal hematoma, which is the most common cause or a complication of septoplasty and SMR. Okay. Now, what exactly, what will you do in this case? What will be the treatment of septal hematoma? So obviously we will take a syringe and we will drain this. We will take a syringe and we will drain this. Or we will give an incision over the septal hematoma and we will do something called as incision and drainage. Very, very important, right? Together with some high-grade antibiotics. Together with high-grade antibiotics. Okay? If we don't drain the septal hematoma, तो क्या होगा? Our chondrocytes, remaining chondrocytes will get pressurized and they will die. And if the cartilage chondrocytes are dead, then it will lead to saddle nose deformity. हमारी जो septum है, it will become necrosed and the whole nose will become like a saddle. जैसे horse का saddle होता है ना, on which we sit. That is called as saddle nose deformity. So saddle nose deformity is something which is very, very common post septal hematomas if we don't drain them. Another important complication post-septal hematoma is that let's say you didn't drain the septal hematoma, now it became an abscess. And that abscess is called as septal abscess. Now, septal abscess ka problem ye hai that it is occurring in the dangerous triangle of the face. What is the dangerous triangle? If you draw true imaginary lines from the dorsum of the root of the nose up till the angle of the lips, any particular lesion that occurs between this area has the potential to spread directly into the cavernous sinus. And this can lead to cavernous sinus thrombosis. That is why septal abscess can directly lead into cavernous sinus thrombosis. So in this case, if a patient has septal abscess, you need to do an incision and drainage together with high-grade antibiotics. Okay, fine. Chalo. Now we move on to the next one. The next one is septal perforation. Most common cause of septal perforation is trauma. So whenever we do any septal surgeries, most common cause how we can produce a hole in the septum is by trauma. Or it can happen because of certain granulomatous conditions such as tuberculosis, rhinoscleroma, rhinosporidiosis, ye sari ki sari, sarcoidosis, syphilis. All of these granulomatous conditions are destructive. They can destroy the septum. That is why septal perforations are common in granulomatous diseases. How do we close it? Usually we use something called as a elastic button. वो एक button की तरह होता है. It is like a button, and we put that button over on the hole that is present over on the septal side, and it closes off. So this is called as a elastic button. If the perforation is too big, then we need to put a flap. Then we do something called as flap closure. Small perforations we usually close by elastic buttons. Okay? Chalo. Now, if you get any particular history जिसमें आपको ये पूछा गया that there is a child, very young child, school going child has got unilateral nasal obstruction, foul smelling nasal discharge and epistaxis. ये बात याद रखना. Unilateral nasal obstruction, foul smelling nasal discharge and epistaxis, acute history. अभी अभी आई है child में history. The answer is most commonly they are foreign bodies. Foreign bodies is the most common cause, right? So now they will ask you what is the most dangerous foreign body among them. Most dangerous foreign body among all of them happens to be a button battery. So button battery has got the cells that you utilize in your watches, right? Button batteries. So these are now not very much utilized. Why? Because if they touch the mucosa, then they can lead to liquefactive necrosis. They can lead to liquefactive or alkaline necrosis. And that is the reason one of the very common cause of esophageal perforations, septal perforations, tracheal perforations are these button batteries. Very, very dangerous. Most dangerous button battery. Remember that. Okay, fine. Chalo. Now we come to the next thing. Let's say now you don't treat a foreign body. Aapne untreated foreign body chhod di, right? Now let's say this is the foreign body in the child that is left untreated. Now what will happen? The body will start forming granulation tissue around the foreign body. There will be formation of granulation tissue around the foreign body. And not only there will be granulation tissues, the body will also start to lay down calcium and magnesium salts around this missed foreign body. There will be calcium and magnesium salts which will be laid down around this foreign body. So when calcium, magnesium salts together with granulation tissue are laid down around the foreign body, then they form a stone-like structure. Correct, बिल्कुल सही. तो वो एक stone बन जाएगा. And can you see this stone over here? This stony calcareous lesion is given the name as rhinolith. This is called as rhinolith. Rhinolith is a complication which is usually occurring post missed foreign bodies. बहुत time लगता है इनको बनने में, and that is the rhinolith. It's a stone-like structure or a calcareous structure. What is the treatment? You don't require any medical treatment. Either you remove it in piecemeal, छोटा-छोटा करके, or you remove it in toto. पूरा निकाल लो. But the only thing is surgical management. Okay, so management is always piecemeal or complete in toto surgical removal. Okay, chalo. Now let's move on to the next one. What is the blood supply of the nasal septum? Now this is very, very important question. कि Kezia-Bax plexus या little's area में कौन contribute नहीं करता, or what exactly is this, right? So you have got two important arterial systems in the nose. One is from the internal carotid artery, one is from the external carotid artery, right? Internal carotid artery gives off some important branch which is called as ophthalmic artery, right? Ophthalmic artery will give off anterior ethmoidal branch or anterior ethmoidal artery, which is the first artery which will contribute to the formation of 𝐒𝐿 plexus. Okay? Second important artery, which is all branches of external carotid artery. So external carotid artery will give facial artery. Facial artery se niklegi superior labial artery, and this is the lip superior labial. So there will be a labial branch or a septal branch of the superior labial artery, and that will go on to form the second thing in the 𝐒𝐿 plexus. You've got anterior ethmoidal branch, you have got septal branch from the superior labial artery. Third artery is a greater palatine artery, which is a further continuation from the maxillary artery, and the greater palatine artery will go and also contribute to the formation of 𝐒𝐿 plexus. And finally, from the maxillary artery is the largest artery which contributes, which is called as sphenopalatine artery. So other name for sphenopalatine artery is what? It is also called as artery of epistaxis. सबसे बड़ी artery or सबसे important artery. It is a branch of maxillary artery, which is a branch of external carotid artery. तो चार artery contribute करती हैं: anterior ethmoidal artery, superior labial artery की septal branch, greater palatine artery, as well as sphenopalatine artery. Question आएगा, which among them do not contribute to the formation of 𝐒𝐿 plexus? Answer होगा posterior ethmoidal artery. बस यही इंपॉर्टेंट चीजें याद रखनी है. So posterior ethmoid provides supply to the posterior part of the septum that does not contribute to the formation of 𝐒𝐿 plexus. Okay? चार important MCQ, चार important answers. Most common cause of epistaxis in children is trauma. Nose picking. Most common cause or common area for epistaxis in children is 𝐒𝐿 plexus or Little's area. Now there is another important vein which is just behind the columella, जिसे हम कहते हैं retrocolumnar vein. तो अगर 𝐒𝐿 plexus नहीं दिया है, so the answer will become retrocolumnar vein. Okay? Now comes the next one. Correct? 3. Third is most common cause of epistaxis in adult. Answer is hypertension. Most common area for epistaxis in adults. Answer is Woodruff's plexus. So Woodruff's plexus is a venous plexus which is present in the posterior end of the inferior turbinate, and that is the most common cause to bleed in hypertension. Most common cause to bleed in trauma, 𝐒𝐿 plexus or Little's area. ये चारों question है as it is in MCQs I have given. Okay? चलो आगे बढ़ते हैं. अगर आपके पास कोई भी पेशेंट आया in case with epistaxis, so आप क्या करेंगे? This is a very important thing. So they gave a photo recently कि एक आदमी है जो ऐसे बैठा हुआ है nose लेके. They have asked what is this maneuver that the patient is doing. So the maneuver that you will let the patient do first is called as Trotter's method, also called as Trotter's maneuver. Squeeze the nose and tell the patient to sit in front with an open mouth. That is called as Trotter's maneuver. Okay? Second, identify the site of the epistaxis. हम try करेंगे कि हमें पता चल जाए epistaxis कहाँ से हो रही है. If we identify the epistaxis site, अगर हमें पता चल गई, then and we identify where it is bleeding from, then what we do something called as chemical cauterization or we burn that bleeder. Chemical cauterization solution कौन सी होती है? Silver nitrate or trichloroacetic acid. We apply these solutions over there and it burns or closes that or seals the vessel. Right? अगर हमारे पास chemical cauterization नहीं है, we always have got an electrocautery and we can just cauterize that area with the help of electrical stimulation. That is called as electrocautery. अगर हमें bleeder मिल गया, अगर हमें bleeder नहीं मिला, in case we have not identified, it's bleeding a lot, then what will we do? We will do anterior nasal packing. We'll pack the entire nose. Otherwise, we will try to do posterior nasal packing. We will pack the posterior part of the nose. And then also if we can't control the bleed, then we will do something called as TESPAL. They have asked a question, what is TESPAL? TESPAL is transnasal endoscopic sphenopalatine artery ligation. मतलब एंडोस्कोप से स्फीनोपैलेटाइन आर्टरी को लाइगेट कर दिया. दैट इज कॉल्ड एज टेस्पैल. ओके, सो दिस इज समथिंग विच वी यूज एज अ रूटीन in as a algorithm in controlling epistaxis in any possible adult. Okay, chalo. Now let's move on to the next one. ये क्या है? What is this incision? I'll just wait for your answers to come. This is a particular patient who has got some kind of a tumor over the maxilla. What is this incision given in this patient? I'll just wait for your answers to come. You can see, this is something which is coming from the medial canthus, going around the ala of the nose, and then going down to split the lip. So, no, this is not Blair. This is called as Weber-Ferguson incision. Weber-Ferguson incision. This is given in cases of maxillectomy. Maxillectomy. ठीक है? Blair incision is given in cases of parotid surgeries, where we come from the preauricular area. Tragus के सामने से we come down. We turn the incision behind along the lobule. We go up till the mastoid and then turn the incision 2 centimeters below the angle of mandible onto the neck. This is called as Blair's incision. This is Weber-Ferguson incision. Right? Okay, so remember these two incisions, right? What is this? This line is called as Orngren line. This is called as Orngren line. What is Orngren's line? Orngren's line usually tells us the prognosis of maxillary tumors. So if we draw an imaginary line from the medial canthus down till the angle of mandible, medial canthus to angle of mandible, this will divide the whole of maxilla into an area called as suprastructure and infrastructure. If the tumor is present below this line or infrastructure, then it has got a good prognosis. If the tumor is present above this line or suprastructure, then the tumor has got poor prognosis. Because it is near the orbit, it is near the brain. Simple. ठीक है? चलो आगे बढ़ते हैं. Now you have got two types of nasal fractures, right? Nasal fracture कौन से हैं? दो, these are the two types of nasal fractures or septal fractures, right? एक होता है जार जवे, एक होता है शेवलेट. Jar-Jave fractures usually happen when the blow is from the front or from the side. अगर सामने से किसी ने मारा या साइड से मारा, you will get Jar-Jave. अगर नीचे से किसी ने मारा, blow from below, then you will get chevalet fracture of the nasal septum. ठीक है? अब इसको ऐसे सोचो. Jar-Jave मतलब away, जा रहा है away. तो अगर कोई भी फ्रैक्चर की लाइन which is starting from the anterior nasal spine, ये एक projection है which is called as anterior nasal spine, which is present at the anterior end of the floor of the nose. And if this creates a fracture line which goes parallel to the septal cartilage and parallel to the junction between the vomer and the septal cartilage. देखो ये junction है vomer and septal cartilage का. This fracture line is running parallel to this junction and it is going away. It is going away towards the perpendicular plate of ethmoid. This is called as Jar-Jave fracture. This happens when somebody has beaten someone from the front or from the side. But if there is a fracture which is occurring right from the anterior nasal spine and it is going vertically upwards and it goes right up till the nasal bone. You can see this is the nasal bone. This is a vertical fracture and this is called as chevalet fracture. तो नीचे से कोई मारेगा तो fracture ऐसे जाएगा, which is called as chevalet. सामने से कोई मारेगा तो it will cause Jar-Jave. These are the two types of fractures which are there in the nasal septum. Okay? चलो. We'll move more now. Now we come to CSF rhinorrhea. ठीक है? So let's say now you got a patient जिसके leak हो रही है CSF from the nose, right? There are very important signs which are there in CSF rhinorrhea. Okay, जब CSF leak करता है. The first sign is called as halo sign या target sign. Now what is halo sign या target sign? Whenever the CSF is mixed with blood, जब blood के साथ होता है, so what do? We take a blotting paper, हम एक blotting paper लेते हैं, and we drop that CSF with blood over that blotting paper. Blood is heavy, it stays in the center, and the CSF is light, so it will form a rim around the blood. This is called as halo sign, yeah, it is called as target sign. It is also called as bullseye sign, which is seen in cases of CSF rhinorrhea. Second important sign of CSF rhinorrhea is sniff sign. Sniff sign का मतलब क्या होता है? That the patient is not able to sniff back the CSF, but they can sniff back the discharge. Third important sign is handkerchief sign. We always ask the patient कि जो आपका handkerchief है, वो stiff हुआ कि नहीं हुआ? क्योंकि जब भी आपके nose में mucus निकलता है, that makes the handkerchief stiff. But always remember, CSF will never make the handkerchief stiff. That is why CSF does not stiffen the hanky, and that is why it is a significant thing called as handkerchief sign. Right? Last is called as reservoir sign. Reservoir sign का क्या मतलब है? That patient जब सोएगा तो सारा CSF उसका sphenoid sinus में इकट्ठा हो जाएगा. It will start pouring into the sphenoid sinus, and suddenly when the patient will get up, under gravity, all that CSF will come out. So the sphenoid sinus acts as a reservoir when the patient is sleeping, and when the patient gets up, all the CSF comes out. This is called as reservoir sign. These are the classical signs seen in CSF rhinorrhea. अब आता है एक important question. अगर आपसे ये पूछा जाए कि what is the most sensitive marker for CSF leak on the basis of laboratory diagnosis, biochemical marker. Initially आपके questions जो होते थे, they contained something called as beta 2 transferrin. अब questions change हो गए and they have put a beta trace protein also. तो अगर आपको बीटा 2 ट्रांसफेरिन ऑप्शन मिल रहा है तो बीटा 2 ट्रांसफेरिन इज द राइट आंसर. अगर बीटा ट्रेस प्रोटीन मिल रहा है, बीटा ट्रेस प्रोटीन इज अ बेटर ऑप्शन देन बीटा 2 ट्रांसफेरिन because this is more sensitive and more specific than beta 2 transferrin. So classically beta 2 transferrin option आता रहा है, but recently what we are seeing that they have started to put beta trace protein as well. तो अगर दोनों में से ऑप्शन आए तो beta trace protein is a better option. अगर beta 2 transferrin आता है then beta 2 transferrin is the right answer. Okay? What is the radiological investigation of choice? Radiological investigation of choice is again CT or MR cysternography. Okay? That has to be the answer. ये हमें साइट ऑफ लीक बता देगा. इट विल हेल्प अस टू सी एनी काइंड ऑफ व्हाट वी नीड टू क्लोज ड्यूरिंग सर्जरी. ओके, सो इट विल टेल अस द एग्जैक्ट साइट ऑफ लीक. व्हाट इज द मैनेजमेंट ऑफ CSF rhinorrhea? This is a classical question that comes whenever you are asked about CSF rhinorrhea. They will tell you that the patient has CSF rhinorrhea. What will be the next step of management? Never ever say surgical straight away. The first and foremost management of CSF rhinorrhea is watchful waiting. And we do a conservative management for the first 14 days for spontaneous closure of CSF leak. उसके लिए mnemonic है AQBCD, ABCD, right? ये हम देते हैं in cases of CSF rhinorrhea. First is avoidance of straining. Give the patient antibiotics to prevent meningitis. Give the patient antihistamine so that the patient does not sneeze and does not create a lot of pressure. Give the patient bed rest with the head end a little elevated. Give the patient constipation relief by giving stool softeners. And give the patient diuretics like acetazolamide that decreases the production of CSF. It is a carbonic anhydrase inhibitor. ये हमारा पहला line of action होगा in CSF rhinorrhea, right? After that, if this particular person is not working out, then only we do an endoscopic leak repair, which is called as sandwich technique. हम बहुत sandwich मतलब बहुत सारी layers लगाते हैं. We keep fat, we keep fascia, we keep bone, we keep cartilage, we keep mucosa और बहुत सारी sandwich बना के we close that leak. That is called as a sandwich endoscopic leak repair. That's all. Okay, fine. चलो, now let's move on to important granulomatous diseases of the nose. ये बड़ा important question है आपका, ठीक है? दो important granulomatous diseases आती है. One is rhinosporidiosis, one is rhinoscleroma. What is rhinosporidiosis? Rhinosporidiosis is a chronic granulomatous disease which is caused by an aquatic protestin which is called as Rhinosporidium seabury. ये पहले फंगस माना जाता था. Now it has become an aquatic protestin, and this particular aquatic protestin belongs to the family Mesomycetozoa. Mesomycetozoa. Okay. Now what is this rhinosporidiosis? ये एक granulomatous condition है. आपको question क्या आएगा? आपको question आएगा that the patient has a history of swimming in a local pond या dirty pond, and now the patient has got a mass in the nasal cavity which bleeds on touch. बस खत्म. Whenever you see that there is a mass in the nasal cavity which is bleeding or there is epistaxis and there is swimming in a dirty pond, answer is rhinosporidiosis. ये dirty pond बहुत important है. Why? Because this particular thing lives in dirty ponds or dirty areas. So always remember all the areas around in southern part of India. बहुत बढ़िया. So I think Shuman has already told. So all in the southern part of area, सारे tropical areas, patient will be from Tamil Nadu, patient will be from Kerala, or they will give Sri Lanka. All these areas, they've got a lot of water bodies, and this will be the point where they will target rhinosporidiosis क्योंकि वहाँ पे ज़्यादा होता है. Okay. Clinical features. Now you will see a strawberry-like mass. ये देखो strawberry-like mass है. Strawberry क्यों? It will be a red mass and it will have white dots over it. इसके ऊपर खूब सारे white dots होंगे. White dots जो होते हैं, these are the sporangia which are present over on this lesion. Sporangia contains spores of this organism. So sporangia के अंदर होते हैं spores. So you can see these are the big sporangia. You can see these globular sporangia. और इनके अंदर there are spores, and these spores are basophilic spores. ये basophilic spores हैं, right? These are classical basophilic spores, and these are the sporangia which are classical for rhinosporidiosis. Okay. Now, how will we treat rhinosporidiosis? Rhinosporidiosis का एक treatment है which is medical and which is surgical. Ultimately, we have to do a surgery, so we surgically remove it, right? But we have to give one important drug to this patient. Drug of choice for rhinosporidiosis is dapsone, which has to be given once a day for a period of 3 to 4 months to prevent recurrence of rhinosporidiosis. Otherwise, we have to do a surgical excision. Drug of choice, dapsone. ठीक है? चलो. Let's move on to the next. Next आती है rhinoscleroma. Scleroma, उधर rhinosporidium से rhinosporidiosis, इधर rhinoscleroma से rhinoscleromatis. So Klebsiella rhinoscleromatis is the important organism which causes this particular condition, which is called as rhinoscleroma, right? अब rhinoscleroma का जो organism है, the rhinoscleromatous, it is also called as Frisch bacillus. The other name is also called as Frisch bacillus. Okay? 3 stages are there in rhinoscleroma. 3 stages होती हैं जिसमें rhinoscleroma बढ़ता है. Atrophic stage, granulomatous stage and cicatricial stage. ये 3 stages बड़ी important है. Atrophic stage का क्या मतलब है? Atrophic stage का मतलब atrophic rhinitis की तरह. Crust बनेंगे, foul smelling discharge होगा. So if there is crusting and foul smelling discharge, it is called as atrophic stage. That is the first stage of rhinoscleroma. Second stage of rhinoscleroma में खूब सारे nodules बनते हैं. And if I show you, these are the nodules which will form in cases of rhinoscleroma. बड़े बड़े nodules बनेंगे, right? This is the granulomatous stage. Okay. Now, what is granulomatous stage? These kind of granulomas or these kind of nodules which will form, they will not ulcerate. ये important point है. So if they tell you that there is a nodule inside the nose which it does not ulcerate, they are classically for rhinoscleroma. These are very hard, firm, bluish to reddish in appearance. They are hard and firm. And that is the reason ये बढ़ते चले जाते हैं. They are hard, they are firm, and they produce something called as a Hebra nose deformity. They cause Hebra nose deformity. बहुत important question. तो Hebra का मतलब zebra और horse को अगर हम cross कर दें, that forms a Hebra. तो अगर हमारी nose इतनी बड़ी हो जाएगी, that's called as Hebra nose. बड़ी easy हो जाएगी nose. That's called as a Hebra nose deformity. Right? Hebra nose deformity is seen in which cases? It's seen in the granulomatous stage of rhinoscleroma. Very important question. Right? Now, one important thing also is there that Hebra nose deformity में ये nodules ulcerate नहीं कर रहे. So how will they heal? These nodules break and they undergo scarring. So they will break and they will undergo scarring. They will fibrose. And if these nodules break and they become fibrosed, then what will happen? They will shrink the nose. ये fibrosis की वजह से nose बहुत चपटी और पतली हो जाएगी. So if you see, when they actually heal, they will make the nose very, very small. You can see the shrunken nose over here. It has become very distorted and small. And this nose actually looks like this animal, right? This animal is a herbivore and this is called as a tapir. This animal is a tapir, and you can see the snout of this tapir, a very, very pointed snout. This is the same nose that the man will have. That is why this is called as tapir nose deformity. This is called as tapir nose deformity. So tapir nose deformity is seen in cicatricial stage, जिसमें stenosis हो जाएगी. Hebra nose deformity is seen in granulomatous stage. चलो, अब एक important चीज. Tapir nose deformity, unfortunately, Shubman is already asking, it is not curable unless and until we do something called as septorhinoplasty. तो इसको ठीक करने के लिए we do a procedure called as septorhinoplasty. Septorhinoplasty का मतलब we take the rib of the patient and we make the whole nose again. That's called as septorhinoplasty, and we need to break these bands which have formed. Okay? The fibrous bands which have formed. That's called as the tapir nose deformity. ठीक है? चले? Okay. चलो, अब एक इंपॉर्टेंट क्वेश्चन इसमें ये आता है हिस्टोपैथोलॉजी से. ये आपके पैथोलॉजी में भी बड़ा इंपॉर्टेंट क्वेश्चन है, राइट? कि व्हाट इज द कैरेक्टरिस्टिक हिस्टोपैथोलॉजिकल फाइंडिंग ऑफ rhinoscleroma? इट इज मिकलिक सेल्स एंड रसल बॉडीज. वेरी इंपॉर्टेंट क्वेश्चन. व्हाट इज मिकलिक सेल्स? अगर आप देखें इसे बहुत सारे छोटे छोटे सेल्स हैं विच आर व्हाइट, राइट? दीज व्हाइटिश सेल्स आर foamy macrophages. These are foamy macrophages. Foamy macrophages in cases of histopathology of rhinoscleroma are given the name as Mikulicz cells. And you will see there are certain plasma cells. And plasma cells के जो एक portion होता है, end portion होता है, there will be collection of acidophilic immunoglobulins. There will be immunoglobulins which will collect over at one end of the plasma cell, and they will be acidophilic or they will be eosinophilic. So ये जो बनी है, these pink type of lesions here, these pinkish lesions are actually immunoglobulins which are collected inside in these plasma cells. And these immunoglobulins stain pink in color. And these are the ones which are given the name as Russell bodies. So Russell bodies and Mikulicz cells are the ones which are classical in cases of rhinoscleroma. How will you treat it? The drug of choice for rhinoscleroma is streptomycin. Other drugs of choice are rifampicin and ciprofloxacin. Okay, and I've already told you that only surgery that we do in cases of rhinoscleroma is post in the cicatricial stage. Granulomatous stage, we don't do the surgery. We only do it in cicatricial stage, and that is septorhinoplasty, where we need to make the nose. Okay, fine. Chalo. Now we come to the next one. अब ये क्या है? What is this? A patient had acute sinusitis and now they present such kind of a huge lesion over their forehead. What is this? So this is called as Pott's puffy tumor. This is called as Pott's puffy tumor. बहुत important question है. What is Pott's puffy tumor? Pott's puffy tumor is osteomyelitis of the frontal bone. Osteomyelitis of frontal bone. So whenever there is frontal bone osteomyelitis, there will be collection of pus beneath the scalp, and this is called as Pott's puffy tumor. Okay. Now, what is this? What exactly are they showing you here? Can you identify? Right? No, encephalocele ऐसा नहीं है. Encephalocele नाक के ऊपर अंदर यहाँ होगा. नाक के ऊपर होगा. Over the dorsum of the nose. This is above the forehead. So this is Pott's puffy. Okay. What is this? This is something called as a Waters view. This is something called as Waters view. Right? So this is a modified Waters view, also called as Spear's view. Also called as Spear's view. Now remember one thing. If the patient is having a mouth open like this, जैसे हम पानी पीते हैं ना, यही होता है Waters view. ठीक है? So what is that? That's also called as occipitomental view. Occipitomental view का मतलब क्या हुआ? That the patient will bend his head 45 degree back and place his chin over the X-ray film like this and open the mouth. And the beam will come from occiput to the mentum and it will create this kind of an image. तो इसको हम लोग मॉडिफाइड वाटर्स व्यू भी कहते हैं या पियर्स व्यू भी कहते हैं. अगर मुंह बंद होता है तो वाटर्स व्यू है, मुंह खुला हुआ है तो इट इज पियर्स व्यू और मॉडिफाइड वाटर्स व्यू. अब इसका इंपॉर्टेंस क्या है? इसका इंपॉर्टेंस ये है कि थ्रू द ओपन माउथ यू विल बी एबल टू सी वन साइनस ओवर हियर एंड दिस इज योर स्फीनॉइड साइनस. So sphenoid sinus is seen through the open mouth in the X-ray of Pierce view. Very important. What is the best views to see frontal sinus? It is Caldwell view. What is the best view to see maxillary sinus? It is Waters view. दो important question. तो maxillary अगर देखना है तो Waters view लगाओ. If you have to see Caldwell view, then it is for frontal sinus. Caldwell means occipitofrontal. मतलब सर ऐसे रखेंगे. Occiput to frontal, Caldwell. Occiput to mentum, water. Remember that. And both the sinuses. Okay, chalo. Now we come to a more important point, nasal polyps. ठीक है? अब nasal polyps में क्या important है? What is a polyp? ये important चीज है, right? Paranasal sinus bone होती हैं. There are bones in the paranasal sinuses. And the bones are covered by a mucosa. Right? Bones are covered by a mucosa. Now, if there is any type of a factor, कोई भी अगर external factor इस म्यूकोजा को स्टिम्युलेट कर दे, इफ इट स्टिम्युलेट्स दिस म्यूकोजा, देन दिस म्यूकोजा विल हॉप आउट. इट विल हॉप आउट. हॉप का मतलब क्या हुआ? दिस म्यूकोजा विल बिकम हाइपरट्रोफीड, एडिमेटस, प्रोलैप्स्ड. हॉप आता है ना, कूद के आया बाहर. तो दिस हैज बिकम हाइपरट्रोफीड, एडिमेटस एंड प्रोलैप्स्ड फ्रॉम द एरिया वेयर इट वाज. दिस इज कॉल्ड एज पॉलिप. तो अगर कोई भी ट्रिगरिंग फैक्टर म्यूकोजा को स्टिम्युलेट करता है टू हॉप आउट, बिकम हाइपरट्रोफीड, बिकम एडिमेटस एंड बिकम प्रोलैप्स्ड, वी कॉल दैट एज a polyp. There are two primary polyps, ethmoidal polyp और antroconal polyp, right? Antroconal हमेशा unilateral होता है, ethmoidal bilateral होते हैं. तो antroconal is unilateral, ethmoidal is bilateral. Most common cause of antroconal polyp is infection. Most common cause of ethmoidal polyp is allergy. Very very important point. ठीक? अब आते हैं साइट पे. Antroconal, antrum का मतलब ही हो गया maxillary sinus. So antroconal polyp arises from what? It arises from maxillary sinus. Ethmoidal मतलब ethmoid sinus. It arises from the ethmoid sinus. Antroconal में हमेशा वो हिस्ट्री क्या देंगे? That there is a young patient, 28, 29, 30-year-old male who has unilateral nasal obstruction. Unilateral grey glistening mass is seen arising from the maxillary sinus. तो आंसर antroconal है. But in cases of adults, 45, 50-year-old bilateral nasal obstruction, आंसर ethmoidal है. Right? So now, what will they have? Age group is younger over here. This is in older. This is solitary. Antroconal is only on one side, single. These are multiple and grape-like. बहुत सारे होते हैं, like a grape. Right? Now, this is unilateral antroconal. Obviously, this is bilateral. Okay? One important point is कि how will you treat? This is something that is asked as a question. कि अगर आपको antroconal polyp मिला तो आपका क्या treatment होगा? Ethmoidal polyp हुआ तो क्या treatment होगा? Always remember, antroconal polyp में the first line of management is surgery. क्योंकि उसमें infection is the most important cause. हम कुछ नहीं कर सकते, सिर्फ उसको निकाल लो. तो FES या functional endoscopic sinus surgery is the management of choice in antroconal polyp. It is always FES. But if there is ethmoidal polyp, it is happening due to allergy. तो यू एलर्जी इज सिस्टमिक. एलर्जी अगर हमने पॉलिप निकाल भी दिए, एलर्जी विल कम बैक. So obviously we need to do a medical line of management first. Then we need to do FES. So in ethmoidal polyp, first do medical line of management, then do FES. Medical line of management is usually antihistamines, nasal steroids in order to shrink the polyp. And then after that we continue with FES. This is what is the classical way in which we see both of them. ठीक है? चलो. Now we come to a very very important point. That ये एक क्वेश्चन रिसेंटली आया है इन योर INI-CET पेपर ऑल्सो. Potential question for your FMGE also, what I believe. What are the syndromes that are associated with ethmoidal polyps and what are the causes of ethmoidal polyps? ठीक है, अब इसका मैंने आपको निमोनिक दिया है that there are 4C and 4A which are related to ethmoidal polyp formation. ठीक है, first important is cystic fibrosis. अगर उन्होंने ये गलती से बता दिया that the sweat chloride is raised and the patient has polyps, then the answer will become cystic fibrosis. Simple. Second C is obviously long-standing chronic rhinosinusitis will produce polyps. Bar there will be inflammation. Bar there will be polyp formation. Third important syndrome is Churg-Strauss syndrome. Churg-Strauss syndrome is characterized by what? It is characterized by rapidly progressive glomerulonephritis together with eosinophilia and asthma. तीन important चीजें, RPGN, eosinophilia, asthma. That is Churg-Strauss syndrome, which also is associated with polyp formation. अब ये क्वेश्चन दिस इज एज इट इज बीन आस्क्ड इन योर INI-CET इन मैच द फॉलोइंग, और ये बड़ा इंपॉर्टेंट क्वेश्चन है फॉर योर FMGs एज वेल. कार्टगनस सिंड्रोम क्या होता है? कार्टगनस सिंड्रोम मींस द पेशेंट हैज गॉट साइनोसाइटिस विद ब्रोंकिएक्टासिस एंड साइटस इनवर्सस. सीलिया काम नहीं कर रहे, देयर इज सिलियरी डिसऑर्डर. साइनस में सीलिया काम नहीं कर रहे तो दे विल बी साइनोसाइटिस. लंग में सीलिया होते हैं, दे आर नॉट वर्किंग सो दे विल बी ब्रोंकिएक्टासिस. एंड साइटस इनवर्सस मतलब सारे ऑर्गन उल्टे हो गए, मतलब डेक्स्ट्रोकार्डिया हो गया. दैट मींस इफ द हार्ट इज ऑन द लेफ्ट साइड इट विल टर्न ऑन द राइट. So this is called as साइटस इनवर्सस, ऑर्गन उल्टे हो गए. दिस इज कार्टेगनस. अब देखो बड़ा सिंपल है ये, साइनोसाइटिस, ब्रोंकिएक्टासिस, साइटस इनवर्सस, कार्टेगनस है. बस साइटस इनवर्सस हटा दो और उसकी जगह एजोस्पर्मिया लगा दो, इट विल बिकम यंग्स. तो यंग लोगों में क्या होगा? एजोस्पर्मिया. That's how I remember it. So young लोगों में एजोस्पर्मिया. So obviously now if you put situs inversus out and put azoospermia with sinusitis and bronchiectasis, answer will become young syndrome, which is another important syndrome for ethmoidal polyps. ठीक है, अब आते हैं A पे. 4A, asthma, allergic rhinitis, allergic fungal rhinosinusitis, and then there is a very important thing which is called as aspirin intolerance, asthma and polyps. आम आदमी पार्टी आप. एस्पिरिन इंटॉलरेंस, एस्थमा एंड पॉलिप, इसको हम बोलते हैं सैम्टर्स ट्रायड. ये बड़ा क्लासिकल क्वेश्चन है फॉर एथमोइडल पॉलिप, राइट? सैम्टर्स ट्रायड क्या होता है? आम आदमी पार्टी, एस्पिरिन इंटॉलरेंस, एस्थमा एंड पॉलिप्स, थ्री थिंग्स. ठीक है, चले. सो दीज आर द 4C and 4A mnemonic that you need to know as far as ethmoidal polyps are concerned. See, multiple polyps, खूब सारे polyps, you can see that. These are multiple polyps and these are grape-like. This is grape-like appearance. And grape-like appearance is seen in cases of ethmoidal polyps. Right? This is what we have learned. Okay? Now see this. This is another important sign. अब ये nose है, right? This is the nose. And from the nose you can see a gray mass that is coming behind like this. You can see this? This is a gray mass which is coming behind. Right? अब एक चीज इंपॉर्टेंट है, इस ग्रे मास के बिहाइंड यू कैन सी देयर इज अ कफ ऑफ एयर. इसके पीछे देखो, यहां पे आपको एक शैडो दिख रही है, एक शैडो दिख रही है ब्लैक कलर की पीछे, राइट? इफ यू सी अ ब्लैक कलर्ड शैडो बिहाइंड अ मास एंड दिस शैडो इज एक्चुअली लाइक अ क्रिसेंट. यू कैन सी दिस क्रिसेंट लाइक शैडो, ये काली है शैडो. दिस इज कॉल्ड एज क्रिसेंट साइन एंड क्रिसेंट साइन इज क्लासिकली सीन इन केसेस ऑफ AC पॉलिप. तो AC पॉलिप में होता है समथिंग कॉल्ड एज क्रिसेंट साइन एंड दिस इज ऑल्सो कॉल्ड एज डॉड साइन. इसे हम लोग डॉड साइन भी बोलते हैं. ठीक है, थैंक यू ऑल ऑफ यू. थैंक यू रवि, थैंक यू सोम सुब्रा, दैट्स रियली नाइस ऑफ यू, राइट? सो जब तक आप लोग पढ़ते जाएंगे, दैट इज हाउ वी आर. वी विल कीप टीचिंग यू. दिस इज व्हाट आवर मोटिव इज, टू पुश यू so that you can get out of this whole funda of giving exams and you can finally end up into your dream branch. Right? That is the whole motive behind all these lectures. चलो, अब आगे बढ़ते हैं. Now, this is something related to acute and chronic rhinitis. Okay? क्या questions होते हैं acute और chronic rhinitis के? ये फटाफट कर लेते हैं. Most common acute infection of the nose कौन सा है? वी कॉल इट एज वायरल राइनाइटिस, इसे हम कॉमन कोल्ड भी कहते हैं। तो अगर मोस्ट कॉमन अक्यूट इन्फेक्शन ऑफ द नोज पूछा गया तो कॉमन कोल्ड है, या उसे हम कोराइजा भी बोलते हैं, या फिर उसे हम वायरल राइनाइटिस भी बोलते हैं। अब एक इंपॉर्टेंट चीज आती है, आपको एक क्वेश्चन दिया जाएगा जिसमें होगा कि देयर इज अ 29-30-year-old मैन who has been having nasal obstruction which is worsening, and he has been taking some drops like xylometazoline for a very long time. Initially xylometazoline used to work, now his congestion has become worsened. What is the diagnosis? तो अगर आपको ड्रॉप से रिलेटेड कोई भी क्वेश्चन आया, close your eyes and tell that what is the answer here. The answer is rhinitis medicamentosa. Simple. Whenever they ask you regarding drops, तो एक चीज याद रखना that your turbinates, right? Turbinates are there. Turbinates have got important alpha-1 receptors. They've got alpha-1 receptors over their blood vessels, right? So what happens when you keep taking these nasal decongestant drops, xylometazoline, oxymetazoline, there is a down regulation of these alpha-1 receptors. ये नीचे हो जाते हैं, और जब ये alpha-1 receptors नीचे हो जाएंगे, so there will be rebound congestion, मतलब हमारी turbinate और फूल जाएंगे. And that is the reason why there will be more nasal obstruction in these patients, and the turbinates will cause rebound congestion. Now, what is the treatment of choice? आप क्या करेंगे? So the treatment of choice is कि इस congestion और इस hypertrophy को reduce करें, और उसके लिए क्या drug of choice होता है? Steroids. So usually we give topical steroids, and we tell the patient to avoid nasal decongestant drops. तो सबसे पहले steroids डालो, tell the patients to stop the drops, and that is the whole funda how this particular condition will get reversed. Okay? अब एक और इंपॉर्टेंट क्वेश्चन आता है, आपके पास होगी क्रस्टिंग इनसाइड द नोज। अगर क्रस्टिंग इनसाइड द नोज आपको पता चल रही है दैट इट इज ओनली इन द एंटीरियर 1/3 ऑफ द नोज, मतलब सिर्फ यहीं पे एंटीरियर 1/3 पे थोड़े क्रस्ट बन जाते हैं, दिस इज कॉल्ड एज राइनाइटिस सिक्का। टिक्का, एट्रोफिक राइनाइटिस नहीं, एट्रोफिक राइनाइटिस में पूरी नोज के अंदर क्रस्ट बनेंगे। अगर सिर्फ एंटीरियर 1/3 में क्रस्टिंग हो रही है, दैट इज कॉल्ड एज राइनाइटिस सिक्का। ये बहुत ड्राई क्लाइमेट्स में दिखता है, एंड ड्राई क्लाइमेट्स का मतलब इट इज सीन इन केसेस ऑफ बेकर्स, और you कैन सी इट इन आयरन स्मिथ्स, और यू कैन इवन सी इन पेशेंट्स हु आर लिविंग इन डेजर्ट्स, राइट? सो दिस इज समथिंग व्हिच इज कॉल्ड एज बेकर्स नोज या राइनाइटिस सिक्का। ठीक है? वेजोमोटर राइनाइटिस क्या होती है? वेजोमोटर राइनाइटिस का मतलब होता है नैनीपर। नैनीपर का क्या मतलब होता है? नॉन एलर्जिक, नॉन इन्फेक्टिव पेरिनियल राइनाइटिस। पेरिनियल मतलब पूरे साल रहेगी, एज वेल एज इट इज नॉट एलर्जिक, इट इज नॉट इन्फेक्टिव, ये नहीं है। तो व्हाट इट इज वेजोमोटर। वेजोमोटर राइनाइटिस का मतलब कि इट इज बिकॉज ऑफ द ओवर स्टिमुलेशन ऑफ पैरासिम्पैथेटिक ओवर एक्टिविटी। हमारे पास पैरासिम्पैथेटिक ओवर एक्टिविटी बढ़ी है। पैरासिम्पैथेटिक जब ओवर एक्टिविटी बढ़ेगी तो क्या होगा? देयर विल बी वेजोडाइलेशन, हमारी वेसल्स डायलेट हो जाएंगी। वेसल्स डायलेट हो जाएंगी, सो देयर विल बी मोर नेजल ऑब्स्ट्रक्शन, देयर विल बी मोर डिस्चार्ज। तो पेशेंट्स में क्या होता है? देयर इज पैरासिम्पैथेटिक ओवरड्राइव, राइट? अब इसमें हम क्या करेंगे? व्हाट इज द थिंग? इट इज मैनेज्ड बाय समथिंग कॉल्ड एज वीडियन न्यूरेक्टमी। वीडियन नर्व एक पैरासिम्पैथेटिक नर्व है विच सप्लाइज आवर नेजल कैविटी, उसको हम काट देंगे। वी डू नॉट वांट द पैरासिम्पैथेटिक ओवरड्राइव टू हैपन। तो वीडियन न्यूरेक्टमी, अगेन सर्जरी ऑफ चॉइस फॉर वेजोमोटर राइनाइटिस। ठीक, चलो एलर्जिक राइनाइटिस, वेरी इंपॉर्टेंट। एलर्जिक राइनाइटिस क्या होती है? एलर्जिक राइनाइटिस इज अ टाइप 1 IgE मीडिएटेड हाइपरसेंसिटिविटी रिएक्शन, राइट? अब ये दो तरीके की होती है। इट इज हैपनिंग ईदर इन वन सीजन, इट इज कॉल्ड एज सीजनल, और इट हैपेंस थ्रू आउट द ईयर, इट इज कॉल्ड एज पेरिनियल। दो तरीके की एलर्जिक राइनाइटिस होती है, राइट? ओके, नाउ what exactly is the symptoms, right? What are the symptoms? Symptoms is basically ribs. You can remember the mnemonic ribs. Rhinorrhea, itching, block, sneezing. Rhinorrhea, itching, block, and sneezing. These are the three things that you will see in cases of allergic rhinitis. Okay? Now, what exactly are the important signs of allergic rhinitis? Bar patient will keep doing like this, right? Like this. What will it do? What is this called as? This is called as an allergic salute. This is called as allergic salute. अब allergic salute करते करते क्या हो जाएगा? उसकी नाक के ऊपर एक लाइन बन जाएगी. There will be a line which will form over on the dorsum of the nose. This is called as Darrier line. Darrier line. Okay? This is called as a Darrier line. Or hyperpigmentation. This is also called as dorsal nasal pleat. ठीक है? थर्ड इंपॉर्टेंट साइन ऑफ एलर्जिक राइनाइटिस, बार बार जब एलर्जी होती है तो दे विल कीप रबिंग द आईज, so there will be an infraorbital fold which will get prominent. What is that called as? So if there is a prominence of the infraorbital fold, we will call this as Denny-Morgan crease. Denny-Morgan crease. Okay, so Denny-Morgan crease, Darrier line, allergic salute. तीन important चीज है. There will be big dark circles below. Big dark circles below the eye. What is that called as? These are called as allergic shiners. These are called as allergic shiners. Or big dark circles present beneath the eyes. These are called as allergic shiners, right? अब अगर हम इसके अंदर चले गए नाक के, and what do we see inside? We will see that the turbinates are actually boggy and they are having multiple bumps. These are called as mulberry turbinates. ऐसी क्वेश्चन आता है, mulberry turbinates are seen in which condition? They are seen in cases of allergic rhinitis. Right? Okay. अब एक question I think somebody asked me about that video neurectomy कहाँ से करते हैं? So basically क्या होता है कि median nerve is very closely related to the sphenoid sinus. तो अगर suppose ये sphenoid sinus है, this is your sphenoid sinus, इसी के just नीचे यहाँ पे median canal होती है. So we go transsphenoidal. हम sphenoid के नीचे जाते हैं. We go lateral to the sphenoid sinus and we buzz the nerve there. That's called as transsphenoidal approach. Okay, it's endonasal. हम endoscopic करेंगे. That's the endoscopic approach for video neurectomy. Okay, fine. चलो. Okay. अब आते हैं next पे. What is atrophic rhinitis? Atrophic rhinitis for obvious reasons means atrophy that has happened inside the nose. Right? इसमें blood vessels atrophy कर जाती हैं, mucous glands atrophy कर जाते हैं, nerves atrophy कर जाती हैं, mucosa atrophy कर जाते हैं. Right? Everything gets atrophied. Right? That is called as atrophic rhinitis. Correct? Now, there are two types of atrophic rhinitis. One is called as primary, one is called as secondary. Okay? Primary atrophic rhinitis means that there is no specific cause for atrophy. It is idiopathic. तो जब हमें cause नहीं पता, we call it primary atrophic rhinitis. Primary atrophic rhinitis के causes क्या है? The mnemonic is hernia. Mnemonic is hernia. H for hereditary. E for endocrine. Endocrine means this usually happens during in the menopause or puberty era. Why? Because there is that is the time where the patient has got estrogen deficiency. Okay, so that is why endocrine. R means racial, which is most common in Caucasian population. N is nutritional. Nutritional मतलब vitamin A, D, iron deficiency. That is very common. उसके बाद आता है infection. What is the infective organism for atrophic rhinitis? It is Klebsiella ozoeni. Klebsiella ozoeni. Then comes A, that means autoimmune. Hernia, mnemonic. ठीक है? Secondary atrophic rhinitis मतलब किसी भी particular चीज के secondary हो रहा है. कोई disease के secondary हो रहा है, कोई surgery के secondary हो रहा है. Right? So what are the causes of secondary AR or secondary atrophic rhinitis? Secondary atrophic rhinitis matlab that it is granulomatous diseases, which is tuberculosis, syphilis as well as leprosy. ये सारी हमारी granulomatous diseases होती हैं, right? And finally there is trauma. The most important thing है कि in trauma, what is the most common surgery that will lead to this? The most common surgery that will lead to atrophic rhinitis is about turbinoplasty. Turbinoplasty matlab when we remove the turbinates. That is the most common cause for creating atrophic rhinitis. Right? Okay. बेटा ये image based question नहीं है. This is about a marathon in which we teach. This is not about IBQs. We are already doing those sessions since a long time. Right? So this is all about what we revise with you. Right? Okay. Now we come to clinical features. Clinical features important तीन होते हैं. There are three things. What are the clinical features of atrophic rhinitis? And these features are called as Frenkel's triad. Frenkel's triad. तीन features होते हैं. Okay. Now what is the Frenkel's triad? एक इनमें होगा foul smelling nasal discharge. Second, there will be green colored crusts. And the third will be roomy nasal cavity. तीन चीजें दिखेंगी. These are the three qualifying features to be called as atrophic rhinitis, right? So what do you see over here? You can see over here there are green colored crust which are filled inside the nose, right? You will have a lot of discharge which is foul smelling. Foul smelling nasal discharge को हम लोग कहते हैं ozena. We call it as ozena, right? And at the same time, you will also see that this cavity has become bigger. This is called as roomy nasal cavity because of the destruction of the mucosa and the turbinates that has happened. Okay, fine. Chalo. Now let me move to the management. Management के लिए I have given you a mnemonic. Mnemonic of management of atrophic rhinitis is dogs bark. Dogs क्या करते हैं? They bark. Simple. ठीक. सबसे important is D. D मतलब douching. Douching matlab we clean the nose. Now how do we clean the nose? We take 280 ml of water, right? And we mix alkaline salts inside it. Alkaline salts कौन से mix करते हैं? We mix 28.4 grams of sodium bicarbonate, 28.4 grams of sodium biborate, and 56.7 grams of sodium chloride. ये सब mix करके, what do we tell the patient? We tell the patient to put this solution inside the nose and clean. So what will happen? It will produce an antiseptic action and it will dissolve the crust and it will get them out. Okay, fine. After that comes O. O का मतलब हुआ estradiol nasal spray. Estrogen जरूरी होता है for vasodilation. So obviously, we'll give estradiol nasal spray for vasodilation for better healing. G. Glucose glycerine drops. Glucose glycerine drops कितना देते हैं? Why we do give it? Because this is an anaerobic environment जो नाक के अंदर बना हुआ है. If we give glucose, glucose under anaerobic conditions will get converted into what? Into lactic acid. And if it undergoes lactic acid formation, it will disrupt the growth of Klebsiella ozonae. So we will give glucose glycerine drops, that is G. S is submucosal injection of placental extract, which is again a healer, which will increase the healing power of the nasal mucosa. Correct? Then comes bark, B12, A, D iron supplementation, which is rich. Correct? Then comes A. What is the antibiotic of choice for atrophic rhinitis? It is streptomycin, which is usually given 1 gram a day. R is rich protein diet because most of the people are malnourished. And K is a solution जो हम अंदर डालते हैं in the form of drops. This is called as chemicitin solution. Chemicitin is made up of chloramphenicol plus estradiol plus vitamin D2. These are the three things which are required inside chemicitin solution. ये सारे के सारे चीजें are management और dogs bark is a management of atrophic rhinitis. एक question important जो आता है कि what is this particular operation that is done over here? ये कौन सा operation है? So this procedure that is done over here, this is called as Young's procedure. This is called as Young's procedure. या फिर इसे कहते हैं Young's operation. Okay, fine. That is closure of the nostril by raising the mucocutaneous flaps. Mucocutaneous flap raise करके we close the nostril completely. Right? If we make a 3 millimeter hole inside it, छोटा सा hole बना दें, then we call that as modified Young's procedure. Then we call it as modified Young's procedure. Okay? Fine? चलो. Now we move on to the next one. अब ये important चीज है कि they have asked you 2 important cells related to the nose. Right? आपको स्कैन्स देंगे और 2 सेल पूछेंगे. एक तरफ उन्होंने एक सेल मार्क करा हुआ है, एक तरफ एक और सेल मार्क किया हुआ है. Right? So what is this? These are the CT scans where I've cut over my skull in a coronal plane and I'm showing it to you here. ठीक है? पहले देखते हैं कि what we can identify. So we can identify ये सेंटर में सेप्टम है and जो भी ये scroll like projections दिख रहे हैं, these are the turbinates. So this is your inferior turbinate, right? Then from the top, this is your middle turbinate. Okay, this is also your middle turbinate. And what do you see here? This is your maxillary sinus. This is also your maxillary sinus, which is black, right? Now, do you see, this is your orbit. And if you have been asked कि orbit के floor पे एक cell है, if there is any cell that is pneumatized at the floor of orbit, we will call this as Haller cell. We will call this as Haller cell. बहुत बढ़िया. So I think already Som Subra has already answered. So this is Haller cell. That is along the floor of the orbit, right? If you get any pneumatization, that is because of posterior ethmoidal air cells which have gone into the sphenoid sinus. So if the posterior ethmoidal air cells go into the sphenoid sinus and they pneumatize the sphenoid sinus, so you can see this is your sphenoid sinus, this is your sphenoid sinus, but ये कुछ extra आ गया. तो ये हमेशा याद रखना. Sphenoid sinus के अंदर अगर कोई cell है, which is usually posterolateral, मतलब ये देखो ये posterior है and laterally है, then this cell is called as Ono-D cell. Now what structure is present over here? This is your optic nerve. So in between the Ono-D cell and the optic nerve, there is a very little or a very less bone, very, very thin bone. So very highly chances are there that when you are removing the Ono-D cell, you accidentally injure the optic nerve too. That is why this Ono-D cell has an importance in sphenoidal diseases. Okay, fine. Chalo. Okay, now comes a very last of the nose segment. Okay, so you have got important sinuses: maxillary, frontal, ethmoid, sphenoid. Question क्या आता है? Which is the first sinus to develop in a child? The first sinus to develop in a child is maxillary sinus, earliest at birth. The first sinus to appear on an X-ray, maxillary sinus, around 4 to 5 months. ठीक है? The last sinus to develop after birth, frontal sinus. This is the sinus which is absent at birth. ये हमें याद रखना है. One sinus which is most pneumatized at birth, ethmoidal sinus. Okay, fine. Now, इनकी opening कहाँ होती है? Remember, family से fam, maxillary, anterior ethmoid, frontal. These open into middle meatus. Together, fam opens into middle meatus. Posterior ethmoid opens into superior meatus. And sphenoid opens into a recess called as sphenoethmoidal recess. Simple? ठीक है? सारे के सारे जितने sinus हैं, be it any sinus, they are supplied by the ophthalmic division of the trigeminal nerve, except maxillary sinus, which is supplied by maxillary division of the trigeminal nerve. Maxillary से maxillary. Ophthalmic बाकी सारे supply करेगा, V1 division, except for maxillary division, which is supplying the maxillary sinus. खत्म. This finishes our first segment of ear and nose. ठीक है? अब लेके भागते हैं the third segment, oral cavity and pharynx. चलो, अब ये एक endoscopic picture है, which is a diagnostic nasal endoscopy picture, जिसमें the diagnostic nasal endoscope has crossed into the nasopharynx, और nasopharynx में हमें क्या क्या दिखाई दे रहा है, right? This is something that they will ask you. ये nasopharynx है. This is something what you see over here, right? So they will point कि ये क्या है, ये opening कौन सी है? तो this is your eustachian tube opening, which is present on the lateral wall of the nasopharynx. Eustachian tube की opening के ऊपर there is a bulge. The bulge is called as torus tubarius. Torus tubarius. Torus tubarius is a bulge over the eustachian tube opening, which is produced by the cartilaginous end of the eustachian tube. Okay? There is a recess present behind the torus tubarius. There is a recess present behind the torus tubarius. This recess, which is present behind the torus tubarius, this is called as fossa of Rosenmuller. Fossa of Rosenmuller is the most common site for nasopharyngeal carcinoma. यहीं से निकलता है. This is the most common site for nasopharyngeal carcinoma. Okay, these are the potential thing that is important. अब ये side कैसे determine करेंगे? अब ऐसे सोचो कि patient ऐसे लेटा हुआ है, right? अब ये मेरा बिल्कुल lateral है, right? And ये मेरा बिल्कुल ये इधर का बिल्कुल lateral है. So obviously this lateral has to be my left side. So this has to be my left side. My right side will be on this side. Correct? So see me lying down. Just lie down in front of the patient. This is how the side determination can be done. And always on the lateral wall, you will have the eustachian tube orifice. Okay? Fine? Okay. Now let's come to important elements of Walde's ring. Walde's ring में क्या क्या होता है? Right? So you have got adenoids in the Walde's ring. Other name for adenoids? Luschka's tonsil. Right? Any easy way to identify fossa of Rosenmuller? Not, because it is a three-dimensional fossa. You cannot identify it. You can actually open it with a forceps. So fossa of Rosenmuller, just remember, if they are marking anything behind the torus tubarius, that is fossa, what they are asking about. Okay? Because it's a collapsed fossa. You understand, until you open it, you won't be able to see. Okay? So adenoids, other name, Luschka's tonsil. Other thing is called as tubal tonsil. Tubal tonsil का क्या मतलब है? That above this torus tubarius also there is some amount of lymphoid tissue. And that tissue that is present over the tube that is present over the torus tubarius is given the name as Gerlach tonsil. That's called as Gerlach tonsil. You have got two important tonsils present in the oropharynx called as palatine tonsil or facial tonsil. Then you have got tonsils which are present at the base of tongue. There is a tissue present at the base of tongue which is called as lingual tonsil. And then you have got certain important bands which are present in your pharyngeal wall. They are called as lateral pharyngeal bands. All of these are components of the Walde's ring, and these are important for you to know as far as a question comes, what among them is not a part of Walde's ring. ये सारे parts हैं of Walde's ring. Okay, and you should know about the other names as well. Okay, now one important thing I want to tell you about adenoid hypertrophy. Adenoid hypertrophy is also given the name as nasopharyngeal tonsil. Okay, right? Now, one important thing is that whenever you get any question in your paper that you have got a child 7 to 8 years old, which child has got nasal obstruction, mouth breathing, snoring, close your eyes and say it is about adenoid hypertrophy. But if they are asking you this child has nasal obstruction, mouth breathing and snoring at 20 years of age, the answer is not adenoid. Adenoid hypertrophy occurs from 6 to 7 years of age and atrophies by the age of 12 to 14 years because it is a lymphoid tissue. See what they are asking as far as age is concerned. So if they are asking about mouth breathing, snoring, nasal obstruction, mass in the nasopharynx of a child of 7 years, 8 years, be it till 12 years, answer is adenoid. But if they are asking about an adolescent male, 18, 20-year-old, nasopharyngeal mass, epistaxis, they are talking about juvenile angiofibroma. Remember this line, right? So this is upon the basis of age, right? So obviously this is a nasopharyngeal tonsil. So if this is your nasopharynx, this is your eustachian tube, this is your adenoid. It is present from the roof of the nasopharynx and it hangs downwards, right? That is what I have written over here. It starts to grow at 2 years of age, increases in size at 6 to 8 years and atrophies post-puberty. You won't find post-puberty. Okay? Now, one important difference between a tonsil and an adenoid is the adenoids do not have crypts and a capsule. 2 C's absent in adenoid, don't have crypts, don't have tonsil, don't have a capsule. Okay? Which both of them are present in a tonsil. Chalo. Now we come to what are the features of adenoid hypertrophy? Now simple features you tell me. If something is blocking the nasal cavity here, then obviously the child will breathe from the mouth. So these children will be mouth breathers, right? They will have nasal obstruction. So they will have nasal obstruction. They will have mouth breathing, right? Now, if there is such a big mass in the nasal cavity, in the nasopharynx, unke kya hoga? They will snore during the time of sleeping. So they will be snoring. And I also told you when I was teaching you ear that the most common cause of otitis media with effusion in children is they will have eustachian tube blockage because of adenoids. So most common cause of conductive hearing loss in children is because of otitis media with effusion, is because of adenoid hypertrophy. So you can see over here, it's because of otitis media with effusion causing conductive hearing loss. Sometimes, in some cases, there could be even epistaxis, but epistaxis is not a primary feature of adenoid hypertrophy. Okay, fine. Now, because these children are having nasal obstruction, they are not sleeping properly, and also they are snoring. So snoring ke chakkar mein they have carbon dioxide retention. Because they have got carbon dioxide retention, their brain becomes foggy. So in the morning, they are not very fresh. If they are not fresh in the morning and their brain is foggy, that will lead to an inattentive behavior. मतलब वो ध्यान नहीं देंगे किसी चीज में. That is the reason they don't perform well in school. They drop out from school. They go bad in ranks. This particular phenomena is called as Guy's aproxia. What is Guy's aproxia? It is an inattentive behavior due to decreased hearing, and it is because of the CO2 retention that is happening because of obstructive sleep apnea. Okay, fine. Now, if there is nasal blockage, now see my nose, I am blocked. What is this nose voice called as? If my nose is blocked, what is this voice called as? If my nose is blocked, that voice is called as hyponasal voice. And that hyponasal voice is called as rhinolalia clausa. So if I have hyponasality of voice, I have rhinolalia clausa. So one more thing. If I have hypernasality of voice, then it is called as rhinolalia aperta. अब ये important 2 question है. Hyponasal, नाक बंद हो गई. Hypernasal मतलब बहुत ज़्यादा नाक से हवा आ रही है. So hypernasal of voice is called as rhinolalia aperta. Hyponasal voice is called as rhinolalia clausa. Hypernasal voice or aperta is a feature of cleft palate. It is a feature of cleft palate. Okay, so remember this line. Now, obviously, these patients are breathing from the mouth, so they will have adenoid facies. What is adenoid facies? Adenoid facies means their whole face will become elongated. Why? Because now they are mouth breathers. So they are breathing from the mouth. They will have an elongated mandible, right? At the same time, they are not using their nose much. So they will have pinched in nose, right? Their nose will be pointed out, right? At the same time, because their mouths are always open, their tongue never touches over their gums. And you know children are very important for causing stimulation of the gums to get teeth out. So if their tongue will not touch the gums, their teeth will come crowded. And that is the reason they will have crowded upper incisor. ये सारे दांत आगे crowded हो जाएंगे. Now because the upper incisors become crowded, their lip becomes pinched up. ये lip ऊपर चली जाएगी. So they will have an elongated mandible, they will have a pinched upper lip, they will have crowded incisors, they will have a pinched in nose. Why? Because they have alar atrophy. Alar use नहीं कर रहे. And they will have a very dull expression over their face. Now one more important thing is that not only the teeth come out when the tongue is touching the gums, it also molds your palate. These children are having an open mouth, their tongue never touches the palate. And that is the reason why they get a high arched palate. These are the classical features why these people are having this adenoid facies. The other name of adenoid facies is also called as long face syndrome. It's also called as long face syndrome. Okay? Chalo. Now we come to the next one. How do we manage, right? So usually in small adenoids, the drug of choice is intranasal steroid, mometasone. We give intranasal mometasone nasal spray, right? What is the surgery that we do? Surgery is adenoidectomy. Okay. What is the position for adenoidectomy? It is Rose position. Now remember one thing. Rose position क्या होती है? Rose position is extension at the atlanto-occipital and cervicothoracic joint. Cervicothoracic matlab between the chest and the neck and the atlanto-occipital joint. If I have extension on both the joints, now rose कैसे दिया जाता है? A boy sits down and gives a girl a rose like this, right? So if there are extension at both the joints, we call that as rose position. Rose position में कौन सी surgery करते हैं? In rose position, you do tonsillectomy, you do adenoidectomy, you do tracheostomy. 3 surgeries that are done in cases with rose position. Very important, very, very important point. Right? Now, if you are asked a question that the child is having mouth breathing and snoring as primary symptoms, no ear complaints, your plan of management should be adenoidectomy alone. But if you are told that the child has adenoid hypertrophy with conductive hearing loss, that means child also has otitis media with effusion. So your answer will become adenoidectomy with myringotomy. Okay, then you will choose both with grommet insertion. Right? Okay. Chalo. So now I'll just come directly to one important thing, that is what are the complications of adenoidectomy, right? Complications of adenoidectomy means they will ask you one important question. कि complication में सबसे important complication जो होती है, that is Grissel syndrome. This is something that they will ask you. So what is Grissel syndrome? Grissel syndrome means subluxation of the atlanto-occipital joint. अब क्या होता है? We use something called as an adenoid curette. Adenoid curette को हम dagger की तरह पकड़ते हैं. And what do? We put the patient in a rose position, put the adenoid curette inside and scrape the adenoids. Now, whenever we are scraping the adenoids, we put a lot of pressure over the atlanto-occipital joint. And when we put a lot of pressure over the atlanto-occipital joint, it might accidentally cause its subluxation. अगर subluxation हो गई, it can even lead to paraplegia. This is called as Grissel syndrome. ये सबसे important question है that has come over in this complications of adenoidectomy. Other than that, obviously, adenoid is next to the eustachian tube. So we can lead to eustachian tube injury, right? We can also lead to palatal injury, which can lead to hypernasality. We can lead to hemorrhage directly from the adenoid, which can start bleeding. Okay? So this is something that is very important. Grissel syndrome is very important as far as adenoidectomy is concerned. Chalo. Now let me come down to the next topic, JNA. Okay, एक और बड़ा important topic, एक और बड़े important questions. Very, very famous topic that has been asked previously too. What is juvenile nasopharyngeal angiofibroma? Juvenile nasopharyngeal angiofibroma is the most common benign tumor of the nasopharynx. It is a benign tumor of the nasopharynx, right? But yet it is locally invasive. अगर आपके पास ये question आता है that you have got a nasopharyngeal mass in an 18 or 20-year-old boy. Remember boy, because this is a tumor in males, predominant males. Why? Because it is an androgen-dependent tumor. It is a tumor which depends on testosterone. Okay? So this will be in young adolescent males. Why? Because it is hormonal dependent. Okay? 18 से 20 साल वाले males. Now, why does that happen? So there is a foramen which is called as sphenopalatine foramen. And sphenopalatine foramen में एक आर्च की आर्टरी जाती है. द फर्स्ट ब्रांकियल आर्च आर्टरी इज द मैक्सिलरी आर्टरी. If by any chance that maxillary artery remains patent or it remains as a remnant in that area, that under the influence of certain hormones can start becoming a tumor. So the most accepted theory for juvenile angiofibroma is that if there are certain vascular remnants of the first pharyngeal artery, first pharyngeal arch artery कौन सी है? Maxillary artery. And if there are certain remains or certain remnants that remain behind in the sphenopalatine foramen area, then they might grow under the influence of testosterone, and that might lead to later on angiofibroma formation. Right? So what is the site of origin? Site of origin is the sphenopalatine foramen superior lip. This is as it is how they ask the question. कहाँ से आ रहा है? Superior lip of the sphenopalatine foramen. Okay? चलो. Now let me come to the next one. One important thing that they will ask you is JNA में क्या नहीं करते हैं? This is something what they have asked you recently in your INI-CET paper. What is one thing that you do not do in JNA? The one thing that you do not do in JNA is a biopsy. Never ever do a biopsy in juvenile angiofibroma. Why? Because these angiofibromas do not have a smooth muscle coat. इनकी जो ये उनकी vessel है, right? ये vessels हैं angiofibroma की, and they lack a smooth muscle coat. इनकी smooth muscles बनी नहीं है. So what will happen? If you punch a biopsy out, this tumor will keep bleeding out and it will keep oozing blood. And that is the reason we do not biopsy these tumors, because of delayed vasoconstriction, right? What is the investigation of choice? CECT. Contrast enhanced CT scan. That is the investigation of choice. Thank you, Harshit. Thank you. Okay. दो important sign. Holman-Miller sign, Hondusa sign, as it is, बहुत बार पूछे गए. What is Holman-Miller sign? अब ये क्या होता है? Now, what you are seeing over here, see, this is your nose, right? This is your nose. Behind the nose, this is the area for nasopharynx. Nasopharynx काला होना चाहिए था. It should have been black. Why? Because it contains air. But you don't see anything black over here. You see something gray. Gray means obviously tumor. Anything soft tissue is gray, right? Now what will happen? If this particular area has got this JNA, right, it will spread into this area which is called as pterygopalatine fossa. Pterygopalatine fossa is a fossa present behind the maxillary sinus. You can see this is your maxillary sinus, this is your maxillary sinus, and behind that sinus, this is your pterygopalatine fossa. If the tumor is spread into the pterygopalatine fossa, it will push the posterior wall of the maxilla anteriorly. You can see here, this maxillary sinus posterior wall is shifted more anteriorly. So anterior bowing of the posterior maxillary wall is given the name as what? It is given the name as Holman-Miller sign. And this is a classical feature when the tumor has invaded into the pterygopalatine fossa, which is a fossa present behind the posterior wall of maxilla. Okay? Now we come to the next sign, which is called as Hondusa sign. Hondusa का क्या मतलब है? Now the tumor has gone more lateral, और आगे चला गया. Now when it comes more laterally, it will displace the mandible laterally. मतलब ये हमारी mandible है. This is mandible. If the tumor comes just beneath the mandible, it will displace the mandible laterally. You can see here. This is the mandible, right? This is the mandible. It has displaced the mandible laterally. More displacement of the mandible laterally. If the mandible gets displaced laterally, we call that sign as Hondusa sign. Hondusa sign is a classical feature that the tumor has spread into the infratemporal fossa. क्योंकि ये temporal है, इसके नीचे infratemporal. So if the tumor is in infratemporal fossa, we will tell Hondusa sign. If it is in pterygopalatine fossa, we will have Holman-Miller sign. Okay? Fine? Stage of GT. बिल्कुल सही जवाब, stage of GT. तो एक sign हम और कर लेते हैं. I'll tell you the stage of GT. Okay? एक sign we will also do, that's called as chopstick sign. Chopstick sign का क्या मतलब है? So can you see this pterygoid plates? Can you see these pterygoid plates coming medial and lateral pterygoid plate? If the juvenile angiofibroма has spread and it has caused these pterygoid plates to become disrupted, मतलब अब ये pterygoid plate पहले ऐसी थी, अब ये ऐसी हो गई हैं. They are dancing. They do not have any attachment because now the tumor has spread over here. So this is called like a chopstick. Chopstick की तरह ऐसे दो पड़ी हुई हैं. This is called as chopstick sign, right? Where the attachment of the pterygoid plates has actually been eroded. These are the three signs which you need to know in GNA. Okay. Now I'll come to what you asked about. What is the staging? ठीक है. अब ये staging दिखती बहुत लंबी चौड़ी है और बहुत बहुत बड़ी दिखती है, डरावनी दिखती है. But I'll tell you a very simple way to crack this answer as far as staging is concerned. The staging that we do for JNA is called as 𝐒𝐿𝐄𝐝 staging. 𝐒𝐿𝐄𝐝 staging. Okay, it has got 3 stages, 1, 2, and 3. One is divided into 1A and 1B. 1A means that the tumor is only inside the nose and nasopharynx. मतलब शुरू हुआ है. The tumor is only inside the nose and nasopharynx. That is 1A. So they will tell you सिर्फ वहीं पे है, in the nasopharynx area. 1A. If they tell you that any sinus gets involved, any sinus जहां पे word आ गया, make it 1B. That means one or more sinus gets involved. That is 1B. Now comes 2. 2 में I told you one fossa where JNA loves to go is pterygopalatine fossa. So if there is minimal extension into pterygopalatine, बस I start हुआ है, minimal extension into pterygopalatine fossa, it becomes 2A. If there is complete involvement of pterygopalatine fossa, it becomes 2B, or it has invaded into the orbit also. So complete invasion into the pterygopalatine plus the orbit, 2B. Whenever they say the word infratemporal, close your eyes, it is 2C. Simple. Infratemporal, 2C. Now comes to 3A and 3B. 3A का मतलब it has eroded the skull base but not gone intracranial. So there is minimal erosion into the skull base. Completely it has gone into the intracranial compartment, 3B. So catch points are complete involvement of pterygopalatine fossa, orbit, 2B, infratemporal wherever they use, 2C. These are the two things which they will ask you as questions, 2B and 2C, because these, and 2A, which is minimal extension into pterygopalatine, because these are the ones which confuse you. 2, stage 2 से ही question आएंगे if they ask you any stage related question. Okay? What do we do before? The only thing, conducer sign will be in 2C, infratemporal na. So infratemporal fossa, when the lateral mandible will be shifted, that is 2C. Okay? Treatment is surgical. We do not have any drug to treat JNA. The only thing is surgical, right? Surgical treatment means that we always do something called as preoperative embolization. We close the vessels. That is called as preoperative embolization. Other than that, we do a surgical approach. You don't need to know any other thing except for endoscopic. Don't bother about any other names. There are many names to it. I've just written it because of your notes. Okay, because I gave you notes, that's why I written it. But actually you need to focus upon only one thing which is quite commonly done in our practice. That is endoscopic transnasal approach. That is the most common thing that we do. But before that, we do something called as preoperative embolization because we know that this bleeds a lot. है ना? If the JNA is too huge, बहुत बड़ा JNA हो चुका है, and it is not, we cannot operate it, it's gone into the intracranial compartment too. In those cases, we can give something as a medical line of treatment to shrink the tumor. And that drug is an anti-androgen drug. Uska naam hota hai flutamide. Flutamide is a drug of choice to shrink the tumor if it is very big. Or we can also give a short radiotherapy in order to shrink the tumor. But again, these are not the first line of treatment. First line of treatment for JNA is always pre-op embolization and surgical management. That's it. Okay? चलो आगे बढ़ते हैं. Nasopharyngeal carcinoma. इससे क्या क्वेश्चन आए हैं? Most common carcinoma of nasopharynx is nasopharyngeal carcinoma. Most common histological subtype of nasopharyngeal carcinoma is squamous cell carcinoma. Most common site where nasopharyngeal carcinoma comes out, fossa of Rosenmuller. Simple. 3 question, तीनों straightforward from nasopharyngeal carcinoma. Okay? अगला. What is the etiology of nasopharyngeal carcinoma? Sometimes they ask you this question very, very commonly. Now, this is something जहाँ पे आपको वो देंगे कि that patient has come from Southeast Asia, कहीं से, like China, Indonesia, Hong Kong, northeast part of India. They will tell these areas. हमेशा देखना यही सारे areas हैं. Most commonly they will have a Chinese population because this is something which is most commonly indolent to Chinese population. Okay? Now, one thing why it is common in Chinese area and Chinese or Southeast Asia is क्योंकि वहाँ पे consumption होता है of something called as salted fish. Right? Salted fish में एक चीज होती है which is called as nitrosamine. And nitrosamines are carcinogens which are released from the salted fish and which can directly lead to nasopharyngeal carcinoma formation. So that is the reason why this carcinogen is present and that is the environmental cause for nasopharyngeal carcinoma. Right? Okay? So clinical presentation of NPC मैं बताऊंगा. I'll tell you how this clinical presentation of NPC question will come. Okay? One important question is कि what is the virus associated with NPC? Your answer is Epstein-Barr virus. क्योंकि there are certain IgA antibodies against Epstein-Barr virus which are seen in NPC patients. Okay, that is why we commonly do something called as viral capsid antigen as well as nuclear core early antigen testing. So we see IgA against viral capsid antigen as well as early antigen which is present in the Epstein-Barr virus, and these are very good markers to screen population whether they have NPC or not. So अगर उनकी IgA antibodies are raised against this viral capsid antigen as well as this nuclear antigen, then obviously there will be there'll be a high chance that these people have NPC. Okay, so these are very important sensitive and specific markers. Okay, now one more important thing that you need to know about is that what recently what asked. Okay, clinical features कि क्या clinical features आएंगे. अब एक चीज याद रखना, this will be the hit question how they will give you. The only symptom, the earliest symptom that comes in nasopharyngeal carcinoma is not nasopharyngeal symptom. It is painless cervical lymphadenopathy. Please remember this line. If a patient has got NPC, the first and foremost symptom that they will give you will be a level 2 or a level 5 lymph node which has enlarged. It is painless and palpable. This is the first thing that will be presented in the patient. Second important question that they will ask you is, what is the most common cause of unilateral otitis media with effusion in an old adult? Which I think you have already written. So always remember, unilateral serous otitis media or otitis media with effusion in an aged adult, you should think about nasopharyngeal carcinoma. These are the two questions which they will give you, right? So if the patient has got first symptom is always painless cervical lymphadenopathy. What are the two lymph node? It is lymph node level 2 and level 5, which I've already written over here, right? Then I wrote for you, there is unilateral serous otitis media. Any adult unilateral serous otitis media, you have to think about NPC, right? And if this goes or spreads into the parapharyngeal space matlab space around the pharynx, then obviously the patient will also have cranial nerve involvement, and the most common cranial nerve involvement will be 9th, 10th, 11th, 12th and sympathetic chain, right? So glossopharyngeal, vagus, spinal accessory, hypoglossal together with sympathetic chain, these are the cranial nerve paralysis that you will get. If it goes into the orbit, if it spreads into the orbit from the nasopharynx, then you will have ophthalmoplegia. Why? Because there will be oculomotor, there will be trochlear and as well as abducent nerve involvement, right? And if in case the second nerve gets involved, it will lead to blindness. But these are all late features. Again telling you two important questions. One is serous otitis media, one is cervical lymphadenopathy. Remember them. Okay? चलो अब आते हैं next. Most common distant mets occurs skeletal. Most common area thoracolumbar spine. Okay? What is Trotter's triad? This is a classical question of FMGE. Trotter's triad का मतलब the patient will have ipsilateral palatal palsy, ipsilateral conductive hearing loss and ipsilateral temporoparietal neuralgia. Trotter's triad का mnemonic NPC में दिखता है NPC. NPC means neuralgia because of the involvement of fifth cranial nerve, palatal palsy because of the involvement of 10th cranial nerve, and conductive hearing loss because of the eustachian tube invasion, right? So this is something that is about Trotter's triad. What is the investigation of choice? CCT, MRI with gadolinium contrast. What will be used for screening? I already told you, IgA against viral capsid antigen and early antigen of VVV. Okay? Chalo. Now let's go on to the next one. What is the treatment of choice? The treatment of choice for NPC always remains non-surgical because this particular area is difficult to resect. So that is the reason the first and foremost treatment of choice for NPC is always intensity modified radiotherapy, chemotherapy. So we will give radiotherapy together with concurrent chemoradiation. This is the first treatment of choice. This is something we always give. Okay, concurrent chemoradiation together with intensity modified radiotherapy. When do we do surgical? Surgical is only reserved in those cases jahan pe the tumor is very small. Only in those cases we try surgery and we do something called as nasopharyngectomy. That is only for the very small tumors. But again, large tumors, we have to do this. First line of treatment is this. Okay? Chalo. Now we move on to tonsils. अब हम थोड़ा नीचे आ जाते हैं. Okay? अब ऊपर हमने कर लिया काम खत्म, अब नीचे आते हैं. Tonsils में what do they ask as a question? Obviously, let's finish off the important tonsillar infections. Acute tonsillitis, obviously it's an acute infection of the tonsil, is called as acute tonsillitis, right? Most common cause or most common organism which is causing acute tonsillitis is what? It is always group A beta hemolytic streptococci. So group A beta hemolytic streptococci forms the most common organism which causes acute tonsillitis. Okay. So this is something which is easy. What are the types of acute tonsillitis, right? So let's say this is the tonsil, right? And you can see that the medial surface of the tonsil has got crypts, right? The largest crypt of the tonsil is called as crypta magna. Crypta magna. Crypta magna is a remnant of the ventral portion of second pharyngeal pouch. As it is asked question, what is the derivative for crypta magna? It is the ventral portion of the second pharyngeal pouch which remains. That's called as crypta magna, which is the largest crypt of the tonsil. Okay? Chalo. Ab. If there is inflammation of the superficial surface of the tonsil, सिर्फ ऊपर का tonsil inflame हो गया है, we will call that as acute catarrhal tonsillitis, which is called as superficial tonsillitis. That is the first stage of acute tonsillitis. Second stage of tonsillitis is if the whole substance of tonsil is inflamed. ये सब inflame हो गया. The whole substance of the tonsil is inflamed. We will call this as acute parenchymatous tonsillitis. That means पूरा parenchyma inflame हो गया. Third, if the tonsil is now containing pus within this crypt, then it is called as acute follicular tonsillitis. अब crypt के अंदर pus बन गया. If these pus points join together to form a membrane, then it is called as acute membranous tonsillitis. These are the types of tonsillitis: catarrhal, parenchymatous, follicular, and membranous. Right? Chalo. Now I come to the next question. What are the following signs of chronic tonsillitis? ये बहुत important question है. Chronic tonsillitis के क्या signs होते हैं? Right? Let's say this is your tonsillar fossa. This is uvula. And you have got the tonsil inside it. This is your tonsil. This is your tonsil. This is your tonsil. What are the things that you will see in cases of chronic tonsillitis? The first thing that you will see in chronic tonsillitis is that this anterior pillar will be congested. It will be red in color. I've already made it in red color, so this will be red in color, right? So this is called as flushing of the anterior pillar, first sign of chronic tonsillitis. Second sign of chronic tonsillitis is called as Irwin-Moore sign. What is Irwin-Moore sign? Very, very important. If I take a tongue depressor, let's say this is my tongue depressor, and I push the anterior pillar. So when I push the anterior pillar, there will be dirty pus-like extrusion from the crypt. Pus niklega crypt ke bahar. If pus comes out from the crypt after I push the tonsil or I push the anterior pillar, that is called as Irwin-Moore sign. Expression of cheesy material or pus after I push the tonsil. Third sign of chronic tonsillitis is enlarged non-tender jugulodigastric node. What is the lymph node of tonsil? Jugulodigastric or upper jugular node, which is the node which is commonly enlarged in cases of tonsillitis. If the upper jugular node is involved, it's called as it's called as the lymph node of tonsil, right? So you will have non-tender enlarged jugulodigastric nodes because they have been enlarged since a very long time. Finally, there will be hypertrophied or shrunken tonsil. So you will either see a very big tonsil or you will see a shrunken tonsil. These are the four classical hallmark signs whenever chronic tonsillitis comes. They will tell you which among them are not the features of chronic tonsillitis. And they will ask you these questions. Irwin-Moore is a direct question in FMGE. Okay? Chalo. Now let me come to the next question. अब मैं आता हूं, what exactly are the important positions that you require in tonsillectomy? Right? Tonsillectomy kya? The two important positions that you use in cases of tonsillectomy as well as other things. Now, दो important position होती हैं, Rose position and Boyce position. One is called as Rose position and one is called as Boyce position. What is Rose? Rose and Boyce का क्या फर्क है? Rose means that there is extension at the atlanto-occipital plus the cervicothoracic joint. Both the joints are extended. Then it is Rose. What are the 3 surgeries we do under Rose? Tonsillectomy, adenoidectomy, tracheostomy. That is all. अब आता है Boyce position. What is Boyce position? Boyce means sniffing position and this is used in all scopies. सारी जितनी स्कोपी पता है, esophagoscopy, bronchoscopy, laryngoscopy, सारी स्कोपी में there is Boyce position. So remember these 2 positions. Other name for Boyce position is sniffing position or barking dog position. Okay, fine. अब एक क्वेश्चन आपके पास आएगा which was very recently asked question, right? That there was a patient who that was the last FMGE paper question actually. There was a patient, young boy, who underwent tonsillectomy. Then what happened was on the 3rd or 4th day that patient ate chips. और chips खाने के बाद उसके गले से bleeding होने लगी. That boy rushed to the doctor. What is the diagnosis of this patient? That was the question that was asked in the previous FMGE paper. Previous क्या? Because the last year पूछा गया. Okay. So what are the types of hemorrhage you see in tonsillectomy? Correct. So already I've got an answer. It's secondary. You've got primary hemorrhage, you have got reactionary, and you have got secondary. What is primary? अगर bleeding आपको during the intraoperative period दिख गई, it is called as primary hemorrhage that occurs during surgery. What is the most common site to bleed during surgery? The most common site to bleed during surgery is basically paratonsillar vein and the tonsillar branch of facial artery. Tonsillar artery or the tonsillar branch of facial artery is a very big artery which supplies the tonsil. And there is a vein called as paratonsillar vein, right? These are the 2 things which bleed primarily in primary hemorrhage. So we cauterize them, we ligate them, that's done. If the hemorrhage occurs after the surgery or within 24 hours, you shifted the patient to post-operative ward, within 6 hours you got a call that come back. That is called as reactionary hemorrhage. Reactionary hemorrhage occurs either कि clot होगा, that clot got dislodged, or there would have been a ligature, that ligature got slipped, or maybe the patient became hypertensive, suddenly hypertension, blood vessel opened. All of these things will lead to reactionary hemorrhage. So if a patient has reactionary hemorrhage, you need to go to the OT, re-explore the site and close it. That is how you treat it. What is secondary? Patient will be discharged. This is after 24 hours, you have gone home. Within 7 to 10 days, the patient had an infection in the tonsillar fossa. Most common cause of secondary hemorrhage is infection. So now the patient will come back with secondary fossa infection and the most common cause is an infection. So obviously we give antibiotics as the first line of treatment. After that, if there is a lot of bleeding, we re-explore, right? That is how we treat secondary hemorrhage. Okay. Now let me go to the pre-malignant lesions of the oral cavity. अब pre-malignant lesions of the oral cavity में आपको at least देखने जरूरी है कि what are the important pre-malignant lesions of the oral cavity. If they show you a picture or if they tell you that there is a 𝐒𝐿𝐴 and that particular patient has got a white patch or a plaque which cannot be scraped off easily from the oral cavity, that answer will be leukoplakia. So you can see this is a white patch or a plaque which you cannot scrape off easily. It is large, more than 5 millimeters, right? You cannot scrape that out. Answer will be leukoplakia. Leukos matlab white, plakia matlab patch. Okay, fine. Obviously, how will you treat it? If you have so all types of pre-malignant lesions, we do surgical excision. We tell them cessation of habits. Drug of choice is an antioxidant which is called as beta-carotene. Beta-carotene is an antioxidant which is a drug of choice for all types of pre-malignant lesions of the oral cavity, right? Now, one important thing, right? Yes, only candida can be scraped off. Candidiasis, that is why, is not a pre-malignant lesion. Hypertrophic candidiasis question आया था that which among them following is not a pre-malignant lesion. You cannot scrape off any other lesion except for candida. That's right. Okay. If you see instead of white there is something red, that means now you see a red velvety patch over on the oral cavity and that cannot be scraped off easily. Answer is erythroplakia. If they ask you which among the following pre-malignant lesions has the highest predisposition to becoming a malignancy, answer is erythroplakia. Erythroplakia has the highest chance of becoming malignancy, which is 30%. Okay, fine. Same surgical excision, cessation of habits, beta-carotene. Same thing, even in this. Now we come to the next one. If they show you this kind of a picture, If they show you this kind of a picture where a person has been a chronic betel nut chewer and this particular person now has got dense fibrous bands, and there is also something like an ulcer that is present in the cavity. So now you have got an ulcer. Now you have got dense fibrous bands. What will be this particular condition? This has to be oral submucous fibrosis. What is oral submucous fibrosis? Oral submucous fibrosis is a condition which is containing blisters. Because of chronic betel nut chewing, you'll get blisters in the oral cavity. These blisters will again, fibrose, and when they fibrose, they will lead to dense fibrous tissue formation. So you'll see these kind of white bands, right? And they will classically give you that this patient has got trismus. They will have trismus or difficulty in mouth opening. Okay, they will have restricted mouth opening. Answer is trismus. Now I've been asked, importantly, is lacy pattern. Nahi. Lacy pattern is seen in cases of lichen planus. Okay, if you see something white and lacy, let's say this is a buccal mucosa, if you see white lacy like lesions, is tarike se, these are called as 𝐒𝐿𝐻𝐵𝐻𝐻's tria. These are called as 𝐒𝐿𝐻𝐵𝐻𝐻's tria. 𝐒𝐿𝐻𝐵𝐻𝐻's tria. 𝐒𝐿𝐻𝐵𝐻𝐻's tria is a classical thing which we see in cases of LP or we see in cases of lichen planus. Okay, fine. Chalo. So now, how will you treat this particular condition, OSMF? So for obviously we need to cure this condition, plus we need to open the mouth, right? It's a locked jaw, correct? So now we need to avoid the habits for obvious reasons. We need to give them high dose of antioxidants, which is beta carotene as well as lycopene. We also do something called as intralesional injections. Now this is something which has been asked to you. Intralesional injections kya hote hain? Intralesional injections contain triamcinolone as well as hyaluronidase. Triamcinolone एक steroid है which is anti-fibroblastic. जब हम steroid डालते हैं तो fibroblast कम हो जाते हैं, तो collagen deposition कम हो जाएगा. Hyaluronidase will get or cut the ground substance. It will get down the hyaluronic acid. So if we give this injection weekly, inside we directly take an injection and we put it inside and we inject that solution in various sites, and at the same time we tell the patient to open the mouth by the use of a jaw appliance. We give the patient a jaw appliance. So jaw appliance से क्या होता है? He will keep stretching the mouth with the jaw appliance. This is the classical way in which we treat oral submucous fibrosis. If in case oral submucous fibrosis is not getting treated, तब हम क्या करते हैं? We do something called as surgical management. Yes, we can give Placentrex also because it promotes healing, right? But at the same time, surgical management is only done in cases when we cannot treat them medically. सर्जिकल मैनेजमेंट में क्या करते हैं? वी कट दीज बैंड्स, हम ये फाइबर्स को रिलीज कर देते हैं. वी कट ओपन दीज फाइबर्स, एंड व्हेन वी कट दीज फाइबर्स वी नीड टू पुट समथिंग इन बिटवीन देम, नहीं तो अदरवाइज दे विल अगेन फाइब्रोज. इन ऑर्डर टू मेक देम अवे, व्हाट वी डू? We put a graft in between them. We put an interposition graft in between them. So we cut and we put a graft in between them. That's called as an interposition graft. Okay, that's how we treat submucous fibrosis. If in case this also doesn't work, then what we need to do? We need to cut open the temporalis muscle fibers. Temporalis is a mouth closer. So we need to cut the temporalis muscle so that the mouth can open more. This is the surgical management. The last one is cut the temporalis muscle, which is reserved only for those cases which have got severe trismus. Okay, fine. This finishes about my important thing, which is related to oral submucous fibrosis. अब आते हैं थोड़ा और नीचे. थोड़ा और नीचे क्या है? Pharyngeal, pharynx. Or like now we come into the laryngopharynx or the hypopharynx. Very important question, pharyngeal pouch, right? What is pharyngeal pouch? So you must have seen this particular image, right? इस particular image में what are these patients immunocompromised? Not exactly. This is because of the chronic chewing that they have been doing since a very long time, and that is the reason why they have got these particular conditions to happen. Okay, they are very normal people. Okay, not immunocompromised. Now you can see this particular cross section of the pharyngeal muscles, right? So you have got a muscle which is called as inferior constrictor. उसके दो part होते हैं, which is thyropharyngeus and cricopharyngeus, right? So what is this? Above this is your thyropharyngeus part, and below this is your cricopharyngeus part. This is your cricopharyngeus part. Okay. Now the space present between the cricopharyngeus below and the thyropharyngeus above, this space that is present like a triangle, this space which is present between the thyropharyngeus fibers above and the cricopharyngeus below. This space is called as 𝐒𝐿iens dehiscens. 𝐒𝐿iens dehiscens. Okay, this is called as 𝐒𝐿iens dehiscens. एक और space होती है. There is one more space which is present between the cricopharyngeus above and the outer longitudinal fibers of esophagus below. This is your esophagus fibers. So this little space over here between the cricopharynx and the outer longitudinal fibers of the esophagus, this is called as Lammer's dehiscence या Lammer's triangle. दो important जगह होती हैं जहां से pharyngeal pouch होता है. Lammer's triangle below and 𝐒𝐿iens dehiscence above. 𝐒𝐿iens dehiscence is the most common, which is present between the thyropharyngeus and cricopharyngeus. Okay. Now what is this particular pouch all about? When the food is getting pushed from above, right? Then what happens? The food bolus gets pushed and the cricopharyngeus muscle undergoes tonic spasm. मतलब ये cricopharyngeus बंदी रहती है. It keeps closed. So from above the food is getting pushed, but the cricopharyngeus is not relaxing. It is under tonic spasm. So what will it do? It will push the mucosa of the pharynx out in the form of a pouch. That is why this is a false diverticulum. That is why it is a false diverticulum, or it is also called as a Pulsion diverticulum, or we also call it as Zenker's diverticulum. So any of the things, Zenker's, Pulsion, pharyngeal pouch, hypopharyngeal pouch, anything, it qualifies into the same thing. Okay, fine. Now, one important thing is that if you get this particular pouch, what will happen? So you can see that this is a barium swallow, which is the investigation of choice, right? No true mucosal layer. That is why it is false. So what do you see over here? This is your Pulsion diverticulum, and what you see inside, this is your barium swallow. Barium swallow is the investigation of choice, what you do for seeing it, correct? Now, what will be the symptoms of this patient? The symptoms of this patient will be that they will always have regurgitation of food. Whenever they will eat, the food will get stuck over in this pouch, and it will again regurgitate through the mouth, and they will vomit it out, right? So they will be intolerant to eating, and that at the same time, they might get that food inside into the trachea also, and that might lead to hoarseness and aspiration. So they have a fear of eating, and because they cannot eat, that is why they undergo significant weight loss, right? So that is why there is undigested food, there is halitosis, there is aspiration, hoarseness, weight loss, and they will feel there is something as a lump in the throat. Okay. Now remember one thing, feeling of lump in the throat is called as globus. This is called as globus. Feeling of something stuck in the throat is called as globus. Okay. What is the sign that you see over here? The sign that you see is called as Boy's sign. This is called as Boy's sign. Okay, that is the sign that you see over in this condition. What is Boy's sign? That if there is a swelling which is produced by a pharyngeal pouch in the neck, if you compress it, it will produce a gurgling sound. So gurgling sound produced by pressing is called as Boy's. Remember two signs. Boy's sign is seen in pharyngeal pouch. Bryce sign is seen in laryngocele. So Boy's or Bryce में confusion मत करना. Bryce is laryngo. Boy's is hypopharyngeal pouch. Okay, or Zenker's diverticulum. Right? Now, what is the diagnostic investigation of choice? I already told you that is the barium swallow. Now, this lesion occurs on the left side because of the curvature of the esophagus towards the left. That is why you can see it most towards the left side. Okay? Okay. How do you treat it? For obvious reasons, we need to excise it out. So we do some procedure. And what is that procedure? Either we excise it out transcervically, we put an incision from outside and we remove the sac, and we do something called as a cricopharyngeal myotomy. We release the fibers of the cricopharyngeus muscle so that the tonic spasm is relieved. But more commonly, we do something called as endoscopic stapling and Dolman's procedure. Right? Okay. So that is the treatment of choice. Where what do we do? That let's say this is the esophagoscopic view. This is the true lumen of the esophagoscope. This is the pouch, right? So what do? We break this wall or this partition between the lumen and the pouch. And what do? We staple them together. We staple them together so that it becomes a huge pouch now, right? This is called as Dolman's procedure. Okay. So this is something that is very commonly done nowadays because we have got good amount of esophagoscopes and we can do this easily. Okay. So no need to go for the transcervical approach. चलो अब आते हैं next पे. अब this is something I need to explain you guys. Okay. Four important actually deep neck spaces infections. One is peritonsillar abscess, retropharyngeal abscess, parapharyngeal abscess, Ludwig's angina. ठीक है, ये सारे क्या होते हैं? कैसे होते हैं? How do we identify them? How do we actually get these options right? Okay. So first and foremost, I'm going to talk about what is peritonsillar abscess. Okay, peritonsillar abscess means quinsy. Whenever you get a question of quinsy, you will get a child who has recently had tonsillitis, and now this particular child has got some kind of hot potato voice, or there is severe edema over on unilateral area of the tonsil. अब ये होता क्या है? Let me just explain you. Okay. Now see, this is your tonsil. This is your tonsil. Okay, this is your tonsil. Lateral to the tonsil is your tonsil capsule. This is tonsil capsule. Then more lateral to the capsule is something called as a loose areolar tissue. This is loose areolar tissue. Lateral to the loose areolar tissue is a fascia which is called as pharyngobasilar fascia. Lateral to the pharyngobasilar fascia, you have got a muscle which is called as superior constrictor muscle. And lateral to the superior constrictor muscle, there is another fascia which is called as buccopharyngeal fascia. So bucco matlab bahar, pharyngo matlab andar. And uske beech mein there is a muscle called as superior constrictor muscle, right? The space present between the tonsil capsule and the superior constrictor muscle, this space is called as peritonsillar space. Okay? If there is any infection that happens, or if there is any suppuration which happens in this peritonsillar space, then what will happen? This is called as peritonsillar abscess. This is called as peritonsillar abscess, right? So now what will happen? If there is infection in this peritonsillar space and there is a peritonsillar abscess, then for obvious reasons, what will happen? This you can just see over here. See, this is the normal side. This area, the tonsil will get shifted more medially. You can see that. Why? Because there is pus all over in this area, in this peritonsillar space, right? So what exactly will be the feature? You will see a lot of edema and erythema over the soft palate. Ye sara ka sara will be edematous. This all area will be edematous, right? Okay. Now, one more important feature is that you will see that pus is going to come out from the tonsil. There will be pus that will be coming out of the tonsil. The uvula will be deviated towards the opposite side because the tonsil is pushing this uvula towards the opposite side. The uvular deviation will be towards the opposite side. That also we can see over here, right? Okay. And one more important point is because this tonsil is very near to our pterygoid muscles, it will cause stimulation of the pterygoid muscles, it will cause contraction of the pterygoid muscles, and the patient will develop trismus. So these are the classical signs which you will see in peritonsillar abscess. Always remember, they will confuse you. This is the same picture that is there in your parapharyngeal space also. But in parapharyngeal abscess, you will not have a neck, you will always have a neck swelling also associated with this. Peritonsillar abscess, there is no neck swelling. There is only intraoral findings that you will get. That is the only thing that you have to differentiate both of them. So in peritonsillar abscess, there will be edema of the soft palate, tonsil will be shifted medially, uvula will be deviated laterally, there will be frank pus coming out of the crypta magna. That is peritonsillar abscess. What is peritonsillar space? Space present between the superior constrictor and the capsule. Khatam. This is what you need to learn about, right? Once you have finished about the peritonsillar space abscess, the other name for this is quinsy. The other name is quinsy. And what is the most common organism that causes this abscess? The most common organism is again Streptococcus pneumoniae. Most common organism is Streptococcus pneumoniae. Okay? Other name is quinsy. That is the only thing that you need to remember as far as this is concerned. This is unilateral. This is unilateral. Okay? Remember that. This is unilateral. Okay? Fine. Now let me come to the next one. Let me show you. Okay, so what will you do? If you get a peritonsillar abscess, what will you do? In cases of peritonsillar abscess, the first and foremost thing is we need to drain, right? Now, how do we drain it? We drain it intraorally by making an imaginary line along the base of uvula. Now see, this is uvula, so we make an imaginary line along the base of uvula and one imaginary line along the anterior pillar. One imaginary line along anterior pillar, one line along the base of uvula. The point of intersection, jahan pe point intersect kar raha hai, this is the point. We will just go and poke in and open it. We'll just poke our instrument inside and open it with the help of a forceps. As soon as we open it, all the pus will get drained out. This is how we drain quinsy. Tonsillectomy is never done in quinsy. We always do something called as incision and drainage. After some time, after 1 month or 2 months, once the infection has subsided completely, then we do something called as interval tonsillectomy. But in cases of hot stages, जब infection है, तब कभी भी tonsillectomy नहीं करते. We do something called as interval tonsillectomy, कुछ interval के बाद. Initially, we only do incision and drainage with broad spectrum antibiotics. This finishes what is quinsy or peritonsillar abscess. ठीक है? Now let me come to the next point. Next point is Ludwig's angina. What is Ludwig's angina? Ludwig's angina is basically a polymicrobial superficial spreading cellulitis. It does not have pus. It is something which is there in the submandibular area, in the submental area. Ye pura area will become swollen like a balloon, but it will not have pus. Always remember, Ludwig's does not have pus. It only contains superficial spreading cellulitis. Now I told you this is there in this space, which is the submandibular space. यहाँ से शुरू होती है. So submandibular space is further divided by one muscle. You can see this muscle over here. This is your 𝐒𝐿-hyoid muscle, which divides this submandibular space into one space which is above. This space is called as sublingual space. And एक space बड़ी नीचे, this is called as submyelohyoid space because it is below the mylohyoid. Submyelohyoid space together with the sublingual space together is called as submandibular space. Any infection or superficial spreading cellulitis which occurs in this area will be called as Ludwig's angina. Okay, fine. One more important question is, ये Ludwig's angina का सबसे common cause होगा क्या? What do you see over here? You see a teeth, right? Tooth infections can directly lead to any of these conditions. So you will get a history of the patient who went for a root canal treatment, tooth extraction, or there were tooth caries, and the patient got this kind of a swelling. Answer is Ludwig's angina. Okay? So the most common way in which they get it is dental infections. Most common organism is a mixed aerobic as well as anaerobic organisms. Okay? Right? And I told you two things that you need to remember. This is not containing pus. This is only containing a superficial spreading cellulitis. That's why it is woody hard. It is woody hard. It is like wood. You won't be, if it would have been pus, it would have been boggy. This is wood-like. This is very, very hard and tender. Okay, let me show you how this particular person will look like. See this. You can see superficial spreading cellulitis from one side to the other side. Huge neck. Right? Now, because of this, even the floor of mouth will become edematous and the tongue will get raised. The tongue will also get raised. And that is the reason, because their tongue will get raised, that is the reason they end up into respiratory difficulties. They come up in stridor. That is an important point. Okay, fine. So what is this? They will have pain as well as drooling of saliva. And this neck is swollen and hard. That is called as Brownie induration. Neck is hard and tender. That's called as Brownie neck edema or Brownie induration. Okay, fine. And you can see that the tongue is elevated. There is floor of mouth which has been edematous, and there is difficulty in mouth opening because of the contraction of the pterygoid muscles. So there is trismus. Okay. What will you do in this case? How will you treat it? So of course we need to give antibiotics. That is the first point. We need to give antibiotics. But more than that, we need to assess the airway. If the airway of the child is compromised, then we need to do a tracheostomy. We can't intubate the patient from above. So we need to do a tracheostomy, right? We need to assess the airway of the child. After that, what do? We give something called as release incisions. Release matlab, we give an incision in bilateral submandibular area and we release the edema. We release the edema, but we will never get pus. Pus kabhi nahi hoga. Hum bas isko khol denge and we will open these compartments and put a drain. But we will never ever achieve, we will never get pus that will get drained and the patient will be fine. This is Ludwig's angina. Okay, fine. चलो आगे बढ़ते हैं. Now, अगली चीज आती है retropharyngeal and parapharyngeal abscess. Okay. Now, just let me explain this with a very, very simple way. Okay. How this particular thing presents. Now, see this. Okay. What I'm doing is I'm going to explain you very easily parapharyngeal or retropharyngeal abscess होती क्या है. Let's suppose I've cut open my neck in an axial plane. मैंने ऐसे काटा और आप ऊपर से देख रहे हो. अब you're seeing from the top. ठीक है? तो सबसे पहले क्या होता है पीछे? There is your vertebrae. Right? This is your vertebra. This is your vertebra. Vertebra के ऊपर क्या होता है? There is muscles above the vertebra. which is called as prevertebral muscles. In front of the prevertebral muscle, there is a fascia, which is called as prevertebral fascia. Okay? Correct? This is called as prevertebral fascia. The space present between the prevertebral muscle and the prevertebral fascia, this space is called as prevertebral space. This is called as prevertebral space. Okay? Fine. Now let me come to another thing. In front of this prevertebral fascia, there is yet another fascia, and this is called as alar fascia. The space present between the alar fascia and the prevertebral fascia, this space is called as danger space. Okay, this is called as danger space. Okay? Ab, what I told you, I've drawn a cross section. Na? So now this is your tonsil that you can see from the top. This is other side tonsil which you can see from the top, right? Now I told you that behind the tonsil, you have got a tonsil capsule, what we read in the bed of tonsil, right? Capsule ke piche there is loose areolar tissue, right? Behind the loose areolar tissue, there is pharyngobasilar fascia. Behind the pharyngobasilar fascia, there is superior constrictor muscle. And behind the superior constrictor muscle, there is buccopharyngeal fascia. Buccopharyngeal fascia. ये हमने पढ़ा था, correct? Right? Now, the space present between this alar fascia posteriorly and the buccopharyngeal fascia anteriorly, this space is called as retropharyngeal space. This space over here. Present between the alar fascia posteriorly and the buccopharyngeal fascia anteriorly is the retropharyngeal space. Retropharyngeal space is further divided into two small compartments by a median partition, and these two spaces are called as space of Gillette. They are called as space of Gillette or spaces of Gillette, which contain very important nodes which are called as retropharyngeal nodes. These are the most common sites which get enlarged in retropharyngeal infections whenever happens. Okay, fine. Lateral to the retropharyngeal space, idhar, lateral to the retropharyngeal space. अगर मैं इधर आ जाऊं, अभी मैंने ऊपर से देखा. Now if I come more laterally, more on this side, more on the lateral aspect, what is there? If I come lateral to on this space, I'll get my mandible over here. This is my mandible, right? So my lateral space has got the mandible laterally. This is my mandible. Mandible के inner surface पे, there is a muscle called as medial pterygoid, and laterally there is a muscle called as masseter. Okay? This space, lateral to the retropharyngeal space, this is called as parapharyngeal space. This is called as parapharyngeal space. Right? Parapharyngeal space is further subdivided by an important bone which is called as styloid process into one compartment in front of the styloid, one compartment behind the styloid. One compartment which is in front of the styloid, this is called as pre-styloid compartment. एक compartment जो पीछे होता है styloid के, this is called as post-styloid compartment. ये important part होता है. That is the reason in parapharyngeal space infections, pre-styloid infections में और post-styloid infections में अलग-अलग clinical features भी दिखते हैं. Right? Now let me come back to on this diagram. On the basis of this diagram, अब खुद सोच के बताएंगे what are going to be the clinical features of this particular condition. Right? Now let me come to retropharyngeal abscess first. What I taught you. So I taught you what is retropharyngeal abscess. Retropharyngeal abscess is an infection which occurs in the retropharyngeal space. Right? Retropharyngeal space में होने वाले infection को हम कहते हैं retropharyngeal abscess. Right? And what did I do? That if there is any infection which will occur in this little space over here, that is called as retropharyngeal abscess. Correct? Okay? In this retropharyngeal abscess, what is the most common cause of retropharyngeal abscess in children? It will be because of pharyngeal trauma. Whenever there will be pharyngeal trauma, there will be enlargement or separation of these nodes. Or what are these retropharyngeal nodes? And that will be the most common cause of retropharyngeal abscess in children. Right? That will be the reason why this particular area will become a paramedian bulge. ये देखो ये median में नहीं आएगा. It will be on one side. So when you see the posterior pharyngeal wall, there will be a paramedian bulge on the posterior pharyngeal wall. That is a classical case that retropharyngeal abscess is present. Okay. What is the commonest cause of retropharyngeal abscess in adults? It is caries spine. Caries spine. So now this particular caries will straight away enter into this retropharyngeal space and produce infection. So tuberculous spine or caries spine is the most common cause of retropharyngeal abscess in adults. Trauma or infection or suppression of the retropharyngeal nodes is the most common cause of retropharyngeal abscess in children. These are the two important things. Okay, what you need to understand. Now what we come to, now let's come to the parapharyngeal part. Okay, parapharyngeal part mein kya hoga? If infection comes into this area, into the parapharyngeal area, what will happen? If it involves the pre-styloid compartment, matlab ye compartment, what will it do? It will push the tonsil medially. It will push the tonsil medially, right? Same as we saw in peritonsillar abscess, same presentation. Pushing of the tonsil medially, erythema and edema over the soft palate, uvula is deviated to the lateral aspect. So you can see that all of this will get deviated towards the medial aspect. It will push the tonsil towards the medial side. Why? Because it is lateral to the tonsil. It will also go and it will cause contraction of the medial pterygoid muscle, which will cause trismus. So always remember, if a patient has come with a pre-styloid parapharyngeal space infection, the patient will have the tonsil will be shifted medially. You'll see a huge tonsil on the medial aspect, which is shifted medially. Patient will have trismus because of the pterygoid muscle spasm, and this will produce a considerable neck swelling below the angle of the jaw. So always remember one thing: if you have a swelling at the angle of the jaw, trismus, and the tonsil is shifted medially, answer is parapharyngeal space. Answer is pre-styloid involvement. Simple. Agar sirf aur sirf tonsil dikhai hai and they have not told about any angle of the jaw, they have not told any other thing, then the answer is peritonsillar abscess. Itna simple hai. Okay? By any chance, if this infection goes into the post-styloid compartment, post-styloid compartment contains 9th cranial nerve, 10th cranial nerve, 11th cranial nerve, internal jugular vein, carotid artery. So there will be multiple cranial nerve palsies. 9th, 10th, 11th, sympathetic chain. There will be internal jugular vein thrombosis. There will be carotid artery rupture. All these things. Neurovascular compromise will be in the post-styloid compartment, which is dangerous. But that is what what is the main thing. तो buzzword क्या है? Buzzword ये है कि अगर आपको सिर्फ tonsil दिखाई जाती है अंदर, they tell you hot potato voice, 𝐒𝐿, the patient had a history of tonsillitis, but external swelling नहीं बताई जाती, तो answer peritonsillar abscess है. Where you'll see a huge tonsil, uvula deviated towards the opposite side. अगर आपको ये बताया जाता है that the patient had a history of trauma to the posterior pharyngeal wall, you see a paramedian bulge over the posterior pharyngeal wall, fever, your answer is retropharyngeal abscess. अगर आपको ये बताया जाता है that the patient had got angle पे swelling, jaw पे swelling, the patient had tonsil which is enlarged, medially shifting the uvula, the patient has got trismus, the answer is parapharyngeal abscess. खत्म. इतना ही है. This is what is the buzzword. This is what exactly you mean by all of these abscesses. ठीक है? So this is what exactly what I wanted to tell you all about both of them. That's what I've written over here. This is the post-styloid abscess. I've written over everything. So this is something that completes our oral cavity and pharynx, right? Okay, चलो. Final आ जाते हैं. आज का last topic, and this is going to be a huge rush of all of ENT. Larynx. Okay, so this is going to be short and crisp. Because pharynx was more complicated than larynx. Larynx is a little more easier. So we're going to have a quick run through all the larynx questions and all the laryngoscopies what you have been shown, right? और हम इसी से अपना सारा larynx खत्म कर देते हैं. ठीक है? That will be my whole of larynx, not larynx, the whole of ENT today. Okay, right. Chalo, let's come now. Okay, first let me come to this particular thing. ये क्या है? What is this? And the associated questions I'll tell you. Now what do you see over here? You see, I'll tell you the question. There is a young boy, school-going child, who has come recently with severe odynophagia and distress. Now the patient also has got high-grade fever. You see that there is something present over here on the X-ray, and there is something present over on the over here when you do a laryngoscopy. What is the finding classically seen on the X-ray, and what do you see over here? Correct. That is epiglottitis. So this answer is epiglottitis. ठीक है, अब मैंने क्या बताया आपको, मैंने बताया एक यंग मेल, मतलब कि दिस इज अ स्कूल गोइंग चाइल्ड. सो ऑलवेज रिमेंबर एपिग्लोटाइटिस इज ऑलवेज हैपनिंग इन स्कूल गोइंग चिल्ड्रन. What is the most common cause? What is the most common organism for epiglottitis? It is Haemophilus influenza. If I ask you what is the most common organism in adults for epiglottitis, the answer is Streptococcus pneumoniae. ये दो क्वेश्चन याद रखना. In adults it is Streptococcus pneumoniae. In children it is Haemophilus influenza. Okay. Now these particular children, when they have got an enlarged epiglottis, obviously you can see here, this is an enlarged epiglottis. So what is this called as? This is called as cherry red epiglottis या cherry red sign. It's called as a cherry red sign or a cherry red epiglottis, right? Now, because these children will not be able to breathe because of such a big epiglottis, तो ये बैठेंगे कैसे? In order to make them breathe, they will sit like this. They will sit. They put their hands and they will sit like this, right? Now, when they are going to sit like this, then obviously they are going to breathe more. Right, when they are going to breathe more, so obviously they are going to have better breathing. इस particular position को जब ये ऐसे बैठते हैं, this is called as tripod position. Called as tripod position. ठीक है, अब वैक्सीनेशन आ चुके हैं. सो हीमोफिलस इन्फ्लुएंजा के वैक्सीनेशन आ चुके हैं. दैट इज व्हाई दिस चाइल्डहुड रिलेटेड हीमोफिलस इन्फ्लुएंजा इन्फेक्शंस हैव कम डाउन. तो स्ट्रेप्टोकोकस न्यूमोनिया का राइज आ गया है. ओके, नाउ ओमेगा साइन नहीं है. ओमेगा साइन विल बी सीन इन लैरिंगोमलेशिया. आई विल शो इट टू यू, बट ये ओमेगा साइन नहीं है. दिस इज चेरी रेड साइन. ठीक है, ओमेगा साइन विल बी देयर. चलो अब आते हैं. इफ यू डू एन एक्सरे ऑफ एपिग्लोटाइटिस, आपको क्या दिखेगा? यू विल सी दैट द एपिग्लोटिस विल बी लाइक अ थंब, एंड दिस इज कॉल्ड एज थंब साइन. दिस इज कॉल्ड एज थंब साइन. ओके, सिंपल सिंपल थंब साइन. ठीक है, चलो अब इससे रिलेटेड इंपॉर्टेंट एक और चीज आती है, दैट इन केस आई गेव यू अ क्वेश्चन over on a person who's been 6 months to 2 years of age. 6 months to 2 years of age, right? मैंने ये बताया था ये स्कूल गोइंग चिल्ड्रन है. एपिग्लोटाइटिस विल ऑलवेज हैपन इन ओल्डर चिल्ड्रन, 3 to 4 years of age, 5 to 6 years of age. ये स्कूल गोइंग नहीं है. These are 6 months to 2 years. Now I'll tell you what they will present with. 3 चीजें इनको निमोनिक में याद रखना. If this particular patient presents with seal-like barking cough, severe chest retractions, and stridor. 3 S. What is this particular condition? This is laryngotracheobronchitis. So 6 या 7 month old child जिसके seal-like cough, severe retractions of chest, stridor present है, they will have laryngotracheobronchitis as the primary. वही होगी. That is the diagnosis. That is the catch point. So always remember this. उम्र इसमें बहुत इंपॉर्टेंट है. Epiglottitis is a bacterial condition. Croup या laryngotracheal bronchitis is a viral condition. Most common virus, that is para-influenza virus, is the most common virus that is associated with croup. I told you that was bacterial. That was in Haemophilus influenza and Streptococcus pneumoniae. This is viral. Okay. Now what happens is, in cases of croup or laryngotracheobronchitis, there is significant narrowing that occurs in the cervical trachea and the subglottic area. So let's say this is the subglottis. Subglottis मतलब cricoid cartilage है. Cricoid cartilage के within जो area होता है, we call it subglottis. This is subglottis. And this is your trachea. This is cervical trachea. So now there is so much of edema in both of them that it will lead to narrowing. So it will produce a kind of a pencil tip appearance. Can you see that? You can see this has produced a kind of a pencil tip appearance. This is called as steeple sign, also called as pencil tip sign, also called as wine bottle sign. Right? These are the things that you will see in these cases as far as laryngotracheobronchitis is concerned. But catch point हमेशा याद रखना, इसमें age important है, 3 S important है, right? अब एक और चीज इसमें बहुत इंपॉर्टेंट आ जाती है, that how will you treat laryngotracheobronchitis and epiglottitis, and this is my mnemonic of 6H दोनों conditions के लिए. हम क्या करेंगे? कोई भी बच्चा हमारे पास आएगा, चाहे उसको जो भी हो, first we will do H for hospitalization of that patient. Second, we will try to assess the airway. उसी hospitalization के time पे we'll assess the airway, whether he can be intubated or we can do a tracheostomy, because airway important है, right? Second H, we will elevate the head end of the patient. Head end elevate कर देंगे, right? ताकि epiglottis पीछे ना गिरे. the airway is better. तो head and हम थोड़ा elevated रखेंगे. Third H, we will start the patient on humidified oxygen to increase the airway, to increase the breathing. Fourth H, we need to decrease the edema, both in epiglottitis, both in croup. We will give hydrocortisone. Hydrocortisone obviously is a steroid which decreases edema, right? Fifth is high dose antibiotics. High dose antibiotics में we will give penicillins or cephalosporins, which are the drug of choice. Okay? Sixth H is high dose racemic epinephrine. Epinephrine क्या है? Epinephrine is a sympathomimetic drug, right? So it will act on the alpha 1 receptors, it will act on the beta 1 and beta 2 receptors, right? And it will increase the sympathetic activity. So when epinephrine, racemic epinephrine or nebulized epinephrine is given, what does it do? It will act on alpha 1 receptors and cause vasoconstriction, which will cause decrease in the inflammation, decrease or airway will open up more. It will act on beta 1 receptors, right, which are present over in the heart. So it will increase the heart rate of the patient, will improve the cardiac output. Also, it will act on beta 2 receptors, which are present on the smooth muscles of the airway, and it will undergo bronchodilation. These are the three ways in which racemic epinephrine works. तो जब हम उसको nebulize कराएंगे तो ये सारी चीजें अच्छी हो जाएंगी. So airway will become better. The patient will be able to breathe. This is the 6H mnemonic we follow for epiglottitis plus croup. तो ये हमारा सारा कहानी खत्म होता है. What is the difference between croup and epiglottitis, right? And the related signs to it. चलो, अब आते हैं next पे, right? Now, next thing that you need to know about is about laryngeal papillomatosis. Okay? What is laryngeal papillomatosis got to do? Most common benign tumor of the larynx again has to be a laryngeal papilloma. Okay? Now, I told you that papillomas are something which is related to a name of a virus, जिसका नाम क्या हो जाएगा? Human papilloma virus. तो laryngeal papilloma भी किसकी वजह से होते हैं? They occur because of human papilloma virus. Human papilloma virus का कौन सा strain? 6 and 11. These are the most common strains which produce benign lesions like genital warts, like papillomas. But अगर कोई human papilloma virus का strain है which produces malignancy, so malignant strains of human papilloma virus are 16 and 18, which are dangerous. This we need to remember. Okay? So this is produced by 6 and 11. Right? Now, if this particular papilloma or papillomatous lesion occurs in younger or children, we call it juvenile onset recurrent respiratory papillomatosis. अगर ये बड़ों में होता है, we call it as adult respiratory papillomatosis. Right? Let me just show you how it looks like. So see this. This will be your question. If they are giving you something like this, like a polypoidal lesion which is grossly going here and there, answer is a papilloma. Answer is a papilloma. Okay, fine. Now, how do you treat these particular things? So they can be treated by either a medical management or a surgical. Surgical we reserve if they are very big. If they are small, then we give a medical therapy. Medical therapy, ABC, we can give alpha interferon therapy. There is a monoclonal antibody which is called as bevacizumab, which is the drug of choice nowadays for papillomas. This is the drug of choice. It has got excellent results. And an antiviral against HPV is cidofovir, ABC. Otherwise, we do a surgical excision, which is called as laser excision. We do a laser excision. Okay, fine. So this is something that is related to the questions that are asked to you in human papillomavirus associated laryngeal papillomatosis. Okay, chalo. Now let me come to the next important question of larynx. That are congenital lesions of larynx. Congenital lesions of larynx में एक important चीज आपको ये समझनी है. What is stridor? Stridor means that there is a high pitched turbulent sound which comes because of an obstructed airway. तो जब हमारा upper airway obstructed होता है, so upper airway obstructed है, there will be a sound that will come out. That turbulent sound is called as stridor. Okay, fine. Now, remember one thing. These three are important zones of stridor. Anything which is at supraglottic or glottic level, मतलब vocal cord या उसके ऊपर, they will be the reasons for inspiratory stridor. Inspiratory मतलब normal expiration, inspiration पे sound. If the patient has got subglottic, मतलब vocal cord के नीचे, subglottis में या फिर cervical trachea में pathology, they will have biphasic stridor. Biphasic का मतलब inspiration, expiration के time दोनों में stridor है. क्यों? क्योंकि this is a closed area. ट्रेकिया भी क्लोज्ड है, Cricoid cartilage भी closed है, उसके बीच में जगह बहुत कम है. So obviously any pathology in that area, in the cervical trachea and subglottis, will lead to biphasic stridor. And anything below that, in the thoracic or bronchi, will be leading expiratory stridor. ये बहुत important है. Okay, fine. Now see this. First important condition, laryngomalacia. What will they ask you? Most common cause of congenital lesion of larynx is laryngomalacia. Most common cause of inspiratory stridor in children is laryngomalacia. Okay. Now, what is laryngomalacia? Let me just show it to you. This is what is laryngomalacia looks like, right? So what happens in laryngomalacia is that there is flaccidity of cartilages. Flaccidity matlab these cartilages are very, very soft. They are flaccid. They are soft. So what happens during inspiration? These cartilages fall inwards. ये अंदर collapse कर जाती हैं. And because they are getting enrolled or they are getting rolled up inwards, they produce this kind of an omega shape. So this is a classical thing called as omega shaped epiglottis, which is seen in cases of laryngomalacia because of the partial collapse or the flaccidity of these cartilages. Okay, and that is the reason the flow inside to the vocal cords will become very turbulent and inspiratory stridor will happen. This is called as an omega sign. Okay, fine. Chalo. Ab, how will we manage these people? So always remember one thing, they will ask you this. Laryngomalacia में management आप क्या करेंगे? Laryngomalacia में never ever we do a surgery first choice. We never operate first choice. First thing we always see, because larynx की cartilages will become more and more strengthened with time. वो धीरे धीरे strength पकड़ेंगी. So we wait and watch. Till the time they will become 2 to 3 years old, their cartilages will become strengthened. Right? So what do we tell them? That don't nurse the patient in a supine position. उसको उल्टा कर दो. अगर आप उल्टा कर देंगे बच्चे को, so what will happen? The epiglottis will fall forward. So always nurse the patient in a prone position so that the epiglottis does not fall back. Right? Always try to slow feed the child so that the child does not aspirate. So slow feeding of the child, thick feeds of the child, right? And we will tell the patient if the patient has got more desaturation, patient has got failure to thrive, patient is in gross stridor. In those cases only we will do surgery. Surgery laryngomalacia की क्या होती है? Epiglottoplexy and supraglottoplasty. What do you mean by this? इसका ये मतलब होता है कि जो epiglottis है, we actually take a suture and we tie it to the base of tongue. इस सूचर लेके हम लोग बेस ऑफ टंग पे से अटैच कर देते हैं सो दैट इट डज नॉट फॉल बैक, इट डज नॉट गो इनवर्ड्स. दिस इज कॉल्ड एज एपीग्लॉटोपेक्सी. पेक्सी मतलब जोड़ना. तो एपीग्लॉटिस को बेस ऑफ टंग से अगर हम एक सूचर लगा के जोड़ देंगे, दैट इज कॉल्ड एज एपीग्लॉटोपेक्सी. सुप्राग्लॉटोप्लास्टी का क्या मतलब है? यू कैन सी दिस इज गेटिंग कर्ल्ड. वी विल गिव 2 रिलीज इंसिजंस लाइक दिस ताकि ये अनकर्ल हो जाए. So if we give 2 release incisions lateral to the epiglottis, then it will uncurl and that is called as supraglottoplasty. यही इसके इंपॉर्टेंट ट्रीटमेंट है. राइट? ओके. अब आपके पास एक और इंपॉर्टेंट चीज आती है. आपके पास एक बच्चा आता है एंड दैट बच्चा हैज गॉट इंपॉर्टेंट biphasic stridor. That kid has got biphasic stridor. Can you tell me what is the diagnosis, what you can see from the image? What can you see over here? You can see these are the 2 vocal cords, but there is something below the vocal cords that you can see here. There is a pinhole, right? I told you, according to the zones of stridor, if the patient has got subglottic pathology or cervical trachea pathology, the answer will always be biphasic stridor. That means during inspiration and expiration, the patient develops sound. This is subglottic stenosis. This is subglottic stenosis. Very clearly. Okay, fine. Now, one important point, subglottic stenosis का cause क्या होता है? Most common cause of subglottic stenosis, either it could be congenital or it could be acquired. Right? Congenital means that the cricoid cartilage is small and elliptical. Small elliptical cricoid cartilage. That means since birth, the cricoid cartilage is very small. So that is the reason subglottic area is also very small. This congenital lesion is very commonly seen in 𝐑𝐄𝐶 syndrome. Very commonly seen in 𝐑𝐄𝐶 syndrome. Okay? But what is the most common cause acquired for subglottic stenosis? It is repeated intubations. ये बहुत important question है. आपको एक पास एक patient आएगा, उसको बार बार intubate किया गया है, and now the patient has got this kind of a lesion with biphasic stridor. Your answer is subglottic stenosis. Okay? How do we classify it? Classification of subglottic stenosis is by a classification called as Cotton-Myers classification. This is called as Cotton-Myers classification system, right? If this particular opening is 0 to 50% obstruction, we call it grade 1. If it is between 51 to 70, we call it grade 2. If it is between 71 to 99 almost, that is grade 3. And we cannot find anything, everything is blocked, that is grade 4. That is the last one, right? This is about what is subglottic stenosis. Okay? Chalo. Now let me move on to the next question. What is laryngocele? Laryngocele में आपसे question ये आएगा that there will be a patient in his 30s, 40s and the patient is a glass blower or a trumpet player. Trumpet player होगा या glass blower होगा. And now the patient has got a visible swelling over the neck. What is the likely diagnosis? That is laryngocele, right? Now what is laryngocele? Let me first tell you that. For this, I want you all to understand, अगर हम larynx को यूं काटेंगे, cross section यूं काटेंगे coronal section में, तो larynx कैसा दिखेगा? Because this is something I'll tell you the anatomy of larynx also. In the coronal plane, this is a very important question. Okay. So if we cut the larynx in a coronal plane, what are we going to see is, first, we will see the hyoid bone, जो हमने काट दी है. So the hyoid bone is getting cut. This is our hyoid bone, which is above. जिसको हमने काट दी है, right? Below the hyoid is your thyroid cartilage. This is thyroid cartilage. Between the thyroid and hyoid is your thyrohyoid membrane. This is thyrohyoid membrane, right? What I'm showing you is the front portion of the larynx, right? Coronal section. Below the thyroid cartilage is another important cartilage which is called as cricoid cartilage, right? And below the cricoid are your tracheal rings. Below them are tracheal rings. Okay. Okay. Between the cricoid and thyroid, there is cricothyroid membrane. जैसे यहाँ पे thyroid membrane है. The same thing you draw over here also. This will figure out a lot of things in your syllabus. Okay. So the same thing I've drawn over here. These are the tracheal rings. Okay. Now how to draw the larynx or how to understand the larynx? First I'm going to draw the inside. Draw one up like this, and come down. Then come up, draw up, go back, draw down and come down. This is how the whole larynx look like in a coronal plane. Okay. Now what are these areas, right? What I've drawn over here, I've cut open. The upper one are called as false vocal cords. Lower one are called as true vocal cords, right? And the space present between the false vocal cord above and true vocal cord below, this space is called as laryngeal ventricle. What is ventricle? Ventricle is the space present between the false vocal cord above and the true vocal cord below. Okay? The ventricle dilates laterally into a blind spot or into a blind space, and this space, that is the lateral extension of the ventricle, this is called as laryngeal saccule. This is called as saccule. Saccule is the dilation of the ventricle laterally. Okay? Saccule has got a lot of seromucinous gland. इसके अंदर बहुत सारे gland होते हैं. There are a lot of seromucinous glands inside the saccule. That is the reason this saccule will keep providing lubrication to the true cord and false cords. And because it provides lubrication to the true cord and false cord, that is the reason it is called as oil can of larynx. The important oil can of larynx is, it is the laryngeal saccule. Now, for any possible reason, if suppose he is a trumpet player, he pushes excessive air inside and accidentally that air gets inside the laryngeal ventricle. So it will cause abnormal dilation of the saccule, and that saccule will come out of the thyrohyoid membrane as a swelling. And when it comes out of the thyrohyoid membrane as a swelling, we will call this particular thing as a laryngocele. Simple. Okay? This is called as laryngocele. Now what will happen? If I put pressure over the laryngocele, अगर मैं इसके ऊपर pressure डालूं, so what will it do? It will produce a hissing sound. And that is called as Bryce sign. That's called as Bryce sign. If you remember, we did Boyce sign when we were dealing Zenker's diverticulum. This is called as Bryce sign. Okay, fine. So question, trumpet player, glass blower, Bryce sign, and what is the laryngocele? किसके through आता है? Abnormal dilation of saccule कैसे होता है? Right? This is what it is. Okay. How do you treat laryngocele? For obvious reasons, we do an excision. We do an excision. If it is large, If it is small, we do something called as marsupialization. Marsupialization. Okay, fine. Chalo. So this was a crash course on what is laryngocele and what all I have written over here. So this is the same thing what I have written over here. So that doesn't require much of reading. चलो अब मैं आता हूँ इंपॉर्टेंट वोकल डिसऑर्डर्स पे. ये बड़ा इंपॉर्टेंट क्वेश्चन है. आपके पास एक टीचर आया, there he has been teaching from almost 20-30 years, and that patient has got now voice hoarseness of voice. So what I'm telling about one side about a chronic voice abuser, right? And he has primary symptom of hoarseness of voice. Okay, fine. The second side I have got an acute voice abuse. Let's say कोई पेशेंट था, वो आरसीबी का मैच देखने गया, आरसीबी जीत गई, उसने चीखा और सडनली उसने आया कि नाउ आई हैव गॉट होर्सनेस, acute onset of hoarseness. So I have got two important things over in front of me. एक तरफ acute है, एक तरफ chronic है. Correct? Okay? What exactly is this chronic? तो chronic का मतलब ये हुआ कि बहुत टाइम से हो रहा है. दो vocal cord होते हैं. When the vocal cord shut, तो vocal cord जब shut करते हैं, तो at the junction between the anterior 1/3 and mid 1/3 of the cord, ये पोजीशन पे, इस पोजीशन पे, दिस पोजीशन इज द मैक्सिमम स्ट्राइकिंग जोन वेयर वोकल पैथोलॉजीज अकर. क्योंकि सबसे ज्यादा स्ट्राइक यहीं पे होती है, सबसे ज्यादा फ्रिक्शन यहीं पे होता है व्हेन द वोकल कॉर्ड्स आर शटिंग. राइट? सो व्हेन द वोकल कॉर्ड्स आर शटिंग, द मैक्सिमम स्ट्राइक यहीं पे होती है. दिस इज कॉल्ड एज स्ट्राइकिंग जोन और द जोन ऑफ फ्रिक्शन. राइट? नाउ व्हाट विल हैपन, जब जोन ऑफ फ्रिक्शन सबसे ज्यादा यहीं पे होगी, सो द एंटीरियर 1/3 एंड मिड 1/3 ऑफ द कॉर्ड में देयर विल बी सर्टेन लीजन्स व्हिच विल फॉर्म. Right? There will be certain lesions which will form because of chronic voice abuse. And these lesions, if they are bilateral and symmetrical, and they are less than 3 millimeters, bilateral, symmetrical, and less than 3 millimeters, chronic voice abuser, then it will be vocal nodule. काम खत्म. Right? अब आता है दूसरा. एक तरफ आया acute voice abuser. I told you about the guy who screamed about RCB. He came back to the hospital. This is something which also has happened at the anterior 1/3 and mid 1/3 junction. But ये unilateral है. This is not flat. This is not a flat swelling. ये देखो ये flat swelling है. This is like a pedunculated swelling. So it is pedunculated. It is pedunculated. It is unilateral. It is reddish and it is over on one cord. So it is solitary. ये है आपका vocal polyp. This is a polyp. This is a nodule. So nodules are bilateral, polyps are unilateral. Nodules are symmetrical, ये asymmetrical swellings हैं. ये single है, वो double हैं. They are flat and sessile, they are pedunculated. This is acute history, this is chronic history. This is how they will present. यही दोनों का difference है, यही दोनों का catch है. Right? Now, important thing है कि इसमें आप कैसे approach करेंगे? How will you approach this patient? This patient has to be approached medically. यहाँ medical management देना है, यहाँ पे surgery का ज़्यादा रोल नहीं है. This is medical line of management. So medical line of management में हम क्या देंगे? We will give the patient treatment for GERD या gastroesophageal reflux disease, because reflux अगर आएगा, acidity होगी तो बार बार there will be throat clearing. ये करेगा. So that is why we will give them PPI or proton pump inhibitor. We will give the patient antihistamine. We will give the patient mucolytics, and we will tell the patient to have absolute voice rest. बिल्कुल मत बोलो. Okay, but what will be the point? इसमें हमें क्या करना होगा? What will be the management in cases of vocal polyp? It is always surgical. यहाँ medical line of management का कोई रोल नहीं है. So here what we will do microlaryngoscopy plus excision under GA. So this will be microlaryngoscopy plus excision. That is what is the difference between a vocal nodule and a vocal polyp. Finished. Okay, and these are the catches that you will get. Now let me tell you another important thing. आपके पास एक क्वेश्चन आया, where there is a patient who has got irreversible chronic swelling that is present on bilateral cords. The patient is a chronic smoker and usually a female. What is your answer now? So there is a chronic irreversible swelling present on bilateral vocal cords, and this patient is usually a female and the patient is a smoker. That is why this is also called as smoker's larynx. It is also given the name as pseudomyxomatous laryngitis, and we can also say this is also called as Rinke's edema. When you see swollen cords, this is also called as Rinke's edema. तो obviously हमें क्या होगा? See, vocal cords are thin, right? अगर vocal cords में हम बहुत सारा पानी भर दें, तो they will become heavy. The moment the vocal cord will become heavy, our voice will become also heavy. So these people will become heavy in voice. They will have a low pitched voice. And similarly, अगर women में हुआ, तो women में उनकी low pitched voice की वजह से they will sound like a man on a telephone. हम उनके telephone में बात करेंगे, they might sound like a man. That is the importance, क्योंकि that is the importance. Rinke's edema is a very, very problematic disease because voice change इतना prominent है, right? Now, if they have big Rinke's edema, अगर बहुत सारा इनमें ये पानी भर गया, right? Then what will happen? Then they will have chronic cough and even they can go into stridor. If they are very big, then they can also go into stridor, right? Now, this particular edema, because it produces chronic swelling over the vocal cords, that is the reason this is also called as a bag of water appearance. This looks like a polythene bag filled with water, right? So this is called as bag of water appearance. How do we treat it? Medical line of management is same as vocal nodule. जो भी मैंने बताया था, same as vocal nodule. Same medical line of management. We will tell also that the patient should stop smoking. And surgically what we will do a procedure called as reduction glottoplasty. Reduction glottoplasty का मतलब glotto मतलब vocal cord, plasty मतलब repair, reduction मतलब reduce करना. So we will put an incision over the vocal cords and we will suction out all the mucinous discharge which is present in the Rinke's space. And we will take that out. That is what Rinke's edema is all about. Okay, fine. चलो, ये खत्म होता है हमारा एक और important point. अब आते हैं into vocal cord palsy and related questions to vocal cord palsy. ठीक है? अब इसमें एक बहुत important question है, what is related to vocal cord paralysis. See, this is a simple thing. All the muscles of the larynx are supplied by what nerve? All the muscles of the larynx are supplied by recurrent laryngeal nerve. All muscles of larynx except one muscle, which is cricothyroid. Cricothyroid is one muscle which is only supplied by external branch of superior laryngeal nerve. ये as it is question हजारों बार पूछा गया है. This is a favorite question from vocal paralysis. So except external branch of superior laryngeal nerve is supplying cricothyroid, बाकी सारी की सारी branches supply करती है RLN. Okay, this is something what you should know about, right? Now, this is one more important thing is that whenever we read about larynx की muscles, right? उसमें दो important muscles के नाम और इनके function याद करने जरूरी हैं. What is the only abductor of vocal cord? एक ही है abductor. What is the only abductor of vocal cord called as? Only abductor of the vocal cord is posterior cricoarytenoid muscle, which is the only abductor of the vocal cord. मतलब अगर RLN इंजर हो गई, हमारी vocal cords बाहर move नहीं करेंगी. They will not undergo abduction. That is posterior cricoarytenoid muscle. What is the function of cricothyroid muscle? It is adduction and tension. Tension and adduction are two important functions of cricothyroid muscle. And very rightly said by Som Sobra, posterior cricoarytenoid को इसीलिए safety muscle of the larynx भी कहते हैं. Because it is an abductor of the vocal cord, it is helping us breathe. Right? Adduction and tension का काम है हमारा cricothyroid का. Okay. Now, how you should remember vocal paralysis? Vocal paralysis समझने के लिए ये दो चीजें हमें बस समझनी जरूरी हैं और पूरी हमें समझ में आ जाएगी. The whole chapter will be understood if we can understand these two things what they have told. और इसको समझने के लिए इसको भूल जाओ अभी. इसको समझने के लिए I'll tell you a very, very simple logic. Okay. Think this way. We have got cricothyroid muscle जो करती है adduction plus tension of vocal cords. We have got abductor जिसका नाम है posterior cricoarytenoid muscle. ठीक है? Let's say this is your larynx. Let's say this is the larynx. What I'm drawing over here, this is your inside of the larynx. Okay? This is your epiglottis. This is your arytenoid. And these are the two vocal cords. Okay? This is what I have drawn. ठीक है? अब अगर हम सांस लेंगे तो vocal cord बाहर जाएंगे. अगर हम बातें करेंगे तो vocal cord adduct करेंगे. This is what we read in normal people. अब चार situation देखते हैं. First situation is patient has got unilateral RLN palsy. Recurrent laryngeal nerve injure हो गई. अब एक चीज याद रखना, पहला लॉ I'll tell you now. If a patient develops recurrent laryngeal nerve palsy only, that means still the superior laryngeal nerve is functional. Superior laryngeal nerve supplies cricothyroid muscle. So matlab one nerve is still functional, superior laryngeal nerve, which is supplying the cricothyroid, and the cricothyroid causes adduction and tension. Matlab kya hoga? If one side recurrent laryngeal nerve is injured, that means that side cord abduction cannot happen. The only function the cord can do is one function which the cricothyroid is doing. That is adduction and tension. तो अगर किसी की RLN इंजर हुई है, that paralyzed cord will reach into a paramedian position. It will reach into a paramedian position. Paramedian का मतलब this position is a position where the cord is 1.5 millimeters away from the midline. You can see ये ऐसे ही cord रखा रहेगा क्योंकि ये क्रिकोथायरॉइड के फंक्शन की वजह से है. It will stay adducted, it will stay tensed, it will just stay like this. The other cord is going to move in and out. So obviously in this case we don't have a problem because one cord is still mobile. So in cases of unilateral RLN palsy, where the other cord is attained a paramedian position, the other cord has attained a paramedian position. Why? Because of the functioning cricothyroid muscle. So in this case, because the opposite side cord is still functional and only one cord is attained a paramedian position, in such cases we don't do much, we give conservative management. We give conservative management. इसमें ज़्यादा कुछ नहीं करते. अब आते हैं, let's say दोनों RLN इंजर हो गई. If both the RLN are injured, मतलब both the vocal cords will attain a paramedian position because of the unopposed action of cricothyroid muscle. वो still काम कर रही है. So now if both the sides are injured, then what will happen? Both the vocal cords will attain a paramedian position. They will come straight away in the center. बिल्कुल यूं रहेंगे and they will not move out क्योंकि RLN injure हो चुकी है. So now both the vocal cords will stay in the center and this is the reason why the patient will end up into stridor. What is the management that we do in bilateral RLN palsy? We do something called as 𝐒𝐿 operation. And we do something called as type 2 thyroplasty. Type 2 thyroplasty is also called as lateralization thyroplasty. What is 𝐒𝐿 procedure? 𝐒𝐿 procedure means posterior 1/3 of the cord will be excised. इतना हम excised करके निकाल लेंगे. So that there is some place for the patient to breathe. Right? So we will excise out posterior 1/3 of the cord. Okay? और lateralization thyroplasty का मतलब हम vocal cord को दूर ले जाएंगे. We will take it, we will stretch it out a little more. ताकि हमारी थोड़ी सी जगह बने for breathing. So always remember, ये होता है in cases of unilateral and bilateral RLN palsy. If in case they tell you in your question कि RLN, SLN दोनों injure हो गई हैं, both are injured, in that case the patient will achieve a vocal cord cadaveric position. Cadaveric position का क्या मतलब होता है? Cadaveric position का मतलब होता है that the vocal cord is now 3.5 millimeters away from the midline. वो ऐसे पड़ा रहेगा. One vocal cord is functional, दूसरा vocal cord will be 3.5 millimeters away from the midline. It will neither adduct nor abduct. वो पड़ा रहेगा यहीं पे. That is the reason which is called as cadaveric position या intermediate position. Cadaveric position is only seen in vocal cords where RLN and SLN both are injured. This is the most important point that I told you to remember. One is about what will happen in RLN palsy, what will happen in RLN plus SLN palsy. Okay, fine. चलो. Now I'll tell you a mnemonic कि थायरोप्लास्टी जो पूछते हैं उसमें क्या पूछेंगे. तो 4 टाइप की थायरोप्लास्टी होती हैं. हम लोग कौन सा what operation do we do in larynx? We do microlaryngoscopy. तो mnemonic है MLS. Simple. टाइप 1 थायरोप्लास्टी होती है मीडियलाइजेशन, मतलब कॉर्ड को पास ले आओ. टाइप 2 होती है लैटरलाइजेशन, मतलब कॉर्ड को दूर ले जाओ. टाइप 3 होती है शॉर्टनिंग ऑफ द वोकल कॉर्ड. जितना हम शॉर्ट करेंगे वोकल कॉर्ड को उतना ज़्यादा वोकल कॉर्ड विल इंक्रीज इन और डीपन द वॉइस. जितना हम लेंथन करेंगे वोकल कॉर्ड को उतना द वॉइस विल बिकम मोर एंड मोर फेमिनिन. तो टाइटनिंग एंड लेंथनिंग इज टाइप 4. टाइप 3 इज शॉर्टनिंग. तो अगर हमें किसी फीमेल वॉइस को मेल बनानी है, we do shortening of chords. अगर male voice को female बनानी है, then we do lengthening. Okay, so this is something that that are the 4 types, and what Som Sobra has already answered is puberphonia, right? So male बहुत सारे ऐसे होते हैं जो females की तरह voice होती है, right from puberty, right? So in that case we need to what we need to do, we need to heavy their chords, और उसको heavy करने के लिए we need to shorten them. Okay, fine, that's called as puberphonia. Okay, and in transgender voices we need to convert a male voice to a female voice, तो उनको हम rubber band की तरह खींच देते हैं, so they will become more stretched and they will become more at a higher pitch. Okay, fine, chalo, this is about thyroplasty. Okay, अब आ जाते हैं एक important चीज पे, that is what is laryngeal malignancy. Okay, what is laryngeal malignancy? Now this is something also which has been asked as a question, together with what is the voice rehabilitation measures we give in laryngeal malignancy, right? So what is laryngeal malignancy? ये मैं बहुत आसानी से बहुत जल्दी आपको पढ़ाऊंगा, और इसकी स्टेजिंग आपके लिए बहुत इंपॉर्टेंट है, इसकी बहुत इंपॉर्टेंट आपकी वॉइस रिहैबिलिटेशन आती है, राइट? मोस्ट कॉमन कार्सिनोमा ऑफ लैरिंक्स इज स्क्वैमोस सेल कार्सिनोमा, दैट वी ऑलरेडी नो, राइट? Usually occurs between 50 to 70 years of age. Most common risk factors are what? Though usually this occurs in smokers, obviously it is related to alcohol, irradiation, but very commonly seen in wood dust, asbestos and cement factory workers. This is something which is very, very genuinely seen in laryngeal carcinomas, right? Most common site for laryngeal carcinoma is glottis. उसके बाद आती है supraglottis, उसके बाद आती है subglottis, सबसे पहले आती है ग्लॉटिस. ओके, फाइन. अब ये देखो, ये वही डायग्राम है दैट आई जस्ट ड्रू फॉर यू, राइट? ये वही डायग्राम है दैट आई मेड फॉर यू. सो आई टोल्ड यू दैट दिस इज योर false vocal cord, this is false vocal cord, this is true vocal cord, right? This is a true vocal cord. So anything that happens at the level of the true vocal cord, it will be called as glottic carcinoma. Anything which occurs above the level of true vocal cord will be called as supraglottic carcinoma, and anything which occurs below the true vocal cord will be called as subglottic carcinoma, right? अब अगर इनमें से मैं पूछूं सबसे खराब कौन है, तो सबसे खराब इनमें से जो है that is subglottic carcinoma, which is the worst. Why it is the worst? Because it has got the highest amount of nodal metastasis. सबसे ज्यादा neck node metastasis is seen in cases of subglottic carcinoma. Okay, fine. Okay, now one more important thing is that there is biphasic stridor. सारी की सारी क्रिकोइड कार्टिलेज बंद होती है, तो क्रिकोइड कार्टिलेज के अंदर सबग्लॉटिक एरिया होता है, एंड सबग्लॉटिक एरिया में जो कैंसर होगा तो दैट विल प्रोड्यूस biphasic stridor, right? That is why this particular area is the worst, subglottic area. ठीक है? सबसे अच्छी प्रोग्नोसिस इज सीन इन केसेस ऑफ ग्लॉटिक कार्सिनोमा. ग्लॉटिक कार्सिनोमा की बेस्ट प्रोग्नोसिस क्यों है? इट्स ओनली बिकॉज दैट दिस पर्टिकुलर थिंग हैज गॉट लीस्ट नोड्स. लिम्फैटिक्स वोकल कॉर्ड पे नहीं होती, वोकल कॉर्ड पे लिम्फैटिक्स नहीं होती, तो ऑब्वियसली ये मेटास्टेसाइज नहीं करता. तो इसीलिए इसकी सबसे अच्छी प्रोग्नोसिस होती है, राइट? So remember this, worst prognosis subglottic carcinoma, glottic carcinoma की सबसे अच्छी prognosis. ठीक है, चलो अब देखो, अब एक चीज इसमें आती है कि इनकी स्टेजिंग कैसे पढ़नी है, और वो बहुत आसान है. ओके, हाउ टू रिमेंबर द स्टेजिंग इज वेरी वेरी सिंपल. ठीक है, अब इसको देखो कैसे पढ़नी है. लेट्स से द सेम थिंग दैट आई ड्रू फॉर यू. लेट्स से ये लैरिंक्स है, ये फॉल्स वोकल कॉर्ड है, ये वेंट्रिकल है, ये ट्रू कॉर्ड है, ये नीचे आ गए, राइट? ये false vocal cord, ये ventricle, this is your true vocal cord, ये नीचे आ गए. This is true vocal cord, this is false vocal cord. Okay, fine. अब इसमें देखो क्या है. If I draw this like this is arytenoid and these are your vocal cords. ठीक है? अगर आपको ये क्वेश्चन आता है that the tumor of the larynx is involving only one cord, सिर्फ एक कॉर्ड पे larynx में ट्यूमर है, and both the vocal cords are moving, your answer is the tumor is in stage T1A. A मतलब एक, दोनों कॉर्ड मोबाइल हैं, चलते हैं, और एक ही कॉर्ड पे ट्यूमर है. आंसर इज T1A. दोनों कॉर्ड पे ट्यूमर आ गया एंड दोनों कॉर्ड अभी भी मोबाइल हैं, चल रहे हैं। आंसर इज T1B, मतलब बायलैटरल। दोनों कॉर्ड पे ट्यूमर है बट अभी भी वोकल कॉर्ड चल रहे हैं। आंसर इज T1B। जहां पे आपको ये दिखा दैट द ट्यूमर हैज स्प्रेड आइदर टू द सबग्लॉटिस और सुप्राग्लॉटिस, मतलब अब ग्लॉटिस के बाहर ट्यूमर चला गया, या ऊपर चला गया या नीचे चला गया, आइदर इट हैज गॉन टू द सुप्राग्लॉटिक एरिया और सबग्लॉटिक एरिया, then it will straight away come to T2, and in T2 they will tell you एक catch point, impaired mobility of cord, vocal cord की mobility impair हो जाएगी, मतलब रुकेगा नहीं, it will not get fixed but it will get sluggish, it will get impaired, that is T2। ठीक है, उसके बाद आते हैं T3। T3 में the moment they say T3 they will say vocal cord is fixed, vocal cord नहीं चल रहा, it is fixed, एक vocal cord काम करना बंद कर दिया। तो the moment they use impaired mobility say T2, the moment they say fixity say T3। अब T3 में the tumor will also spread to important areas। कौन से areas? Remember 4P, 4P are the important areas of T3। अब कौन से होते हैं 4P? 4P का मतलब if the patient has got involvement of paraglottic space, paraglottic मतलब vocal cord से बाहर, around the vocal cord, this space, this is paraglottic space, so around the vocal cord it is involved the paraglottic space, or pre-epiglottic space, or the perichondrium of thyroid cartilage, or the post-cricoid area, 4P, pre-epiglottic space, paraglottic space, perichondrium of thyroid and post-cricoid। इनमें से कोई भी मेंशन किया है together with fixity of cord, your answer should be upstage to T3 carcinoma। ठीक है, T4 is again divided into T4A, 4B। 4A का मतलब ट्यूमर लैरिंग से बाहर आ गया है, और लैरिंग से बाहर सारे एक्स्ट्रा लैरिंजियल स्ट्रक्चर्स को इन्वेड कर दिया है। लैरिंग से बाहर क्या है? स्किन है, ट्रैप मसल्स हैं, ईसोफेगस है, ट्रेकिया है, राइट, और ग्रॉस कार्टिलेजेस ऑफ लैरिंग्स हैं और सारी, एवरीथिंग इज इन्वेडेड। तो इफ यू सी एनी ऑफ द एक्स्ट्रा लैरिंजियल स्ट्रक्चर्स गेटिंग इन्वेडेड जो लैरिंग्स के बाहर है, आंसर इज दैट दे हैव गॉन इनटू T4A, अप स्टेज, फाइनल स्टेज। T4B का मतलब PCM, फिजिक्स केमिस्ट्री मैथ्स नहीं, PCM मतलब प्रीवर्टिब्रल स्पेस, कैरोटिड आर्टरी और मेडियास्टिनम। PCM में कभी भी लैरिंजियल ट्यूमर जाता है, हम उसे T4B कह देते हैं। दिस इज द स्टेज विच वी कैन नॉट डू एनीथिंग अबाउट, दिस इज द फाइनल स्टेज ऑफ लैरिंजियल कैंसर्स। ठीक है, डन। चलो, अब इसी के बेस पे आपसे पूछेंगे कि आप मैनेजमेंट क्या करेंगे। अगर स्टेज 1 और स्टेज 2 में ट्यूमर है, मतलब सिर्फ अर्ली स्टेज ट्यूमर है, तो स्टेज 1 और स्टेज 2 में द फर्स्ट लाइन ऑफ ट्रीटमेंट स्टिल रिमेन्स टू बी रेडिएशन। हम रेडिएशन के लिए पेशेंट को भेज देंगे। वाई? बिकॉज अगर हम सर्जरी करते हैं तो हमें डैमेज नहीं करने वोकल कॉर्ड्स, वी कैन सेव द वोकल कॉर्ड्स, वी कैन सेव द ऑर्गन। So radiation is the first choice in the earlier stages in stage 1 and stage 2. We can choose to do a laser microsurgery. We can choose to do a laser microsurgery. This is again dependent on the age and choice of the patient. But again, according to what we do, something called as organ preservation protocol. Organ preservation का मतलब हमें बचाना है larynx, हमें जबरदस्ती नहीं निकाल लेना है. That is why radiation is the first choice. अब आता है स्टेज 3. स्टेज 3 का मतलब हुआ ये है ग्रे जोन. इसमें सर्जरी ऑप्शन भी है, कीमो रेडिएशन ऑप्शन भी है, राइट? इसमें हम क्या करते हैं, स्टेज 3 में वोकल कॉर्ड फिक्स हुआ है, तो व्हाट वी डू, वी असेस द लैरेंजियल फंक्शन. और हम लैरिंग्स को असेस करने के लिए 3 चीजें देखते हैं: स्पीच, एस्पिरेशन, रेस्पिरेशन. अगर पेशेंट की स्पीच, एस्पिरेशन, रेस्पिरेशन सब ओके है, देन द फर्स्ट मोडालिटी ऑफ चॉइस इन T3 कार्सिनोमास इज कीमो रेडिएशन. अगर इस केस में स्पीच, एस्पिरेशन, रेस्पिरेशन इन्वॉल्व है, then in that case the first treatment is to do a laryngectomy or removal of the larynx. That is how we approach a case. तो कभी भी आप देखेंगे तो आपको अगर पूछा जाए what is the T3 में what is the choice, आप कीमो रेडिएशन लिखना अगर वहां पे laryngeal status preserved है. अगर laryngeal status preserved नहीं है, स्पीच अफेक्टेड है, एस्पिरेट कर रहा है, रेस्पायर नहीं कर रहा है, स्ट्राइडर में है, तो हम क्यों रखेंगे? Why will we keep it? Then we will go for straight away removing it. That is total laryngectomy. T4 में हमारे पास कोई ऑप्शन नहीं है. स्टेज 4A, द ओनली ऑप्शन दैट वी हैव इज टोटल लैरिंजेक्टमी. इसमें हम कुछ नहीं कर सकते बिकॉज देयर इज एब्सोल्यूट इन्वेजन ऑफ ऑल द स्ट्रक्चर्स ऑफ द लैरिंग्स. वी कैन नॉट डू एनीथिंग. वी हैव टू डू अ कंप्लीट रिमूवल ऑफ द लैरिंग्स, फॉलोड बाय आफ्टर द होल एक्सिजन इज डन, वी विल फॉलो इट अप विद कंकरेंट कीमो रेडिएशन. मतलब ऑपरेशन करने के बाद वी विल गिव कीमो रेडिएशन थेरेपी. क्वेश्चन आता है, what is this incision that you see? In this case, in laryngectomy, the incision is called as Gluck-Sorensen incision. Gluck-Sorensen मतलब mastoid to mastoid like an apron. This is called as Gluck-Sorensen incision. 4B में कुछ नहीं कर सकते, we only give palliative treatment. Okay, fine. चलो, okay. अब आ गए हम लोग फाइनल पार्ट पे. दिस इज द लास्ट पार्ट ऑफ टुडेज लेक्चर. ह्यूज लेक्चर इट्स बीन, एंड आई एम वेरी हैप्पी टू सी मेनी ऑफ यू हैव बीन एक्टिव right throughout. It's been almost 5 hours we've been talking with each other, but this was a whole run through of ENT. इसके बाहर से कुछ नहीं आएगा, I can promise you that. Okay, if you just see this is more than enough. So what is rehabilitation in post laryngectomy? हमने larynx निकाल दिया, अब हम क्या करें? We need to do something about the speech, right? So 3 चीजों की तरीके से we rehabilitate the patient to speak. One is called as esophageal speech. Esophageal speech का क्या मतलब होता है? Esophageal speech का मतलब होता है that we create sound like a burp, right? अब जैसे हम क्या करते हैं, we burp, right? हम burp में एक sound create करते हैं, तो हमारा esophagus बचा हुआ है, pharynx बचा हुआ है, but larynx जा चुका है. अब हमें क्या करना है, जितनी pharynx की walls है ना, उनमें we need to put pressure and vibrate them so that we can create a speech. अब उसको vibrate करने के लिए what we need to do, right? That is something we need to understand. हमारे पास एक बहुत इंपॉर्टेंट चीज है जिसको हम कहते हैं ट्रेकियो-इसोफेजियल प्रोसेसेस. ये क्वेश्चन एज इट इज आपके पेपर में आता है और ये लिख दिया जाता है कि ये है क्या. दिस इज कॉल्ड एज ट्रेकियो-इसोफेजियल प्रोसेसेस. आपका नाम इसमें आएगा एंड दैट यू कॉल इट एज ब्लॉम-सिंगर प्रोसेसेस. नाउ व्हाट इज दिस ट्रेकियो-इसोफेजियल प्रोसेसेस? नाम देखो, ट्रेकियो-इसोफेजियल, राइट? अब इसमें हमने किया क्या है? व्हाट हैव वी डन इन लैरिंजेक्टमी? In laryngectomy, we have actually created a hole over on the neck and we have sutured the trachea to the neck. और पीछे esophagus है. But we have sutured the trachea to the neck क्योंकि यहीं से patient breathe करेगा. Correct? Right? अब हमें करना क्या है? अब obviously larynx चला गया है, so we can't have any way to breathe, right? We don't have any way to speak. So what we do? We take a processes. Processes मतलब tracheo-esophageal processes. What do? We create an incision on the posterior wall of the trachea and the anterior wall of esophagus. और इसके बीच में we keep this processes. Now this is a one-way processes. One way. ठीक है? अब क्या करेगा patient? I need the air to come inside the upper portion of the pharynx. यहाँ आनी चाहिए air, so that the air can vibrate the pharynx and create speech. So what will the patient do? Now in order to get the air inside, when the patient is expiring, जब बाहर निकाल होगा हवा, the patient will close the stoma with the finger. Stoma के ऊपर finger रख लेगा patient. And now what will happen when the air is coming out during expiration and the stoma is closed from outside, all the air will get diverted from the trachea into the esophagus and the pharynx. And now this air will vibrate the columns of the pharynx. It will cause vibration of the pharyngeal columns, and that will be produced through the mouth in the form of some sound. This is called as tracheo-esophageal speech. और इसमें जो दो phalange हैं that you can see over here, this is the esophageal phalange and this is the tracheal phalange, through which things work, and this is a one-way valve. Okay, fine. So this is how exactly your tracheo-esophageal processes work. This is what I have told you. This is a whole flowchart that explains, but what I've told you, this is the same thing, right? What the flowchart is telling, right? But अब हम इस area में आ चुके हैं कि we have got this kind of an appliance nowadays. And this handheld appliance is just like a pen. उसमें मैं यहाँ पे रख लूँगा over my submandibular area, and this will create a vibration. That vibration will be directly entering inside my mouth, and that vibration will be created in the form of a sound. I can create sound directly through the vibrations of this handheld device. इस device का नाम होता है electrolarynx. This is something that is a very common device used nowadays, and it produces a very robotic voice, but yet a very, very handy instrument for any laryngectomy patient, because see the magic, patients are speaking without a larynx. And that is what we have reached in our recent advances nowadays. Right? Okay. Chalo. Last slide for is this particular chapter, this particular segment, and my whole of ENT. Okay. What is this? This is about tracheostomy. एक क्वेश्चन आपका जो ट्रेकियोस्टमी से आता है वो आता है हाई, मिड और लो ट्रेकियोस्टमी पे, राइट? सो दिस इज समथिंग दैट आई एम जस्ट गोइंग टू टेल यू अ क्विक रिकैप अबाउट इट. हाई, मिड और लो ट्रेकियोस्टमी क्या होती है? तो ये हो गई नेक, राइट? एंड लेट्स से दिस इज योर ट्रेकिया, ओके, गोइंग इनसाइड द नेक, राइट? एंड ट्रेकिया के ऊपर दिस इज योर क्रिकॉइड कार्टिलेज, राइट? इफ वी डू अ ट्रेकियोस्टमी, राइट, इफ वी गिव अ ट्रेकियोस्टमी, At the level of the first tracheal ring, we will call this as high tracheostomy, right? Which is called as high tracheostomy. Okay. Now, high tracheostomy का only indication, एक question आता है, what is the indication for high tracheostomy? The only indication for doing a high tracheostomy is to save as much trachea possible when we are doing a laryngectomy, क्योंकि उसे हमें suture करना है to the skin, because this all area will be removed, right? So the indication for high tracheostomy is basically total laryngectomy, where we are removing the whole of the larynx. That is total laryngectomy. Normally, where do we do tracheostomy? We usually do between 2nd to 4th tracheal rings. This is a segment where we do normal tracheostomy. Okay. If we do any tracheostomy below the level of 5th tracheal ring, then we call it as low tracheostomy. Okay. So this is what you should remember about what is high, what is mid, what is low. High का बस एक indication जो question आता है, that is about total laryngectomy. Okay, fine. Chalo. This finishes my whole lecture about what was today. I hope you guys have enjoyed it. Thank you for joining. This finishes my whole of ENT as a run through, right from the beginning till the end. Iske beyond, I don't think so you require anything else. This is the complete revision aspect. There's a complete thing what I can give you in a crux about whatever has to be learnt by you. What I would suggest is go through the workbook. You will get all the notes there. Go through whatever I've written. I've written it in the way in which you can remember it. I've written it in the way in which you can recapitulate it very, very fine, right? So this is something that is my takeaway for you. All the very best for your examinations. Give yourself some time to relax also, right? Keep reading at the same time, but relax down at the same time. It's just one exam and you can just go through it as it is, okay? So good night to all of you. Thank you for joining. You will get the PDF over on our Telegram group. So just join over on our Telegram group, right? And you will get everything there. And whoever is joined, thank you very much. You can just recap all the session as it will be on YouTube as it is. Okay, thank you. Thank you for joining.